in cancer patient amid COVID-19. It's not. The COVID-19 pandemic has brought a surge of anxiety, stress, and death with financial and social instability. It is especially seen in cancer patients where there is enormous uncertainty, stress, and dilemma affecting their treatment and outcome. Here comes the role of supportive care in the form of palliation, which is an ethical obligation even at the time of pandemic. The provision of such care is a major concern and challenge at the same time. Therefore, cancer patients need a comprehensive care based on holistic care approach. Now, the challenges and dilemma in cancer patient is the dilemma and the challenges in cancer patient is related to patient safety and outcome. The poor outcomes are seen in COVID patient, as we know that, and the cancer is a time-sensitive disease. So the dilemma revolves around whether a patient should come out of his home to visit the hospital to continue the treatment. Also, the cancer therapy can increase the risk of getting infected with the COVID-19 infection. The lack of trained palliative physician and the availability of morphine and the other essential drugs forces a patient to visit hospital, thereby increasing the chance of getting infection. Also, the institutional challenges such as diversion of majority of resources to the COVID and neglecting the cancer patient can have a significant impact on their treatment, affecting the quality of life, their survival, and outcome. Therefore, a comprehensive care approach model is the need of the hour. Evidence-based 5 major domains can be summarized as TRI-SPREED. The TRI stand for the triage, S for symptom control, P for psychosocial support, E for ethical based care discussion, and ED is the end of the life care. Now I'll be talking about each of the domain. The first comes the triage. The triage is a priority-based management. It helps in prioritizing the care and also the better utilization of the available resources. As the pictorial shows, the cancer patient can be divided into the 3 categories with the highest priority of the patient who are terminally ill with the need of end-of-life care. Also, the patient with severe symptoms such as the agonizing pain and the emergency such as the spinal cord tumor. Such patients can be shifted to the hospital or the home-based care can be given accordingly, and the patient with the need of end-of-life care can be shifted to a nearby hospice. The aggressive symptom management can be done in the cases with the patient having the severe symptom. The next priority comes to the patient who are not on active disease modifying treatment and with the mild and moderate symptoms. In such patient, telecommunication and the routine home based are given. Now the least priority comes with the patient who are well controlled, who are on well controlled symptoms and on active disease modifying treatment. In these patients, integrated palliative care with the active disease modifying intervention and follow-up with the help of telecommunication and the assessment of physical and emotional distress can be given. And it should be remembered, however, that this symptom management and psychosocial support should be given to each and every patient. Now comes the symptom control. The cancer patient present with both physical and psychosocial suffering. Therefore, palliative care principles should be followed, and the symptom control should continue till the end of life. The symptoms such as pain, nausea, and vomiting should be treated at home with the help of telecommunication. The extra morphine tablets and the other essential drugs should be given to the patient in order to prevent their frequent visit to the hospital. The home-based palliative care worker plays an important role in the symptom control at home, and the patient with having the overlapping symptoms of COVID-19 should be isolated, tested, and treated according to the government guideline. As the pandemic has brought a surge of fear, uncertainty, anxiety, and depression, so the psychosocial support is must, especially in the cancer patient and the survivors and their family members. And the patient who somehow fail to continue or complete their cancer therapy are filled with guilt and depressive thoughts. Therefore, empathetic communication should continue throughout the process. Now comes the ethical based care discussion. The decision making in a cancer patient for and against intervention is a major ethical challenge. Therefore, effective communication and detailed discussion can simplify this complex process. Documentation of ethical based discussion and decision is important, and the patient denied of further medical intervention should not feel to be neglected, and the care should be given till his or her last breath. And the ethical based care discussion is only possible with sensitive and compassionate discussion. Now comes the end of life care. For the end of life care, use of technology can be done, such as the telecommunication, recorded religious or spiritual messages, musics, and prayers. The palliative sedation can be done in the cases of refractory cases. Realistic hope and the true communication regarding the prognosis is the key of the end of life care. And as we know, because of the lockdowns and the government policies, the less family members are allowed at the funeral process and the rituals. And a good end of life care ends with good bereavement process. Therefore, I would like to summarize as pandemic is closely associated with panic. Therefore, it requires evidence-based comprehensive approach and shifting resources into the community via video conferencing and telemedicine, triaging cancer patient on priority basis, minimizing risk benefit ratio for intervention with palliative intent is the need of hour. Therefore, we propose tri-speed approach for holistic care in cancer patient. Thank you.
The time is up, Dr. Wasim.
Yes, sir. I'm done, sir.
Dr. Wasim.
Okay.
Yes, sir. Yes, sir.
Dr. Kutti, that was a good presentation and a good eye-opener for a message that palliation needs to be continued in pandemic times. But since this is a paper presentation, my question to you is, other than this information that palliation is needed, what exactly has been your work has not been highlighted? Neither have you highlighted what exactly you want to bring out of this paper other than this general information that palliation should continue. Anyway, home care was there before also. So how has things changed as far as Corona, the pandemic is concerned?
Yes, sir.
Both these things have not been addressed.
Yes, sir. So the new thing is the emergence of this telecommunication. So the emergence has telecommunication has come into the play, and there is the some much more involvement of the of the ground level palliative physicians or the home based palliative physician. So there is a need of encouraging or supporting or to say to make them much more informative about the need of the palliative care at the grassroots level, because in such cases such pandemic the cancer patient cannot come or visit to the hospital very frequently, as there is the risk of getting infection.
Thank you. Your point is well taken. That's what I was telling. So your work or the number of telemedicines that you consulted and all should have come out in the paper. Thank you.
Yes, sir. Yes,
Okay,
sir.
it's Dr. Sanjay speaking. I saw a very nice presentation, good presentation. I just wanted to know whether what principle where you are talking about.
Sir, the
Palliative principle. I mean
yes,
to say palliative principle.
yes, sir. Yes, sir. Sir, so what is the case? We should follow the four cardinal principles of the palliative care, such as the patient. The first is the patient autonomy, that the patient wish, and the second is the beneficence. This is the do good, and the third is do not harm, called as the non malfeasance, and the fourth is the justice or the judicious use of the available resources.
Okay. Okay. Thank you. Thank you.
Dr. Wasim, I think we'll
Yes,
have
sir.
to go to
Thank you.
speaker now. Dr. Abhinav Prakash, are we ready?
Okay, thank you, sir. Thank you.
Ready, sir.
Abhinav, could you please start sharing your presentation?
Is my presentation visible?
Yes, Abhinav, you may start, please.
Good morning, everyone. I'm Dr. Abhinav Prakash, and I'm a senior resident at AIIMS Patna. The topic of my presentation today is COVID-19 lockdown and its impact on pain management in cancer patients, a telephonic survey. The co-author of the study is Dr. Nishant Sahai, who's additional professor at AIIMS Patna. The novel coronavirus, also known as SARS-CoV-2 or COVID-19, started in late December 2019 from Wuhan, Hubei, China, and later spread worldwide. This pandemic has caused major limitations in all sections of the society and has affected not just health, but livelihood of people across the globe. One such section of population severely affected are people living with cancer. Patients with cancer need frequent access to pain medications, as pain due to cancer is known to be excruciating. However, with the unprecedented lockdown in various places across the country, access to pain medication has been a real challenge for these patients. Our aim was to study the effect of COVID lockdown on access to healthcare facility for purpose of analgesia in patients suffering from terminal cancer. Our objective was to assess the percentage of people who had access to opioid analgesics and to know whether patients' family faced any problems in getting treatment for pain. This was a single center observational cross-sectional study by telephonic survey done by Department of Anesthesiology at AIIMS Patna. Patient registered with Pain and Palliative Clinic from January 2019 to May 2020 who gave oral consent were included. They were called and explained regarding the purpose of the call and were asked questions as per a prepared questionnaire. It was with respect to the lockdown from the months of March to May this year. Faulty or wrong numbers were noted, and patients who had died, their details were also noted. The data was entered in MS Excel and analysis was done. Here's a snapshot of the questionnaire that we had prepared. It included questions. It was in the local language, that is Hindi. I'll be translating it here. Are you aware of the disease? Are you presently in pain? Do you have access to pain medication? Where are you getting your pain medicines from? And the last question was an open-ended so that we could actually know what problems they faced, as in, did you encounter any difficulty in access to pain medication? Coming to results, we had a total of 499 patients from our database. 176 out of 499, that is 37%, responded and completed the questionnaire. 197 out of 499, that is 39%, had unfortunately expired. In 20%, there was no response from the registered phone number despite calling twice on 2 different occasions. 3% had incorrect phone numbers. 1%, that is 7 patients, refused to participate in the survey. Amongst the total respondents, that is the total of 176, 10 out of 176, that is 5.6%, said they had no pain at the time of survey. 11 out of 176, that is 6.2%, said they were getting treated in a different hospital. 8.5% of the respondents said they had pain at the time of survey. 20 out of 176, that is 11.3% of the patients, said they had medicines available from their previous visits, and hence they did not need to travel during the lockdown period. 27 out of 176 patients, that is 15.3%, had access to over-the-counter drugs from nearby pharmacies. 25% were unable to travel due to various reasons. 27.8, that is 49 out of 176, were able to travel to a hospital during the lockdown period. I'll just like to add that 4 of them had difficulty with the police personnel, and they had difficulty negotiating regarding their travel. Now, coming to the reasons for inability to travel, 57% did not have any access to public mode of transport, and they had inability to pay for private transport. 32% had general paranoia of COVID, and they did not want to get out of their houses. 11% had no access to any mode of transport, be it private or public. Now, in conclusion, due to COVID-19 lockdown, many patients suffering from chronic ailments, such as cancer, have experienced difficulty in access to healthcare for their visits and follow-up care. Now, our study, which was done in patients suffering from cancer, showed that significant number of patients were unable to come to the hospital for their evaluation and treatment. However, contrary to popular belief, government officials such as police in most circumstances had been very helpful. As shown by our study, major drawbacks of lockdown was lack of availability of affordable public transport and increased cost of private transport. One major limitation was that since it was a single center study and the respondents were from a limited geographical region, hence the conclusion might not be applicable at a pan-India level. Thank you.
Thank you, Doctor. Dr. Koshi here. That was a
Good
very
morning.
good presentation, Dr. Abhinav. Could you just go back to your slide of what was your aim? Because in your result, that aim was not coming out. Could you just
Yeah.
take me back to the slide where the aim was written, your objective?
Is this okay? Is it visible,
Yeah.
sir?
Yeah. To assess, see, this too, information did not come out in your conclusion slide. So what exactly was your conclusion? I would like to know.
So the aim was to know what was the general effect on the cancer patients. Our objective was specifically to know what percentage of people, how many had access to opioid analgesics, and whether they had any problems. So that is what we concluded, as in we found out that they had significant people did not have access to pain medications. And regarding the second objective, where we were going to find out what problems they faced, we found out that around many patients did not have access to any mode of transport, and the ones that had access to mode of transport, that is private mode of transport, uh, they could not afford it.
Okay, so this is you did not compare it with your pre-existing data. This was just for the pandemic lockdown only.
Yeah, this is a cross-sectional observation study, sir. So just a snapshot.
Thank you, doctor. But it was a very good effort to know about what these people were doing during lockdown.
Thank you,
Yeah,
sir.
Dr. Abhinav, I have a question. In your
Abhinav?
presentation results, you've
Hello.
mentioned that certain percentage of the patients had access to over-the-counter drugs. Now, since your primary aim was accessibility of analgesic medication, had you subgrouped into this as to what was the treatment pattern with respect to WHO ladder, or what was the treatment pattern with respect to opioid? How many of your patients were on opioids and non-opioid medication? So did you have a subgroup analysis of this?
We did not do a subgroup analysis, sir, but from what I found out from them, we were actually asking them, as you see in the objective, we were asking them about the opioid analgesics. So in our hospital, as a part of tertiary care management, we prescribed them morphine for their pain management. So that was the main concern, and the data was from our hospital. So we were asking them whether morphine is still available. If it's not available, or if for some reason, how are they managing pain if they are still in pain? So for that, we wanted to know, are they going for any over-the-counter drugs, or are they going to any other hospital, as I mentioned it?
Unfortunately, that's not coming out very well in your results, that how many percentage of your patients were on morphine and did not have access to morphine because the medication was over, or they did not have access to a healthcare facility which would supply that. So that was my first question. The second question was, did it make any difference in the treatment patterns? I know you're not assessing that, but when you say that the patient was not able to travel to a healthcare facility or not having access to pain medication, did it finally, was the patient apprehensive with respect to not receiving treatment, or not nobody looking at their daily advancement patterns and things like that?
More than apprehensive, what I found out during my talk with them, they were in pain, and they were in significant pain, but because of unavailability of transport and because of general paranoia about COVID, when they did not want to go out, many times their proxies were talking, the patients, the attenders who were taking care. So they were pretty hapless that they could not go out and take medicines, and their patients were suffering in pain.
Sure. Thanks.
Thanks.
Thank you. Thank you, judges. I think the time is over for one candidate. Can we go to the next candidate?
Shant, who is the next? Please take the name. Slide and share karo jara, Abhinav.
Dr. Ankesh. Dr. Ankesh,
Yes, sir.
are we ready?
Yes, sir.
Can you start the presentation, please?
Yes, sir. Am I audible, sir?
Yes, you are audible, but we are not able to see your presentation, Ankesh. Can you start share screen?
Yes, sir. I have started share screen, sir.
Have you Opened your PowerPoint presentation, Ankesh.
Yes, sir.
Okay, it is
Is
coming now.
it? Yes, sir.
Start slide share, please.
I have started the slides, yeah.
Share is not coming. Full screen mode.
I think
Slide
you have to
share.
go to full screen
Oh,
mode,
right.
yeah. Full screen.
Full screen. Yeah. There. I request all the
Yes,
other
sir.
contestants to start their PowerPoint presentation before starting share screen. Ankesh, you may start.
Hello.
Let's move
Yeah,
on.
Ankesh, you may start,
Yeah,
please. Please start.
yes, sir.
Please
Sir,
start.
a very good morning to respected judges, my seniors, colleagues, and juniors. I'm Dr. Ankesh. I'm presenting my study on comparing different doses of intrathecal 2-chlorprocaine 1% in daycare settings for urological procedures. 2-chlorprocaine is an amino ester local anesthetic. The study design is prospective randomized double-blind study. We aim to evaluate the adequacy of 3 doses of 1% 2-chlorprocaine, that is 30 milligram, 40 milligram, and 50 milligram. We have taken in urological surgeries lasting 30 to 60 minutes. The study was conducted at IGMS Patna and was enrolled in clinical trial registry with a CTRI number. Inclusion criteria: 90 ASA physical status 1 and 2 patients for daycare surgery were selected, age 18 to 55 years, undergoing urological procedures up to 60 minutes were enrolled. Exclusion criteria as per the standard guidelines of regional anesthesia. Spinal anesthesia was performed at L4, L5 interspace. Group A, that is of 30 milligram, Group B 40 milligram, and Group C is 50 milligram of 1% 2-chlorprocaine. Patient was evaluated for sensory and motor blockade every 3 minutes until readiness of surgery, and then every 5 minutes until the maximum level of sensory block was reached. Further assessments were performed every 15 minutes for 60 minutes, then every 30 minutes until fulfillment of home discharge criteria. Readiness of surgery was defined as loss of pinprick sensation at up to T10 and modified Bromase score of 2. We assessed and evaluated onset of sensory and motor blockade, time for complete regression of spinal block, voiding, unassisted ambulation, eligibility of home discharge. Transient neurological syndrome was assessed 24 hours and 7 days after the surgery using a standardized telephone questionnaire. Criteria for home discharge were stable vital signs, patient tolerating liquids by mouth, walk with crutches and void, and there were no nausea or pain. Results. In table 1, there was no difference in anthropometric variables and duration of surgery among the 3 groups. Table 2, spinal block resolution in group A was 60 in minutes was 60 minutes, in group B it was 85 minutes, and in group C it was 97 minutes. Unassisted ambulation in minutes was 85 in group A. Group B, that is 40 milligram, is 180 minutes. In group C, it is 185 minutes. Spontaneous voiding, the time in group A is 182 minutes, and group B is 198 minutes. In group C is 203 minutes. Home discharge time in group A is 182 minutes. In group B is 198 minutes. In group C, it is 203 minutes. Median time to achieve readiness of surgery in group A was 8 minutes, that is 3 to 25 minutes. In group B was 7 minutes, 3 to 26 minutes, and group C was 6 minutes, that is 3 to 20 minutes. Medium maximum level of sensory block was T9 in group A, T9, that is T12 to T6 in group B, and T9 in T12 to T7 in group A. The spinal block resolution was faster in group A than group B and C. Unassisted ambulation was earlier in patients of group A as compared to other 2 groups. There was no signs of transient neurological symptoms reported both at 24 hours and 7-day phone follow-up. Conclusion is that availability of reliable and safe short-acting local anesthetic has recently renewed interest in spinal technique for outpatient surgery, offering an alternative to general anesthesia. 40 to 50 milligram of plain chlorprocaine provides adequate spinal anesthesia for urological procedures lasting 45 to 60 minutes. Reducing the dose of 2-chlorprocaine to 30 milligram resulted in early ambulation and had advantage in terms of home discharge time. My take-home message is, in the era of fast life and overburdened hospital infrastructure, neither the patient nor the hospital wants to retain the patient in the hospital settings if the home discharge criteria is being met. Thank you.
This is Dr. Shagufta. Ankesh, this was a good presentation by you. I want to ask one thing. What was the primary outcome that you were studying?
That is ambulatory time. Ambulatory time in I'm studying the ambulation time in daycare setting by using 2-chlorprocaine. When will be the patient will be ambulatory, and when the patient has meeting the criteria of daycare discharge.
So how did you calculate the sample size?
So, madam, sample size, I have taken 30 and 90 patients in this, all the three groups, 30 each. And I have used a statistical analysis and ANOVA for the purpose. And this is according to our stats, we calculated that it is approximately 30 patients in each group.
So the sample size was calculated according to some previous study, or on what basis?
Yeah, yes, ma'am.
Hello.
Hello.
Yes, please. Just wanted to know if you have divided your patients in 3 groups.
Yes, sir.
Hello. Yeah, in 3 groups. So you taken 30 patients in each group.
Yes, sir.
All these data are adequate, or you should have done some more. So you should have taken some more samples.
Sir, that is the limitation of my study also, that we have to check the adequacy or the ambulatory time or the any side effects coming up with 2-chlorprocaine in large number of people. I am conducting another study also to test this.
Okay. Are there any further questions, judges, or should we go to the next?
Thank you, sir.
Yes, please carry on.
Okay. Dr. Gunjan.
1 minute, Ankesh. How did you randomize and blind your population, in the sense? How was randomization done, and allocation, concealment, and all of that?
That is by computer generated number, sir.
And how was blinding ensured?
So it is a double-blind study. Neither the investigator nor the patient knew how much.
Who loaded the drug?
Pardon, sir?
Who loaded the drugs?
So it was our technician that loaded the drug. He was not knowing in which subset I am giving the drug. That is how much ml. That is 10 milligram per ml. How much I am giving to the subset of the patient.
You ensure that the volume of all the 3 syringes remains the same. Otherwise, there is no chance of blinding, right? If the volume becomes different.
So chlorprocaine is available in 10 milligram per ml. That is of chloroquine 1%. And if we have to give 30 milligram, it's we take 3 ml of drug for an intrathecal injection.
Correct.
And
Correct.
And if I have to give 40 milligram, I have to take 4 ml of the drugs. So
then the person giving the drug will come to know what blinding arm the patient is in, right? Because the volume will be different. So it won't be a blinded study then.
So the technicians, we didn't tell them which group the patient is in.
Fine. Okay. Next, please.
Okay. Next, Dr. Gunjan, could you please be ready?
Yes, sir, I'm ready.
Yeah, Dr. Ankesh, can you please stop sharing?
Yes, sir.
Dr. Gunjan, is your PowerPoint open? Please start sharing. Dr. Gunjan.
Yes, sir. Just a second. Just a moment, sir.
Yeah, okay, sure.
Request, just a request. The next 5 speakers, please keep your PowerPoint open on the desktop. I request, please don't waste time.
Can I get the name of the participant, please?
Gunjan is going to speak. Are you ready, Gunjan?
Should I proceed, sir?
Dr. Gunjan.
Should I proceed, sir?
Please do.
A very good morning to all. Today, my
But
topic.
your PowerPoint is not showing, Dr. Gunjan. Please share your PowerPoint. Yeah, it has started now. Slide share.
Yes, sir.
Yeah. Okay, you may start.
A very good morning to all. Today, my topic of presentation is a comparison between ultrasonography aided and physical indices based formula for estimation of endotracheal tube estimation in pediatric age group. Coming to the introduction part, providing safe anesthesia to pediatric patient is a very challenging task. It requires not only a thorough knowledge of the soft and the pliable pediatric airway, but also demands experienced hands. Owing to the vulnerability of the structures involved, choosing an appropriate size endotracheal tube is of utmost importance. It has been seen that the physical indices-based formula have often failed to justify the purpose. The increasing availability or accessibility of the modern ultrasound devices have shown to be quite promising in these cases. The aim of our study was to primarily estimate the correlation of the tube size used clinically on the OT table with that of the ET tube size estimated firstly by USG, secondly by age-based formula, and thirdly by the height-based formula in the pediatric age group. Secondly, we wanted to estimate the number of the endotracheal tubes predicted by USG that was exchanged for a larger or smaller tube on the basis of air leak test. 100 pediatric patients belonging to the age group of 1 to 5 years were enrolled for the study. Those patients belonging to ASA grade 1 and 2 posted for elective surgeries under GA and requiring endotracheal intubation were included in the study, whereas those having airway pathology, anticipated difficult airway, and delayed milestones were excluded. The sizes predicted by the physical indices formula and USG were calculated preoperatively and recorded. The USG was done with the head in this sniffing position. The true vocal cords were localized as two pair structures which moved on deglutition and swallowing. The probe was then moved caudally. The transverse air column at the cephalic half of the cricoid cartilage was then identified and was taken to be the tracheal diameter. During anesthesia, induction was done and the patient was relaxed, patient intubated. If cup ET tube was chosen, the size used was 1 mm external diameter, less than that of estimated by USG. If cup ET tube was chosen, then the size was same as that estimated by USG. If the air leakage was satisfactory at 50 to 20 centimeter of water airway pressure, the tube was considered to be clinically optimal. Thereby, a comparative analysis was done amongst the ET tube size estimated, first by age-based formula, then the height-based formula, then the ultrasound-guided, and then the clinically used. Age-based formula we classified into two parts. For the uncuffed tube, modified Coley's formula was used, and for the cuffed one, the Kynes formula was used. Statistical analysis was done using ANOVA test, dependent t-test, and any value of p-value of less than 0.05 was considered statistically significant. In this picture, we can see the air column in the trachea at the subglottic level, which was considered to be the tracheal diameter in the pediatric age group. Now, coming to the results section, all the patients were considered demographically comparable. Out of 100 patients enrolled, 66 patients were intubated in the first attempt, 25 in the second attempt, and 9 patients required intubation at the third attempt. If we look at this table, we can see that a comparison is drawn between the clinically used tube and the USG. Secondly, clinically used tube with the height-based formula, and in the third, the clinically used tube with the age-based formula. In the p-value, we can see that the value is significant in the third case. That is when the age, in the second case, sorry, when the height-based formula was compared with the clinically used tube on the OT table. Now coming to the second table, we can see that a comparison was drawn between the tube size estimated by USG with that of height-based formula, then USG with the age-based formula, and then the height-based formula and the age-based formula. Again, in the results section, the p-value is found to be significant in the first and the third case. That is when the USG was used in height-based form compared with height-based formula, and the height-based formula was compared with the age-based formula. In pediatric anesthesia, the selection of properly sized ET tube is critical for successful intubation. High correlation is predicted between clinically used tube and predetermined size by USG. Age-based formula predicted tube size better for cuff tubes, whereas for the uncuffed tubes, it predicted a larger size. Height-based formula overestimated the ET tube size both for cuffed and uncuffed tubes. Thereby, USG does not require strict immobility, especially in infants and children, as in case of MRI and CT scan. Nevertheless, USG depends upon the skill of the operator, required skill, and relatively is simple to learn. Now, we can strongly recommend that USG can be used to assess the appropriate size ET tube in children, especially in cases like subglottic stenosis, which is a common complication in neonates in pediatric anesthesia. So the crux of the study is that USG is effective in estimating the appropriate size ET tube, both for cuffed and uncuffed tubes. When we talk about age-based formula, it is effective only for cuffed tubes and not effective for uncuffed tubes. And the height-based formula is not at all effective both for cuffed and the uncuffed tube. Thank you.
Dr. Gunjan,
Yes,
that
sir.
was a good presentation.
Thank you, sir.
The premise with which you started is physical indices-based formula have failed to justify.
Yes, sir.
But when you come to the USG-based paper which you have presented,
Yes,
it
sir.
will not be justified because of one reason, that there is a great operator variability. In the physical indices formula, at least everybody used to calculate the same. How do you explain this operator variability, and how many operators did this particular study? Was it a single operator or did multiple operators do this study?
So to eliminate the bias in this study, we chose only one operator in this study. Therefore, the USG was done pre-operatively and not in the OT room, because it's very difficult to gather a radiologist in the OT room every time we have a case. So the ultrasonography was done freehand in the pre-operative period. So this was a step to eliminate the bias in this case.
Therefore, Dr. Gunjan, I would prefer not to agree with this conclusion that it is more effective, because we have not done a study with multiple operators to know what would be the operator variability while using USG. Then only you can compare and come out with a recommendation that USG is better or not better.
Okay,
Thank
sir.
you.
Thank you, sir.
Is it possible, Dr. Gunjan, Dr. Jason here, is it
Yes, sir.
possible that had you standardized the level at which the measurement for ultrasound guided measurement of tube was done?
Yes,
So you
sir.
have a single operator, but did you identify that it will be just immediately subcricoid or at the level of cricoid, or where was it done? You haven't mentioned that in the presentation, so I was wondering
I have mentioned it, sir. I have mentioned it, sir, in the slide. So the true vocal cords were localized, and then the probe was just moved caudally. The transverse air column was taken at the cephalic half of the cricoid cartilage, which is assumed to be the narrowest part in the pediatric airway, that is in the subglottic region.
Okay, fine, thanks.
Dr. Gunjan,
Yes, ma'am.
you have mentioned that you made the measurement pre-operatively.
Yes, yes, ma'am.
On making the measurement pre-operatively, can it affect the desired length?
Yes, ma'am. Yes, ma'am. This is a limitation of my study, ma'am. Since the patients are usually of the pediatric age group, so there was incorporation seen, but sir, there was a limitations in the procedure, sir, because if we anesthetize the patient and then measure it in the OT, it's very difficult to manage, sir, in the OT, that we get a proper radiologist every time we have a case in the OT. So that was a limitation in my case, ma'am. That must have affected the result.
Okay.
Okay, thank you, Dr. Gunjan. Next is Dr. Malka here, Dr. Malka Samina. If Dr. Malka is not here, we'll go to Dr. Manisha. Manisha, Dr. Manisha, are you here? Dr. Gunjan, please stop slide share.
Yes, sir.
Dr. Manisha?
Yes, sir.
Okay, is your PowerPoint presentation? I request all the contestants to please open your PowerPoint presentation right now before slide sharing, okay? Dr. Manisha, and please stop sharing once you're done, okay? Dr. Manisha.
Yes, sir.
Start. You may begin.
Yes, sir. Good morning, judges, my seniors, my colleagues. I'm Dr. Manisha. Today I'm going to give my presentation on ultrasound guided transversalis fascia plane block compared to caudal block for post-operative analgesia for herniatomy in pediatric population. Introduction: ultrasound guided transversalis fascia plane block is a truncal block that targets the L1 nerve branches, that is ilioinguinal and heliohypogastric nerve emerging from the lateral border of the psoas major muscle and courses over anterior surface of quadratus lumborum muscle. Local anesthetic injected between transversalis abdominis muscle and transversalis fascia, which lies beneath it, will spread over the inner surface of the quadratus lumborum muscle and block the proximal portion of the T1 and L1 nerves. Till date, there are no study on this block in pediatric population. Method: the study was designed as a prospective randomized control trial and included pediatric patient of 2 to 8 years at Indira Gandhi Institute of Medical Science, Patna. 30 patients were taken in each group, that is group T and group C. Inclusion criteria are male child, age 2 to 8 years, undergoing herniatomy operation, ASA 1 and 2, patient posted under general anesthesia. Exclusion criteria are signs of infection close to puncture site, severely altered hemostasis, platelet count less than 50,000, history of previous surgical intervention, history of bleeding diathesis, patient on anticoagulation. So here in this figure, I am depicting how the block is given. So using a 2 to 5 Hz probe of sonocyte machine, we take a 50 mm of needle, 22 gauge, and we pierce the external oblique, internal oblique, and transversus abdominis, and at the tapering end of the internal oblique and transversus abdominis, seeing the quadratus lumborum, we inject the drug, and analgesic dose of 0.25% bupivacaine, that is 0.5 ml per kg body weight is used. Coming to result, so in group T compared to group C, we see that total rescue analgesia in 24 hours has reduced. Here we have used intravenous paracetamol 10 mg per kg as rescue analgesia, and it gives a significant p-value. Also, time to first analgesia given is more in group T, that is also significant. We have done the pain scoring in child according to CHIOP score. So in CHIOP score, we see till 6 hours, there is no significant difference. But after 6 hours, we have seen that there is reduced pain scoring in the group T until 24 hours. And 0.4 is given to no pain, and 0.13 is worst pain according to the CHIOP score. Coming to discussion part, our result shows that USG guided transversalis fascia plane block provides longer duration of analgesia compared with caudal block at 6 to 24 hours after block placement. Caudal block has been widely used for lower abdominal surgery in children, but it is contraindicated in case of coagulopathy, sacral anomalies, hypovolemia. Also, it has its own complications. Ischemia et al. Reported the use of TFP block in one patient undergoing inguinal herniorrhaphy. In case report by Chaudhary et al., they used TFP block for chronic neuropathic post-herniorrhaphy pain because there was a post-surgical scarring at the ilioinguinal and hypogastric nerve injection site. So till now, only 2 pediatric case reports have been done in this block. So thus we conclude that USG guided TFP block provides longer duration of post-operative analgesia as demonstrated by a significant decrease in frequency of rescue analgesic drug uses without causing any significant side effect as compared with caudal block. Thank you, sir.
Did I miss that? How many? What was your patient number of patients that you studied in each group?
30 patients, sir, in each group.
And how was that calculated? Did you?
Since then there is not much study, only case reports are there. So firstly, we did the case series in our institution, and case series was done in 20 patients, and then according to that we calculated this number of patients for this study, sir.
Okay. And the primary objective out of all of this, what
to see the post-operative outcome, how much analgesia is provided.
Duration was your primary objective, and that you used to calculate your sample size of 30 after doing your pilot of 20.
Yes, sir.
Okay.
So, and use of rescue analgesia, how much rescue analgesia in form of intravenous paracetamol.
These were all your objectives, but what primary objective did you base your sample size on?
The post-operative analgesia.
Okay, fine.
Dr. Manisha, how do you justify the longer duration of analgesia with this TFP block as compared to caudal?
Ma'am, TFP block is causes unilateral sensory block, whereas caudal block causes bilateral. And ma'am, it is more localized near to the nerve. And so, ma'am, we are doing with ultrasounded guided procedure. So also precision, according to it, is more. Failure rates are less, ma'am. So we have found that it causes more post-operative analgesia in the pediatric population. Only unilateral
does TFP block cause visceral pain inhibition?
Ma'am, it blocks the L1 dermatome level and also to some extent T12 blockage. So mostly, ma'am, it is for sensory pain relief only, ma'am.
Dr. Manisha, Dr. Koshi,
yes. Yes,
in between, I just had a problem with the net. You just tell me how much was the equipotent doses? What is the volume used in both the things?
Sir, according to the Armitage score, it is lower lumbar surgery. So according to the Armitage score, it is given 0.5 ml of bupivacaine, 0.25% according to the body weight of the pediatric population. And we have taken 2 to 8 years age group. So according to the body weight, 0.25%, 0.5 ml of bupivacaine is given, sir.
My question is the total volumes that you were using in either procedure.
The total volume will depend on the body weight.
What was the variation in that volume? Because in both the volumes required would be different. Therefore, I'm asking you.
Yes, because it will depend on the weight of the child, sir. So that's why there will be a variation, sir, according to the Armitage formula, sir.
So you were able to manage the total dose within the safe limit with the volumes used?
Yes, sir.
Okay.
Okay, thank you, Dr. Manisha.
Thank you, sir.
Next, Dr. Navya.
Yes, sir.
Dr. Manisha. Please stop sharing, please. Manisha, please stop sharing. Dr. Manisha, please stop sharing.
Yes, sir.
Dr. Navya, are we ready?
Yes, sir. Yes, sir.
Okay. please open your PowerPoint and
Yes, sir.
start sharing. Dr. Manisha finishes.
Yes, sir.
Or you can just log out, please. Okay, Dr. Navya, please start.
Yes, sir. Yes, sir. Is it there, sir? Hello?
Yes, it is coming. Yeah, you may
Yes,
start,
sir.
please.
Yes, sir. Good morning, everyone. My topic for today is fiber optic guided tracheal intubation through AMBU or eye in COVID patients. It's a randomized clinical study. Now, airway management is the most challenging task for the anesthesia and critical care providers, especially in this COVID era. AMBU or eye is a new second generation magnetic resonance compatible, phthalate-free disposable supraglottic airway device designed to allow the passage of conventional cuff tracheal tubes in patients of all age groups. COVID-19 pandemic has taken a lot of a toll on numerous anesthetists and healthcare workers. Therefore, safe methods of intubation are extremely required. Fiber optic intubation definitely increases the distance between the person intubating and the patient's airway, therefore can be useful and protective. Hence, I have conducted this study. The primary aim of the study was to analyze intubation characteristics and effectiveness of AMBU or eye as a conduit for facilitating fiber optic guided intubation. Now, in terms of time taken in fiber optic guided intubation, ease of intubation, success rate of intubation, and time taken in removal of devices over the tracheal tube. This study has This study was conducted on 40 patients at RIMS Ranchi, and the time taken for insertion of AMBU or eye was measured from time AMBU or eye was picked up to the appearance of the first capnographic waveform following AMBU or eye insertion. On achieving optimum glottic view, fiber optic guided tracheal intubation was done with preloaded tracheal tube. After successful placement of the tracheal tube, the AMBU or eye was removed using plain tracheal tube, one size smaller, by railroading the AMBU or eye over it. Now, the observations of my study were the time taken for insertion of AMBU or eye. We took a mean of 40 patients, that was around 13.98 plus minus 2.41 seconds. Time taken for fiber optic intubation was 14.15 plus minus 1.37 seconds. And time taken in removal of AMBU or eye was around 11.25 plus minus 1.28 seconds. Now, ease of insertion of AMBU or eye was also noted, and we studied that out of 40 AMBU or eye, while we found it difficult in 2 out of 40 patients, as 2 attempts were taken for insertion of AMBU or eye. Now, the number of attempts of fiber optic intubation was also observed, and 35 out of 40 patients, the fiber optic intubation was done in first attempt. In 4 out of 40 patients, it was done in 2 attempts. And unfortunately, in 1 patient, we had to take 3 attempts for successful fiber optic intubation. Now, the conclusions and recommendations of my study was that the following qualities of AMBU or eye makes it desirable for fiber optic intubation, such as lesser cost as compared to other supraglottic airway devices, its availability in all sizes, suitable for all age groups, sterile, meant for single-use dispensation, as it is cheap and for we can use it for 1 patient, and then so it prevents the carrying of infection. It is MR compatible, and availability of phthalate-free version is also patient-friendly. Lesser chances of contamination to health worker, as fiber optic intubation increases the distance of anesthetist from patient's airway. Although I agree that the time taken for fiber optic intubation is more than what we take for when we use video laryngoscopes or normal laryngoscope, but still it is a safer method for the health worker, for us as anesthetists, as we have to take care of our own safety as well as save our patients. Therefore, I'll suggest that we can go for fiber optic guided intubations through AMBU or I for successfully intubating our patients for general surgeries who are COVID positive, such as we have conducted many laparotomies of COVID positive patients in our institute. Whereas we can also use it in ICU for intubation, as nowadays high flow nasal cannula is being used. So the nasal cannula can still be in while we try oral fiber optic intubation in such patients if intubation is required. Thank you.
Navya, is this a PowerPoint presentation?
Yes, sir, it's a PowerPoint presentation, but I have to present it through my iPhone because the MacBook is not supporting the Zoom.
Unfortunately, we were not able to.
Unfortunately for me, the slides were not moving, Navya.
Sir, can I again show you the slides? Sorry, I'm so
Could you
sorry.
just scroll through the slides? At least
Yes,
let me
sir.
see the presentation.
Sure,
Dr.
sure, sir. Sure, sir.
Just a second, Dr. Jason, are you there? One of our judges,
Yeah,
Dr.
I'm
Jason.
very much there. I was not able to see any of the slides.
Yeah.
So I put it up on the chat.
I just request Dr. Manisha to just within 1 minute, please show the slide to our judges. Please do it.
Yes, sir.
And I request
Is
all.
it now? Can you see it, sir?
Yeah, so this is only one slide that I can see. When you talk
Not there. Same thing is coming.
Sir, I'll show you. I'll show you from my computer only, sir.
No, unfortunately, we do not have that time, Dr. Navya. The judges may ask the questions.
Hello.
Yes, sir.
So
Yes,
Navya,
sir.
what was your sample size in that? We were unable to see your slides.
Yes, sir. The sample size was 40.
Sample size. And how did
40.
you 14, 1-4?
40, sir. Can you see the slides, sir?
Yeah, now it's.
Can you see the slides, sir?
No, not seen, please.
Show the full screen. Navya, please show the full screen. Judges, any question? Sorry, Navya, actually we are supposed to show on the PowerPoint and we are wasting our time. Although judges are trying their best to see your presentation and they can ask any question, otherwise we will move on. Nishant, please take.
Yeah. The judges, please ask her the questions. We are actually running short of time. We are running behind.
We are running sad. We have to move fast, Nishant.
Yeah.
Yes, sir.
Judges, please.
Any question from the judges?
Navya?
Yes, ma'am.
You recommend using fiber optic intubation for ICU patients as well.
Yes,
but don't you think that for preparing for fiber optic intubation through Oregon and all, it takes a lot of time? And in such patients who are in urgent need of intubation, can we wait for so long to prepare everything and use fiber optic?
Yeah. Yes, ma'am, I do agree. I do agree with your point. But since in most of the patients in ICU, we are basically using high flow nasal cannula. So if there's a dire need of intubation, then for sure we should go for video laryngoscope. But if we are just switching the patient from high flow nasal cannula to intubation to the ventilator intubation by observing the ABGs or the ABG results, then since high flow nasal cannula also helps in maintaining good saturation level, we can still use the nasal cannula probe and go for oral fiber optic intubation in such patients. So for those patients, we have used fiber optic. But if the patient is in gasping state, we should not use this. We should immediately go for intubation through video laryngoscope or normal laryngoscope as per the availability, because the utmost interest should be to secure the airway and save the patient's life.
So a generalization cannot be done.
Yes, ma'am.
Okay, thank you, Dr. Navya. Next, Dr. Pallavi. Dr. Pallavi. Start your slides, Dr. Pallavi. Yeah, full screen, please. Pallavi, please start slide share.
Go top. Pallavi, go top. Home, near home, home insert, design.
Yeah, okay. Click there.
Okay, don't waste time, please. Carry on.
Please unmute yourself.
Pallavi, we cannot hear you. Please unmute yourself.
Pallavi, we are not able to hear you.
Yes, sir.
Pallavi, yeah.
Can you please restart, Dr. Pallavi?
Yes, sir. Yes, sir.
Pallavi, can go to the first slide, please. Go to the first slide and start. Don't waste time. Please start.
Good morning. It is pleasure and privilege to be part of this webinar, and I'm going to talk about anesthetic challenges in a case of cerebral palsy. As we all know that cerebral palsy is a non-progressive central motor disorder due to insult of developing brain, which can occur antenatally or perinatally. With the incidence of 1 to 2 per 1,000 live birth, it can present in a number of deformities, which are progressive. Surgery is indicated for correction of these deformities and rehabilitation. The very first benchmark is the defective communication and cognitive skill. So no communication, more pain, more problem. The spastic mouth opening, temporomandibular joint dislocation, all adding to scary airway. The defective cuff reflex, superimposed on gastroesophageal reflux, are all challenging to anesthesiologists. Then the involvement of lung, the stigma of neonatal respiratory distress, lung scarring, repeated aspiration, chest infection, decrease the lung compliance, increased heat loss, less body fat, malnutrition, defective thermoregulation, all complicate the issue. Then the incidence of latex allergy, musculoskeletal flexion deformity leading to defective positioning of patient in operating room and making access to veins and arteries difficult. Multiple drug therapy, altering the pharmacokinetic profile, especially the anti-spasticity and anti-seizure one. Increased blood loss is expected for surgeon cutting on through the contracted spastic muscles. So we face a similar situation in a recent past when a 5-year-old male child presented in orthopedic OPD with history of bilateral congenital talipes equinovarus and was on baclofen for spasticity, valproate for seizure, and ranitidine for GERD. His pre-anesthetic examination was done, had abnormal gait, his heart rate was 110 per minute, his BP was 96/64 mm of Hg, his airway with Malampati grade 1, his chest showed bilateral air entry and trachea was central. All routine investigations were normal. Chest physiotherapy was advised and the patient was kept on nil by mouth. While the morning dose of baclofen, valproate, and ranitidine were given, the patient was nebulized with bronchodilator. The patient was pre-medicated with glycopyrrolate, fentanyl, and ondansetron. As the patient was uncooperative, we decided to go for inhalational induction. The patient was pre-oxygenated with 100% oxygen and suction was done. Induction was done with isoflurane and propofol. An airway secured with supraglottic airway device, IGEL, and surgery started. With a stable intraoperative course, SF for seizure, for which lorazepam was given, there was smooth emergence. For a pain-free post-operative event, patient was kept on multimodal pain therapy comprising of diclofenac and paracetamol infusion. The parents were counseled for chances of hypoxia, hypothermia, hypotension in post-operative period. Maintaining inhalation anesthesia and preserving spontaneous respiration was ideal in this case. Anesthetic challenges in CP can be as diverse and complicated as the presentation of deformities. Poor patient compliance and lack of support system add to these difficulties. Thank you for patient hearing.
So, hello, Palvi. Hello.
Yes, sir. Yes.
So, why did you choose this to be presented here for the award?
Sir, I wanted to emphasize on the complication which we face in operation room while we anesthetize such type of patients, sir.
So, you wanted to highlight the complication you come across while doing the case.
Yes, sir.
So, what were your conclusion that what complication and how it should be treated? What to do for improvement?
Sir, my conclusion was if we use any anesthetic agent in a low dose and if we continue the patient on anti-seizure and anti-spastic medication, we can, and if we take care of the oral suction and secretion, we can prevent the complications, which by taking care of the airway.
Okay, fine.
Dr. Pallavi,
Yes, sir.
your spastic cerebral palsy patient was already on baclofen. So you increased the dose of baclofen or kept it the same or decreased it?
No, sir, I kept the same as it is given in a thrice daily dose. Sir, I prescribe it the morning dose, which was same because, sir, the major concern is for the surgeon. They will they apply for the positioning which on which we want to keep the patient, because for them they cutting when they cut through the muscle which are mainly contracted and not relaxed, sir. There is a mode of blood loss which is major concern even for the anesthetist and even for the surgeon. And surgeon plying with the anesthetist is a very big issue in operating room, sir.
So did in this case, how did you get the relaxation? That's what I wanted to ask, is because there is spasticity, you have already given baclofen. How did you ensure adequate relaxation in this case?
Sir, sir, as a patient was uncooperative, sir, my main aim was to just to sedate the patient, sir, and I gave some propofol infusion, which decreases the tone of the muscle, not to relax, sir, because, sir, even if we give relaxant, and there and because of baclofen, which either compromises the potassium release, so I which interferes with the muscle relaxant dose, sir. So we have to give frequent. So we have to give frequent dosing of the muscle relaxant, which can land the patient or us, we anesthesiologist, that patient will be relaxed for a long duration, even if the surgery gets over, sir. So we prefer for inhalation only, sir.
So therefore, you kept with intravenous with inhalation.
Yes, sir.
To maintain the plane.
Yes, sir.
And the child came out okay in the end, or was there a delayed recovery?
No, sir, it was okay, sir. It was except for Caesar, except for Caesar, sir. Yes. Thanks. Screen sharing, stop. Screen sharing.
Okay. Dr. Pallavi.
Yes, sir.
Next, we'll go to Dr. Sushant. Dr. Sushant, are we ready? Dr. Sushant, yeah.
Yes, sir.
Could you please start sharing? Please start.
Yes, sir.
Dr. Sushant, we are not able to hear you. Please unmute yourself.
Good morning, sir. Sir, I'm audible, sir.
Yes, start, please.
So good morning, everyone. I'm Dr. Sushant Satpriya, sir in anesthesia, AIIMS Patna. My topic for today's presentation is insufflation anesthesia for balloon dilatation of trachea in a child with tracheal stenosis. So coming to the introduction part, the balloon dilatation of the tracheal stenosis in a child is a real challenge for both the anesthesiologist and the ENT surgeon because they will be competing for the airway. The tracheal diameter of the child being already narrow can cause severe hypoxemia preoperatively, and also the oxygenation during the procedure is also challenging. So here we are presenting such a case managed with insufflation anesthesia. So my case was 7-year-old male child presented with to the ENT OPD with exertional stridor. So he was admitted in ICU of our hospital 3 months back with pneumonia and respiratory failure. He was intubated. He was on mechanical ventilation for 8 days. So after coming to the OPD, he underwent diagnostic flexible laryngoscopy under sedation. So which showed a stenosis of less than 3 mm at the level of fourth tracheal ring, which required balloon dilatation. So my anesthetic plan was to keep spontaneous ventilation of the child, preserve and allowing clear surgical site for ENT surgeon for balloon dilatation. Hence, insufflation anesthesia was selected using nasopharyngeal airway. So we medicated the child and induced with the propofol and introduced nasopharyngeal airway. So propofol was induction dose was used 2 milligram per 2 milligram per kg body weight and maintained using 100% oxygen with 6 to 8% sevoflurane with intermittent doses of propofol. So prior to after that scopy was done and we sprayed the local 10% lignocaine local anesthetics to vocal cord, and then we went to go ahead with the procedure. The whole procedure took around 30 minutes. Trachea was dilated to more than 5 millimeter and procedure was uneventful. The after 10 days child was posted for repeat balloon dilatation. Again, insufflation anesthesia was used for dilatation. So coming to the discussion part, maintaining airway in a patient undergoing airway surgery is an absolute challenge for an anesthesiologist. In addition, to facilitate surgery through providing an unobstructed and immobilized operative field is also make it difficult. So in that, our main goal to patient must be provided with the oxygenation, carbon dioxide elimination, adequate anesthesia, rapid return of consciousness, and airway reflexes. So in our case, the child had stenosis at the level of fourth tracheal ring. This made anesthesia for him more challenging by making it difficult to attend surgical airway in case of catastrophe. So we preserved the spontaneous ventilation of the child at the same time, keeping him deep using inhalational anesthesia. So high flow of 100% oxygen through nasopharyngeal airway also took care of his oxygenation. The oxygen saturation never dipped below 97% and end-tidal carbon dioxide remained in the permissible range even after 30 minutes of procedure. So other method we could have used high frequency ventilation or transnasal humidified rapid insufflation ventilatory exchange, that is Thrive, but it was not available at that point of time. So now these days in our department, these procedures are usually done with the help of high frequency nasal cannula. So coming to conclude this Case management, pharyngeal insufflation anesthesia using nasopharyngeal airway with spontaneous ventilation is one of the effective technique for the providing ideal surgical condition in short airway procedures. So these are my references. Thank you, sir.
Dr. Sushant.
Yes, sir.
Dr. Koshiya.
Yes, sir.
My question is, what is the type of anesthesia that you used?
Sir, it was used, GA was used. So we induced the child with propofol after pre-medication. So we gave propofol around 2 milligram per kg body weight. And then we started high flow oxygen while after putting the nasopharyngeal tube inside the nostril. And we gave with the help of Jackson Reach circuit, we gave around 10 liter of oxygen through that nasopharyngeal tube. So oxygenation was maintained with that, and we kept 8%, 6 to 8% of dial concentration of sevoflurane. So depth of anesthesia I was able to achieve with that sevoflurane.
What is the exact definition of insufflation anesthesia?
So insufflation anesthesia, so it was will give the high flow of oxygen with without much effort of the patient's inspiratory effort. So work of breathing is also reduced, and exchange of gases also happen.
Please revisit the definition of insufflation anesthesia. Second part is you were flushing it constantly with 100% oxygen. So what exactly was the method? Would be a balance between both. That is, you were insufflating with oxygen, you maintained with IV anesthesia.
Yes.
And to start with, maybe sevoflurane was added.
Yes,
you cannot tell that this paper that the patient was maintained only on insufflation anesthesia, right?
Yes.
I had a question,
Yes.
Sushant.
Yes, sir.
So you said 10 liters of flow was used with JR circuit and oxygen flow.
Yes.
And you, so with sevoflurane maintenance, you kept those 10 liters flow on?
Yes, sir, because 8 to 10 liter of oxygen was there, because that in Draga's workstation, only that maximum limit was the 10 liters. So I kept 8 to 10 liter of oxygen, sir.
So my concern would be with such a high flow of oxygen, which is not humidified, one, and
Yes.
second, you are giving sevoflurane with a tracheal stenosis. So the amount of sevoflurane that is actually going into the patient's lung and maintaining the depth of anesthesia with that high flow, I would be a little worried about how the patient having awareness or moving and the plane of anesthesia not getting maintained. So if you have a patient who gets light, you may have a problem with the laryngospasm. Even if you're bypassing, fine.
So, sir, yes, sir. We had pre-medicated the child with the dexamethasone priorly. Pre-medication we had given, and we kept because the procedure was short, so we kept the sevoflurane high concentration so that we could achieve depth of anesthesia quite early.
I would actually be worried about giving sevoflurane inhalational. It would be better off to give titrated doses of propofol or a TCI or something like that with a high flow oxygen, so that you don't have environmental pollution. That is one. And what was your backup airway plan? And in case the patient became apneic, and what equipment did you keep ready?
Sir, we kept difficult airway cart ready, and we kept all emergency tracheostomy set was ready in case if any catastrophe happened, we could have managed with emergency airway.
And did they use a rigid bronchoscope, or how did they do a balloon dilatation? Did they use a
So, sir, they did. They used, sir, one bronchoscope, that rigid bronchoscope, and they put that balloon dilatation inside. That it was like a 5 to 7 minute procedure. In that apnea time was the patient was apneic.
So I had two questions. If you are giving insufflation anesthesia with a rigid bronchoscope in the oral cavity, then your upper airway insufflation may not work. You may need to side ventilate using a side ventilating bronchoscope, rigid bronchoscope. You can attach your JR circuit there and continue to oxygenate through that. But at the same time, your depth of anesthesia will need to be maintained with a TIVA and not with an inhalational agent. Otherwise, your surgeon will go to sleep rather than the patient.
Sir, I was giving, sir, intermittent dose of propofol. I was giving when patient feels light. Then I was giving with I was attached the IV propofol was attached with the patient, And sir, that nasopharyngeal airway was inserted inside nostril, so that oxygenation was also going
Sure.
on.
I think judges will have to go to the next candidate now. We are running short of time. We have two more left. Just the last two candidates. Hope we'll finish it off right now. Okay. Thank you, Dr. Sushant.
Thank you, sir.
Please open your slideshow.
Hello, sir. I'm audible?
Yes, you are audible. Could you please start your slide share, please?
Yes, sir. Is it showing? Is it visible, my screen?
Yes, Tapas, continue. Yeah, start.
So, good morning, everyone. Today, I'm going to present on the topic that is anesthetic management for morbid obesity, a case report. Here, she is a 52 years old female patient whose weight was 154 kg, height 1.5 meter, and the BMI was 68.4 kg per meter square. She was diagnosed as a case of fracture right humerus posted for open reduction and internal fixation with plating. She was a known case of hypothyroidism. She was a habitual snorer with frequent interruptions during sleeps, breath during sleeps, with excessive daytime sleepiness suggestive of obstructive sleep apnea. She also had a history of orthopnea, dyspnea on exertion, and palpitation. On the examination, if we see the positive findings, she was a morbidly obese. Her saturation was 88% room air and 95% with oxygen at 5 liters per minute via the face mask. Her mates was 1 to 4. The stock bank questionnaire value was 6. The breath holding time was 15 seconds. In the AR examination, the Mallampati class was 3. The thyromental distance was 5.9 centimeter. Neck was short neck with slight restriction of the movement to the extension, with the neck circumference was 48.5 centimeter. Hence, it was an anticipated difficult intubation. In the investigation part, all the routine investigation was okay, except the serum albumin, which was 2.74 gram per dl. The ECG was showing right bundle branch block with left ventricular hypertrophy. Echo was also showing the left ventricular hypertrophy with ejection fraction 62% and grade 1 diastolic dysfunction. In the X-ray, as you can see, there is obliteration of the bilateral costophrenic angle. The pulmonary function test was okay for this patient. In the AVG, as you can see, the partial pressure of oxygen was decreased, which was 58 millimeter of mercury. The saturation was also decreased, that is 86% approximately, and the lactate was increased, that is 4.5 millimole per liter. So this was classified under ASA class 3. The plan of anesthesia was general anesthesia, and plan to secure the airway was airway flexible fibrillary intubation. Adequate counseling and reassurance was given to the patient, which written informed consent was taken. Incentive spirometry and breathing exercise was given by the chest physician. Adequate fasting along with anti-aspiration prophylaxis and antibiotic prophylaxis was given. All the ASA standard monitors were attached along with the invasive BP monitoring. In the ARA management, the difficult ARA cuts was really 2 IV access was done. The ARA preparation was done with the help of nebulization with the local anesthetist along with blocking the recurrent laryngeal nerve block. During the procedure, continuous flow of oxygen was given via the nasal cannula, and ultimately airway flexible fibrillary intubation was done. During the intubation, it has been seen there is increased amount of fatty tissue around the glottis, along with some sorts of glottic edema was there, as you can see in this picture. Induction was done with the agents according to the ideal body weight in a titrated dose. In the interrupt period was uneventful, and adequate PEEP and intermittent recruitment maneuver was given to this patient. In the post-op period, electric ventilation was given with adequate analgesia, and extubation was done on the first post-operative day, followed by propped up position and continuous positive air pressure with salbutamol nebulization, DVT prophylaxis, and chest physiotherapy. So, all we know that obesity is defined as increasing ideal body weight of more than 10% with respect to age, sex, height, and the body weight. And according to classification, if the BMI is more than 40, then it is called morbid obese, and if it is more than 50, it is called super obese. And it is a multisystem disorder, more specifically involve the respiratory and cardiological system. So if we see the anesthesiologist concerns here, there's altered physiology, altered pharmacokinetics and dynamics with increased morbidity. So we need a meticulous perioperative plan for such kind of patient. Transpose of this patient is very difficult. So we need adequate manpower along with a special movable bed to move the patient. IV access was difficult, but 2 IV access was done. BP cuff was inadequate for this patient. That's why you had to put an arterial line for invasive BP monitoring. Positioning of this patient in a normal OT table is not possible. So we had to join 2 OT tables side to side with proper padding for proper positioning. And it was the anticipated difficult airway, so we put the patient in RAM position, as you can see here. and this is the ultimate position of the patient just before the surgery. Among the other concerns like hypothermia, difficult extubation, delayed recovery, hypoxia, post-operative pain, deep vein thrombosis, and the wound infection. And this is the patient after extubation, where the continuous positive airway pressure was given to the patient, and this is the final day when the patient was discharged. Now, considering the current scenario regarding the COVID-19, according to the American Heart Association, they have said that because of the obesity with increased amount of excessive ectopic fat, there is decreased cardiorespiratory reserve, along with hyperreactivity of the immunological system, lead to dysregulation of the immunological system with increased viral shedding and increased viral load, ultimately the increased severity of COVID-19 infection. According to the article in the British Journal of Anesthesia, they have said that because of the increased amount of adipose tissue, there is increased number of angiotensin converting enzyme 2 receptor, which leads to increased amount of binding of the SARS-CoV-2 virus, leading to increased severity in obese patient. So you can say that extensive preoperative assessment needed for such a patient because of the airway challenges. A meticulous preoperative plans are needed, team effort and systematic approaches are needed, and ultimately tailored to individual patient characteristics. And last but not the least, such patient associated with a major comorbidity. So prevention is always better than cure with respect to the COVID-19 infection. Thank you.
Dr. Tapas, Dr. Koshi here. That
Yes,
was a
sir.
good presentation about managing a morbidly obese patient. I couldn't get the correlation with the COVID-19 which you introduced. Could you
Yes,
just clarify on that part?
Yes, sir. Actually, this is a case of morbid obese patient, and this patient was done before the COVID era. And right now, the situation we have already in a pandemic situation of COVID, and already know that obesity is an epidemic. So I think that in the discussion, I need to have a better relationship between the epidemic and the pandemic disease in this COVID era. That's why I put up in the discussion session, so that we have a better management for an obese patient during the anesthesia.
Dr. Tapas, you
Yes, sir.
did a fiber optic intubation which was awake through the oral route or nasotracheal route, and how did you topicalize this patient?
So it was oral route,
Okay.
and topicalization was done first. We avoided the sedation. First the adequate counseling was done to the patient, and reassurance was given to the patient regarding all the whole procedure. And after that, after adequate counseling and reassurance, he was ready for that. And then we give a glycopyrrolate according to 10 micron per kg body, according to ideal body weight, along with 1 cetron. After that, the air preparation was done with the help of nebulization. It was 4% of lignocaine with 4 to 5 ml of 4% lignocaine was given to this patient for approximately 30 minutes. And along with that, we have blocked the recurrent laryngeal nerve block through the transtracheal route, where we have given again 4% of 4 ml of lignocaine.
Yeah. And did you actually
and one thing, sir, extra, and also, sir, 10% spray was also given in the posterior wall of the pharynx.
Did you consider awake video laryngoscopy or something in your anesthetic plan? That has changed the way we manage. So in this case, if the mouth opening is adequate, an angulated blade or a channeled video laryngoscope would have been superior, don't you think?
Yes, sir, definitely, sir. That was a good option. But this patient, one problem was that the chance of difficult mask ventilation was also a concern for such kind of patient. And if we try to do the difficult mask ventilation for this patient, the chances of gastric insufflation is much more higher compared to the other patient.
And the way you prepare a patient for topicalization with fiber optics, similarly, patients are prepared with for awake video laryngoscoping intubation with topicalization.
Yes,
so
sir.
I say an awake video laryngoscope guided intubation and not fiber optic. That is
actually, sir. Truly speaking, sir, we did not have the video laryngoscope in our operation theater. That's why I did not think about that.
Okay.
Okay, thank you, Dr. Tapas. Can go to our last speaker of the day, Dr. Vamsi. Dr. Vamsi? Dr. Tapas, could you please stop sharing, please?
Yes, sir.
Dr. Vamsi, are you ready with your presentation, sir?
Yes, sir.
Tapas, please.
Yeah. Could you please stop
sharing
sharing?
Please stop sharing, Tapas.
Yes, sir. I'm trying, but I'm not getting the.
Switch off. Log off. Log off. Just log off.
Okay, okay, sir.
Be ready. Open with PPT. Tapas, log off.
Yes, sir.
Okay. We can see your presentation, Dr. Vamsi.
Yes, sir.
You may start, please.
Yes. September being the academic month of the year, September 5th is celebrated as the Teachers' Day, and September 18th being the World Literacy Day. And today, September 13th, it's our first Bihar Jharkhand anesthesia first web conference. Good morning, one and all. This is Dr. Vamsi Upalpati, and I'm going to present about Marfan syndrome with severe left ventricular.
Full screen, please. Slide share.
Yes, good morning, one and all. This is Dr. Vamsi Upalpati. Today I'm going to present about Marfan syndrome with severe left ventricular failure and regional anesthesia, the game changer. And this is my registration number, and I'm a consultant specialist anesthesiologist in Tata Main Hospital, Jamshedpur. Just briefing about the case, is a 37-year-old fruit vendor by occupation coming from a low socioeconomic status who sustained an injury to the right forearm during his day-to-day work and which was neglected for more than 10 days, subsequently leading to abscess or bar necrosis and scheduled for an emergency wound debridement. And this was his picture when we had a quick assessment for him before before coming to the theater. He had very considerably long upper limb segments and long segments, and here we can note a very high arched palate, and he has a crowded teeth. And past and family history, the patient is a known case of Marfan's syndrome since childhood, and is a known case of pulmonary cox. And he did admit that he had incomplete treatment for his pulmonary cox. And prior to the admission to the ER, he had multiple admissions with syncopal attacks, for which he was advised for a higher cardiac setup, for which he subsequently denied. So his sibling and brother and father were known case of Marfan syndrome, and they eventually expired, but the exact root cause for the death was unclear and unknown. We did order for a routine investigations before we scheduled him for an emergency surgery. We sent all the investigations of hemoglobin, total count, serum creatinine, electrolytes, LFT, and serology. But as this was an emergency case, we did proceed with the surgery just with the serology. As this patient is a known case of Marfan syndrome, we did have a doubt about his cardiac complications. So we did an emergency screening echo, which showed that he had a dilated LV, generalized wall hypokinesia, mild AR, severe AR, and his EF ejection fraction was 20% with dilated cardiomyopathy and severe left ventricular failure. With this background, this patient was scheduled for an emergency wound debridement, bar incision and drainage of the abscess. So weighing all the pros and cons and all this thing, we had taken a time for our detailed counseling of the patients. We weighed all the pros and cons, and we had the concerns and goals in this, particularly in this patient specific regarding to pertain to the Marfan syndrome and the mortality and morbidity involved. So we prepared the patient thoroughly. We took a high risk informed consent, and we prepared a theater with all the defibrillator, all the emergency cart, with all the emergency drugs, everything. And the infrastructure, our plan of anesthesia was an ultrasound guided regional anesthesia block with a 5 centimeter stimoplex needle. So as our anesthesia of choice was a regional anesthesia, and the drug we chose for this kind of patient was total volume of 25 ml with 15 ml of 2% xylocaine and 10 ml of 0.5% bupivacaine. And final outcome of the patient, we did the patient under complete regional anesthesia with a supraclavicular ultrasound guided nerve block with a single pocket injection with the total volume being 20 ml. And the patient had perfect hemodynamics. The interrupt, the patient was totally uneventful. His hemodynamics were always stable, and the patient had never any mortality or morbidity. And we could discharge the patient the next day. And we finally further referred the patient for higher management center, as this patient was having severe aortic registration and he needs an aortic wall replacement. Summarizing my case, this is a 32-year-old patient with a known case of congenital Marfan syndrome with a strong positive history, sibling brother and father being having mortality with the same problems. And as there were many other complications involved because of his poor cardiac function and the dilated cardiomyopathy and ejection fraction. So the regional anesthesia would be the ideal anesthesia of choice, because this doesn't alter your hemodynamic parameters or your cardiac status in any possible way. So the mortality and morbidity of the patient is significantly decreased, and the outcome of the patient is better. So with the era of ultrasound and with the era of regional anesthesia, in such kind of situations where you have a compromised cardiac status, any point the ultrasound would be a game changer in considerable decrease in the hospital stay, cost, and the mortality and morbidity of the patient. Thank you.
Dr. Vamsi.
Good morning, madam.
Good morning. What were your anesthetic goals in this case, and how did you do the hemodynamic monitoring?
Yes, madam. Our main goals for in this patient was to maintain the adequate venous return, decrease the systemic vascular resistance, and we didn't want any response in this kind of patient. So this is the whole and sole reason which we avoided a general anesthesia. We wanted to avoid intubation response and other stress response in this kind of patient. So hemodynamic monitoring, we didn't do any hemodynamic monitoring because none of the parameters or we didn't alter any of the parameters, as this was under solely regional anesthesia, and the surgery was a quite short surgery, and there were financial issues also involved in this patient.
How did you decide how much fluid to give to the patient?
Fluid, basically we replaced only the fasting status, madam, and there was not much ongoing loss because this was a small incision and drainage, so there was not major fluid loss. Clinically, the patient didn't have any signs of anemia or didn't have signs of any failure, so we gave only the fasting and whatever, not much of replacing third space or ongoing loss, madam.
Good morning, Dr. Vamsi, Dr. Koshi here.
Good morning, sir.
So irrespective of Marfan's or not, a peripheral ID, normally you would have chosen this anesthesia only, isn't it?
Yes, sir.
Because we are only doing a peripheral surgery. So Marfan's basically did not change our anesthetic plan much. My other question, which I want to ask you is, did you score this patient? What was the score for Marfan syndrome in this case, if you go by the criteria? Out of curiosity, I'm asking.
No, sir, we didn't score, sir.
Okay. A very good presentation, otherwise.
Thank you, sir. Thank you, sir.
Does any other judge want to question or? Okay, thank you, Dr. Vamsi.
Welcome, sir. Thank you.
Dr. Vamsi. This brings us to the end of the first session of the day. Dr. Ashok Kumar Gupta, Young Analyst Award.
Hello, Dr. Nishant. Just I wanted to say something.
Right, sir.
Out of 11, only 10 has presented.
Yes, one person has not, sir.
Malka, she has not presented.
Yeah. She is not present, sir.
So we have time, or whether she is not ready?
She is not here yet.
Oh, it's not here. Okay, fine. Thank you. Thank you.
So out of only one presenter has not presented today, Dr. Malika, and Best of health. So we've just concluded the first session, and all the audience must have realized that the standard of the presentations were very high. We are very satisfied. We are very happy with the enthusiasm of all the contestants, and I'd like to give a special thanks to all our judges who've come early and have so beautifully. I mean, the standard of judging also needs to be commended. Very nice. With this, I hand the stage to Dr. Sharad, who will do the needful.
Good morning, everybody. First of all, I would like to thank my scientific committee coordinator for doing the wonderful job. As well, he was the coordinator of this session also, along with Dr. Moib Ahmed. So thanks to both of them. And I first thanks. Other than that, I would like to thank our esteemed judges. We had 4 judges. Dr. Jason, I request everyone to please mute your mic. I just request everyone to please mute your mic. Please mute your mic. I request everyone to please mute your mic. Please mute your mic. Thank you very much. Our first judge is of the day is Dr. Jason Doctor. Jason Doctor is from Mumbai. He is professor and consultant anesthesiologist at Tata Medical Hospital, Mumbai, and he has total 32 publications in his name, and he has 10 chapters in the book. And he is also the member of the guideline committee, member for drafting AIDA airway guidelines, and he is the treasurer of the AIDA also, and he is the assistant editor of Indian Journal of Anesthesia. So thank you, Dr. Jason, for giving your valuable time so early in the morning. Thank you very much. Society is in debt for you. Thank you very much, sir. And the other judges of the day, Dr. Kosi Varghese, he is consultant at Tata Main Hospital. Thank you, Dr. Kosi Varghese. And the third judge of the day, Dr. Sagufta Nag, is also assistant professor at All India Institute of Medical Science, Patna. Thank you, Dr. Sagufta. And the fourth judge, sorry, my mistake. Associate professor at Patna Medical, All India Institute of Medical Science, Patna. And the fourth judge is Dr. Sanjay Kumar, is the assistant professor at Tata Rajendra Medical College and Hospital, RIMS, Ranchi. So I would like to thank all the judges. Thank you very much for giving your valuable time so early in the morning. And our coordinator will contact you just after this session for the result, because we have to publish in the evening. And I also like to thank our speakers. All the 11, all the 10 participated. They were very happy to participate in this conference. There was so much enthusiasm, and they logged in exactly on the time, followed all the guidelines. Their presentation was of very high standard. I hope judges will have a tough time in giving the marking to all of them, but wish them all the best. So with this, I want to conclude the first session of the day. That was Dr. Ashok Kumar Gupta Young Anesthesiologist Award. And after that, we will have the inaugural ceremony exactly at 10 a.m. So we have 10 minutes in our hand. I want to give this time to our inaugural committee members, Dr. Srividya, Dr. Neelam, and Mr. Anand, and to take over from me and start continuing the program. We will exactly start at 10 a.m., madam. So I hand over to Dr. Srividya and Dr. Neelam to take over the program from here, and then I will join again. Thank you, madam. And one thing I just want, our esteemed our president of ISA National, Dr. Muralidhar Joshi sir, has joined. Dr. Chakra Rao sir, our past president and president Indian Resuscitation Council, has joined us. Dr. Venkatgiri sir has joined us, and I'm just waiting for Dr. K. Venkatgiri, Naveen Malhotra sir to join. Yeah, I hope he will also join in a minute. We have 10 minutes in our hand. But again, I request everyone to please mute your mic. Please mute your mic, switch off your camera unless until you are not asked by the coordinator. And please switch off your, keep your mobile on the vibrator or the silent mode. Please maintain the decorum. We are going live on the YouTube and the Facebook. So I request, personal request from me to all of you, all the members who are sitting on the Zoom, please maintain the decorum. And because we are going live on the YouTube and the Facebook, just a personal request, please keep your things in place. So I will welcome Dr. Srividya and Dr. Neelam to take over from me for the inaugural ceremony. Thank you very much, madam. Welcome, madam.
Thank you, Sharad.
Thank you, Sharad.
And good morning, everybody. Since we will be starting the inaugural ceremony in about 5 minutes from now, it is 9:48, so about 10 minutes, 12 minutes from now. I would like to request just the dignitaries to keep their videos on. The people who are a part of the inaugural ceremony. Can I read out the names whose videos need to be on? Dr. Ashok Jadon, sir.
Dr. Srividya, sorry to interrupt you. This is my mistake. Just a minute, madam. Dr. Ashok Kumar Gupta, sir, जिनके नाम पे ये award है, he is with us here. I can see Dr. Ashok Kumar Gupta, sir. Can I request Dr. Ashok Kumar Gupta, sir, be online? Dr. Ashok Kumar Gupta, sir, just wait a minute. Dr. Ashok Kumar Gupta, sir, please unmute yourself. This award is in your name, so I would like to hear something. We all want to hear something from you because this is a very prestigious award. I request Dr. Ashok Kumar Gupta to say a few words.
Thank you, Sharad. I am thankful to all the organizing committee and all the 4 judges and coordinators. They have conducted the session very well. The participants are from every part of Bihar and Jharkhand, and all of them have very nicely presented their papers. This is very, very good. Thank you.
Thank you very much, sir. Thank you. We need your blessings to make this program a grand success. Thank you very much, sir. So we move to Srividya and Dr. Neelam.
So good morning. I can see Dr. Venkatagiri has joined and Dr. Chakra Rao, Dr. Manoj Kumar.
Dr. Srividya and Dr. Neelam, please.
Sharad has Dr. Naveen Malhotra joined. I'm not able to see him on my screen. Dr.
Sir
BK
has not
Prasad
joined.
has
I'm
also
watching.
joined. Yes.
I'm calling Dr. Naveen Malhotra, sir. He will join in a minute.
And
Till then we can work on
also Dr. Murlidhar Joshi. I can't see him on my screen.
Dr. Murlidhar Joshi is there, Srividya. Sir has joined.
Only I'm waiting for Dr. Naveen Malhotra, sir. And our president is here. Our organizing chairman, Ashok Jadon. Dr. Rajiv Shukla, our organizing co-chairman, is there. I can see. Only I am waiting for the Dr. Naveen Malhotra, our secretary.
Rajiv sir, please switch on your video.
Dr. Rajiv Shukla, sir, please come.
Sharad, who is Galaxy A? Sharad, who is Galaxy A50? Naveen sir का तो नहीं है.
I don't think so. Naveen sir का होगा. Give you this. I request Nishan to give him a message. Madam.
Yeah, Sharad, tell me.
Sir, आपका वो वीडियो सर वीडियो देखना चाहते हैं सर प्लीज.
Okay, I'll change that. I'm just showing the video.
This is the inauguration ceremony.
Done. एक minute.
So I'm just.
Malhotra has not joined, I think.
I'm calling him. I'm calling him. Okay, just.
Yeah, I'll just change. Okay. Yeah, Sharad, I'll just change. Okay. Sharad. Sharad.
Sir, you have another.
Madam, आप जरा एक बार राजीव सर को गाइड कीजिए. हम फोन कर रहे हैं अभी.
Yeah.
8 minutes, sir.
Yeah, Vidya.
Yeah, we can see you if you want.
Yeah, I'll change it. I'll change and come. Yeah.
Yes, sir. In 8 minutes.
Okay,
time.
right.
Sir, quickly.
Okay.
Yes, Dr. Our governing council member, Dr. Manoj, to say a few words because he is the coordinator between the.
Sharad, just a minute. Let me ask all the dignitaries to switch on their videos once we set up, and then we can start. Just a second, Sharad, please. Just a second. Umesh Badani, sir, can you switch on your video, please? Yeah. Good morning, Dr. Murlidhar Joshi is already on video. Dr. Badani, can you please switch on your video? Neelam, can you call Dr. Badani sir and ask him a little bit to
Yes,
speak
yes.
up? Yeah.
I just called Dr. Navil Malhotra sir. He's joining. Anand, are you there?
Yes, sir.
Anand?
Yes, sir.
Okay, okay. Keep a watch on everything.
Yes.
We are going. We have only 5 minutes for the inauguration.
Yes, sir. We are live, sir.
We are live. We are live. We are live on the YouTube and the Facebook. So I have sent the link to all of you. I request everyone to please pass your local groups. You can watch this program live on the YouTube and the Facebook.
Dr. Mullidhar Joshi sir, please keep your video on. We are only having the videos for the dignitaries, and everybody else we are asking them to switch off. Thank you, sir.
Badani, please switch on your video.
Dr. Bhadani is doing so, Srividya.
Yeah, thank you, Neelam.
Request everyone to mute their mobiles, please.
So we are just waiting for Dr. Naveen Malhotra and Dr. Rajiv Shukla to join us, and then we can start proceedings another 5 minutes.
Yes.
So during the meantime, I would like to use this time to the coordinator, Dr. Manoj Kumar, who is the link between the state and the national, to say a few words. This is not the program; this is just the unofficial thing.
It is my great pleasure. In inaugural function, we have our chief guest, Murlidhar Joshi, sir. So it is our great pleasure. And our mentor, Dr. Chakra Rao, with us in this inaugural function. It is very good for us. So Chakra Rao is a dynamic person, and he is line of the ISA. You know, I say whole, and he is my mentor also. So, and we are great pleasure. Our president elect, Dr. Venkat Giri sir, is my friend, my very dynamic person. He will the president in next year. So I welcome all of you. And meantime, Dr. Naveen Ultra will join shortly around 10 a.m. So Bihar Jharkhand Society of Anesthesiology had two great persons, Dr. B.K. Prasad sir, our president, I say Bihar Jharkhand Society of Anesthesiology, and Dr. Sarad, you are you have very great potential, and you have great leadership. So this is because of our teamwork, the first virtual conference of the ISA Bihar Jharkhand Society of Anesthesiology. So I am very happy. So we are working together and do our best in this conference. So my best wishes, Dr. Sarad, my best wishes.
Thank you, sir. Thank you, sir. I just request also personal request. I am also calling Dr. Naveen Malhotra, sir. Can you call? This personal request?
Okay.
Please try.
Okay.
So we are just short of time. 2 minutes. Dr. Shivita, please allow us 2 minutes to call Dr. Naveen Malhotra. We are waiting for it. And Dr. Rajiv Shukla sir has joined.
शरद नवीन सर से बात हुई, वो लॉगिन कर रहे हैं.
Okay, very nice. That's perfect. That's perfect.
Charun sir, please switch on your video.
Just a personal, polite request. Just a polite request. Srividya will take the name whose camera will be on. I request all the delegates and the dignitaries, please follow her request Just we are having 2 minutes for the inauguration, and she will give the command for everyone to follow. I request everyone, please follow Neelam and she with that order. Thank you very much.
डॉक्टर वेंकट गिरी सर का स्विच ऑन हो गया है वीडियो?
हाँ हो गया मनोज.
Yeah.
I can see.
Doctor. Yeah, he is there.
Okay, sir. Nice to see you.
Sharad, now you also need to come on.
डॉक्टर नवीन मल्होत्रा सर लॉग इन कर रहे हैं, कर लिए, मैंने उनको एडमिट कर लिया.
Very nice. So it's
Good morning, Naveen sir.
Good morning.
Our dynamic state, our dynamic national secretary, Dr. Naveen sir. Welcome in the Bihar and Jharkhand Society of Anesthesiology platform. Sir.
Thank you, Dr. Manoj. Good morning, President sir. Good morning, sir.
Good morning, Naveen sir.
Good morning, sir. Good morning.
Good morning, Dr. Naveen.
Good morning, sir. Good morning.
Good morning, sir. Good morning.
Good morning, everyone.
Morning, sir.
Chakra here.
Sharad, are you on?
Good morning, Chakra. Good morning,
yes, madam. I am on.
Can't see you.
I am on, madam. I am here, madam. I can see you. I am here, madam. You can see me. Neelam, Dr. Shividya, I am online. You can see me.
Please switch on your video.
My video is on, madam.
Yeah, I can see you now. I can see you now.
Rajiv sir, it's almost 10. I request
Rajiv sir,
everyone.
please
Dr.
come on
Shividya.
and we'll start now.
Yeah,
Sharad,
it's already 10. Just call.
Yes, sir, please. Yeah, Rajiv sir is coming on. Yeah.
Yeah, let's start, Dr. Shividya. It's already exactly 10 a.m.
Good morning, ladies and gentlemen. It is my proud privilege to welcome you to the first ISA Bihar Jharkhand WEBCON 2020. And this inaugural ceremony is unique in its way that today we are meeting virtually, where every year we would be meeting face to face. So before we begin, I would like to request all the dignitaries to please keep their videos on, but their microphones on mute mode. And also all the participants on Zoom to please mute their microphones and also their videos. Please switch on your microphones when you're speaking only. The year 2020 indeed has been very unprecedented and eventful this year for the entire world and also for the medical fraternity particularly. I would like to take this opportunity to begin with a prayer to the Almighty that He may bless us all, and let today be the beginning of a new normal, a one with healing and one on a path to recovery. Today, our chief guest is the ISA National President, Dr. Muralidhar Joshi, and we have our co-chair, Dr. Naveen Malhotra, ISA National Secretary. I welcome all of you, sir. It is also my privilege now to welcome my co-host for the inaugural ceremony, Dr. Neelam Sinha, who is ISA Bihar Jharkhand Treasurer. With this, I would now like to call upon Dr. Ashok Jadon, Organizing Chairperson of ISA Bihar Jharkhand 2020, to deliver his welcome address.
Good morning, everyone. On this great occasion of ISA Bihar Jharkhand first conclave, that is virtual conclave, I, Dr. Ashok Jadon, the President for this committee, organizing committee, welcome you all. I welcome our National President, Dr. Muralidhar Joshi, and National Secretary, Dr. Naveen Malhotra. I take this opportunity to thank President-elect National Dr. K. Venkatgiri, our past president, very dynamic, we all know, Lion of the ISA, Dr. Chakra Rao, I welcome our state president, Dr. B.K. Prasad, and our GC member, my dear friend, Dr. Manoj Kumar. I welcome all the delegates, speakers, committee members, PG students, and the sponsorer. And I hope this will be a great milestone on the path of success in the Bihar Jharkhand Anesthesia Society. So I welcome you all and hope this will be a grand success. Thank you once again.
Thank you, sir.
Thank you, sir. Now I request our President, Bihar Jharkhand Society of Anesthesiology, Dr. B.K. Prasad, sir, to address this August gathering.
Sure. Sir, I, Dr. B.K. Prasad, President, ISA Bihar Jharkhand, consider myself fortunate to welcome you for the first online academic fest ISA Bihar Jharkhand webinar 2020. I welcome our National President, Dr. Muralidhar Joshi, and our National Secretary, Dr. Nabeel Malhotra, and other national dignitaries like Dr. Venkat Giri, our President-elect, Dr. S.S. Chakra Rao, the past President, and Dr. Manoj, our Council member. I welcome all the eminent guest speakers, Dr. Shiv Kumar Singh from Liverpool, Dr. Anjan Tirkha from AIMS, Dr. J.B. Divishia from TMH, Dr. Anil Patel, Dr. Vala Venkat, Dr. Saikat Sen Gupta, Dr. P.K. Singh, and others, so many senior members of the society. I welcome all the delegates, speakers, all committee members, PGA students, and sponsors for their enthusiasm, and I hope this will pave the way for the future events of the conferences. I thank all the judges, members of the organizing committee, scientific committee, and others who has worked day and night to make this event a great success. Wishing you a happy learning, long life ISA. Thank you very much, and namaskar.
Thank you, sir. Thank you, sir, for your very kind words. We will now inaugurate the WEBCON ISA Bihar Jharkhand 2020 WEBCON by e-lighting the ceremonial lamp. May I request our chief guest, Dr. Muralidhar Joshi, President ISA National, to please press the enter button on his laptop. May I also request all the other dignitaries on the dais to also press the enter button on their laptop.
Madam, please unmute you.
Please unmute.
I now request Dr. Sharad Kumar, Secretary ISA Bihar Jharkhand, to record his secretary's report.
Thank you, Dr. Srividya. Thank you very much. On the occasion of our first WEBCON, Bihar and Jharkhand, ISA BJ WEBCON 2020, I welcome our chief guest, Dr. Muralidhar Joshi, President ISA National, I welcome Dr. Naveen Malhotra, Secretary ISA National, on this grand occasion. I welcome President-elect Dr. K. Venkat Girish and Dr. SSC Chakra Rao, our past President ISA National. I also take opportunity to welcome all the dignitaries on the dais and off the dais. I'm very thankful to our state president, Dr. B.K. Prasad, and our national GC member, Dr. Manoj Kumar, for their constant support, guidance, and words of encouragement. I welcome both of them on this. You know, at this pandemic, in spite of having so many problems, we started to that we will do a 2-hour webinar, but somehow it went to become a full day conference. And I received huge support from all the members of our society. Each and everyone helped me in this journey. And I also received from the support from the national headquarters. In this pandemic, we received a huge amount of money, that was around 2 lakh rupees from the ISA National, which we distributed to our city branches and state also distributed it. This money, our city branch purchased the PPE and the mask, which was distributed to the anesthesiologist and the other concerned persons. Many of the city branch honored the Corona Warrior by the Appreciation Award, which was started by our ISA National, and our city honored them with that Warrior certificate. In the month of January, the Patna City branch organized a PG assembly where more than 100 students from all over India participated. For a huge success. Many faculty from our state simply participated in the East Zone Web Conference and the ISA. And we got opportunity from the national where our state faculty participated. And during this meantime, we also had the opportunity to develop our website, dynamic website, which will be released later on in this program. And during this last 6 months, almost 75 members from the Bihar and Jharkhand joined the ISA fraternity and they became a member. Once again, I welcome all the delegates, speaker, panelists, chairpersons, all the members of the society, advisory committee, scientific committee, executive committee, our PG students, with great enthusiasm in participating and presenting their paper. Almost we had 83 scientific paper, competitive papers. I also would like to thank the pharma company. And with this, I would like to say thanks to all the members present over here. Jai Hind, Jai ISA. Thank you very much.
Thank you, Dr. Sharath. Moving ahead, now I request our special invitee, Dr. Chakra Rao, who is past president of ISA National and presently the chairman of Indian Resuscitation Council, for your words of encouragement, sir.
Thank you very much, President B.K. Prasad and my friends. I'm very happy to participate in this inaugural function. Actually, Bihar and Jharkhand, they are conducting regularly the state conferences. And this year I felt they are more active and probably Manoj has activated everybody. And I acknowledge the presence of Dr. Rajiv Gupta and all the Rajesh Shukla and all the other friends. My Ashok Kumar is also there. Thank you very much for inviting me. Thank you, Sharath Kumar. Thank you.
Thank you, sir. May I now request ISA Governing Council member from his zone, Dr. Manoj Kumar, to share his views with us. Dr. Manoj, please unmute yourself.
Respected Chief Guest Dr. Muralidhar Joshi, sir, President ISA National, our guest of Naveen Malhotra, sir, Secretary ISA National, our special guest Dr. SSC Chakra Rao, sir, Chairman ISA Indian Resuscitation Council and past President of ISA National, Dr. BK Prasad, sir, President Bihar Jharkhand Society of Anesthesiologists, respected dignitary on the dais and off the dais, distinguished invitee, past President and Secretary of the ISA Bihar Jharkhand Society of Anesthesiology, Governing Council, member of the Bihar Jharkhand Society of Anesthesiology, delegate faculty, guest speaker, representative from industry, ladies and gentlemen. I warmly welcome all of you at the first wave conference of the ISA Bihar Jharkhand WEBCON 2020. I feel heartfelt pleasure that Bihar Jharkhand Society of Anesthesiologists is organizing a state conference in virtual platform during this pandemic situation. Definitely, it will enlighten the recent advantage in the anesthesiology, critical care, pain and palliative management, particularly among the young anesthesiology. Finally, I thank the organizing secretary, Dr. Sarath Kumar, who always appears with a smiling face. Thank you, boss. Organizing committee, whose entirely effort made this ISA Bihar Jharkhand WEBCON 2020 a grand success. I wish all good luck. Long live ISA. Long live ISA. Thank you.
Thank you, Dr. Manoj, for your kind words. Now I'll request our past General Council member and Secretary ISA National and President-elect Dr. K. Venkatagiri KM to give his words of blessings.
Good morning, President Dr. BK Prasad, National President Dr. Joshi, National Secretary Naveen, Bihar Sharad, my colleague, friend Manoj, and Partner Chakra Rao, organizing chairman, organizing secretary, and all friends from Bihar, Jharkhand, and friends. Good morning to you all. Happy that I think Bihar, Jharkhand is the first state to start online conference this year. And though other states had their conferences started from April, now the Bihar is the one which is having the first state web conference. And Manoj and Sharad called me many times and asked me to be present here. And even last week, I was there during your PG program also, going well. And activities are also going well. So these webinars have become the new norms, and our PGs and practical NS are getting, because I myself feel that I attend more these webinars, because when I go for the actual physical conference, we talk with our friends, go here and there, and I think it was very minimum CMEs I have attended, but now I attend more CMEs because at a free time, 1 or 2 lecture attending also good, that it improves our knowledge. Otherwise, this maybe this 20 years of IS activities, myself attending CMEs were very, very few. Maybe Chakra also, myself and we are sitting out talking, and but now we are accustomed to this and improve knowledge. And wish you all the best. And this will be the initiation for everybody all over India, and help all the members. In between, I had to move switch off because my son was going for the entrance NEET, so I had to. That's why I had to switch off my video, went and set him off. I did not accompany, sent with driver and came back. Thank you all.
Thank you, sir. Despite your very busy schedule, thank you for being with us today morning. Our guest of honor today is Dr. Naveen Malhotra, Secretary ISA National. May I call upon him to share his thoughts with us on this occasion.
Good morning, dear ISANs, ISA, Bihar and Jharkhand Society of Anesthesiologists members. I'm really very happy today. Yes, I echo the previous speaker's comment. Bihar has become the first state in India out of all the branches of ISA to hold a first virtual conference. So lots of congratulations to all of you. And definitely this will be followed by the other branches across the country. Respected Dr. Muralidhar Joshi, President ISA National, Dr. Venkat Giri, President-elect, Dr. Bala Bhaskar, Chairman Academic Committee, Dr. S.C. Chakra Rao, past President ISA National and Chairperson IRC, Dr. Ajit Kumar, Patron-in-Chief, Dr. Ashok Kumar Gupta, Patron, my dear Dr. Manoj Kumar, my colleague in the Governing Council, Dr. B.K. Prasad, President, Bihar and Jharkhand Society of Anesthesiologists, Dr. Sharad Kumar, Secretary, Dr. Ashok Jadon, Organizing Chairperson, Dr. Rajesh Shukla, Organizing Co-Chairperson, Dr. Sinha, Treasurer, and other dignitaries, Dr. Umesh Kumar Badani, Chairman, Scientific Committee. And I also pay my regard and gratitude to Dr. S.P. Singh and Dr. G.K. Sinha, past President ISA National, Dr. Vijay Kumar Gupta, past Vice President ISA National, and Dr. P.K. Singh, who is now also in AIIMS Patna, the past GC member of ISA National. I'm really very happy that the Bihar and Jharkhand team has worked enthusiastically to conduct this conference, and that shows in the numerous communications I have been receiving regarding minute-to-minute details and minute-to-minute programming. And I must share here with you that the ISA National is offering a virtual platform to all the state branches to conduct the virtual conferences. As desired by our president and approved by the Governing Council, this platform will be available to all the state branches to conduct their CMEs or the state conferences, and these will be partly sponsored and funded by ISA National. We want to promote academics and clinics under the banner of ISA National, and the show must go on. At the same time, I must say that anesthesiologists are leading from front in this COVID pandemic. 60 to 70% of the anesthesiologists who are working in COVID ICUs, HDUs are anesthesiologists. So we should keep on working with the same sincerity and keep on doing hard work, but at the same time keep us and ourselves protected also. We are important for patient care, but we are also important for our family members and friends and children. Soon ISA National will start the online PG classes, because this is the now new normal. We had already decided that we want to ensure a uniform PG and UG curriculum across the country in anesthesia under the banner of ISA. And for that, we shall be soon having online classes for postgraduates. Anybody can attend from their laptops or mobile phones and learn from the eminent examiners and teachers of the country. We will be soon having ISA sponsored PG assembly also in near future. The president and the Governing Council always is keeping and pushing that academics and clinics should continue. Keeping in the mind the health of our members, ISA has endorsed the COVID health insurance policy, and we are soon launching COVID unfortunate event, maybe nobody should utilize it, COVID death care policy for our ISA members through ICICI Lombard with Cover You as intermediary. And all other programs of ISA National are going in full steam, whether it is Indian Journal of Anesthesia. Recently, we had launched the supplements, the zonal supplements, the supplement of IJA, FBF, IRC. We recently had guidelines by the IRC, and new guidelines are also being made. FBF, PPF, UISA. Last weekend, we had a national conference of UISA. Activities of the PG classes will be increased under the ISA HOD club, the cultural club, art and literary club. They are all going full steam. The innovation cell, social outreach program, they're also going good. And our coordinators for the sports club are also thinking about having a virtual sports event. So we are trying to keep the ISA flag high in this pandemic. We are also interacting with the government authorities, the authorities which matter, whether they're the politicians, bureaucrats, or the press and electronic media, to ensure that the work done by anesthesiologists across the country in this COVID pandemic is highlighted, not only nationally, but also internationally. Once again, I congratulate the Bihar Jharkhand Society of Anesthesiologists for organizing this WEBCON 2020. I am very sure that the delegates will have a very good time interacting with the speakers and the eminent faculty. Heartiest congratulations. Long live ISA. Jai ISCN. Jai Hind. Thank you.
Thank you, sir, for your very kind words. Dr. Muralidhar Joshi, President ISA National, has kindly graced the occasion today as chief guest for this WEBCON 2020. Can I now request him to enlighten us with his valuable words?
Greetings of the day to everyone, all Bihar Jharkhand members and respected Chairman Economic Committee, Dr. Balabhaskar, President-elect Dr. Venkat Giri, Vice President Dr. Suresh Bhargava, Honorary Secretary Dr. Naveen Malhotra, Honorary Treasurer Dr. Virendra Sharma. Of course, many of them may not be here, but they are there everywhere for us because their background office runs and somebody is working elsewhere. Of course, our Editor-in-Chief Dr. Lalit Medaratha, Bihar Jharkhand President Dr. Braj Kishore Prasad sir, and the Organizing Chairperson Dr. Ashok Jadan, and my friend, of course, the Organizing Secretary Dr. Sharad, and Dr. Umesh Badani, Scientific Committee Chairman, Sri Vidyaji, and of course, Nilima Sinha, the Treasurer of the Bihar Society. And of course, not to forget the past presidents, who's already here, Dr. Chakra Rao, and of course, past president from Bihar, Dr. G.K. Sinha, and others, Vice President from Bihar Jharkhand, Dr. Vijay Kumar Gupta, because without taking their names, the show will not be complete. And all the speakers, panelists, and delegates who are attending this event, once again, greetings of the day and good morning to everyone. At the outset, I would like to congratulate, like everybody, the Bihar Jharkhand doing the first Web State conference kind of thing for the first time in India, and congratulations for you. And let me remind everyone, when we got independence in 1947, the two states at the top for education and minerals and professionalism, that was Bihar and West Bengal. There was no Jharkhand at that time. So let me say, again, you echoed the same thing. I congratulate you for that one, for reminding everyone, yes, there were some difficulties here and there. Maybe the commitment from different sectors were not there. But I think you have overgrown all those things and stepped in, and that's the way to go about it. ISA National has been trying to do its best, what best it can do, and all those things. In the testing time, nobody expected pandemic, not that we wanted to continue. But even in this tough period also, the ISA has bounced back. It's shown its organizing capacity as such. And definitely water funds were released from ISA as a grant in aid for almost all state and city branches. They utilize it efficiently. And in fact, so many societies are feeling jealous or shy, like jealous of our society. Like when ISA can do all these things, what's wrong with our society? So they are asked, question here is, you set the benchmark. People should look at you, look up to you. And with the COVID-19 statement, we are being invited, the ISA is being invited to the government authority discussion about finalizing out what kind of ventilator they want to procure, what kind of PPE or academic. A new wave is happening in ISA. A new wave is happening, and I think every challenge comes a new opportunity. I think this particular challenge definitely got new opportunity for ISA. I think almost all ISA city state branches, they are becoming opinion leaders in their own state, and of course, so is ISA national. That's a good news. And as our honorary secretary and our president-elect, they expressed about the activities and all, we should respect the amount of IJ activity that is going on, even though it is tough at this time, but still editorial team, the chief editor is working hard to bring out journals for all the 5 zones. We have no North Central, now he's coming for East. He's looking at probably the West and also South. So question is, the ISS spirit has not lost and all those things. And this, of course, we had USOCon, which was a trendsetter kind of thing. And soon we're going to have our own registered office at Chennai, which is going permanent. Right now we're having it, thanks to Balakrishnan sir, we're having it as home. We're going to have it soon at Chennai. Already the place has been identified. We paid the part payment, just we have to acquire the property. But one thing I would like to say, one important thing is everybody comes to innovative ideas. And in this context, I think Dr. Chakra sir is here. The Indian Registration Council, it's making a quiet mark like an elephant, like India, like, it's making its IRC activities are being acknowledged globally. And a lot of people working. Of course, probably we are not able to do IRC workshop at this pandemic time because of the COVID infection transmission and all. But it's going to be way forward because we have to reach, that's advocacy. We have to reach the common man, what anesthesiologists are doing. A lot of our own colleagues are writing articles here and there, newspapers or discussions. They are being invited at different places. So it's a good thing. It's good. But one thing is, We should not stop the journey here. We have to move forward. And if e-learning is the way of thing, and if that's the way we have to make the PGs learn about it, and if that's the way everything is running, even judiciary is giving the e-judgment now. If judiciary is doing e-judgment, your children are appearing for e-exams, I think soon our only fear as national body is we might lose attendance in our national regular physical conference, which is very important, we might lose attendance. So that is our fear. But well, that also has to be the part of life. But what I think is every challenge comes the opportunity. Let's not lose our heart. Pandemic might stay for some more time. You never mind about that one. ISA Governing Council is always with you and always willing to serve you. We've taken the vote to serve you. So with these few words, again, once again, all the best for all of you. Have a fantastic academic event. Long live ISA. Jai Hind. Namaste.
Thank you so much, sir, for your kind words. Now, one of the most long-awaited event for the Bihar-Jharkhand Society of Anesthesiology. Respected sirs, Bihar-Jharkhand Society of Anesthesiology is going to launch its first dynamic website today on this day of our first virtual WEBCON, and would request our dignitaries, Dr. Murlidhar Joshi, our Chief Guest and President ISA National, Dr. Naveen Malhotra, Secretary ISA National, Dr. BK Prasad, President Bihar Jharkhand Society of Anesthesiology, Dr. Manoj Kumar, GC member ISA National, to do the honors by taking the cursor on the website logo and officially inaugurate our website. Sirs, please unmute your mic and say.
Yeah, I think you have taken one more step ahead with the website and all those things. I think you're going more and more e-mode. And the only thing is, I hope this distance will not increase between the members. We need to meet, personally greet. And see, that is the way to go. But that's what India is. So question here is, Vasudhaiva Kutumbam is what we have to say. Let's not become a virtual family in our own family. Already families are on phones and all those things. But I think website is a very good idea. I think it is going to open up a new this thing. And I think a lot of youngsters I can see in Bihar, Jharkhand. We wish you all the best. Good luck once again to Bihar, Jharkhand team. All the best.
Good luck.
We are happy to inaugurate Bihar Jharkhand Society of Anesthesiology website. Thank you, madam.
Heartiest congratulations.
The few glimpses of our website. The president message. This is the past president and the members who represented national from our state. So the city branch. Go to the city branch activities. Branch activities. This program is simultaneously running on the YouTube and the Facebook. Anand, please show the city branch activities. Yes, this is the Corona Warrior Appreciation Certificate distribution, which was initiated by our national. And this is the PG assembly, where more than 100 students participated. It was success. Thank you, Anand. And please show the YouTube live streaming on the website. We are running on the YouTube also, side by side, as well as on Facebook also. Thank you, Anand. Thank you very much. We will move on. Thank you very much, sir. Hand over to Shivitya.
Thank you very much, all our dignitaries, for officially inaugurating our dynamic website of Bihar Jharkhand Society of Anesthesiologists. Now I would request our organizing co-chairman, Dr. Rajiv Shukla, to give vote of thanks.
Thank you. Good morning from Jamshedpur to everybody. It is my proud privilege to propose the vote of thanks. At the start, I would like to thank our national president, Dr. Murlidhar Joshi, and the National ISA Secretary, Dr. Naveen Malhotra, for their valuable participation. We are indeed honored to have you with us on this momentous occasion. Thank you, sir. I also take this opportunity to thank our President-elect, National Dr. K. Venkatgiri. Thank you, sir. Our past President, Dr. SSC Chakrarao, sir. Thank you so much for joining us. It has indeed made us proud. I thank our State President, Dr. B.K. Prasad, and our General Council member, Dr. Manoj Kumar. I thank all the delegates, the speakers, the postgraduate students, all the committee members, and the sponsors for making this conference a vibrant success. When we started this journey, like Dr. Sharad said, we never imagined that this could be such a big affair. We had thought initially that it's going to be only about an hour or two, maybe 3 hours. And I thank Dr. Sharad, Dr. Jadon, Dr. Neelam, Dr. Vidya, and Dr. Everybody who was involved here, Dr. Badani, Dr. Nishant, for making this an grand success. I'm sure there's going to be a lot of exchange of valuable information, learnings, teachings, experience, and all of us will come back and look forward to such more conferences in the future. Thank you all so much for joining us and making this a success. Thank you very much.
Thank you very much, sir, Dr. Rajiv Shukla. We now come to the end of this inaugural session. May I request all the dignitaries and the delegates to switch off their videos, please. And also mute their audios.
Everyone, please switch off your video.
Dr. Sukesh, please switch off your video.
Dr. Sukesh, switch off your video.
We will now rise for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा चल जलधि तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, Dr. Neelam. Thank you all the dignitaries for joining in on today morning's inaugural session. I now hand over to the coordinator of the next scientific session, Dr. Sukesh Kumar, to take the proceedings forward. Thank you all. Long live ISA.
Thank you, ma'am, for taking us through our grand inaugural function. And now handing over the baton.
सुकेश, जैसे सेकंड तुम्हारा माइक इको कर रहा है, मोबाइल बंद करो या कुछ हो रहा है, अदर इलेक्ट्रॉनिक डिवाइस बगल में होगा, correct it, please correct it.
Now it's all right, sir?
Yeah, it's still okay.
Sir, you have connected with other device also. Please mute that also.
Us
If
through
you have
our
extra
grand
device.
inaugural function. And now handing the baton of ISA Bihar Jharkhand to run the academic session. Myself, Dr. Sukesh Kumar, welcome you all on the behalf of whole organizing committee of ISA Bihar Jharkhand first WEBCON. Now we will cruise through the academic session. Here we will start the guest lectures. And our chairpersons for the first lecture are Dr. Vijay Kumar Gupta, and he was ex-vice president of ISA National. He has held the post of Principal and Head of the Anesthesiology and Critical Care, Patna Medical College, Patna. He has just retired from the post of Principal, Nalanda Medical College, Patna. And currently he is working as a professor, post-retirement, Professor of Anesthesiology at Patna Medical College, Patna. Our next chairperson of this first lecture is Dr. Sasikant. He was our ex-president ISA Bihar Jharkhand and ex-head of the Anesthesiology and Critical Care TMH Jamshedpur. I welcome both of the chairpersons and I will request Dr. Nidhi ma'am to display the CV of the first speaker. Dr. Deepak Govil sir.
Hello. Hello.
Dr. Vijay Kumar Gupta sir, please
Can you
introduce
hear
our
me?
speaker.
Can you hear me? Can you hear me?
Yes, sir. Yes, sir. We can hear you. Go ahead, sir.
Good morning, friends. It was a brilliant effort by Bihar and Jharkhand chapter of IESA. Looks like our dreams coming true. I appreciate the efforts of Dr. Sharad and his full team for organizing brilliant academic program in this difficult time. Well, subject is very interesting, infrastructure in a COVID ICU. As being the head of a COVID medical college hospital, I have faced many problems of infrastructure like management of beds, management of aerosol transmission, change of PPE tests, single room, negative pressure room, high pressure oxygen flows, and other things. And above all, human resources management, because nobody wanted to go inside the ICU of COVID wards and all. So we have the best person here to speak about this is none other than Dr. Deepak Govil, who is Director of Critical Care, Medanta, Gurgaon, New Delhi. He is also a President-elect Indian Society of Critical Care. In fact, he's a very much critical care person. He's Associate Editor, Indian Journal of Critical Care, past Vice Chancellor of Indian College of Critical Care Medicine, and absolutely he's a devoted person for a critical care patient. Now I hand over the audience to Dr. Deepak Govil for his lecture. Thank you very much.
Thank you very much, sir, for kind introduction. I would like to thank all the organizing committee, including our national president and general secretary. Can you please switch on my video? I'm not able to switch on the video. It says it's stopped by host. So if we can switch on my video, and then if you can give me the, yeah. So without just wasting time, I would start presentation. I would like to again thank to the organizing team for inviting me and giving me this opportunity to share my thoughts. So I hope everybody can see my slide sets. So currently we are having problem, as you can see that this is the today's statistics. If we look at the world, we have got this much of the number where it's around huge number, a huge explosion of the coronavirus cases, and deaths are again very high, although recovered people are also very high. So 2,89,43,528 people have been infected world over. This is, I am talking about around 2 hours back statistics. The deaths are around 9,24,000. So just to give you a glimpse, as you can see, these graphs are still not flattening. Initially they rose exponentially. Now they are becoming almost static, but it is not flattening now. If we look at the Indian scenario, as you can see here, the Indian scenario, we are at the second level, second position, just after the US, with almost 90 plus new cases every day. So just imagine how problematic this situation is. This is the current situation around 1 hour back. Around, I have taken this snapshot at around 9:25 a.m. So as you can see here, today we are having 47 lakh patients and active cases are around 10 lakh cases. So it's a huge number to deal with a decade of the neglect of the healthcare by government and private sector. It is very difficult to cope it now. So just look at the problem. What is this? If we are having mild disease, then moderate, then severe, and the critical. As you all know, hardly 5 to 10% of the patients are critical. They require ICU. But just look at the requirement of the resources. These 5 to 10% patients, they use almost 80% to 90% of the resources what we are having today. And as the disease severity goes down, the resource requirement is very less. So just look at this situation where the patient is in sickest patient who are coming to the ICU requiring mechanical ventilation. Do we have that much of resources? Again, everybody is struggling, whether it's a 5-star corporate hospital like Medanta or a small primary health center. Everybody, believe me, everybody is struggling all over the India, and not over the India, even in the world, people are struggling. So what type of situation, what is the main problem we are facing? So we in ICU, we are facing three type of the problem. First problem, unsuspected, unrelated patient coming to the ICU, like antenatal patient who is full term coming to the ICU for some other reason, patient with pancreatitis, patient with liver failure, intestinal obstruction. I'm not talking about the pneumonia patient here. Other patients coming with a head injury, coming with the coronary artery disease, which it is sometimes it becomes very difficult to correlate that whether they are having corona or not. Then what we do, we keep them in a suspected ICU, and then we take their sample. Once their sample is negative, they are taken into the main ICU. But again, second type of the patient are those patients who are having some sort of the symptom of the corona, where we can roughly correlate that this patient could be a high suspected patient. Of course, we keep them in isolation, do their corona testing, and divide accordingly. Third type of the patient, I'm not talking about the diagnosed corona patient, because nobody takes them directly to the main ICU. They automatically go to the corona ICU. So we'll be talking about them in the last. But biggest challenge now, we are having those patients who are with the corona positive, 10-15 days with the corona. Now they have become negative. Now they are coming with some other problem. It could be symptom, respiratory symptom. It could be some other thing. But on paper, they are having a negative RT-PCR. So these three categories, they are making challenge to our general ICU, where the other patients are there, where the healthcare workers are not so aware or unaware about the possibility of corona. I'm facing this situation every day, that out of the normal ICU or liver transplant, I'm looking after 2 ICUs of liver transplant and gastro ICU. Side by side, I'm looking after 2 COVID ICUs right now, all 24 each. So I'm practically looking at 80 plus beds every day. Of course, it's not me who is looking after, it's my entire team who is looking after and putting their hard work. So we in normal ICU, where we don't suspect that patient is having corona, every day or alternate day, 1 or 2 patients are coming corona positive, and then they are getting shifted to the COVID ICU. But imagine, initially when it was happening, we used to do the contact tracing, we used to isolate those nurses, doctors, other patients. But in current situation, when every day, if I start doing contact tracing, probably all the ICU nursing and staff and doctors will be quarantined. So this is a big challenge. How to deal with this situation, I'll try to summarize in next 10 minutes or so. So there could be 2 general strategies to improve ICU surge capacity. I'm sure everybody is having surge capacity. Everybody is facing the same problem. Every hospital in North India, in Delhi, NCR, I know not a single corporate or government hospital is having ICU beds right now. Everywhere people are calling that, can we have an ICU bed? And we have to say no to them. So we have to have an executable plan to help decrease routine bed demand. How to do that? The basic thing is avoid those surgeries which are pre-planned and they are not so urgent, like cosmetology surgeries, those surgeries which are elective, not so urgent surgeries. Then the ability to increase the availability of 3S: stuff, space, and staff. So stuff means equipment, space means beds, and staff, of course, our own staff, which everybody know that it is, all 3 things are in right now in scarcity. So the goal should be to deploy an adequate quantity of material and personnel into the response. Whenever there is a problem or we are having many patients of the COVID, we have to do this. In this case, we need to forget business as usual. We can't say that we used to work like this. We are having 1:1 nursing. It's not possible. We are having so many doctors in a shift. That is not possible nowadays. So discontinue elective cases and procedures that require ICU bed support. That is one possibility. I know it is easier to set, but very difficult to do, because everybody has got to earn his own livelihood and where these patients will go. But again, we have to prioritize them. Expedite discharge and move patient to lower level of care or home. So what is happening? Those patients who can be discharged in a daycare or in a wards, we are trying to send them as early as possible to their home. That will help in two ways. Those patients will be lesser exposed to the infection, because in hospital, whenever the patient is admitted, the attendants are also coming to the hospital. So cross infection risk is high. Side by side, the nurses will be freed and rooms will be freed. Get some help as soon as possible. Try to enroll as many as people. You can enroll even NGOs working in your area as a support staff. They can't do nursing, but they can do other things. Identify the extra space and extra bed. Look surrounding affiliate facilities such as long-term care facility, nursing homes, and there are mushrooming of home care facilities nowadays. So we can enroll them also. That look, we are discharging this patient in from ICU or from room. Now the home care nursing care will take charge of that patient. So it will help two ways. Patient will be at their home. The cost will be also less, and the risk of infection will be there less, and we'll free up some space. So how to start with the space? We can free up some beds in ICU, ICCU, surgical ICU, post-op area, wherever you find bed, prepare them for the COVID beds or non-COVID beds. Allocate them, make a vertical differentiation between COVID zone and non-COVID zone, so that intermixing doesn't happen as far as possible. Areas outside of the ICU that can be modified to allow care of critically ill patients like SDUs, pre-op, OTs, post-op, chemo units, daycare, dialysis unit can be enrolled. So as I showed you in first slide, majority of these patients, almost 90% of these patients, they will require mainly the oxygen therapy. So we have to engage all those beds where we can create oxygen therapy or we can create oxygen support. Few of them, out of, if you are having 100 patients, our hospital statistics is like this. If you are having admitted 100 patients, hardly 10% or 5% patients will actually require the NIV or invasive ventilator. So almost 90% of the patient will require high flow oxygen or simple oxygen therapy. So try to enroll all those beds which are having at least pulse oximeter and cardiac monitoring with oxygen supply to this. One should also be aware that adjunct area of maybe of impact flow in and out. So just look at those areas. If you are converting your post-op or chemo unit into the COVID area or suspected zone, then you have to see that your normal patient, like patient who are coming for chemotherapy or patient who are coming for routine surgery, they are not exposed to that area. So it is not possible that if somebody has to walk through that area to reach the theater or to the chemotherapy unit, then it becomes a risky thing. Then one can have a hub and spoke model. So you can have one ICU which is looking after 5-6 wards. Doctor are in regular touch and they are monitoring the oxygen saturation level. And if need be, patient are being shifted or into the ICU or being shifted out of the ICU. And this hub and spoke model even work for a broader range, where a particular hospital is working as a hub and lot of home care patients are being there and they are being remotely monitored from that hospital. And once you feel that this patient is now becoming more sick, you can bring to the hospital. And once you feel that this patient is now on 2-3 liters of oxygen, rock stable for 3-4 days, not requiring too much oxygen, can be shifted to that smaller center or home care. Coming to the staffing, again, staff is a scarce commodity nowadays. As sir has already said, our chairperson, learned chairperson has already commented, many people are not ready to go to the COVID ward, but that is not for escape. In our hospital, our chairman has clearly said that those who don't want to go to the COVID area, they can be chucked out or they can leave the organization. But again, you cannot force everybody. And even if you force everybody, then also we are running short, because as we all know, the doctors, the nurses were always in shortage. And now with this epidemic, we are in gross shortage. So you can, in addition to your routine ICU staff, you can employ your like you can divert your infection control nurses, your pain control nurses if you are having any. I am not sure what is the situation in smaller places. In bigger places, there are lot many staff which is attached to the administrative or teaching duties. They are being relieved from those duties, are being brought to the bedside, because there are many layer of the staffing which are doing only administrative duties, so they can be. Then usual ICU staffing ratio. When we started COVID ICU, we started with a 4-hour duty schedule, 4 hours, then it is extended to 6 hours. We thought it is very difficult for any person to wear the PPE, work for 4 hours, 6 hours, 8 hours. And believe me, now it has become a 12-hour duty because we are running short of the staff. So what we are doing, between 12-hour, person usually goes out of the ICU, doffs, takes lunch, dinner, takes some break, and comes back to the ICU. That is the only thing. There is no other way. We can't escape that thing.
Why there is no audio?
Hello?
Has it completed 15 minutes?
Yeah, I'll complete, sir. Don't worry. Prior just in timing and the training of the supporting staff should be considered, and the roster of the staff outside of the ICU should be helpful. Then comes the staff. The equipment and supplies required to manage critically ill patients may include cardiac monitors, mechanical ventilators, non-invasive ventilation units, IV pumps, medication, medical gas, and other material. Consider disposable and the support item like sufficient ventilator circuit, mask, and PPE. Then one has to have a supply chain backup, because nowadays the supply chain is also disrupted because of the prolonged lockdown and surge in the demand. So then one has to have some general concept. Shift planning has to be there, care plan, hands out, documentation, infection prevention, critical care procedures, psychological assessment and care, team building, and the unit meeting and inventory management has to be done. So one has to obtain resources, medical supplies, reuse of the medical supply. This is a very vital thing. We have to judiciously use. Earlier in days, because of the JCI, we were throwing everything for after single use, but now it is not possible. Pharmaceutical supplies, personal protective equipment, they are very important. Evacuation and transport of ICU patients and casualties, patient triaging, personal triage, telemedicine. Now I would like to emphasize a little bit on telemedicine. This telemedicine has got a biggest role in the current scenario, because with this you can remotely monitor patients. So one has to have a triage scheme, how the patient will come, how the patient will move from one place to another, how the flow from patient casualty will move, how the patient care strategy will take place, and what is the communication plan. Normally patient used to be visiting, attendants used to be visiting to the patient, but in COVID area it is very difficult. So we have to have a clear communication plan, not only with the patient attendant, but between the different departments as well. So we have to prepare, constantly consider what can go wrong, be as self-sufficient as possible, realize that many people are willing to help you, have a backup plan for the backup plan ready. So this is about the fair ethical issues. One has to save most of the lives, but in this epidemic, one has to do, which sometimes you have to take hard decision. You have to treat only those patients who have got best chances of the survival. That is there. So again, ethical issues are there. Protection of staff is the most important. Avoidance of the cross-contamination among healthcare workers, education and re-education on personal protective equipments, provisional for workflow, enhanced surveillance for infection in healthcare worker, strong emphasis on good health hygiene, and robust visitor increase in screening and management. So all the patient, doctors or staff, healthcare worker who are using the confirmed or suspected COVID must use PPE. At least an N95 face mask, gowns, and gloves are the must. Operating room scrub or full overalls should be first layer of the protection beneath PPE. PPE must include fluid-resistant gowns, gloves, goggles, side protection, hair covers, hoods, and of course N95 mask.
Dr. Govil, please conclude. A lot of persons are waiting all over India.
Okay, sir. So I don't want to go into the detail of the sequence of PPE. Everybody knows about it, and that's it. So thank you very much for giving me time. I'm sorry for exceeding my time. Thank you very much.
Thank you, Dr. Govil. Thank you.
Thank you, Govil sir. There is a question for Dr. Deepak Govil sir, and this question is being asked by Dr. Vishal Beval, Patna Medical College, Patna. He is asking that, sir, please tell us the minimum oxygenation delivery devices required in COVID ICU, so that we can effectively treat the COVID patient.
So minimum oxygen delivery device is to start with the nasal prong, which requires 2 to 3 or 4 liters of oxygen. Then comes the Hudson face mask, where you can go up to the 8 or 10 liters of the oxygen. Beyond that, you may require the non-rebreathing mask, where you can go up to 15 liters. Beyond that, you can choose about the high flow nasal cannula versus NIV.
Thank you, sir. And now, please, sir, take off your video. Thanks a lot. So we'll move into the another lecture, and the chairpersons for that second lecture is Dr. Ajit Kumar. He is ex-professor and head RIMS Ranchi. He was ex-vice president of ISA National. So I welcome Dr. Ajit, sir. And our next chairperson is Dr. BK Sinha, sir. He was our ex-president ISA Bihar Jharkhand, and he was our ex-professor and head of the department, Patna Medical College, Patna. So I welcome our both chairpersons. Nidhi ma'am, please show the CV of Dr. Saikat Sen Gupta, our next speaker. And Dr. Ajit, sir, please introduce him.
Dr. Saikat Sen Gupta, a senior consultant in Glendale Apollo, Kolkata. He is one of the top speakers of the country in modern day aspects of anesthesia. I don't think he needs more introduction, as he is a very popular speaker and well known to all of us. Most of all these are at least. Dr. Saikat is requested to start his paper, Modern Day Anesthesia Practice in Change Scenario. Dr. Saikat, please.
Good morning, everybody. And at the outset, I think I would like to thank Dr. Sharad, Dr. Sukesh, and I hope I am visible and I'm audible, and the slides are audible, are visible, yes, rather. So, yeah, I'm good to go. So this is about regional anesthesia in the change scenario. And let me at the outset say this is more of a personal rambling based upon the available evidence that I could lay my hands on. And at the same time, I would declare that I'm a self-proclaimed regional anesthesia bhakt, if you can call me so. I think when this regional anesthesia came in, I was reminded of JFK and possibly more of his gorgeous wife, Jacqueline. And in a crisis, be aware of the danger, but recognize the opportunity. And what have we been hearing since March or April 2020? Regional anesthesia should be preferred over general anesthesia whenever possible. And we found that several practice recommendations for regional anesthesia during the pandemic have been published. They kept on coming. The American Society of Regional Anesthesia and Pain Medicine went quickly off the blocks, much different from what generally the Americans were with the pandemic. And we soon had the joint collaborative efforts of the ASRA along with the European Society about the COVID-19 guidance for regional anesthesia, which has kind of become the benchmark today about neuraxial anesthesia and peripheral nerve blocks. And their blockbuster statement was regional anesthesia is preferred over general anesthesia for patients with COVID-19, and mark the words, to reduce the risk of transmission. We were hearing our secretary, our president, everybody kept on harping on this word, to reduce the risk of transmission. And this was followed by, I think, publications from all societies, including our own society. And I think a speaker who's going to follow me already has a citation even before he opens his mouth. Well done, Dr. Bala. So why regional anesthesia? If you look into it and you look into their objectives, you'll find there are other things also coming in the process. It's about logistics as well. one of the things they mention is that you need to preserve key drugs, read propofol, during the critical care of, for the critical care of the COVID-19 patients. And the people in the UK, in the US were very skeptical whether they will run short of propofol. Thankfully, they never did. Also about reduction in the aerosol generating procedures, regional anesthesia being not one, and thereby you increase the safety. But again, mark these words, saving time, resource, as well as the financial costs of PPE. So there are logistic things that are coming in. Along with it, obviously, certain medical things like preservation of the immune function when compared with general anesthetics, improvement of the post-operative analgesia, and thereby you are decreasing the direct contact with the care of the caregivers with the patient, and you can also possibly plan earlier discharge. So this is the joint statement from Vishal Uppal and his team, and let me take you through the take-home messages which they brought out in flyers, and this came out as posters even in our department, which we put up on our boards. One is about what PPEs that you should wear. They said that regional anesthesias are not aerosol generating, and therefore, mind you, this is coming out in the month of March. Respirator masks are not to be used when you are doing a regional anesthetic procedure, even if you are in close contact. But if you think it is going to be a switch over to general anesthesia at any point of time, then an N95 and above. The patient wears a surgical mask, and it is about your surface contacts, and so that they don't get contaminated, about covering your ultrasounds. They kind of made a bold statement that RA, regional anesthesia, is not contraindicated, but you have a different kind of approach to it. Prepare your syringes, your drugs, keep them in a packet or a box, and bring them with you in the operating room. Think about adjuvants, think about catheters. Don't think about dose modifications. Nerve blocks, ultrasound guided is, if possible, the preferred approach. And minimal oxygen supplementation, if you can do it. They also warn about thrombocytopenia before neuraxial procedures, and obviously things that are very intuitive about hypotension, etc., etc. And we did the same way. We covered our machines, we covered our monitors, we covered ourselves, we covered the ultrasound machine, and it became a huge challenge to look at the screen when you were doing a procedure. The images were not as great as it was to be before the pandemic. And then currently, if you ask me, we have done away with the cover on the screen so far. And also, where did we block? We used to do it in our block area or the holding area, but we do not have the airborne infection isolation room or the negative pressure, but we do have positive pressures with a laminar flow with very good cycles changes per minute. And if you're good above 15 or 20, I think you're good to use it for whatever, even an aerosol generating procedure. But I will take you through a little bit of the fine prints about this joint statement. If you read it in its entirety, you'll find that they tried a formal literature search like a review would do or a meta-analysis would do. They had a paucity of evidence, and they had to recourse to hand searches. And this should ring a bell that they're not then looking at very high quality evidence. This joint statement was based upon 16 papers with only one retrospective cohort study, 4 case series, 4 case reports, and these 8, if you look at it, were nearly, if not all, on subarachnoid blocks for cesarean sections, which you would have anyway given, and certain 7 expert opinions. And they themselves say that the overall, and this is all that I'm putting up on my slides, are whatever is in their print. The overall quality of evidence was moderate to low, and even in that, there was very little evidence for them available from the 17 selected publications regarding oxygen therapy, PPE, or the conduct of regional nerve blocks, about which they have made these recommendations. So they say the quality of evidence was low, and therefore the strength of recommendation is moderate to weak.
this is where I also have my reservations about this recommendations. So if you look at when you are doing your blocks, whether upper limb, lower limb, central neuraxis, even your intraoperative monitoring, the PPE that they are recommending is for droplet precautions. I understand this is in March, April, but unfortunately, I could not figure out, or I could not find another recommendation when they have improved upon it. And all they're recommending is that you have fluid-resistant gowns, gloves, face shields, and a fluid-resistant face mask. That's a surgical 3-ply possibly, and not an N95 and above. Coming to the moot question, therefore, is regional anesthesia safer than general anesthesia vis-a-vis this COVID-19 pandemic? I know I am throwing a hat in the ring, or a kind of a cat in the amongst the pigeons. There are two metrics that I would possibly tried to find. Unfortunately, I could not find out much. Is this better for the patient with respect to post-operative outcomes? Is it better for us, the healthcare workers? Is that there is less incidence of infection when regional anesthesia has been used versus in units where general anesthesia has been used? I know it will be very, very difficult to get this data, but nevertheless, what I am asking all of you is, would you prefer a patient who is infected to stay awake and breathing, talking, and the staff is only wearing droplet precaution PPE? Do they possess a greater risk? Or would you like a well-managed general anesthetic in which a patient is neither coughing and on tracheal intubation or extubation, does not need suctioning, and the staff is wearing aerosol generating procedure PPE? Is that a greater risk? And obviously, this is human psychology. Could the staff be more complacent during a non-NGP, such as a regional anesthesia, and possibly have their guards down? And then comes, I think, this is around May, and people are now figuring out that it is not just coughing and sneezing which are droplet generating. There is this debate about what is a droplet nuclei, what is a droplet, what is an aerosol, and what is that 5 micrometer, the ultimate thing that you're looking at. And now people are realizing that even talking and breathing, when I'm talking at this volume, is generating sufficient amount of aerosol containing possibly sufficient amount of virus to contaminate the other person. One thing people realize that, yes, if you operate on COVID-19 patients, their post-op perioperative mortality morbidity is high. This came out from China, later on in Italy as well. And one of the things that people said that volatile anesthetics, yes, they decrease the perioperative immunity, and therefore that is a potentially significant benefit of regional anesthesia. But till date, this is very, very speculative. And editorial by McFarland on regional anesthesia and COVID-19, and they have, I think somebody's mic is in the background.
Just a minute, second, please. I request everyone to please mute your mic. Please mute your mic. I request everyone, please, this is disturbing. Please, just a polite request. Just a second, please carry on.
No, thank you very much. Thank you. Okay. So they kind of brought this question of consenting. And when you are kind of biased yourself that regional anesthesia is better than general anesthesia, during the consenting process, would you violate these components of an adequate consent and therefore deny people of general anesthesia? Therefore comes the potential risk that the consent becomes more healthcare worker-centered than a patient-centered. Of course, in a pandemic scenario, a lot of things can be excused on that. But be aware that it can have that medical legal consequence that if somebody experiences a material risk that could have been avoided by an alternative technique that was not offered, there is this potential. There comes the patient selection along with it. I think just prior to the pandemic, we figured out And that is about from the, I think, hip attack study that even patients who need early hip surgery, even clopidogrel is no longer considered a contraindication. You would be happy with it as long as the INR is less than 1.5, even for those the other group of patients. But this was done to facilitate timely surgery, mainly about elderly hip surgeries. But should we keep these in mind when you're having a suspected COVID-19? COVID-19, yes, it is all about hypercoagulability when they get into SARI, but there is also a link between COVID-19 and thrombocytopenia. And therefore, what testing and which patients would you happily be taking up for a regional procedure? I think you just need to be aware and be conscious about these factors when you're taking these patients for regional.
Sir, please sum up. We are running short of time.
Yeah, just a couple of minutes. That's it. I'm done. The theater turnover is one issue, but the theater turnover is also dependent upon the block time and the onset time. So choose widely. Guidelines are for guidance, and individualized appropriate patient care is very, very important. I'll finish it off with a food for thought. I'll not make my concluding remarks, but keep it to open it to you, and you think what you would do on this scenario. Say a 40-year-old male with a road traffic accident with a multiple fracture of the lower limbs with a degloving injury and is bleeding, awake oriented but is coughing, tachypneic, low SpO2, and is suggestive of COVID-19. The RT-PCR test is awaited. You need to go into a debridement and external fixation of the lower limbs. The contact time in the OR is going to be 2 to 3 hours. What would be your plan? And the other scenario is a 15-year-old who falls down, has a supracondylar fracture humerus, no comorbid status. On admission, you find that the RT-PCR is positive, so it could be asymptomatic or a pre-symptomatic. The plan is an RF of the fracture. The OR contact time is about a couple of hours. So would you prefer a regional anesthetic? I think you have to take a very individualized call. Remember, there, if not coughing, sneezing, even oxygen therapy, deep breathing, speaking can contaminate the environment, and versus an intubation, which is well managed without coughing, bucking, no bag mask ventilation, extubation, which is well managed. So your choice is yours. I leave it to you, and I'll conclude my my thoughts on regional anesthesia in the current setting with these. Thank you very much for giving me this opportunity, and wish you all the best for the meeting ahead.
Dr. Ajit sir, Dr. BK Sinha sir, are you here? No. So Dr. Ajit sir, please thank our speaker, Dr. Saikat Sen Gupta sir. Ajit sir.
Ajit sir, mic को unmute कीजिए sir. Please unmute your mic.
Dr. Saikat, thank you. It had been a very nice speech and very conclusive. Thank you.
Thanks, Saikat.
Sir, Saikat sir. Hello, Saikat sir.
Yes, yes, I'm there.
There is a question from our one of the beloved professor, Dr. VK Gupta sir. What minimum investigation you expect before taking COVID patient for regional anesthesia? You got my question, sir?
Yeah, I got it. I think it would be the same that you would have done anyway before taking it up. You're depending upon the other patient characteristics, but definitely in the current scenario, the coagulation profile, whether it is the PT, INR, APTT, platelet count, would be needed, because there has been this issue with thrombocytopenia and COVID-19 regional blocks, and that's it. And that is about kind of what I would do.
Thank you, sir. As we are running short of time, so we cannot take more questions.
Thank you, sir.
Thank you, Ajit sir.
Very much, sir.
Thank you, sir. Now we'll move to our next lecture, and the chairpersons for that lecture is Dr. Professor Ashok Kumar Gupta, sir. Please welcome, sir. He was our ex-GC member, ISA National, and ex-professor and head of the Department of Anesthesiology and Critical Care, Patna Medical College, Patna. Welcome, Dr. A.K. Gupta, sir. And our next chairperson is Dr. Dev Sanjay Nag. Sir, are you here, sir? He was ex-president ISA Bihar Jharkhand and senior consultant TMH Jamshedpur. Welcome, Dr. D.S. Nag, sir. Dr. Nidhi ma'am, please show the CV of Dr. Bala Venkat, sir, our next speaker. And Dr. A.K. Gupta, sir, will introduce him.
Thank you, Dr. Sukesh. Dr. Bala Subramaniam is a very eminent speaker, senior consultant and academic director in Ganga Hospital, Coimbatore. He was president Indian Ocean Society. He was a member of Epidural Committee of WFSA and Scientific Care Committee of WCA.
Hello, there is network issue. Yes.
He was founder, president, and current national chairman of ERA, and he is at present DC member of ISA. He is going to speak on legal lessons learned from 3 decades of anesthesia practice. A very good topic, especially for our younger generations. I have the experience of more than 4 decades of practice. A lot of changes has occurred since then regarding in relation to use of drugs, techniques, and development of equipments, etc. you are using nowadays. Now I will request Dr. Bala to proceed with the subject.
Can I share my screen, please? Yeah.
Then we can see your slide. Just go to the slides also.
Can you see my slides?
Yes, sir. Yes, sir.
And my audio is all right?
Perfect, sir.
Good morning to everyone. I bring to you greetings from the city of Coimbatore. I'm extremely delighted to be a part of this state meeting. It's been long due that I wanted to visit Bihar, but I'm extremely delighted and happy to be a part of this virtual, well-conducted meeting. Thanks to Dr. Sharath and Dr. Sukesh, who has been in touch with me, and all the leading lights of Bihar, who have made sure that Bihar has turned out to be an academic extravaganza in the fraternity of anesthesia, especially Dr. V.K. Gupta and several senior anesthesiologists. When Dr. Sharath asked me, I thought I would share the 3 decades of experience as an anesthesiologist. Came into this fold in 1988. And I'm extremely happy that God created me as a doctor and more importantly, as an anesthesiologist. I bring to you greetings from Ganga Medical Center and Hospital, which has just turned to be a 650-bedded tertiary care referral center for trauma, orthopedics, major reconstructive spine surgeries. We roughly operate about 150 to 175 surgeries every day, and the Department of Anesthesia is about 80 anesthesiologists with about 14 ultrasound machines. And when you become an anesthesiologist, it is important that every day you become better, just not because of you, but because of people with whom you are associated. So I take the opportunity to thank my directors of the institution who has given us the free hand to grow. I thank all my department colleagues in surgery and anesthesia for learning and teaching every day. I thank my teachers in Postgraduate Institute Chandigarh and BJ Medical College Pune for making me what I am. My parents, my in-laws, my family, and my friends who all contribute to an individual to become an institution. So whatever you are is not just because of you, it's because of a conglomeration of the inputs that you received from each and every senior and junior. This is the biggest lesson that I have learned in my 3 decades. Alone you can do nothing, together we can achieve everything. And especially anesthesiologists are the chosen special children of God, because there are only 2 things which are very significant for a patient who comes for surgery. Number one, he has to remain alive. Number two, he has to be pain-free. And both these capabilities, God has given only to the fraternity of anesthesia. And anesthesiologists are the only one who read everything in medicine, right from physiology to obstetrics, gynecology, and hence we will call an anesthesiologist the subject as the mother of modern medicine, and it's truly the most sacred branch. If a person has to survive in a critical care, in a trauma unit, it is just because of the presence of an absence of an extremely good quality anesthesiologist who can intubate, who can start a line, and within seconds convert a death into life. It's such a sacred branch, and we are the true angels. And for all the youngsters who are listening to this talk, I just wanted to make sure that you fix a good, important take-home message that I would wanted to. What should be your growth? What should be your progress? This is what I have learned in 3 decades. You cannot be the same in the 30th year, 40th year, 50th year, and 60th year. There should be a tremendous progress that you make holistically in every year that passes by. So I want all of you to take a paper and write what will be your goal every 5 years and every 10 years. And this is another important take-home message I want to give. All things are created twice. The first thing is a mental creation, and second thing is a physical creation. For example, if you're going to do a very tough case tomorrow, after the pre-anesthetic evaluation, you have to have a clear game plan. Mentally, you should give anesthesia to this case before you go in and physically give anesthesia. Right from the way where you start the line, what drugs will you use, what will be the course of events, what will be the expected complication. Mentally, you run through this case, you do the case the day prior, and when you go and do the case next day physically, you will believe it is so nice to see that things flow so smoothly from you. This is what peak performers do. For example, Vishwanath Anand continues to be the world champion in chess because he plays his opponent so many times the day prior to the meeting, due to the match, and every move of his opponent, he has got an opposite move. And when he goes and sits, he wins the battle so easily. I want every young mind to know this, that you have to mentally play your case one day prior before you do physically. Our work is our prayer. Everything we experience, from food to clothes to shelter, the comforts and the luxuries that we enjoy, the car you bought, the video system you have, the mobile you have, are all the rewards from the work we do. So we revere your workplace. Our work is our prayer. I have learned several important lessons, not only professionally, but also personally and ethically. You have to always align only with positive fellows. Move away from negative forces. Number 2, do not speak anything bad about your professional colleague in his absence. If you want to point finger at somebody, do it in his presence. Number 3, do not equate everything to money. Money is not what we are meant for. It is important, but as a professional, as an angel, you're expected to perform the duties and the responsibility given by God to the ailing humanity. So do not equate everything to money. Money will flow in automatically. Get aligned to vibrant, progressive, and ethical surgeon. You grow as far as your surgeon grows. So always align to ethical and brilliant and progressive surgeons. They determine your growth. The more tough cases they do, the more challenging anesthesia becomes, and you become better. Keep expanding your responsibility by increasing your horizons. We just live only once. So you need to lead a legendary life, contribute enormously, just not anesthesia. Take on hospital infection control committee, blood bank committee, fluid committee. Be a part of as many places as possible. Spread your wings to see that you, as an anesthesiologist, give an important contribution to patient safety. And when it comes to the patient, please respect every patient and his privacy. Empathy with the patient and the sub-staff. To be in the operating room minimum 15 minutes before you start your case, not to shout at the staff. Any anesthesiologist who shouts at the staff is definitely an incompetent anesthetist. Please take it from me. So a sign of competence comes with calm and confidence. And even if you become an administrative head, keep doing the procedures every day. Just because you become the head of the department or a professor, it is not enough to get confined to the office table, because you will, in 6 months, we will be de-skilled. And when the chief minister comes for a procedure and they say the head of the department has to give anesthesia, we may not be adequately skilled. So this is a very important message, that every day, all of us as we grow older should make it a point to be a part of anesthesia procedures. And the personal lessons, again, I learned is tremendous integrity to the place you work. Humility, the more you grow, the more humble you be. Extremely graceful in your maneuvers, ever available and approachable to everybody. And I will consider a good anesthetist is one who is holistically involved in the perioperative care. Preoperative history taking is mandatory. Careful listening is very important. Every symptom to be accounted, and you build a plan right at the time. I consider anesthesiologist like a pilot, but also as a tailor. A tailor makes a beautiful cloth for a person. Similarly, the most dedicated anesthesiologist builds a comprehensive plan on an individual basis, not on a collective basis. So build a plan. And next important thing is, hospitals have become very unsafe, and anesthesiologists do contribute to hospital-acquired infection. So the lesson I've learned is, we have to follow the practice of hand hygiene, safe injection practices, all the methods that need to be followed to prevent surgical site infection, prevention of intravascular catheter-related infection, prevention of infection associated with neuraxial procedure. I wanted to emphasize this very much. I want all the anesthetists who is listening to this talk, that every time they scrub up for a spinal, minimum they have to scrub for 6 minutes with betadine on the first time when you enter the operating theater. And for the next scrub, it should be minimum 3 minutes. Less than this, you are prone to transmit a neuraxial infection for your patients. Hand hygiene after every procedure is important. This has been found to be the single most common cause which an anesthetist does not do inside the operating theater. Several audits have indicated. And some simple things you need to give meticulous attention. I wanted every anesthetist to be a master in fixing an endotracheal tube. When you do that, you should not injure the soft structures, especially the very, very soft lip. If they develop a lip ulceration, it will produce a scar and a lifelong memory about anesthesia. I want all the young anesthetists, I just wanted to show, see how we pad it, because we do a lot of cases under prone position. We will, both the upper lip and the lower lip, we got with gauze pieces, and we put plasters, secure it so nicely, cover the eyes. These are all simple things, but I just wanted to tell you that the lessons I've learned starts from simple things. We all think, I'm just going to next few minutes quickly run through some of the big learning lessons that we have. It was always thought malignant hyperthermia was not for India until 2 years ago, we lost a 26-year-old marine engineer, ASA grade 1 patient, no previous history, general anesthesia with a brachial block for a shoulder surgery, profound hyperthermia, hypercarbia, death. We did not have dantrolene. Lesson learned, we stopped dantrolene. And I'm extremely happy to say within next 2 months, we got another child from Kerala. It is known that musculoskeletal problem and patients from Kerala are highly prone for malignant hyperthermia. I'm extremely delighted to say that we could save this child because we stored dantrolene with us. We continuously stored dantrolene with us. In this 2 years, we have given our dantrolene to 8 different institutions and 8 patients survived. So this is an ECG trace on how the EtCO2 and the temperature rises. So one take-home message is, every institution in Bihar should strive to get dantrolene sodium kept ready in their institution, because saving one life is creating one life. And I just want, it's freely available, though it is not commercially available, but it is available with the stockists. I wanted all of you to buy dantrolene. One dantrolene will cost about the current rate is about 8,000 rupees. So for an adult male, it will cost roughly about 1 lakh, and it's got a shelf life of 1 year. Second important thing which I've learned very recently Is a 70-year-old patient, total knee replacement done. Hypertension, no other comorbidities. Of investigations normal. Case was done under combined spinal epidural. On second POD, suddenly you get a call of seizures in the ward. Code blue announced. Patient shifted. We found acute hyponatremia. The point I want to drive now, within 48 hours, patient became symptomatic with acute hyponatremia. And I just wanted to tell you that the myth that we should not correct sodium fast is wrong. In symptomatic hyponatremia, you promptly infuse 150 ml of 3% hypertonic saline IV over 20 minutes. Consider checking the serum sodium concentration after 20 minutes while repeating another infusion of 150 ml of 3% hypertonic saline for the next 20 minutes. This is, I underline, in symptomatic acute hyponatremia with seizures. Please follow this protocol. And if you have doubts, please go to the Google. Do not go for low transfusions like what was advocated earlier and lose the patient. The next patient which I wanted to say is recently encountered local anesthetic systemic toxicity. So we were giving a preoperative femoral nerve block for a patient with a peripheral nerve stimulator for demonstration. Though we use ultrasound, this particular case we used PNS to demonstrate. And as the first 5 ml went inside, patient started shivering and next minute he started convulsing. Later with the USG, we found out that there was a blood vessel going between the anterior and posterior division of the femoral nerve. After 5 ml, when we got immediately, we stopped the injection and started the protocol of treatment of local anesthetic systemic toxicity. Take home messages. I wanted every preoperative room in all the anesthetists who are listening to this talk to take a printout of treatment of last and kindly paste it in your preoperative room. And number 2, make sure that 20% intralipid is available in every operating room where you give a regional block. This is a very important case I will never forget in my life. A patient known to me, 68-year-old patient, ASA grade 2, no major issues, underwent total knee replacement under combined spinal epidural. On second POD, complained of headache, thought to be PDPH, fluids, analgesics, nothing happened. Third POD, intensity increased. And the first time in my life of 30 years of practice that we found out CSF meningitis, and the lesson learned was sterility. Sometimes I see when the junior anesthetist is not able to get a spinal, the senior anesthetist just wears the gloves and goes and gives the spinal. For heaven's sake, I will plead you, please don't do it, because we lost this patient. CSF meningitis is deadly, and we should not be a part of this. Here is a next thing which I learned. A 22-year-old patient with fractured femur tibia and metatarsal, 4-hour surgery done under combined spinal epidural. Everything went on very well. At the end of the procedure, the plastic surgeon came and said, I just wanted to put a K-wire in the metacarpal fracture, and I gave a subclavian perivascular block. Within seconds, patient developed bradycardia and hypotension. What is the lesson learned? Whenever there is a clavicle, whenever there is a polytrauma, you have to make sure that if the patient has got a clavicle fracture. In this, what I missed was, patient had a clavicle fracture. I missed the clavicle fracture. I went ahead and did a block, and it seeped in and produced a high spinal. So the moral of the story is, whenever you prefer to give a block for a clavicle fracture or any other fracture associated with a clavicle fracture, you should know that the brachial plexus covering is also impaired, and the drug that you place in can seep in. This patient survived. Immediately we intubated, ventilated, and vasopressors were given, and he regained spontaneous respiration in 25 minutes. Another important lesson I've learned is, any occipitocervical fusion that you do, patient should not be extubated on table, and overnight ventilation is important. This is something which we have followed. This is a very, very important take-home message. This is a case which was done in Ahmedabad, bilateral shoulder surgery, 52 years old male, 3 hours of bilateral shoulder done in sitting position, totally 6 hours. At the end of the procedure, the patient became bilaterally blind. This is because of the poor perfusion that happened to the to the retina. And the take-home message is never do a shoulder surgery in sitting position for long duration. Only one side shoulder has to be done. And more importantly, the cerebral perfusion pressure is much less than the blood pressure that you monitor in the arm, because the pressure is much lower and the cerebral perfusion and the retinal perfusion is less. So this is a take-home message I would wanted to give you. And how many more minutes I have?
Sir, can you please sum it up, because we are running out of time.
No, because I timed it as 20 minutes. I saw that 2 more minutes were there. That's why I asked you. Okay, sir. I will like to conclude by saying that simple things are simple. In you see severe postoperative hypertension, first thing you see if the bladder is involved, and if it's so, bladder catheterization has to be done. And I will like to say that all major trauma, we have to institute on-arrival blocks, and anesthesiologist has to be a part of it. And this is a great component of multimodal analgesia. And role of therapeutic embolization has to be kept in mind in major pelvic injuries when the patient continues to bleed in spite of external fixator. And this is how you see the minute you do a therapeutic embolization, patient stabilizes, and you can get them back to life. Nothing else can be done in a run-over injury like pelvic injury like this. And whenever you do rounds in a polytrauma, it's important to see the urinary bag. Myoglobinuria and renal shutdown is very common. And the last slide is, always when you do polytrauma, remember about abdomen compartment syndrome and decompressive laparotomy at this stage. The take-home message I would wanted to give to every anesthesiologist is, every day is a learning experience. Every patient teaches you something. Every student teaches you something. Every day some new challenges happen, and we should start perceiving, listening, imbibing all the good things around you, and every day that passes by, you become more holistic, more professional, more ethical, and more empathetic. Sincere thanks for the opportunity, and I look forward for excellent academic deliberations in Bihar, and I look forward to be present in person in Bihar in the days to come. Thank you so much.
Our chairperson, Dr. D.S. Nag, sir, please thank our speaker.
Thank you so much, sir. It was a mesmerizing talk, and it is a lesson for all the, especially the younger people and even for the senior ones, to take the message from your wonderful talks. And I would once again like to thank you from the organizers and from the state of Bihar and Jharkhand. And it was a privilege to have you over for this talk, sir. Thank you so much, sir.
Thank you, sir. Thank you.
Dr. Bala, sir, there is a question from Dr. Apurva Patna. What are the 3 turning points in last 3 decades which you feel should be shared with the budding anesthesiologists?
Can you just repeat it once more?
Sir, what are the 3 turning point in last 3 decades which you feel should be shared with the budding anesthesiologists?
Number 1 is to grow with the time. Like if the ultrasound comes, I think the thirst to learn complete ultrasound should be there. If you know transesophageal echo, you need to learn transesophageal echo. So you have to grow with the time. You can't say that I'm a very good by giving blind blocks, so I will continue to give. So grow with the time and utilize everything that comes into you in your lifetime and make it a part of you so that you become so well versed, number 1. Number 2, never in your life do the same things again and again. Try to do innovative skills and procedures so that you become extremely competent. And number 3, and most important thing is, as you grow higher and higher, you need to keep on sharing all that you know with your juniors, and then learn from every possible person and accumulate more skill, more knowledge, and together with humility and integrity, you will turn out to be a holistic professional. This is what I could sum up on what an anesthesiologist has to do. Thank you so much.
Thank you very much, sir. Now we'll move to our next lecture. And the chairperson for that lecture is Dr. Professor Ajit Gupta. He was our ex-president, Bihar, Jharkhand. He was ex-professor and head of the Department of Anesthesiology and Critical Care, IGMS Patna. I welcome Dr. Ajit Gupta, sir. Dr. Nidhi ma'am, please share the CV of our next speaker, Dr. Rakesh Kumar, sir. And Dr. Ajit Gupta, sir, will introduce him.
Very good morning, all of you. And thanks the organizers for inviting me to chair the session. And I have been given the opportunity to introduce Dr. Rakesh Kumar. He needs no introduction. He is a very known anesthesiologist of the country and a good academician and well known internationally also. Presently, he is Director Professor Anesthesia at Maulana Azad Medical College, New Delhi. He was ex-MS Emergency and ICU of Loknayak Jayaprakash Narayan Hospital, New Delhi. He is ex-HOD Anesthesia of Delhi University. He has been international faculty at different places. He is very much interested in the airway management. He has represented country on World Airway Management in 2015 at Ireland, Difficult Airway Society at UK in 2013. He's been in USA in 2014, Society of Airway Management. He has he was National Orator in 2011, Dr. Kamara Memorial. And he has come up with a very good, nice topic in the present scenario. The airway management, difficult airway management in COVID patients. So I think he will be doing very good justice because he is very much interested with the airway management. So I welcome Dr. Rakesh.
Thank you very much, sir.
To start your
Thank
talk.
you very much. Yes, I'll share my screen first of all.
Any help needed, sir?
Can you see my screen now? Can you see me? No. What has happened?
We can see you. Anand, I request Anand to help, sir.
I could see the share screen. I did that only. And,
okay, sir, just minimize this, sir. Minimize this.
Which one?
The Zoom screen, you can minimize it, sir. Minimize it.
Okay. Okay.
Yeah, you can open your PPT down. All PPTs are opened.
Is it okay now?
Yes, sir. Yes, sir. Please go.
And can you hear me?
Yes, sir.
Okay. So thank you very much, Dr. Ajit, for that kind introduction. And thank you to the Bihar Jharkhand Society for this great opportunity. And as you introduced me, I have spent nearly more than 41 years in anesthesia, and all at Maulana Azad Medical College and Loknayak Hospital, which you see on your screen. And I also have a nice group of people who form the Airway Management Society. And now, after retirement, I have shifted to the SGT University in Gurgaon. And as Bala said very recently, that yes, age should not be a bar for learning, and I continue to learn. And I hope that this our conference will give another opportunity to me to learn from all of you through interaction. And I would like to, along with my grandchild here in my arms, I'm at the moment sitting in Adilabad, which is in Telangana. And I congratulate all the anesthesiologists for a great opportunity that all of us have got through this pandemic. I feel this is a great opportunity. We have come into limelight. Every day we are being talked about. The things that we are giving to the world is very well known now, and we must make the most of it. And we must grow, and should be able to say that this reputation of being the best doctors, being the lifesavers, being the people who are managing to fight COVID on its face, it should be continued. and we must keep it going even after the pandemic is over. So I begin my talk with the assumption that we are dealing with the topic given to me was not what Dr. Ajit said. The topic was main aspects in a COVID suspect intubation. So concentrating on that, I'll assume that the patient is a COVID suspect, not a COVID proven case, and would have required intubation in normal circumstances for that surgery for which patient has come, and he has come to a fully equipped center. Right here, I would like to put a disclaimer that as a 60+ person, I did not get an opportunity to intubate per se, but I have learned through my resident junior consultants a lot about what I have been asked to talk about, and we have been interacting and even looking at the videos of them. So what are the modifications for a suspected COVID patient? Already spoken in detail by many people. The one thing is that test for COVID if the time permits, and avoid intubation as much as possible. Again, talked about a little bit. But if the intubation is unavoidable, then these are the main things. Keep social distancing and barrier as much in mind as possible. Aerosolization to the minimum, and clearing of the aerosol should happen quickly and efficiently. And the personnel number who get exposed should be minimized. Yes, RT-PCR is being done in all the situations, but unfortunately, the reported false negatives are even up to almost 30%. So that means even if the RT-PCR has come as negative and the symptoms are there, we'll have to take that person as COVID positive, because that is when we'll be more vigilant. So avoid intubation. I'll give you an example. In the last week of March, when I was very regularly going to the ORs, but the threat has started looming on our heads, we were able to do a case which we would now normally do with intubation, because this was a patient with placenta accreta who was bleeding, who was still having a BP of 90/60 when we saw her, and the pulse rate was not very high. It was around 96. But and the surgeon said that they might have to go in for hysterectomy, which they finally had to do. But we were able to talk to them, and because of the COVID situation, we were able to impress upon them and do with CSC, starting with spinal at a very low dose of 1.2 ml of bupivacaine, and then adding as and when required with the epidural. And we were able to go through this very successfully. But that, as I said, may not be possible at all times. And these are the things which I've already talked to you about. And let me now go into a little bit more detail about this. So the usual steps of intubation are not inside the OT itself. As my previous speakers have also said, a lot of history taking and airway assessment makes what airway assessment is. You know, the dictum which Airway Management Foundation uses is that no airway is difficult if you have planned properly. So all these things, and inside the OT, the intubation is preceded by pre-oxygenation induction laryngoscopy. Outside, when you are doing airway assessment, you know, it is recommended now that it is a good idea that the patient takes a mouthwash with betadine, dilute betadine solution, and puts it into the nose also for nasal drops, because that is where all these viruses reside and from where the aerosolization occurs. And as my previous speaker had said, that even speaking and other things also generates aerosolization. And let the patient wear surgical mask when you're talking to the patient, when the history taking is happening, and you can sit 2 meters apart when you're taking the focused history. The anesthesiologist must wear an N95 mask. I think that is going to become a norm now whenever we deal with any patient for years to come. A screen between the patient and anesthesiologist is a great idea. A lot of centers are doing it. We are still not doing it. And if there are, we must not only impress upon the anesthesiologist, but the treating surgeons also, that they must also deal with their patients by asking them COVID suggestive symptoms or COVID unsafe behavior. What is that? That the person has traveled in a bus, he has traveled in a metro without people wearing masks around him and so on. So, but during the airway examination, the mask will have to be taken off. But you can, what we have decided and we have started doing is using a smartphone wrapped in a disposable transparent cover with a flash on, and we use pictures to aid our assessment. Taken these pictures from a distance, and you can study them when the patient is gone, and you can make your decision, even the neck movement and so on. So you can see that the pictures can aid assessment very nicely, and they allow us to stay away from the patient. The next step is inside the OT. Remember that these patients are not stopped over in the holding areas. As my previous speakers also said, our holding areas are not made for it, and there are other patients around. So inside the OT, there are some general steps which are being taken, and the other 4 steps. The general steps, as I said, as the patient comes from his room, he should be asked to do mouthwash and nasal drops, and he should be wearing a surgical mask thereafter. If you are able to create a negative pressure OT, great. Negative pressure OT is nothing where it is an OT where the coming air is minimized and the outgoing air is increased. So there is a negative pressure inside, and the outgoing the air is cleaned. And HEPA filters, which are high efficiency particulate air filters, can be easily installed. Our center started doing it very rapidly. MAMC I'm talking about, because at SGT my experience is only 20 days. Scavenging system should be upgraded. Most of our OTs don't have that. And the barriers can be created in a number of ways. There are hundreds and thousands of publications. Everybody, Dr. Bala himself has made a number of intubation boxes. His publication is there in the JOSCP. And people have created plastic screens over them, aerosol boxes with suction and so on. And a lot of people have, after the patient is on the table, have put a plastic sheet over the patient under which the circuit face and chest is all there, and the mask endotracheal tube are below that, and a suction is running underneath it. So the clean, so you can, these are the general things which you can customize to your center. Pre-oxygenation is the best possible thing if we can avoid pre-oxygenation. If we feel that the airway is absolutely fine and we should be able to handle it quickly, we can forego pre-oxygenation. But if we do want to give pre-oxygenation, then the surgical mask should be removed just before the face mask is kept on the patient's face. And then this should be connected to a closed circuit rather than to a Bain circuit and so on, which requires higher flows. So, and when you put a mask, between the mask and the circuit should be one HMEF, which is the heat and moisture exchanger filter. And if you look at this, this is the place where you attach the end-tidal CO2 monitor, and then there is another HME which you put when the expiratory limb gets into the circle absorber. Use two-handed mask ventilation for a tight fit, which I show it here on the figure, and you should use the minimum flow, which will keep the reservoir just full, and inspiratory CO2 should be 0. That is when you are able to give a good pre-oxygenation. The induction should be ensure adequate depth of anesthesia and complete muscle relaxation, so that our intubation doesn't become an aerosol generating procedure. And mask ventilation again is to be avoided, and rapid sequence intubation and induction and intubation should be followed in all cases. And oxygen which you give after muscle relaxant, when the muscle action is coming, again should be held in the same manner as I showed earlier, and keep the minimum flows. And the barrier and suction, as I've told, you can cover the patient with plastic sheet and run a suction underneath it, so that whatever leak is happening is not coming in contact with the healthcare providers. Laryngoscopy is the next thing which we do, and make sure that the patient, the first attempt is the best attempt. And to do that, it is very much underestimated, the patient positioning. The sniffing position, patient on the edge of the table, which you see here, and the head of the patient at the level of the xephisternum of the operator. The best operator must be doing it, and he should use the laryngoscope or the video laryngoscope he or she is most comfortable with. Don't try new things here, or become better in that. Learn it on a mannequin before you work on these patients. Adequate muscle relaxation, which I've already spoken about. The laryngoscopy should be done only when the muscles are, the laryngoscopy, when the depth of anesthesia is adequate, the barrier is in suction in place, and you should stand straight, and if you're required to see inside, bend backwards rather than getting into the patient. These are the two pictures from my theater, and of course, that is why I've hidden the person in the lower, because it is absolutely wrong. But a lot of us are seen almost getting into the mouth of the patient when we are doing laryngoscopy. That itself is a very bad thing to happen in COVID suspect patients. When coming to the intubation, so minimize the aerosolization and clear quickly. So the first attempt has to be best attempt, and it should be as fast as possible, not at the expense of the finesse. Don't lose the finesse. The finesse should be there, but still it should be fast. And once you learn it properly, it actually happens within a matter of 10 seconds. We all know that. And do it only when the vocal cords are absolutely still. And it's a good idea to keep the endotracheal tube clamped with a stillet. I prefer this because if you are using video laryngoscope, they have the habit of showing a beautiful picture on the screen, but the ETT will not go. So you have to use a stillet and keep it clamped with a stillet in place and bent to the liking of the person who is, especially using video laryngoscope. Even with the laryngoscope, I feel that slightly increasing the curvature makes it slightly easier for most of us for a first go. And otherwise, you can, if you don't want to put an ETT with a stillet, then ETT should have an HME attached to it, and the ETT should be clamped when you are intubating it to the patient. And if you want to use an external laryngeal pressure, OELM is optimal external laryngeal manipulation, or bougie, it should be low threshold. You should do it right in the beginning if you have the slightest amount of doubt. Don't go to the second attempt. And then cuff inflation should be done before you give the first IPPV breath, and confirm the tube position by ET CO2, because you can't probably use properly the stethoscope. Bilateral visible chest rise is much better, and you can check the cuff, the position of the cuff over the suprasternal region by pressing on the pilot balloon and feeling the ballotment in the suprasternal region. Very nice way to find out that you are in the mid trachea. So this is the laryngoscopy, which you can see, as I said, the positioning of the patient on the edge of the table and the level of the patient's head, as I said.
Sir, please cut it short. Sir.
Yes,
We are running
we are
short
going.
of time.
Yeah, we are finishing. We're finishing. So just look at the laryngoscope. He's bending only backwards, and when he's putting in the tube, don't get into the patient. And once you're done, you will inflate the cuff and go on. If the intubation fails, we should be ready. One team member should immediately now go for donning PPE if the full PPE has not, because we were dealing with a COVID suspect patient. So I don't expect that everybody should be wearing all the PPEs. So the person goes for donning PPE. The standby devices available should be just outside the theater. And they should be, I feel, my suggestion is a second generation SAD with an HMEF attached, a flexible fibroscope, a high flow nasal oxygen apparatus, and a scalpel cricothyroidotomy. And the suggested flow is that introduce the second generation SAD. That is what we are doing with an HMEF under the plastic sheet of that we have put in, or slide a plastic sheet snugly around the airway tube of the SAD and then introduce it, so that as the SAD reaches the final position, the plastic sheet is covering the mouth nicely and snugly. Then there is a suction catheter lying underneath. Inflate the cuff if only. So I feel that iGel and BASCA mask, which do not need cuff inflation, are better suited for COVID patients. And intubation through SAD under fibroscope guidance if it is absolutely must. And it is a good idea. Of course, a lot of people recommend not to intubate through SAD. I hate to intubate through SAD because I feel all SADs nowadays, second generation, are as good as intubation. But if you feel that you are an intubation centric person, then yes, then you can use, rather than going into the next step, which is of course, if the SpO2 drops at any time, tight fitting mask with OPA and NPA, and then apneic oxygenation and high flow nasal oxygen, only if the mask ventilation is ineffective and causing stomach inflation, which happens very rarely. But even if that happens, then we must be ready with the scalpel cricothyroidotomy. So to summarize, remember the general principles of aerosol bowl based contagions, which are these, and weigh the pros and cons of ideal situations, but which you are unfamiliar with. I feel that you should not try, even if near ideal situation with the familiar techniques is a better option. And finally, practice the new normal beforehand. That means simulation with a PPE on place, clear roles and responsibilities, the teamwork outside the theater before you actually go to the patient, and learn the sign languages to tell whether the patient is deteriorating or improving. And on behalf of my grandchildren who have started wearing masks now, she is the other grandchild who is going to her school with a mask on. I think we are all prepared for the new normal. And I again say that this is a great opportunity for anesthesiologists. So grab it with both the hands and do your best. Thank you very much, BJ Society. Thanks a lot.
Now I request Ajit Gupta sir to thank our speaker.
Thank you, Dr. Rakesh. It was a nice discussion and informative one. It is rightly said that it should be practiced and simulation should be carried on. It is really a matter of practice for the not only seniors, juniors, or even the paramedics should know how to act in the operation theater or in the similar situations in ICUs and places, so that they can save themselves and the environment of the operation theater and ICU nicely. Thank you very much, sir.
Thank you. Thanks so much.
Dr. Rakesh sir,
yes,
there's
sir.
a question for you, sir. Someone want to ask you your take on the use of what to use, either HME filter or HEPA filter.
No, HEPA filter is a filter for the air conditions and the air coming in and out of the operation theater. HMEF is for the tubes and for the supraglottic devices. It is a heat and moisture exchanger filter. These are two different devices for two different places, totally.
Okay, sir. The next question is, what is your stand on the use of the intubation box for intubating the COVID positive patient? Whether to use or not to use?
I told you, familiar with near ideal is better than ideal, but not familiar. So I have found a lot of people groping their way when they have used the intubation box, and they have torn their PPE in the process, when they went too close without realizing that there was a box right there. So a lot of people have started wearing a sheet over them, and that becomes easier for them. So whichever you are familiar with. I personally do not use an intubation box. I love to have the patient covered with a screen or a sheet, and underneath that transparent sheet with the suction running. I feel that most of my is right.
Thank you, sir. Thank you, Rakesh, sir. Thank you, Chairperson Dr. Ajit Gupta, sir. Now we'll start our last lecture of this session, and that is being delivered by our legend of anesthesia, Dr. Chakra Rao, sir.
Last.
Dr. Chakra Rao, sir. And to chair the session, our chairpersons are Professor Dr. Ashok Kumar. He is professor and head of the Nalanda Medical College, Patna. He was our ex-president, ISA Bihar Jharkhand. And another chairperson is Dr. D.K. Singh, sir. He is our president-elect, ISA Bihar Jharkhand. He is currently posted at BCCL Central Hospital, Dhanbad, as head of the department, anesthesiology and critical care. So I welcome my chairpersons, Dr. Ashok Kumar, sir, and Dr. D.K. Singh, sir. And I request Dr. Nidhi, ma'am, to kindly share the CV of Dr. Chakra Rao, sir. Dr. Ashok Kumar, sir, will introduce our speaker.
Hello. Hello.
Yeah.
Am I audible?
Ashok, sir.
Am I audible?
You are audible, sir. Sir, you are audible, sir.
I am audible to you?
Yes, sir.
Yes, sir. On your video, sir.
Okay. Thank you.
Yes, sir.
Good morning, everybody. This is my pleasure. This is my pleasure to chair this session, and our speaker is the great Dr. Chakra Rao, and he will talk on cardiopulmonary resuscitation in COVID-19 patients. Everybody knows that COVID-19 is a burning problem all over the world, and frequently we encounter cardiopulmonary arrest. So this will be a very good topic. regarding introduction of Dr. Chakra, it will be very meager. Words will be very meager for his introduction because he is a anesthesiologist of international repute. He served on the Pradesh government and retired as additional director, medical and health services. Presently, he is chairman resuscitation council, and he has great contribution to our society. He was national secretary of ours during 2008 and 11. He also served our society as national president during 2014. And he is a good friend of mine. I shall request Dr. Chakra to deliver his lecture that will be beneficial to everyone. Thank you, Dr. Chakra. Please have your lecture.
Yes, sir. Go ahead, sir. Chakra, sir.
Can I share the screen?
Yes, sir. Please, sir.
Okay. Thank you very much for inviting me. I am Dr. Chakra Rao. Our thanks for Ashok Kumar. Am I audible? I think. Am I seen?
Sir, you are audible or you must you need to share the slides, sir. You are audible, sir.
But,
I request everyone to please mute your mic. Please mute your mic. Please, everyone, please mute your mic.
okay.
Sir,
My
sir,
greetings
open your
from-
PPT, sir, first.
Yes, I'm in the PPT on that. Greetings from Kakinada. This is Lord Shiva. This is the stack. Can you see?
We can see your desk, sir. We can see your folders, but PPT, we are not able to see your PPT.
So, cardiac arrest actually, sudden cardiac arrest is more common than expected. Usually 4,280 cardiac arrests per 1 lakh population is occurring in India, and most of them they occur at home. Usually the cardiac arrest can occur at any time. It may be within the hospital or outside the hospital. When it comes outside the hospital, we make it.
Please help. Please guide.
So Indian Resuscitation Council, working from 2017, we have developed the Indian resuscitation guidelines to suit to Indian scenario. Now, as the COVID comes, can you hear? Can you see the PPT?
Yes, sir. Yes, sir. Please go ahead, sir. Please go ahead. It's
Okay,
right.
thank
It's
you.
all right.
This is one of the statues or a sculpture that was in Riga. It was because they wanted to pay some homage to the warriors of the COVID. So this was there. And next is I'm with our Prime Minister. There's got a lot of ideas of the new comings. And when I talk about the CPR in COVID patients, it is not much of differences except you have to stay safe. So, but a lot of steps that releases the aerosol that has to be prevented. So as everybody tells, we should be in a PPE, or we should cover ourselves, or we should cover the victim with a plastic sheet or a bed sheet so that we will not be the victim of the aerosol. So Another thing is we have very limited number of workers, and we have to need an isolated place. And COLS also can be done taking all the measures. And nowadays, I advise home CPR or home COLS to protect ourselves when there is a sudden cardiac arrest at home. Because I told you 80% of the cardiac arrests are occurring only at home. And first of all, you save yourself and you save your relatives. So teach CPR to everybody in the house. Next is CPR is high risky because it is generating a lot of aerosol, and chest compression is one of the biggest problems because you will be very close to the victim. And another thing is the airway management, just like Rakesh has told. Bag and mask ventilation also generates a lot of aerosol, and intubation, you will be coming close to the face of the victim, and the supraglottic airway insertion also is a problem. But here we have the core links for the resuscitation. We call it as CCLS. This is comprehensive cardiopulmonary life support. And we have to done first of all, when there is a cardiac arrest, when you have a cardiac arrest in the CCU, you are already prepared, you are already done with the PPE, and you should be able to recognize it early, and you have to manage the pre-arrest conditions. When you suspect any person is going to take an arrest, you try to prevent it. And you have to recognize it very early and call for a code blue. And after calling the code blue, you start high quality CPR. So what is high quality CPR? I'll tell you. So next is you immediately call for the defibrillator and defibrillate. Then the early comprehensive life support and the post-resuscitation care will go on. Next is avoid and modify. So whatever you are doing, your first and most important thing is a safety atmosphere for you, and you should be in a very safe condition trying to save the victim. Next is within the ICU, you keep only limited persons, only 3 persons. One will be doing the chest compression, another will be taking care of the airway, and another will be giving the drugs. And the other support to people will be outside regarding the loading of the drugs or making the records and everything. You have to do it outside. So this is the algorithm of the Indian Resuscitation Council for a CCLS. So I will tell you one by one. So you prevent and early identification. Whenever there is an issue, you prevent it and prevent the problem, identify it, and correction should be done whenever there is a possibility of cardiac arrest. So a suspect, a confirmed COVID patient is there and he had a cardiac arrest. Then you immediately, you are in a PPE, you check for the response, tap on the shoulders in his own regional language. If he is responsive, okay, good. You monitor him with a SpO2 and all the other things. Keep him in the recovery position and assess him every 2 minutes. And if he is non-responsive, activate the code blue. So immediately activate the code blue, ask them to bring the AED or defibrillator. Of course, in the hospitals, we have all defibrillators. Now, check the carotid pulse, monitor if it is attached, observe the breathing, and if it is not on a ventilator, and attach the pulse oximeter and oxygen if it is not there. So what happens is there are only 3 scenarios here. When patient is breathing, a victim is breathing with a definite carotid pulse and perfusion is all right, then you turn him to the recovery position and reassess the victim every 2 minutes regarding the pulse oximetry and the SpO2 levels. If suppose he is abnormal or not breathing well, but there is a pulse, then what you have to do? Secure a definite airway, give 1 breath every 5 seconds, preferably with a ventilator using a closed circuit and a filter, just like what he has told, and reassess every 2 minutes, including SpO2. Another is also abnormal and no breathing without a definite carotid pulse and the perfusion is not there. Then it is the time to start the chest compression, 30 chest compressions and 1 risk breath and 2 breaths every time, and you compress 120 per minute the compressions, and 1 breath you give with a ambu bag. Don't go for a mouth-to-mouth breathing, and or otherwise you connect it to the ventilator. Another is the patient is on ventilator without a definite carotid pulse and nothing. So turn the patient. Sometimes in the COVID ICU, some of the patients or most of the patients are prone ventilated for a better thing. So turn the patient to the supine if prone and start chest compression at the rate of 120 per minute. This is the difference which we have it in Indian resuscitation guidelines. When American guidelines tell 100 to 120, but we tell it is only 120. So the mechanical compression. So if there is a possibility, if there is an availability of a mechanical compression, there are 3 types of mechanical compressions. If you have one, you attach it and it will be compressing because you will be away from the victim. So continuous and previous ventilation with give 100% oxygen. So 50 cycles, 30 chest compressions and 2 breaths. And 2 minutes, these chest compressions will go on with a rate of 120 per minute and breath every 6 seconds. So as it goes on, the patient may recover, and if he is recovering, go to and the pulse and perfusion is good, then it is all right. Go to the recovery position and done. If it is absent, check the rhythm of the monitor, carotid pulse and all. If there is no monitor and all, if the pulse and perfusion is absent, then you have to go to the other thing again. Here, early defibrillation is most standard in compressive cardiopulmonary life-saving. So early, you have already tried all these things. Now you have to try for a venous access, airway, and drugs. Venous access, if not secured, of course, usually in the ICU, there will be a venous access. Do a video laryngoscopy, use a video laryngoscopy. If you are not very comfortable with the video laryngoscopy, don't try it. You use an ordinary laryngoscope and you use it and intubate the patient with all the techniques what Dr. Rakesh Kumar has told you, administer adrenaline and repeat it every 3 to 5 minutes. And what you have to do as antiarrhythmics, if there is a refractory VF or VPT, amlodipine 300 milligrams IV bolus and second dose may be repeated about 150 milligrams. Consider magnesium as a slow infusion if the patient is on hydroxychloroquine and azithromycin, torsade D points. So this is the thing, and always I tell you, I always advise you to prefer and ensure a high quality CPR. What is an high quality CPR? 120 compressions per minute and 1 breath every 6 seconds and with adequate recoil. That is most important. And what are the reversible causes? Identify and investigate. The cause of this cardiac arrest may be with something else. So these things you have to identify. So the post-resuscitation COVID care has to be done with the optimizing things. If no ROSC, follow the institutional protocols, what you are doing, and for handling the dead body. So if the patient doesn't recover, you have to handle the dead body safely, dispose and disinfect all the equipment used. So this is the important thing here is don't get infected, be safe, and otherwise the resuscitation is same like any other thing. So these are the reversible causes. like hypoxia, increased hydrogen ion, tension pneumothorax, toxins, poison, hypovolemia, electrolyte imbalance, tamponade, cardiac tamponade, acute coronary syndrome, rise intracranial syndrome. All these things you have to tackle, then only you can. If the COVID has got a QT prolongation with hydroxychloroquine and azithromycin, the susceptibles have to go for polymorphic VST. The torsade D point has to be. So airway, preferred tech, intubation is it is a must, and because you don't wait for the, otherwise there will be a lot of aerosol generation. The surgical mask has to be applied to the patient, and whether you use a box or plastic drapes or anything, you isolate yourself and isolate the victim so that there will not be any exchange of aerosol between you and him. Though the chest compression, I told you, you should be in PPE, and the aerosol generation should be stopped or should not reach you, and continue the compression till you have a secured airway. So I tell you, 5 cycles, 120 compressions per minute is a must. And if the carotid pulse is there, okay, you go for the other treatment, post-COVID, post-other treatment. If it is not there, continue the chest compression again. If the defibrillator is readily available, defibrillate the shockable rhythm. If it is a shockable rhythm, use the pads of an AED rather than the paddles of a defibrillator, because the paddles, you have to lean on the patient and hold it so that there may be a possibility of more contamination. So use a mechanical, I told you, there are mechanical devices available, but many hospitals we do not have. It is very expensive also. If the patient revived with the signs of circulation, follow the post-resuscitation care protocols, of course. And we are also coming with the entire protocols, making new. And if ROSC cannot be achieved after 20 minutes, stop CPR. There is no point in, and you can declare him as dead, and you have to proceed with the disinfection of the equipment and everything. And you have to do that process. The protocols to be followed after CPR is doping. Doping is the most important. It should be neatly, securely done. Most of the anesthetists are infected only because of the careless doping, and removal of the PPE and discard into a plastic bag, into a bucket. Clean the equipment with the recommended solution and recommend the use of more disposable equipment. No, don't try to reuse whatever you have used, you dispose them. So this is about the home CPR, which if you have some time, you see this, you train all your family members in this. Home COLS CPR. I'm Dr. Chakra Rao, Chairman, Indian Resuscitation Council. I wanted to demonstrate you how to save our friends and relatives against sudden cardiac arrest with your 2 hands. Every year, 4,280 individuals per 1 lakh population fall to victims to sudden cardiac arrest. 80% of these occur at home. In this COVID era, a greater number of cardiac arrests are reported. When you find anybody unconscious, immediately call for help, activate the emergency medical system, calling 108 on speakerphone. Identify yourself, your location, number of victims, mention their age and sex, and ask them to bring an aid. Don't waste time. This COVID era, don't try to check the pulse or watch for respiration, or don't try to. This is at home, outside the hospital. Mouth to mouth breathing. First and foremost is the cover the face and nose of the victim with a towel to prevent the spread of aerosol emission. Then kneel by the side of this victim, check for response. calling by name and tapping on the shoulders. Subbarao, 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 Subbarao. If he is not responding, then we have to start early compression. For early compression, identify the Chimpar process by palpating the lower border of the ribs. Place the heel of one hand and two fingers depth above with one hand and place the second hand and interlock the fingers. Deliver the chest compressions with elbows straight, shoulders vertically above the victim chest. Compress the chest 120 per minute with a depth of 5 to 6 centimeters. Allow adequate recoil to pump the blood. Count the compressions loud. 1, 2, 3, 4 till the ambulance arrive within AED. This is AED. See this, and you apply the balance. See this. These are the voice from the AED. So it is charged. The shock is delivered and the victim has responded, and as the patient has recovered, shift the patient to the nearest medical facility. Your two hands can save a life. Released by the Indian Resuscitation Council on an initiative of Indian Society of Anesthesiologists. Every citizen a lifesaver. Thank you. Thank you very much.
Sir, Dr. D.K. Singh, sir. Dr. D.K. Singh, sir, please thank our speaker, Dr. Chakra Rao, sir.
Thanks, Chakra Rao, sir, for your mesmerizing and informative deliberations.
Oh dear, when did you come?
We are highly obliged, sir. We are highly obliged, and this is our pleasure to hear from an international speaker like you, sir. Thanks again, sir. Thank you, sir. Thank you, sir.
Dr. Chakra Rao, sir, there is a question from Dr. Vijay Kumar Patna.
Okay.
How long we should do the CPR in COVID patient? Is there any time specified? Because it is an aerosol generating technique.
Yes, whenever it is possible, because it is aerosol generating, what is that? Any cardiac arrest has to be addressed immediately. So ideally is you should have a PPE. If there is no PPE, just as I covered with a towel or something like that, you do it. Otherwise, it is very difficult. Don't venture to do a chest compression without protecting yourself.
Okay, sir. Thank you, sir. So now we are at the end of this session. I must thank all our speakers and the chairpersons. Thank you all.
Thank you, Vijay Kumar Gupta. Thank you, Dinesh.
Thank you, sir.
Thank you.
Now I'm handing over the baton of ISA Bihar Jharkhand to Dr. Nidhi Chaube ma'am and Dr. Abhishek Basuki to smoothly run the panel discussion session. Welcome, Dr. Nidhi Chaube ma'am. Are you here?
Yes. Thank you, Dr. Sukesh. Our next session is a panel discussion on high flow nasal oxygenation, uses and advantages during COVID and beyond. It's my proud pleasure to invite our esteemed panelists for this session. Dr. J.V. Devatia.
Good morning.
Good morning, sir.
Good morning. Good morning.
Sir, I have to share my screen for your CV.
I think Chakra sir will have to stop sharing.
Yes, sir. Dr. J.V. Devatia, Professor and Head Department of Anesthesiology, Critical Care and Pain at Tata Memorial Hospital, Mumbai. He is the past editor-in-chief of Indian Journal of Anesthesia and at present President of Society of Onco-Anesthesia and Perioperative Care. He is past President of All India Difficult Airway Association and Indian Society of Critical Care Medicine. He has over 120 publications in various national and international journals. Welcome, sir.
Thank you. Thank you for inviting me. Pleasure to be here.
Our next is Dr. Anil Patel.
Good morning.
A consultant and yes, sir. A consultant anesthetist at the Royal ENT and Eastman Dental Hospital, UCLH and DAS. Professor of Anesthesia and Airway Management. He has played a key role in national and international roles in developing guidelines. Developing guidelines for airway management. He has received various international awards in the field of airway management. He is an honorary member of European Airway Management Society and has more than 130 peer-reviewed publications and 25 book chapters to his name. Welcome, sir.
Thank you.
Our next panelist is Dr. Honorary Secretary, Indian Society of Anesthesiologists, National Headquarters, Professor Anesthesiology and in charge pain management. His area of interest is pain management. He has been awarded the Excellence Award by ISA Bhopal. And he has two publications. His personal work is in the field of submentrofacial and retromolar intubation. Welcome, sir.
Thank you very much.
Moderator of the session is Dr. Sahai, Additional Professor, Department of Anesthesiology, AIMS Patna. His key areas of interest are BCLS and ACLS, airway management, and palliative care. He has total 35 number of publications in peer-reviewed journals, and he has won various awards at various platforms. I would like Dr. to lead the panel discussion. Thank you, sir.
Thank you, Nidhi. Am I audible?
Yes.
Vishal, yes, you are audible.
Okay. Thank you so much. Thank you, Nidhi. You've been kind to share my CV, and I'll take a snapshot of this Zoom meeting and put it on my CV next time. Sir, it is an absolute pleasure to be sharing the same screen as Dr. Devatia sir, Dr. Naveen Malhotra sir, and Dr. Anil Patel sir. For the uninitiated, Dr. Anil Patel, we'll start off with Dr. Anil Patel sir. He's the person who coined the term THRIVE and gave it to the world. THRIVE, Transnasal Humidified Rapid Insufflation Ventilatory Exchange, in his landmark publication in 2015 in anesthesia. So I think there might not be many better people, sir. Sir, what is the basic mechanism? There are a lot of people here who want to know what is the basic mechanism of action of high flow nasal cannula and how it works and why is it effective in hypoxemic failure, sir?
Hello, can you hear me?
Yes, sir.
Yeah. So there's a number of things that probably need just a little bit of clarification. So the terminology is a little bit confusing, and people use different terms for different aspects of high flow. So the first thing to just sort of point out is that nasal high flow is generally flow rates of over 30 liters or so a minute. There is no absolute definition of what constitutes a high flow, but over 30 liters per minute in most patients at rest will constitute a flow rate that's greater than the peak inspiratory flow rate. So that seems reasonable. In terms of what it actually is, I'm not sure if you can see my slide.
Yes, sir, we can see them.
Okay, so so it's been around for quite a long time. So this is some images from the 1960s in a preliminary communication in the Lancet. Really, it's taken another 30 years or so for the technology to be able to deliver what most people will regard as nasal high flow. So what it means is that there is a machine that will humidify and heat. It will then deliver a high flow, anything up to 70 liters or so per minute. And one of the key aspects is that the actual cannula itself is not sealed completely. It has to be open. There has to be some annular orifice around which there can be a release. If you imagine if it was completely sealed and you close the mouth, you'd get a very high pressure, build up of pressure. So the key things are that you need a machine to deliver high flow, which is heated and humidified. You need an interface with the patient that is not sealed, and you need to be able to have some form of tubing that will allow that heated, humidified oxygen or oxygen air mixture to get to a patient without it condensing out. So that is in essence what nasal high flow is, or what high flow nasal oxygen is. So I'm just going to give you a couple of things in terms of terminology, which I think are quite important. So essentially, I think you can physiologically divide all the applications of nasal high flow into applications where you're breathing spontaneously. So the patient is either awake or sedated but breathing. There might be an ICU but breathing. And then there is all the applications where the patient has been deliberately rendered apneic, so paralyzed by us. And if you're breathing spontaneously, there's lots of different terms for this. So nasal high flow is one term, but that is the same as a high flow nasal cannula, HFNC, which is the same as high flow nasal oxygen, which is the same as high flow nasal. So they're all saying the same thing. You're delivering high flow nasal oxygen through some device into the nasal passages, and the patient is breathing spontaneously. The differentiation is if you are apneic, where there's a suggestion that you're partially ventilating the patient. In other words, you're clearing some carbon dioxide as well. We don't really have time to go into that. You asked me to go through really what the different types of uses are. So Dr. Malhotra and Dr. Devachia are going to talk to us about the ICU uses. So that really precedes pre-oxygenation. So you have all the uses in ICU that we're about to talk about, but in an operating theatre setting or in an endoscopy type setting, these are all the sorts of uses that we can use nasal high flow for. So we can pre-oxygenate it, you can use it for pre-oxygenation, you can sedate a patient, keep them breathing spontaneously, and you can use it. You can use it during general anesthesia by keeping the patient breathing spontaneously. Of course, you'd have to use some form of TIVA technique. And if you render the patient apneic, for example, during a peri-intubation process to place a tube, then it's very useful because it extends the apnea time. And then there are very advanced uses that we use them for, which is for undertaking laryngeal procedures in paralyzed patients.
So,
Sorry.
Yeah, in your hospital, sir, for the operating room uses, what is the most common use that you use it for?
So we will use it for all of these uses. It's very useful in endoscopy suites, bronchoscopy suites, for preventing the desaturation that we sometimes see when we sedate patients. So it's a very good sort of safety, has a very good safety margin there. We use it for during apnea in the peri-intubation process. So if we have somebody who we think is a difficult intubation or a problem intubation, then it gives us extra time in that apnea phase. And then the advanced uses by some people are for extension of apnea times, for example, undertaking microlaryngeal procedures, upper airway type procedures in a paralyzed patient. So that's a sort of the remit of the operating theatre uses that we would use.
In a paralyzed patient, sir, if you were giving high flow oxygen, what is the normal duration up to which we can go? What is the time limit the patient gives normally and with high flow?
So it depends on the patient and it depends on their pathology. Our experience of, well, my own experience of approaching 1,200 patients having laryngeal procedures is of an apnea time of just under 30 minutes. So that's the average apnea time. So we are giving muscle relaxants, giving a propofol infusion, and we are undertaking laryngeal procedures for up to approaching 30 minutes or so. But that range is variable. So if you are morbidly obese or super morbidly obese, that range will be very significantly reduced. It may only be 5 or 10 minutes. But what we have realized is that whatever apnea time we think we are going to get, it will be improved by using some form of high flow nasal oxygen Thrive, either in the pre-oxygenation phase and during the apneic phase. So that's the sort of range we're talking about.
So with such long durations of apnea, sir, there is a concern regarding carbon dioxide accumulation. In your term, you described high flow nasal as a ventilatory exchange, Thrive. Is there any sort of carbon dioxide removal possible? And if yes, how is it possible?
So it is possible. Maybe I can flip to this slide here, which really describes the mechanism. So there's a number of papers that have come out now, either in terms of physiological studies with models or computational fluid dynamic modeling. And what they're essentially saying is that there are two mechanisms in play. One is the heart pump mechanism. So we know that cardiac oscillations, the heart pumping, will move blood through the pulmonary vasculature, and that will have a very slight pumping effect and movement of gases in the periphery through to the proximal airways. And we see that every day when, for example, we see the small oscillations on an end-tidal CO2 trace during exhalation. If you're apneic, generally those mechanisms will not clear carbon dioxide. But if you superimposed flow vortices from the very high flow that's taking place within the nasopharynx and the oropharynx, and those flow vortices get transmitted down through the trachea, towards the carina, towards the main bronchi, the interplay between those flow vortices and the cardiopulmonary oscillations removes some carbon dioxide. So that's the proposed mechanism, and there's been some modeling that suggests that. That may not be true for everybody. It may not be true in children, and it may not be true in some subgroups, but certainly in the adults that we see, there is undoubtedly CO2 clearance.
But these cardiac oscillations, sir, will that be enough to clear the amount of carbon dioxide being produced every minute?
No, so it's partial clearance. So this carbon dioxide will still creep upwards, but at a lower rate. So we still have to have either some time limits, or we need to recognize that it will creep up. But really, these are what we're describing is is very advanced uses. The extension of the apnea time is an advanced use for advanced users, for teams that understand the application of nasal high flow and Thrive. The principal applications, I think, are upstream. They are in obviously the ICU uses, which you're about to talk about. It's in the pre-oxygenation phase, it's in sedated patients, and it's in the peri-intubation process. That's really where the vast majority of the use, I think, is going to where it's being used for. The extended use is a highly advanced use that a small number of people will be applying it. But it's important because it gives us comfort around the mechanism, around the potential duration, around the fact that the technology will work in these extreme uses. But most people are not going to be using it for that. Most people will be using it for the earlier uses.
Right, sir. Coming to Devatia, sir, as Nil sir has mentioned, most of the high flow nasal oxygen maximum utility is in the intensive care unit, sir. So, Devatia sir has come up with a very massive publication in Lancet regarding in ICU management of COVID challenges and recommendations, sir. What has been your experience with high flow nasal oxygen in COVID, sir, at your institute, Tata Memorial?
Yeah. Morning, Nishant, and thank you for inviting me. Always a pleasure and honor to speak along with Dr. Anil Patel, who, as you mentioned, has introduced Thrive high flow nasal to the anesthesia community. It's been there in the ICU for a little longer than in anesthesia. So high flow nasal cannula, when we started off, there were two concerns with high flow nasal. One is whether it would lead to more aerosol generation or dispersal. And the other was whether, we didn't know much about how COVID pneumonia and ARDS would progress and whether we would actually end up delaying intubation too much by giving high flow. I think with experience now, both these concerns have been sort of addressed in favor of high flow nasal oxygen. We are now more comfortable giving high flow nasal without much fear of dispersal of aerosols because there have been some studies earlier done on SARS and also some recent studies, which seem to suggest that the dispersal is not as much as we feared. Also, one of the reasons may be that because there's so much humidification, so the water droplets actually make the aerosol heavier and does not lead to very distant dispersal. And also, if the patient tolerates a simple surgical mask, that will also lead to reduced dispersal of the aerosols. As far as delay in intubation, it's always a concern with any non-invasive technique. And whenever you put a patient on high flow nasal, you need to make sure that you catch a deterioration early and cut your losses and intubate rather than persist with high flow nasal oxygen. Having said that, we've had good results in selected patients who've done well with high flow nasal. So if we looked at our own data, which we looked at about on 31st August, we had about 70 odd patients, and of them 30 did not require intubation. So these were patients who just went on nasal oxygen. Most of them were on high flow nasal oxygen, only 10% died. So the mortality is pretty good, and it's quite easy, it's doable, it's comfortable for the patients and staff as well.
What is in your selected, as you mentioned, in selected patients, sir? So what is your selection, sir? When do you start high flow nasal? When do you go for when do you continue with the face mask or non-rebreathing mask? When do you go for high flow nasal?
So I'll be honest that we in the ICU, we do not take patients who are stable on oxygen, on face mask oxygen. If their flows in the wards go up to more than say 8 or 10 liters per minute, that's when they send to the ICU. There are some countries where even high flow nasal oxygen is given on the wards. But at least in our hospital, the protocol is if they require high flow nasal, then they come to the ICU. So we started pretty much on almost everyone who comes to the ICU after getting 10 liters or so on the wards. And so our initial respiratory sort of intervention would be high flow nasal oxygen. Of course, there are some patients who we would not use it in, say someone who was gasping, who was obviously arresting, or some patients who were very severely hypoxic. The PF ratio is somewhere between around 100 or maybe 100 to 150, but we would try to give it in pretty much almost as many as we would be comfortable doing it. Patients in shock, we would not do it. Patients who required multiple organ support and high vasopressors, again, you'd probably go in for intubation. But otherwise, we try to give high flow nasal to most patients who are referred to us.
So coming to the question, sir, again, if some patient is on high flow nasal oxygen, how do you monitor? How do you know that the patient is not doing well, and what is the cutoff limit when you intubate these patients? Is there criteria that you have fixed there?
So
monitoring.
Sorry.
Yeah, the monitoring part first, sir.
I think the monitoring is really clinical. We are looking at saturation. We are looking at the response to high flow nasal oxygen, and I think that is the key. Once you start high flow nasal oxygen, you can bump up the oxygen to 100% with high flow nasal oxygen. When we start, if the patient was hypoxic, we would give a high FiO2, maybe even 100%. But it's very important that you give them a high flow rate initially, because with moderate flow rates, you'll get CO2 clearance, which may be good for the dead space, which may be increased in patients with COVID. But if you need to have patient comfort and maybe introduce a small amount of CPAP in them, then you need to get your flow rate up very quickly, and we would go to 60, which is a maximum you can give from the machine that we have, 60 liters per minute almost as soon as possible, almost straight away. So if with these settings, if you're able to come down on the FiO2, you find the respiratory rate reducing, you find the saturations improving, then you can sort of persist with HFNO. Right now, and there are other things like heart rate, the blood pressure, all that. I mean, basically, you should see signs of the patient settling, or at least in the first hour, not deteriorating. If there is deterioration, you need to go ahead and intubate. If the patient is settling, you can observe for some more time. If you want to be really scientific and academic and you want to write a paper, you can use something called a ROX index, which is the ratio of the SpO2 to the FiO2 divided by the respiratory rate. And if it's more than 4.88 at any time, it gives you confidence that you can persist with high flow nasal oxygen. But then there are cutoffs, at 2 hours, 6 hours, there's a paper which we can mention. At 2 hours, 6 hours, and 12 hours, the cutoffs are a little less. If it's less than 2.85 at 2 hours or 3.45 at 6 hours, then you should intubate. But by and large, it's a clinical response of the patient that you judge by your usual sort of methods.
So, sir, how do you start in a patient? Like, what are your flow rates and what is your FiO2 when you start out? The settings, the relationship between the flow and the FiO2.
So I think you should aim to get your FiO2 as much as possible to maintain saturation. And if the patient was, say, you knew he was just about 90% sats on 8 or 10 liter flow, you can maybe give 70-80% oxygen. But someone just came with a pulse ox sats of 60% or 70%, we just give 100% oxygen. So give as much oxygen initially to make sure you're not making the patient hypoxic. And I think you can quickly bump up I don't think we'll go on a stepwise fashion of increasing flow rate. We'll try and give 50-60 liters almost straight away. Start with 40 and within a few minutes go to 60 liters flow rate, because I think that is the key. Because if you can't give enough flow, if you can, then not only you will not take care of the dyspnea, but you also get air dilution, and even the FiO2 that you set may not be actually delivered to the patient because of air dilution. If the patient's peak flow is much higher than the set flow rate, so you need to make sure that you're giving as high a flow rate as you can. And patients, by and large, tolerate it very well, even when they are hypoxic. And I think one of the big reasons is because the air is humidified and warm, and I think patients really like that quite a lot, and they take it straight away. So I'd go to 60 liters flow at 100% oxygen without
So what we monitor is the respiratory rate and the SpO2 while titrating the flows and the
heart rate and the pattern and the level of dyspnea. And it's basically clinical. I mean, there's no rocket science as such to it, but the key is is not to push it too long. Having said that, patients tolerate this pretty well, and we've given patients high flow nasal oxygen for days, and they've actually come around doing pretty well. So, but the deteriorating patient you need to pick up, because the more you delay in a person who deserves to be intubated, the worse is going to be your outcome.
Naveen Malhotra sir. Sir is working in a very big hospital at Rohtak, and sir is also involved in the advisory and position statements regarding COVID, sir. Sir, in your big setup, sir, what is your experience with high flow nasal oxygen in the COVID patient, sir?
Good morning all, and good morning, Dr. Devetia. It's a pleasure interacting with you and Dr. Patel. See, I can say that it is a lifesaver. Before COVID, our use of high flow nasal cannulation was very, very less. But in COVID, it has dramatically changed. And almost all the patients are in ICU are always given a trial until unless was contraindicated for mechanical ventilation. So patients usually in our setup also, they are initially admitted in triage and SDU. And there, obviously, they receive oxygen through nasal prongs and face mask. Once they are not maintaining with the face mask, maybe they require up to, you can say, 7 to 10 liters, and their saturation is falling, they are shifted to the ICU. Or somebody comes to the triage, as sir said, with a saturation of 64%, 68%, they are shifted straight away to ICU. And in our experience, we try to defer intubation and invasive ventilation as far as possible, except those patients who are gasping, hemodynamically unstable, and whom mechanical ventilation is indicated, we go for that. Because our response rate, recovery rate after mechanical ventilation, to be honest, is those patients, because it's a referral center, those patients who go on mechanical ventilation, recovery rate is less than 5%. So,
Yes.
but as far as high flow nasal oxygenation is concerned, we follow these patients are straight away put on 60 liters, and yes, I agree 100%, and within 1 hour. And then gradually, it is the call of the doctor on the field duty. The anesthesiologist who is on the field duty, the consultant, it is purely his call. He has to see how the patient is clinically comfortable or not.
So
But
what
yes,
should be reduced first, the FiO2 or the flow? What's the target?
See, we cannot achieve a torque flow in our machines also for more than 60 liters. So that is the maximum flow. But yes, once initially we go by decreasing the FiO2. How much is the FiO2 is decreased? First we go by decreasing the FiO2. At the same time, the thing which you have to remember is patients who are on high flow nasal oxygen therapy, they with slight teaching, they tolerate proning also very well. They get accustomed to adjusting their nasal cannula. The commonest problem which we have encountered with high flow nasal cannulation is that the nasal cannula may become slightly loose. So it should be properly fitted, and it should not be, there should not be much leak. Yes, permissible leak is there, but it should not be that everything is going out. And the patients usually, they are monitored clinically, and the doctor on duty on the floor who is seeing the patient takes a call.
Sir, in your experience, and you interact with the whole of the ISA all over the country, sir, what is the some advice or on the practical issues of high flow nasal oxygen which you would like our audience to know about? Practical problems that you have faced, some part.
See, there are few things. Few are about the machines, and few are about the setup. What practical problems we should be very, very cautious is that we should know how much is the oxygen flow for your particular setup. See, we all have liquid oxygen tanks involved, and the diameter of the tube. We should know each company has listed that you can generate this much flow. Suppose for a particular setup, there is that you can generate 1,000, you can extract 1,000 liters of oxygen per minute. So that means if your 15 machines are on high flow oxygen therapy, so you are taking, and they are on 60 liters of flow, you are taking away 900 liters per minute. And you have to also take into account that some patients may be on ventilator, some patients may be on NRM, some patient may be on venti mask or simple face mask. So you should know about your building, how much is the total oxygen extraction per minute. Otherwise, then you will be having pressure drops, and pressure drop alarms will be ringing. So always ensure it is not about the availability of the oxygen quantity. Your liquid oxygen tank may be full, but the gauge of the diameter may restrict. So please always keep in account that your total oxygen extraction is known to you. Second thing is that such patients, transportation is an issue. Usually patients who are on high flow oxygen therapy, we cannot get done on HRCT. We don't have portable HRCT in our place, though in some places HRCT portable is available. Also, these patients may require hemodialysis also frequently. So what we have done is that such patients we shift on NIV. We put the patient on NIV, stabilize for some hours, and then shift that NIV machine can be wheeled in, and we get a hemodialysis done on such patients. So these are the practical problems.
Many ventilators these days, sir, many ventilators, they have that option of providing high flow, sir. What are the options of providing high flow that are available in India currently, sir? Are there any standalone machines, or are there any more cost-effective machines that are available for high flow nasal oxygen, high flow oxygen provision?
See, in the institutes, we have got a high flow oxygen therapy with the attached with the ventilator. We've got Hamilton also, Drager also, and yes, they have been, the Fisher-Paykel system is incorporated into them, but Fisher-Paykel on its own is also providing standalone high flow oxygen therapy machine, Air VO2. And also we have got our indigenous from our anesthesiologist colleague of Vadodara, Dr. Amit and Dr. Peksh, that is WhoFlow 2. So yes, the persons who are working in Gujarat, after interacting with them, they say that it's working nicely, and it's economical also. The Fisher-Paykel one costs somewhere around 3 to 3.5 lakhs, and this one costs somewhere around 1.2 lakhs or so. The only thing which you have to remember is that the oxygen and air blender should be there. If you are not delivering 100% oxygen all the time. And the cost of accessories, the humidification chamber, the facility for your heated tubing, whether it is spiral or simple tube, and where the sensor is placed, temperature sensor is placed, whether it is placed near the patient end or not, inbuilt oxygen sensor is there or not, and whether you can digitally control the airflow and the FiO2 and regulate the temperature also. It's not a fixed device temperature. So the three, usually they come with 3 temperature settings, and you can obviously flow is.
Any idea about the cost implications, sir? What would be the cost of these machines? Any idea regarding the Gujarat model that you were speaking?
The Fisher-Paykel costs more than 3 lakh rupees. This costs somewhere around 1.2 lakh rupees. Accessories are the nasal cannula costs somewhere between 1200 to 1500 INR, and chamber and the heated tubing, the cost is extra.
Right, sir. Sir, this panel can actually go on for a long time, but we are running short on time, sir. We'd just like to wrap it up now. Going back to Anil Patel, sir, again, sir, just to conclude, sir, what do you see the future of high flow nasal oxygen, and why should we purchase a high flow nasal oxygen? I'd like you to address and conclude the session, sir.
So I think Dr. Devachi and Dr. Malhotra have described very elegantly the current uses of nasal high flow in intensive care. There's still question marks about exactly when you add it in, exactly when you stop it, and exactly when you move on to other devices. But it undoubtedly has a very significant role right now in intensive care practice. And that'll get refined over the years. In terms of outside of intensive care practice, I think we will see more and more nasal high flow use. I think for endoscopy type procedures or any types of procedures where we sedate patients and where we all know that there is a risk of desaturation or problems, it will add in a safety margin. I think in the operating theatre itself, I think in a decade's time, I think it will be a standard of care because it adds in an additional margin of safety in terms of a safety against hypoxia when we are doing things in an operating theatre, and that can be during the intubation process, during airway management, during whatever we do in an operating theatre. Our biggest fear, or one of our biggest fears, is hypoxia and sustained hypoxia, and things that we can do to try and limit that are very beneficial, and I think that's we will see more and more use. So that's where we are. I think ICU use will continue. out of operating theatre, but within hospital uses will increase. And I think in theatre use will increase as well. I think we'll look back in 20 years' time and say, why weren't we using it all the time?
Nidhi, do we have any questions on for my esteemed panelist, or should we ask just a...
No, I don't have. No, I have not received any questions from the audience. But one question from my side, sir. Which humidifier the HFO machine should be a built-in part? Because there are various type of humidifiers which come in those machines. Whether it should be a bubble type or heated plate type, or then purchasing that, what should be kept in mind, keeping in view the humidifier?
So I think the question of Nidhi, your actually voice was not very clear. It is, I think, breaking a little bit. What I could gather is that you want to know what are the considerations when we purchase a humidifier. Is that correct? The bubble type or the hot plate type?
Yes.
So any of the panelists want to answer that, sir?
Usually we go for the plate type, and which can deliver a humidity of 95 to 100%. And the temperature range usually for the tubing is 32 to 42 degrees. So we should be able to deliver a humidity of 95 to 100%.
Thank you so much, sir.
I think the key is heated and humidification, because 70 liters, if you give dry and cold gas, you will just slough off the nasal mucosa and maybe the respiratory mucosa. So heating is critical. I don't think a bubble would be adequate. You need a good, reliable heated humidifier. And there's one component which is crucial for safe and effective delivery of high flow oxygen. It's the humidification and the heating.
I think, sir, you will agree, without humidification, you cannot use HFO at all. Don't even think of using it.
So thank you so much, gentlemen. I think our time is up, Nidhi. The panel time is just, if it is possible, Divatya sir, just one final last comment, and there are a lot of administrators here, sir. Why should we purchase an HFNO machine? Why should small setup also? A small setup should have an HFNO. What are just a final remarks, sir?
So I think if you're even able to reduce the number of patients that you need to intubate by half, you've actually done quite a lot of saving in terms of staff, effort, and that sort of thing. Okay, so I think cutting down intubation rates and saving lives is probably quite important. So that's one reason why you should go in for HFNO. The only limitation I might say is, apart from cost, it's not that expensive. It's much less expensive compared to a ventilator. So that's another thing. Is in a small setting, if you don't have liquid oxygen, or if you don't have big oxygen banks, and you're relying on cylinders in the ward or cylinders in the ICU, even the big cylinders, is you might run out of oxygen. So you need to have a very, very reliable oxygen supply at all times. And if you've got, say, 5 or 6 patients running at 60 liters per minute, then you need to make sure you've got enough oxygen. So with that proviso, with that sort of caveat in mind, I think it's an excellent time-saving, cost-saving, and effective sort of device, which saves intubation, saves lives, and you can make do with slightly lesser resources. I'm not saying you don't need any resources at all, but maybe not as intensive as you might need with a mechanically ventilated patient.
Thank you so much, sir. Thank you so much, Dr. Devatya sir, Dr. Anil Patel sir, Dr. Naveen sir. It has been an absolute pleasure, sir. I'm sure we could have gone on for another 2 hours, but the time, we have to respect the time limits. Nidhi, I think I should hand over the stage to you.
Yes.
Nidhi, thank you.
Thank you.
Thank you all the panelists and the moderators for a very nice session. Now, moving on to our next session, I request Dr. Mahesh and Dr. Abhishek Chatterjee to kindly coordinate the next session. Thank you very much.
Thank you, Dr. Nidhi. Thanks to all the previous speakers. Good afternoon, all. I would like to request Dr. Mahesh, who is my co-coordinator for the session. I would like to request Dr. Mahesh to introduce the speakers for the session. Dr. Mahesh, sir, please.
Good afternoon, ladies and gentlemen. I welcome you all for this first web-based annual state conference of ISA WEBCON 2020 being organized by ISA City Branch Jamshedpur. In this panel, the topic of discussion is postgraduate anesthesia education in the change time. And the learned panelists are Dr. P.K. Singh, Dr. Pradeep Bhatia, Dr. Anjan Treka. All panelists are exemplary figure in the field of anesthesiology of the Institute of Best of our country, All India Institute of Medical Sciences. Dr. P.K. Singh is holding the post of director at the All India Institute of Medical Sciences, Patna. Dr. Pradeep Bhatia is holding the post of the head of the Department of Anesthesiology at AIMS, Jodhpur, and Dr. Anjan Treka is at Delhi, AIMS. The session will be moderated by Dr. Umesh Kumar Bhadani. Dr. Bhadani is the head of the Department of Anesthesiology and Critical Care at All India Institute of Medical Sciences, Patna. He is also the chairman of the scientific committee for this webinar. With that, let us welcome Dr. Bhadani here. I request all learned participants to keep your speakers in mute mode as usual, and will request our moderator and panelists to keep track of our timeline. Thanks a lot. Over to Dr. Bhadani.
Morning, everybody. I welcome. Today is the topic of panel discussion is we are passing through a pandemic and human being is fighting this pandemic, and we all teaching institutions has our postgraduate students with us. We are always worried how to deal with this pandemic as well as how to deal with the postgraduate teaching. So this is our panel today. Dr. Prabhat Kumar Singh, our director at AIMS Patna, Dr. Pradeep Kumar Bhatia, professor and head of Department of Anesthesiology at AIMS Jodhpur, and Dr. Anjan Trika, professor of anesthesiology at AIMS Delhi. So, postgraduate anesthesia education in the change time. This is the problem here. How to teach our postgraduate students. Dr. P.K. Singh is director at AIMS Patna. He is JECA fellow in 1993. He is trained in cardiac anesthesiology. Then he was professor of Department of Anesthesia in SDPGI Lucknow in 2002. Then chief medical superintendent in 2010. And now he is serving as director of AIMS Patna, and he is by core an anesthesiologist and a PG teacher. Dr. Pradeep Bhatia is professor and head of the Department of Anesthesiology at AIMS Jodhpur. He is members of Ethics Committee, editor of Indian Anesthetists Forum. I am knowing him since long and this editor. He writes many chapters in the book and he has got about 100 publications. Dr. Anjan Trika, he is not only a good anesthesiologist, he is now working in the Premier Institute of AIMS Delhi, and he is also suggesting government in this pandemic also how to go ahead. He is member of editorial board of 2 published journals. He has got about 200 publications, about more than 200 invited lectures, and he has written many chapters in the books. I welcome all the 3 panelists in this. Now I will like to invite Dr. P.K. Singh, sir. Sir, you are
Sir, you have to unmute yourself.
Yeah, can you see this?
Am I audible now?
Yes,
Yes,
you
sir,
are
you are.
Ah.
You are audible.
So again, good afternoon to everyone, and thanks to the organizer for inviting me and discussing such a important topic. Actually, when the pandemic started, the primary responsibility for everyone who's involved in the providing the medical care to the patient was only limited to the medical facility only or patient care activities. But great and all other activities which is attached to the medical education was put on a backyard. And now a lot of time has passed and we just cannot allow it to go further because we must find out ways that post-graduate education must be put into the place and it should not be allowed to affect it further. As far as the post-graduation education, there are two primary components or objectives that we acquire knowledge and at the same time we develop the skill to practice those knowledge and provide the and practice the specialty to help the patients. Somehow the education part we have taken care as far as the theoretical aspect and classes through e-platform, which we have been using for last so many months for the benefit of our students. So that part has been taken care very well. But postgraduate education is not like a MBBS education. It is more of doing practical work. It is more of working with the patients. And this is how we develop, learn new skills, or master those skills, and then we become a kind of a qualified practitioner to independently practice our specialty. But somehow this portion is completely neglected because of the reasons very well known, all of us, that we are not treating non-COVID patients for a very long time, and even if they are treating, their number is very less. And the whole experience comes to how many patients you actually deal on a day-to-day basis. So that part is certainly missing nowadays, and so we must find out ways out that how to provide a practical training to our postgraduate students. And unless we have start treating the non-COVID patients, perhaps we may not be in a position to provide adequate training to our students. The only way out is what I feel, that we consider all our non-COVID patients as a potential COVID patients. So we take all those measures to protect ourselves and protect our patients from ourselves and from the environment, hospital environment. So somehow we have to, now we have to come out that COVID is okay, but non-COVID are also to be treated. Not only they require a treatment, but at the same time, for the post-graduation education purposes, that is also very mandatory.
Thank you, sir. Now I will request Dr. Pradeep Bhatia, who is Professor and Head of Department of Anesthesiology at AIIMS Jodhpur. We are always worried, and our postgraduate students are worried about PG thesis. How to complete the thesis? We have distributed their topic. They are now worried that this COVID has come. I don't know for how long it will continue. How to complete our thesis work? So this is a very important and pertinent problem and question. Can you share some of your views how to go ahead with the thesis work in this change scenario? Dr. Pradeep Bhatia, sir, please.
Yeah, good afternoon, everyone. Happy to be in the elite club. So, see, the problem of the topics that should be given for thesis is there, definitely. But it can be circumvented, it can be solved in a few novel ideas. Say, for example, we can give a few of the residents the retrospective studies on the cases which have already been done in the pre-COVID era. So that is one, that can be one solution. Another, maybe we are regularly getting cases of trauma, cesareans. Few topics can be selected on these topics because there is no change in the number of cases of cesareans, I guess, because it will always be there, whatever the epidemic remains. So some topics can be given on COVID patients, on ventilatory management, critical care management, early tracheostomy, late tracheostomy, modes of ventilation. Maybe n number of topics can be selected. All those topics, all those studies which have been carried out in non-COVID ARDS can be carried out in the COVID ARDS patients. So to see the effect, whether they respond the same way that the non-COVID ARDS patient they do. So topics can be given, and still I agree that the number of cases, yes, they are much less, and it's difficult to reach the this total number of subjects that are necessary to complete a thesis. So the thesis can be time bound. Say, for example, we'll select all those patients who will be operated in next, say, 1.5 years. So we won't decide on the number of patients that our sample size is 150 or 100 or something. It will be a time bound. So because the sample size, of course, will be much less as a routine, because we won't get that many patients, and the power of the study can be low, but still it can be done in to select this type of cases. So that is how I think.
Excuse me, can we suggest our administrator and examination section, because we also don't know how long this pandemic will
Dr.
go.
Bhatia, we also this pandemic will go.
Yep. See, it has been discussed with the ethical committee, and I am also a part of ethical committee, and it has been decided that instead of the sample size on which the thesis is decided, it will be a time-bound thesis. Whatever the number we get in the next, although we have to have some rough estimate how many patients we may have in the next, say, 1.5 years or 2 years. But then, instead of number, it can be a time bound. So whatever number we get in the next 2 years, we will include all those patients in the study, whether it is cesarean, whether it is, say, chronic pain patients, whether it is a trauma patient, head injury or abdominal injury or whatever. So being time bound, the resident will be able to complete his, whether he completes 30 cases or 40 cases or whatever. So ethical committee has no problem accepting this kind of plan.
Thank you, sir. I will invite
Now, Dr. Ranjan Trikha. There are 3 domains of learning: knowledge, psychomotor skills, and communication. We request you to put some highlight that how these 3 domains training can be achieved in this change scenario, especially the psychomotor skill, because it is the work which has to be taught. Theory can be read from internet, from the books, but how our postgraduates in this change time? Dr. Ranjan Trikha, please.
Can you hear me, please?
Yes, sir. Yes, sir. We can hear you.
Okay. Okay. Thank you very much. Good afternoon.
Can't see you.
Okay.
Please put your camera.
Now I think. Now can you see me? Okay.
No, not yet.
Just a minute, please.
I believe you are tech savvy, Dr. Anjan.
Yeah, it's okay. I've been here since morning. In a different place. Right. Now can you see me?
Sir, we can't see you, sir. Not able to see you, sir.
Neither you or sir. We can hear you.
I think that would do.
Yes. Please
That's better. We can see you now.
Okay. Can you hear me now?
Yeah. Please go ahead, sir.
Okay, if you can't see me, that's fine. I'm sure all of you know me by face. I have some comments to make regarding what Dr. Bhatia also said, and I think if you allow me, we could talk on that also, because that becomes important.
Yes, sir. Yes, sir.
Can I make a comment upon the thesis if Dr. Singh permits?
This is open to all three.
Okay, we had a big discussion regarding all this at various forums here. And I think about even a couple of years ago, we realized that theses were turning into basically projects where the chief guides wanted to go all over the world and present them as their work, and or the candidates wanted to publish them to get their jobs. So we have already done it in certain MCH courses. It will be extrapolated to DM courses, and it's also on in certain courses in MD. That instead of doing a proper study and a research work with 100 patients, 200 patients or so, it's totally justified to carry out a kind of a audit which gets published, or write a meta-analysis which gets published, because what was decided was that each of the postgraduate student should know how about doing research. We could do a small project, that's fine, but in this pandemic, that's a big issue. They can't do any kind of research wearing those PPEs, I assure you. And the consenting as such, we know that it's a big issue. All the papers published by us, and I'm being honest and very frank, if somebody asks for a raw data and a consent from, I don't know what will happen to us. So we could think out of the box. We could do something else. And then I know in 83, 84, there were no theses in PGI Chandigarh, and then they were brought. So the kind of thesis which has to be written has to be thought about. Then I was asked about the psychomotor skills. Now that becomes a problem. And it's a problem more here with us because a couple of years ago, or maybe 1 year ago, the number of postgraduate seats were increased. There were so many people in the theaters. We have about, we counted the other day, even these in COVID times, we had 15 postgraduates of surgery and anesthesia and some other allied fields in an operation theater. So psychomotor skills have to be learned, and the only way to learn them would be on mannequins or simulators or something of that kind. There are online simulators available. Let's say we could have something to do with treatment of arrhythmias intraoperatively. So I'm aware of the fact that in Israel, the Anesthesia Society carries out a test for the exam where a person has to pass a kind of a simulation exercise so that they score well. Similarly, we'll have to work out strategies and think laterally to teach our students on mannequin, improve the mannequin structures. After all, we in anesthesia never try to, in the exam, we never try to ask a candidate, please give anesthesia and then we're going to rate you. There were some exercises done in cardiothoracic anesthesia, surgery which was stopped, and neurosurgery which are still going on, pediatric surgery and urology. I'm talking about the surgical field. But we never tested anybody in anesthesia because we insisted that 3 years of teaching program in a good college or as per the guides would be enough to learn the psychomotor skills of anesthesia. Now this is going to be a big problem, and it's going to go on for at least 1.5 to 2 years, if not more. So the only way out is that you will have to set up CMET facilities, or what kind of facilities. Government has paid medical colleges a lot of money. So let's set up your simulation systems. So starting from an RTL line, there is a simulation available for 40,000 rupees to 2.5 lakh rupees for putting an RTL line with varying pressures. Somebody has to put an RTL line in a systolic pressure of 80 or 120. He has to learn those skills. So this will become mandatory in the next few years, that anybody who passes anesthesia, we may not be sure whether he's put in a double lumen tube at all. But we are also obviously certified that he has learned how to put a double lumen tube or do single lung anesthesia in a simulated session. What Dr. Singh said was very important. We will have to start teaching them on whatever patients come to us. We have been treating only COVID patients. It's something like a lockdown. It's something like an economy. The government has realized that you can't keep the lockdown on. The malls have to open, the cinema has to open, metro has to open. Similarly, the hospitals will have to open. COVID or no COVID, you have to open the hospitals. So maybe that will help us. I don't know when will that happen, but till that time, like what Dr. Singh said, we will have to treat all patients and let our postgraduates go and learn on them. Maybe wearing a PPE like all patients, it will be difficult to give a spinal wearing a PPE. In my place, I have a dedicated theater. An average tracheostomy in an operation theater is taking about 2.5 hours. A tracheostomy in a theater which would take about 30 minutes is taking 2.5 hours. If you see a resident who gives a spinal for a cesarean, and we have done about 50 odd cesareans in the month of May, he insisted that he couldn't really see the space because of the fogging on the goggles. He said it was so difficult, he was going literally, he was never in the midline. So these are different scenarios, challenging scenarios, and we will have to let our postgraduates to learn on these kind of scenarios. I don't know, to do, let's say 50 cesareans in a couple of months is too less a number where the postgraduates can learn. But it is for us to realize, it is for us to go in and do the needful. Yes, sir.
Thank you, Dr. Trikha. Sorry to interrupt you, but again, you have to continue the assessment method, how to assess the postgraduates in this scenario, the examination part. And this is open to all three panelists.
Yeah.
One by one, they will have their say on it. And all of us
Maybe
are HOD and managers of the department. Please, sir, how to assess it to finally send them to the society.
Okay, I can start it because I have taken about 4 exams and conducted about 3 selection interviews. Exams is a bit of a painful thing because sitting that kind of a tachycardia which everybody has during an exam, sitting in a hall, asking the person to come in. What I suggest is that we have to be very strict now with these kind of scenarios for the theory papers. We should insist that the theory papers are taken very seriously and independent person corrects it. The marks are sent and tabulated because we all know that the theory paper always took a back seat as far as anesthesia exam was concerned. It was all about a long case, short case, and vivas. Now, even for a viva, you don't see a candidate. He's looking at you. At times there is a voice drop. There is a wavelength problem. So those things come in. So maybe we could give a big weightage or be very serious about taking care of the theory questions the way they've answered it. Have the questions which are very, very correct and pertinent, including all the. If you see, all 4 papers of theory have 4 different headings, but the recent advances paper, which is the 4th paper, could talk about anatomy also. So we have to be serious. They have to be checked by an independent authority. I think Gujarat and one more state are doing it, like they do it in DNB. They have to pass in your theory if you come for your exams. So let's make our theory very, very pertinent and very serious about it. The rest can opine, please.
Yeah. Pradeep Bhatia, your opinion about the assessment.
Hello. Yeah. I would like to take the argument given by Dr. Anjan forward. There's a lot of noise. So what we have been doing in the end semester exams also, and I believe that can become part of the this university exam also, is assessment using simulators also. Most of the time we have simulated difficult airway simulators. We have mannequins, and ACLS mannequins is almost everywhere nowadays. Then the resident can be asked to perform certain procedures on those simulators. And secondly, what we have been doing for the assessment is we asked to use the ultrasound probe to show the nerve plexuses on a volunteer, on maybe a ward boy. So just how he handles the probe, does he sterilizes that probe or not? And we can ask for which is the long access, short access, everything. So these things can be done. Even if the patients are not there, can be done on volunteers. They can be asked to show us the vessels and nerve bundles and everything. So, and on simulators, they can be assessed. This is my view.
Thank you, sir. Dr. Prabhat Kumar Singh, sir, what is your opinion about this examination or assessment for postgraduate students?
Assessment should have been a very continuous process in all the courses or teaching or training courses what we have. But unfortunately, we do not have that kind of a system. We do assessment on a periodic basis, but it doesn't get a weightage in the final examination, at least on paper. I agree with the Dr. Anjan Trikha in this scenario. Perhaps the giving a more weightage to the knowledge component is a better idea. At least we would know how much knowledge the guy possesses. And as far as his applications through skills or psychometric skills is concerned, there are ways and means to test all those skills, and that is possible. Only problem which I see for the post-graduation examination is the availability of a patient. those I think we can create a virtual scenarios for all those problems for long cases, for short cases, and those virtual scenario can be discussed with the candidate, and we can make a fair assessment about his knowledge of this facility as well as his decision making power in different scenarios. This is what we look for as an examiner.
Thank you, sir, all the panelists for your valuable inputs. Now, just we can summarize in 2 sentences that we should invest for scenarios and simulators in all of the institutes. And another thing, now instead of taking only one institute as a things, we should think for the whole town as a learning things. So some of the hospital may be COVID dedicated hospital, some of the hospital may be going with the usual cases. So we can combine the place for the examination rather than institutions. Thank you very much. Thank you the chairpersons, thank you the coordinators for this session, and thank you the organizers for giving time to very pertinent topic. Now, I am transferring the baton to the organizers here. Thank you very much.
Thank you, Dr. Umesh. Thanks all panelists. Yeah.
Thank you, Vadani sir. Thank you all the speakers, Dr. P.K. Singh sir, Dr. Pradeep Bhatia sir, and Dr. Anjan Trikha sir. Thank you, Vadani sir. We have only one question, but that question has already been answered by Dr. Bhatia sir. It was regarding the sample size selection, how a postgraduate can complete his or her thesis with the present scenario that most of the routine cases are not being done. But that has already been discussed in details by Dr. Bhatia sir. So can we move to our next session with our moderator's permission? We are just moving to our next session, and I am handing over the session to Dr. Alok Jha and Dr. Bhanu Pratap Swain for the next session. Thank you.
Before
Thank you,
starting,
Dr. Abhishek.
Dr. Bhanu, just give me 1 second. Before starting this session, sorry for the delay to all the delegates. Really very sorry. We are working to make the session run smoothly. Sorry for the delay.
Thank you, Dr. Abhishek, and very good afternoon to all of you. Myself, Dr. Bhanu, and along with me, Dr. Alok Jha, the coordinator of this session. I welcome you all to this ProCon session regarding chronic pain management on osteoarthritis knee. And we have got 2 legend speakers in the field of pain management. So before we start, a reminder to our viewers that they can ask questions at the end of this session using our YouTube and Facebook portal. Kindly keep your questions brief and short. So to start the session, I and invite our speakers. I welcome Dr. Srividya, herself physician, currently affiliated to Tata Hospital, Jamshedpur, as a senior consultant anesthesiology and pain management. Thank you. Over to you, madam.
Thank you, Dr. Bhanu. At the outset, I would like to apologize again for the slight delay that we are having. And so I'll quickly move on to introducing the topic. Since there are not many pain physicians working in the area of chronic pain management, I just brief overview of what exactly genicular nerve ablation or radio frequency ablation of genicular nerve is. Very quickly, I will like to just, just a couple of points. Now, osteoarthritis of the knee joint is a very painful condition, which commonly a pain physician encounters in his day-to-day practice. And depending on the radiological features, you have about 5 grades here. The earlier, the grade 0, 1, 2, 1 and 2, you have various modalities of treatment for that. However, in the higher grades, the 3 and 4, you will generally go for surgery. But what do you do generally with patients who have multiple comorbidities and are high risk for surgeries? Then that is where alternative pain management techniques are applied. So, and genicular nerve ablation, a radiofrequency ablation of the genicular nerve, is one of the most commonly used techniques. As you can see here, there are 4 genicular nerves supplying to the knee joints, and for the ablation of these nerves, you will need some modality to identify the nerves, and that is where ultrasound or fluoroscopy comes in. So the topic of debate today is whether ultrasound is the better modality for identifying these genicular nerves vis-a-vis the fluoroscopy. So today, for speaking for the notion, we have Dr. G.P. Dureja, who is the Director, Delhi Pain Management Center's chain of specialty hospitals. He is an extremely learned person in the field of chronic pain management, has written 7 books, published several papers in international and national journals. And to speak against the notion, we have Dr. Professor Ashok Jadon, who is the Chief Medical Superintendent and in charge of pain services in Tata Motors Hospital, Jamshedpur. He also has many publications, more than 80 articles in international, national, and index journals, and also has 7 chapters in various books. So, Dr. Dureja, you can start your deliberations now.
Okay, thank you very much, Sri Vidya, and I must thank Sharad for inviting me to this exciting session. But unfortunately, as Sri Vidya, you told me that there are not very many people in Bihar and Jharkhand practicing pain. I think it is a sad state of affair. There should be more people, and if you have such webinars or something which can stimulate people to become pain physicians, I think that will be great. And I am ready to help you out in organizing such webinars if you're ready. And Bhanu, you must also really work hard to get more people into pain, and Sharad too. So just coming on to the subject, as Sri Vidya has already mentioned, we are talking about patients with osteoarthritis who have a lot of pain. But I must tell you that before I start this debate, because it's a pro and con session, so my opponent may not say that we don't have an ultrasound, so I prefer fluoroscopy. This has a precondition that you have both the modalities, and now you have to choose between either of the modalities. So that's a precondition. So the debate goes when you have both the modalities. And as she has already said that there are lots of patients. This is one of the case scenario. It's a 74-year-old female with a VAS score of 8, severe pain in the knees, left more than right. And she's unable to walk without support for the last 3 months, suffering from osteoarthritis for the last 20 years. So you have these patients coming in because we have a life expectancy of about 70, 80 years in the urban population. So you will have more such patients coming to you, and you will have to do as pain physicians, give them pain relief. So she had received multiple injections of intra-articular steroids, not giving relief. She has a knee flexion deformity of about 30 degrees. She's on painkillers, which is not very good for this age group because it can cause damage to the kidneys. She's got no comorbid condition, but the only fact is that I would still have sort of persuaded her to go for knee replacement, but she refuses surgery, and you have to respect her decision. So the genicular nerve ablation essentially is meant for patients who are unfit for surgery because of obesity or ejection fraction less than 20%, hypertension, or diabetes uncontrolled, like the previous patient, unwilling to go for surgery, and all these things like steroids have not worked. And sometimes we are getting a lot of patients after TKRs and who are continuing to have pain. They keep regretting that why did we get this knee replacement done, because the pain has increased. And there are a number of reasons for that, like cutting of the nerves or central sensitization. So all these patients can be helped with genicular nerve ablation. Just to give you a brief about the genicular nerve, these are branches of tibial and common peroneal nerves. Are essentially sensory nerves. There's no motor component, and they innervate joint capsule and ligaments of the knee. So these are the structures which are responsible for pain, and they are being supplied by these sensory nerves, which are called the genicular nerves. And these are named after the artery. So this is very important because they are very close to the genicular artery, and that's why they call genicular nerves. And once you are doing ultrasonography, you have to identify the artery. So that's as simple as that. Once you identify the artery, you know the nerve lies next to it, and you can go in plane and hit the nerve and do either radio frequency or give local anesthetic. So that's one big advantage in favor of ultrasound being the best mode for such patients. Very important to know the nerve supply because we are fiddling with the joint, doing lots of procedures. So there are not 4 nerves, as Sri Vidya said, there are a number of nerves, but 7 important nerves. Altogether, there are 10 nerves which supply. Femoral nerve gives twigs to the nerve to the 3 vastus, medialis, lateralis, and tibial nerve gives 3 very important branches, superior and inferior medial, which we normally we don't block the middle genicular. And common peroneal nerve gives superior lateral, inferior lateral, and recurrent genicular. So these are again, we are blocking only the superior, and we are not blocking the other two nerves and obturator nerve. So it is essentially because we started doing with fluoroscopy that we were able to block three nerves. The other nerves we don't block because of the fear of inadvertent foot drop, because you may block the main common peroneal nerve, and that's it. That's the reason. Now, initially, radiofrequency was a technique used to partially denervate the knee joint capsule, partially because we were blocking only the three nerves, the superior lateral, superior medial, and inferior medial. We were not blocking the inferior lateral and the other three nerves, like the lateral reticular branch, middle genicular branch, and other two branches. So if you are not branching because of the fear of foot drop, that means you are still having some nerve supply, so you are partially doing the blockade and you are partially giving relief to the pain. Complete denervation is only possible if you're using ultrasound guidance, because you exactly identify the nerve and block it. So that is again a very important point in favor of ultrasound guidance. So normally what we do is we inject some local anesthetic. We do it twice. Two diagnostic blocks are planned few days apart to be very sure that yes, patient has had good relief, which may be more than 50% in pain reduction. And once you have done that, then this is a patient who is fit for going for radiofrequency ablation. So two diagnostic block, few days apart with lidocaine, identifying the nerve with ultrasound guidance, and then going in for radiofrequency. This is the procedure. Patient is placed in supine, knees flexed, pulse oximetry, of course, doing in operation theater, cleaning, draping as you do for any surgical procedure, and then you identify the three nerves. But as I said, if you're using ultrasound and if you can learn to block the other four nerves, the best thing would be to block all the seven nerves. You anesthetize the skin, and then either you place your local anesthetic needle or 22 gauge 10 millimeter active tape radiofrequency needle. So we'll just go into the procedure. Now, what is the difference between fluoroscopy and ultrasound guidance? Fluoroscopy guidance depends on the virtual anatomical location. So what you see is a needle, what you see is a bone, you don't see anything else. And regrettably, as I mentioned, is done only for three genicular nerves. We don't go for the lateral inferior because we are scared that it might block the main branches of common peroneal and cause damage, cause foot drop. So that's the reason. Because we were blind, we were just believing that this is the bone, this is the needle, and we are doing. So that's why we were avoiding blocking other nerves. But yes, there are now techniques which are available under ultrasound guidance where we block all the seven nerves. So that's a big advantage. And this is the study which I am quoting from India, from one of our pain physician, Arif, who mentioned that ultrasound guided, you can block all the seven nerves and give fantastic relief, considerable relief to the patient. Now, if you're doing under fluoroscopy, this is what you get. This is an X-ray. You pinpoint superior medial, superior lateral, inferior medial, and you put the needle there. You are not identifying the nerve. You may stimulate it by your stimulation of the RF mode, but ultimately it is only the bone, and you may not sometimes even get a stimulation of the nerve. So this is just to give you that you have to place the needle. Ashok will go into details of it, but middle of the shaft of the femur or the tibia, and you just think that yes, you are around the nerve. So you don't have any visualization of the neural structure. You don't have a visualization of the genicular artery. It is just a virtual anatomical landmark, and you block it. Now, under ultrasound guidance, you are able to see the neurovascular bundle. If you are a good ultrasoundologist, you can see the nerve. But of course, you see the soft tissue structures, the muscles, you see the bone, and most importantly, you see the genicular artery. And once you see the genicular artery, that helps you in accurately identifying the nerve. And most of the imaging now is restricted to ultrasound. We have forgotten about fluoroscope now for placing our ultrasound needles in genicular nerve ablation. And this is just to show you how we do it. Transducer is placed parallel to the long bone shaft, moved up or down to identify the epicondyle of the long bone. I'll show you some clips, which we just did one patient yesterday. I thought I'll record it and show it to you. The genicular arteries are identified near the periosteal area. this is important that there are a number of arteries there, but this particular artery is very close to the periosteum. And put a color and see the color of the artery over there by a Doppler. And then the genicular nerve block should be the needle has to be placed very close to the genicular artery, and all the 3 or 7 nerves can be easily identified using the artery as one of the identification mark, and the needle inserted in plane, not out of plane, but in plane of the ultrasound probe. And this is just to show you that you can see now this is the artery. So this is the periosteum, and this is the artery. Once again, I'll put this on so that you see this is the artery, right? And now the next slide. The next slide is going to show you again the flow.
Sir, you can use the arrow in the bottom, sir. Bottom of your screen.
Bottom of the screen. Okay. Okay, anyways. So I'll just show you on this. My slides not moving. Yeah. So this was one. And I will see this videos generally cause problems, you know. I'll just move this. So basically, just wanted to show you that you can identify just near the periosteum the artery, and then in plane once you go, you can identify the nerves easily. And that's how you. So I'm sharing it again so that this problem doesn't come up. So essentially, because you are identifying the artery and the nerve lies very close to it, your job becomes easy in terms of this has got stuck. So as I'll just move on to the next slides.
I request Anand to please help. Anand, please guide sir.
This
Yes,
we
sir,
can't
yes.
guide, no? It has got stuck on my computer, so.
Sir, can you press arrow, down arrow button, sir?
Which one?
Down arrow button, sir.
This one?
Sir, down arrow button.
So there is a resume slideshow on your screen, sir. You can
Okay. Yeah. On the.
Share your screen, sir. Share your screen.
Yeah. Okay.
One second, sir. I'll just take a control. Just give me control, sir. I can do that.
Okay. So as we were discussing that you can it got stuck, no?
Yes, sir. It is got stuck, sir.
Yeah.
It's okay, sir. You can continue.
Anyway, so it got stuck.
Yes.
Anyway, so basically just wanted to tell you about differences between the ultrasound guided and fluoroscopy guided, because the other two major advantages are that in fluoroscopy guidance you have if you're doing under fluoroscopy you have a lot of radiation which you basically do not get once you do under ultrasound guidance. And that is one very important benefits of doing these procedures under ultrasound. And as such, we pain physicians are exposed to fluoroscopy and radiation for a number of procedures, like we do spine procedures and we are exposed to radiation. So if you're doing under ultrasound guidance, you're not exposed to radiation. And not only you, but even the staff which is working with you are not exposed to radiation. And then, as I mentioned, the other advantage that the learning curve of using an ultrasound machine is very small, very short, and you can, because as I showed you, you just place the probe, and what you see is the periosteum, and you feel the artery, and that's it. Well, you have to just place the needle in line. You will be reaching near the artery, and you complete the procedure. Either you put local anesthetic, or if you have a RF machine, you stimulate, and then you do a radiofrequency ablation. Unlike fluoroscopy, where you have to keep moving and you are more exposed to radiation. And then, as I said, that you can block all the 7 nerves. So if you are good in ultrasound, you can identify the other 3 nerves too, without causing any injury to the major trunk of common peroneal or tibial nerve, and block other 3 nerves, and you can produce a complete block and give complete relief to the patient. So basically, why I spoke in favor of ultrasound was you don't have radiation exposure, you can block all the 7 nerves, easy to identify the genicular nerve because you have a landmark of genicular artery, and then obviously because of so much of advantages, I will obviously prefer to go for ultrasound. Thank you very much for patient hearing. Thanks a lot.
Thank you, sir. Now I invite Dr. Ashok Jadon to start his deliberations, and he will speak against the motion.
सर अनम्यूट कीजिए सर, जाडद सर अनम्यूट कीजिए.
Yeah, I've unmuted.
Yes, sir.
Is it visible?
Yes, sir.
My screen is on?
Yes, sir. It's flat, so, sir.
Yeah. So good afternoon.
Yeah, we all can see and listen to you.
Yeah, good afternoon. This
please.
is not the debate kind of thing, as Dr. Dureja has started his topic and said both the techniques are complementary to each other. And it is always having a benefit, taken the benefit from both the techniques. And he has already started ball rolling. So I will not go into deeper details of the technique per se, but I will just protect the interest of fluoroscopy for the genicular nerves. So the roadmap for my presentation will be that I will be talking about the historical perspective and of course present and future prospect of the fluoroscopy. I would like to say why fluoroscopy is still being practiced when the Ferrari is there. What is the role of Maruti 800? What are the shortcomings of fluoroscopy and how we can overcome? He had mentioned 3-4 points, so I will refute all those 4 points, how we can overcome those limitations. And I would also like to mention here what are the limitations of the ultrasound, which limits the use of ultrasound, and how to create a win-win situation, and to conclude in the last. We all know whatever we know today about the genicular nerve ablation. It all started with the landmark publication by Choi in 2011. So it is started in 2011, and now it is in 2020. People are still practicing the ablation through fluoroscopy. And here just I want to highlight one point, very important issue, that even with the fluoroscopy, the effect is lasting for 6 months. There are hardly any study in the ultrasound which claim the effect lasting up to the 6 months. We all know that the RCT is having the backbone of our evidence. Whatever we talk in today's science If we have RCT, definitely everyone will accept it. And as you can see on the right hand side, there are many RCTs which are claiming the benefits of fluoroscopic RFA in the genicular nerves.
तो आलोक ये क्या चार्ट सेक्शन में आएगा क्वेश्चंस वगैरह?
Should I continue? Somebody is asking something. Not only the RCTs, the meta-analysis published in 2020 is said that the effective treatment is definitely RFA for OA. 74% people have more than 50% relief even at the end of 6 months, and the procedure is relatively safe. So one thing is sure, it is effective and it is safe if you do the RFA with the fluoroscopy. Now I come to the next question, why people are still using the fluoroscopy. So as you know, this is the picture taken from the original article of Choi. There is a very simple procedure. You know the definitive anatomical landmarks. This is a consistent anatomy, the target nerve, and it is very easy to say. So first doubt what Dr. Dirija has raised, there may be a variable anatomy. I accept it. There is a variable anatomy. But how we can overcome? Definitely we can overcome by increasing the size of the lesion, which can be done either by cooled radiofrequency or by using a bipolar technique, which we have already done and published. This is not the only region the fluoroscopy is being done. There are other regions. We all know the osteoarthritis is very prevalent disease. About 22 to 39% old patients are having the osteoarthritis. And what is the availability of ultrasound? We all know there is still existing lack of concept. Organizers, administrators still ask what is the use of ultrasound for you anesthetists and for the pain physician. So there is a resource limitation. And even if you get it, there is a lot of legislatory issues like PNDT Act, and you are unable to get the ultrasound. And it is not easy. He said it is a very simple learning curve, but to locate this is a very high-end practice to locate the genicular nerves by ultrasound. So I would say it really required a very high level of skill, and there is definitely a learning curve. Last but not the least, obesity and the patient who are already haven't had the surgery, there is a distorted anatomy, definitely ultrasound has the limitation. Now, again, what is the status of ultrasound? I'm not talking about the ultra mod high definition ultrasound. Even we have ultrasound, it is a normal equipment which has a normal efficiency to locate the targets. So it is still a surrogate localization. He said it was surrogate localization in the fluoroscopy. I would say in ultrasound only. Ultrasound also it is a surrogate localization because we see artery. We do not know to go anterior, posterior, medial, or lateral to the artery. There are only few reported case reports. He has given example. It is again a case series or small case report. Very few RCTs are done. And the RCTs which are available, they are also non-blinded. And most of the studies have used the dual technique. They have done the study with the ultrasound, but also use the fluoroscopy also for the confirmation. Now I come to the practical point. Practical point is who those are practicing know when you hold the probe and one hand probe and another hand the cannula, how to put the ultrasound probe, the radiofrequency probe in the cannula. It is very difficult. It becomes more challenging when you are using heavy cannula and probe like in the cooled RF. So it is really difficult. And as I already mentioned, obesity and the distorted tissue anatomy definitely is a challenge. Now I come to the published material. It is the earliest review in 2017 by Sari. And he just compared the ultrasound with the radiofrequency. At that time, the available studies, and what he found that the obesity was the hindrance and the outcome was the proficiency dependent. Means if you know the ultrasound, you are senior enough, your results will be good. And if you're a novice, the definitely result is not going to be good. Fluoroscopic guidance is really good if you are planning to do the cooled RF. As I said, cooled RF probe is very heavy. You have to have, sometimes you have to have both the hands for the putting the cannula. So that is the time the fluoroscopy is better. And he also mentioned that therefore fluoroscopy guided, the genicular nerve ablation will be the first choice. It is the 2017. So it is an old study. What is the 19? In 2019, this is again a randomized comparison where the fluoroscopy is again compared with the ultrasound. And what is the result? You can see on the right hand. There's hardly any difference. 1 month or 3 months, both are the same. Recently published a study in 2020 where the cooled RF was done under ultrasound, and just to recheck the position, he did the fluoroscopy. And you can see on the right hand side, whatever probe, whatever our legendary landmarks, the probes are exactly there. So it hardly matters whether you use fluoroscopy or ultrasound to get the target. Last but not the least, there is a radiation exposure. I again agree. Whenever we do fluoroscopy, definitely there is a radiation exposure. But is there every pain physician is going to suffer with the cancer or malignancy? I would say no. The exposure is calculated by Gray and Sievert. They are the very large, you can say, scale. So the exposure is calculated in the millisievert. And on average interventional fluoroscopy, the exposure is about 5 to 7 to millisievert. I have taken the three very commonly done and time taken procedure where the maximum, the exposure is 57 millisievert. And what is the dangerous limit? As you can say, studies have shown repeatedly that any exposure less than 0.1 Gray is higher than the sievert. So then there is hardly any radiation effect. And why this happens? Because body also overcome by healing, and there is no residual effect for the or the danger with the radiation exposure. Now I come to the latest thing. Why US said ultrasound identifying the different anatomy? I again agree. So debate is no more that you use fluoroscopy or you use ultrasound. What is that? The trans J and many now the cadaveric studies have shown these are not only the 3 nerves which we were hold on. There are many articular branches which we have to block to get the better results. So to create a conclusion win-win situation, I would say both the techniques are good and unique. They have definite potential and disadvantages. How we can improve? We can use ultrasound as a diagnostic block. As you rightly said, for the diagnostic block, you have to put needle here and there, and it's sometimes very painful to the patient. So it is easier to locate the genicular area. I would say not the nerve, but artery, and you inject local anesthetic. So you know that this block is going to be effective pain relief for this patient. And you can mark the point, and definitely you can use the fluoroscopy with almost 1/10 or 1/4 exposure. So the whatever danger of the radiation was there, that also you can take away. And for that, for increasing efficacy of the procedure, you have to use bipolar or the cooled RF. And the success is not dependent upon the ultrasound or the fluoroscopy. Success is dependent. You increase the number of the target site, whether you use ultrasound or the fluoroscopy. Thank you very much.
Thank you, Dr. Jadon. Dr. Dureja, sir, 2 minutes of rebuttal for you, sir.
No, I mean, basically, he has accepted that both the techniques are good. So how can he is not defending the fluoroscope. He's saying that both the techniques are good. And if you combine both of them, it is good. But I mean, I can only say that I would, at my age, when I'm doing 10 procedures, 9 under fluoroscopy, I would like to avoid the 10th under fluoroscopy if I can possibly do it. And he says that you cannot handle both the things together, but obviously you have lots of help with you nowadays. I have my students who just hold the probe and show me the direction of the putting the needle, show me the anatomy, sono anatomy, and I just put the needle with these. So that is one point which I don't really accept, that you have to handle both the things together. Obviously, when you are doing these procedures, you have to have help. Somebody has to operate your cooled RF machine also. Somebody has to really help you in giving you the needle. So you always have assistants, and they can help you out in in holding the probe, and you put the needle. Fluoroscopy, radiation, because you're not doing just one procedure in a day, you're doing 10 procedures. So I would like to limit my radiation exposure to the minimum. And then obviously, I mean, in the past, like 10 years or 15 years, we were doing everything under fluoroscopy. It was only in the last few years, like 5 years, that I have had the opportunity to get my ultrasound machine, and I'm seeing the difference because here I'm able to identify the nerve, I'm able to stimulate the nerve, and my differences in results vis-a-vis done under fluoroscopy are vastly different. I have not published them. These are like, I'm just telling you anecdotal, but not published so far, but definitely they are far better than once we're doing under fluoroscopy. And the limit exposure time was tremendous because you have to keep moving the needle, keep stimulating. You don't get the stimulus, again fluoroscope, and it almost 8 to 10 minutes of exposure time was there if you have to block 3 nerves on one side, 3 nerves on the other side, maybe even 15 to 20 minutes, which was pretty long. And then, of course, even in obese patient, I was finding that localizing the genicular artery was not difficult. If you have a good point of care machine, like we have a sonocyte machine, which is point of care, and identification of the artery was comparatively much easier once I was using this machine, even in obese patients. Yes, there is a little bit of problem once you have a patient with a TKR done, but then
Thank you, sir.
that problem
Thank you, sir.
exists. That problem
Dr.
exists in
Dureja,
a
sir,
patient.
thank you.
Yeah.
You have 2 minutes, sir. Dr. Jadun, sir, your 2 minutes of rebuttal, sir.
He is Guru. His word is the last word. And he said he also accepted. But I just want to tell, the message should not go wrong. If there is no ultrasound, even you can manage the patient. You can do with the fluoroscopy, which is more easily available than the ultrasound.
No, debate is not on no ultrasound. If you know ultrasound, I will definitely do under fluoroscopy. It is once you have both the things together. Debate is.
So I agree with that.
Yeah,
but one thing I just want to increase the knowledge of the audience also, that there are very recently published studies. Those were claiming that there is a variability in the anatomy. Now they have come up with the new ideas. Here you can see the new landmarks. They have been proposed by the cadaveric study, and they have also come out with the, even you add on some blind technique to capture more targets, and it is giving almost 100% relief as they claim. So what he said, if you have ultrasound, definitely you can utilize it. And also this will help you to reduce your radius and exposure if you have already marked the landmarks, and then to put the needle within a minute or so, and definitely you can reduce the exposure. Thank you, sir. Thank you very much, sir.
Thank you. I think, Srividya, the consensus is that we no pro, no con. Both the techniques are good, and if you can reduce your exposure by using fluoroscopy and ultrasound, I think that would be the best approach. So I'm not saying in favor of ultrasound. He is not saying in favor of fluoroscope. We can restrict our fluoroscopy radiation time by using both the techniques together, identify the nerve under ultrasound guidance, put your needle, confirm it under both fluoroscopy and this. And if you have problems, you can use both the techniques together or one technique together.
Thank you, sir. This is my point of view. And grow and learn with the technique each other.
Absolutely.
Thank you, speakers. Dr. Alok and Dr. Bhanu, are there any questions that our speakers can take?
You can ask Alok. You can ask Dr. Bhanu. Network is not.
We don't have any questions from the audience.
So,
as both of the speakers have got consensus that ultrasound guided is better, so we conclude ultrasound guided is better.
So, Dr. Alok, the session ended on a very conciliatory note, I would say, with both my speakers agreeing that both modalities together, probably when we get proficient enough on both modalities and using both of them together, would definitely be the answer and definitely be the roadmap for the future. Thank you, Dr. Dureja.
Thank you very much. Thank you, Srividya. Thank you, Sharad. Thank you, everyone, for inviting me to this very unique Bihar and Jharkhand society. And again, I'm reiterating that you must produce more pain physicians. Every city, every state needs pain physicians. Please. Hi, Shiv. How are you? I'm just seeing my favorite.
Another student.
Thank you very much.
Thank you very much. Thank you, Alok.
Thank you very much, sir. Thank you, Dr. Dureja. I'm sure there will be more people who will be stimulated to practice pain in near future in Bihar and Jharkhand.
Thank you very much.
And I now hand over to Dr. Alok and Dr. Bhanu to take over the session from now.
The next coordinator is our next coordinator is Dr. Nishant and Dr. Prabhat. First of all, I would like to welcome Dr. Siv. Sorry for the delay. We are running 15 minutes late, but my apology for this. I will welcome Dr. Nishant and Dr. Prabhat as coordinator for this session. Dr. Nishant and Prabhat.
Yeah, thank you so much, sir. And we are all excited and eager to listen to Dr. Shiv, sir. The best part is we do not need to introduce the two chairpersons now. They don't need no introduction. Dr. Brij Kishore Prasad, sir, a very highly respected anesthesiologist from Bihar. He's the president of the Bihar Jharkhand Society of Anesthesiology, ex-associate professor at Patna Medical College Hospital, Patna. And the other gentleman, Dr. Manoj Kumar, sir, he's the dynamic face of Bihar and Jharkhand, GC member of ISA National. He's the ex-secretary, Bihar Jharkhand Society of Anesthesia, and currently working as associate professor at the Medical College in Gaya. So I request these gentlemen to take over and handle the stage, sir.
It is my great pleasure to introduce such an eminent international speaker, Dr. Shiv Kumar Singh, sir. He is a consultant anesthesiology at Royal Liverpool University Hospital, UK, visiting faculty at BIDMS at Harvard Medical School Hospital, UK, specialty lead for the regional anesthesia at Royal Liverpool University Hospital. A faculty workshop on management of the different airway and Liverpool course and clinical management of chronic pain. He has more than 40 publications on varying topics in anesthesia and regional anesthesia. I heartily welcome Dr. Shiv Kumar Singh, sir. Kindly proceed, sir.
Hello, guys. Hello, everyone.
Hello, sir.
Yeah. Am I able to actually share my screen? Because I think it's sharing your screen.
Yeah.
Can you see my screen now?
Yeah, yes, sir.
I think thank you for the introduction, and thank you, Dr. Manoj and Dr. Prasad, for moderating this session. And I thank you, Dr. Sharad, for inviting me for this session. And thank you, ISA, Bihar and Jharkhand. I have no conflict of interest and I have no disclaimers. So I think happy hypoxia has been a issue with COVID, and this is what probably has led to a lot of deaths, because we had patients who were hypoxic but still showing no symptoms. And normally, if you actually have somebody who is hypoxic, they will be very anxious, and it is very stressful for the patient. You can actually see them, having air hunger. But these patients with, COVID, happy hypoxia, were like Buddhas. They were happily going around with saturations of in their 70s and 80s. So that was perplexing. So it is actually something which somebody get hypoxic, and they would actually hyperventilate, isn't it? And this we know from the alveolar gas equation, which we teach to all the postgraduates. Now, if you look at the PiO2, which is the barometric pressure into FiO2, the component that is constant, what is actually we can change is only PaCO2. So when we hyperventilate, we actually increase the postural pressure in the alveolus. So we increase the gradient from the lungs to the tissues. So that's what actually helps in hyperventilation. So it is the CO2 which is actually important. But when we looked at the COVID patients, these patients actually had saturation as low as 60%, and somebody who's got saturation of 60%, which equates to almost PO2 around 70 millimeters of mercury, you would actually run for the endotracheal tube. Okay, you would want to do. But what was interesting was these patients were actually maintaining their CO2, so they were not hyperventilating. So the normal response to hypoxia was not there. And they were seemed to be poorly responsive to supplemental oxygen. And we'll talk about this later on. So normally in normal patients, the consciousness is lost when the SpO2 is less than 70. And here you have patients who have the saturation of 60 to 70%, walking around coherent, absolutely clear-headed. And that was actually leading to late diagnosis and probably late treatment of patients. Now, these are some of the blood gases which was actually sent to various people, and you can actually see that PO2 67.3. Now, if somebody actually sees this, you are actually going to say, well, this patient needs intubation. But look at the CO2. CO2 is normal. Now, this does not correlate at all, because in hypoxia, you would expect the CO2 to actually go down because you will hyperventilate. Okay. This is another one. You actually see PO2 of 60, but PCO2 is 34. Okay. Again, PO2 of 67.3, PCO2 of 35.2. So the key to the conundrum was that it is CO2, CO2, CO2. Okay, why is the CO2 remaining like in normal range despite the hypoxia? What is actually causing that? Okay, this is what I'm going to explain about. Now, the other thing is that how come the patient were remaining coherent? They were remaining normal, even though they were hypoxic, because at PO2 of around 70%, patients should have been, unconscious, almost unconscious. And this is related to the cerebral blood flow. Okay. So one of the reasons why you actually get reduced cerebral blood flow is because patients who are hypoxic, they hyperventilate, they reduce their CO2, and CO2 causes vasoconstriction of the cerebral blood flow, and the cerebral blood flow is reduced. But in this COVID patient, the CO2 was being maintained, and because of that, there was no cerebral vasoconstriction. There was enough blood flow to the brain. The brain tissues were getting all the nutrients, and that's why the patients were actually happy and coherent. So there was no cerebral vasoconstriction seen with hypoxia and no unconsciousness in these patients. Now this is a happy hypoxia patient, and here you can see the patient has got a saturation of 61%. And the other noticeable thing is this patient is not on any vasopressor on his support. Heart rate is 97, a little bit on the higher side, and blood pressure has been maintained. So he's got an arterial line in. Okay. So what we're seeing is that the CO2 is actually maintained within normal range, and the mean arterial pressures has been maintained. And this is important because this means that there is actually because of the slight increased heart rate, even though if the stroke volume is a little bit reduced, cardiac output and arterial pressure is maintained, and so is the mean arterial pressure. And this is important to maintain the cerebral perfusion pressure. So mean arterial pressure is maintained. The ICP is not actually there. You can actually take ICP or CVP, whichever is actually on the higher side in this equation. Okay, so because the cerebral perfusion pressure is maintained, the patient are actually conscious and coherent. Okay, this is very, very important. And like I said, because there is no cerebral vasoconstriction, and the brain tends to get its normal nutrients, and it is getting all the all its nutrients. Now, when hypoxia occurs, because there is decrease in oxygen delivery, there is reduction in aerobic metabolism, increase in anaerobic metabolism, and this leads to local CO2 production. So this is what normally would happen in the brain in normal patients. But here, because the cerebral blood flow has been maintained, whatever hypoxia would have been happening locally, the CO2 which is being produced is being washed out. So there is no accumulation of CO2 within the brain. So when there is increase in CO2 in the brain, there is increase in production of carbonic acid, and this hydrogen ions, they actually stimulate the respiratory centers, and you would see increase in respiratory rate. So this is normal response you would see in hypoxia, but this is not happening in these patients. So as the CO2 actually, this is a graph showing the various PaO2 and how the, CO2 and ventilation is actually maintained. So when you actually have a PCO2 around, say, normal 35 to 40, with normal PaO2, then respiratory is normal. But as the PaO2 reduces, you actually see increase in the respiratory rate. And these are actually graphs showing the PaO2 and various CO2 curves. Okay, and we can see that as the PaO2 is low, at this PCO2 37, the respiratory is around 12 to 14. When the PaO2 is 60, with PCO2 of say 44, you see a respiratory around 18 or near to 20. So what we're seeing in these patients is that the patients are hypoxic, but the CO2 is being maintained. Okay, so that is very, very important. So this is showing in COVID, we are seeing changes in the lungs. There are changes in the vasculature, and all this should ideally stimulate the carotid body. So the peripheral chemoreceptors are in the carotid body, and the central receptors in the respiratory center, in the ventromedial medulla, but these are not getting stimulated. Okay, so there is something called desensitization of the peripheral receptors happening. The carotid bodies are not able to respond to this hypoxia. Okay, at the same time, there is depression of the central chemoreceptors. So there is no decrease in the CSF pH. Like I've said, because the cerebral blood flow is being maintained, whatever the increased CO2 is there locally in the brain, that has been washed out. And because there is no, depression of the central or peripheral chemoreceptors, patients tend to actually have, there is a slight increase in the respiratory rate. They have shallow rapid respiration, but despite being hypoxic, they're nice and happy. So when you look at this graph on the left side, when the PO2 is actually reduced, the firing in the carotid body increases. So when PO2 actually is around 70 milliliters of mercury, there should be lots of firing happening from the carotid sinus and the aortic bodies, which actually senses the oxygen saturation, but doesn't happen. So the peripheral chemoreceptors in the carotid bodies, they're not actually able to respond to this. So what is the mechanism of this? So at the lung level, we are seeing that there is increased amount of pulmonary shunting happening. Okay, there is a reduction in PO2, but like I've explained, despite the hypoxia, the patient have no dyspnea, there is no anxiety and no confusion, and this is because of the preserved cerebral blood flow, and this is happening because of the maintained CO2 levels. Okay, so the trick to, or whatever is tricking the brain or the carotid bodies, this is actually needed to be understood. What's actually doing that? In the lungs, we all know that they have ground glass, appearance. There is increase in the mucus secretion. So the stretch receptors are also not actually getting stimulated as much, and you do actually see slight increase in the respiratory rate, but it is not actually great. So what is tricking these sensors? Okay, so obviously this coronavirus. Okay, so the SARS coronavirus 2 is actually hijacking the peripheral chemoreceptors. Okay, we know that this is actually coming through the blood and is actually sticking onto these carotid bodies. Okay, and not allowing the hypoxia to be transmitted through the afferents. There is some role of hypoxic inducible factors. This is actually seen more in chronic hypoxia, where the hypoxia can lead to erythropoiesis, metabolism, and angiogenesis. But it is also said that there is some amount of down regulation of the hypoxic inducible factors as well. The other thing is that it is also known that the SARS-CoV virus 2 is neurotoxic, and this is evidenced by the loss of smell and taste. And there's a very interesting thing about that. So we know that the virus actually goes through the your upper respiratory tract. It can then go through the cribriform plate and attack over the olfactory bulb, so that there's a loss of the smell. But how come it is actually affecting the taste? So that's interesting, and that's because when you actually look at the ninth cranial nerve, the glossopharyngeal nerve, and the respiratory center, in the medulla, they actually are at the similar location, and the COVID virus is actually attacking them there. So if you look at the carotid bodies, this afferent is through the glossopharyngeal nerve. It passes through the petrosal ganglia, and so does your, the glossopharyngeal nerve from the tongue, the taste. So when there is hypoxia, these patients also lose their taste as well. Okay. So it's a common thing. If you actually look at these patients, they do not actually have smell and taste. They stop eating and drinking, and because they just can't feel that, and that is very, very important. So there is dysfunction of the peripheral chemoreceptor, one side. Also, there is a mediocre hyperventilatory response, and there is maintenance of PaCO2. These are key to the happy hypoxia. Okay. Because normally, if you have decrease in CO2, there's shift of the oxygen dissociation curve to the left to increase the hemoglobin affinity. Even this is actually being reduced. Because of the effect of the COVID on the lung tissue, there is increased shunting, there is increased hypoxia. Okay, but there is also something else which is happening at the at the vascular level. It has been seen that with COVID, there is microfibrinous clotting within the alveolar capillaries. There is changes in the endothelium. There is endotheliitis. Okay. And like I've said, there is reduced affinity of hemoglobin for oxygen. And because of these, there is increase in shunts happening in them. So that leads to further hypoxia. So on one side, we're having severe hypoxia. And on the other side, the carotid bodies, that is the peripheral chemoreceptors and central chemoreceptors, are not able to respond to that. So what is the treatment options? Okay. Now, this is one single graph which is most important in understanding the treatment for the COVID. So as the viral load increases, okay, so we're looking at the initial 2 to 5 days. This is the time when the patients need to be actually given antiviral drugs. Okay. So we reduce the viral load. We give around 200 milligrams on day 1, followed by 100 milligrams on day 2 to 10 in single daily infusions. Okay, this will reduce the viral load. As this is happening, if you look at the blue line, and that is the inflammatory response, the inflammatory response is going up. And look at the saturation. So initially the saturation are maintained, and as the virus load is going down and the inflammatory response is increasing, there are cytokines being produced, and people talk about, there is cytokine storm. You can actually stop that cytokine storm if you actually start them. When there is hypoxia, you start them on steroids. And it's important to maintain oxygenation. You supply oxygen, you do awake proning, and you can also use CPAP. Fluid and nutrition are actually very, very important. Like I said, patients lose the sense to smell and to taste. And because of that, they do not actually eat or maintain their hydration. And I actually said that there is actually changes in the endothelium, and that's why there is increase in amount in the initiation of coagulation cascade, and there is also increase in formation of clots, and that's why it's very, very important the patients are put on low molecular weight heparins. So maybe enoxaparin 40 milligrams for someone who's less than 80 kgs or 60. Now, using the simple protocol, okay, you can actually manage patients actually almost at home. or in the wards, you do not need to. So it's very important where you actually initiate the therapy. So this was overall what you do. What about the oxygenation? So using high flow oxygen is very, very important. And it's important that you do not actually start on very high flows and high temperatures. So you start with 25 liters per minute at 31 degrees for initial 15 minutes, and then slowly increase the temperature and flow. Okay, so that patient actually get used to this heat and moisture, and also to the increased flows. So if you want to actually make them comfortable, do that. Okay. Now, we have known that with high flow nasal oxygenation, it reduces dead space, it can wash out CO2, but that is not our aim. So it has been seen with electrical lung impedance tomography that using high flow oxygenation increases the and expiratory lung volumes, and it causes alveolar recruitment, and hence it can actually help in the thing. And you can use non-invasive ventilation with prone positioning. This actually helps. And this is how you actually see the x-rays. And why prone ventilation work is this is normal. This is how the ventilation perfusion looks like in normal position. But when you actually prone them, you're able to recruit the areas. Okay, so there are areas which are actually called the airway opening pressure areas reduce. The other things is we have seen that we do not want to wash out the CO2. So experimentally, can we also introduce a little bit of CO2 when you are actually giving oxygen therapy? And this is just a thought. The other things which can be used is acetylzolamides, which dampens up CO2. So you do not actually wash out CO2 that much and increase the PaCO2. This is another thing which nobody has probably tried. The other thing is trying to stimulate the respiration using chemical respirators like doxapram, which stimulate respiration. So can we do that with that? Okay. So SARS-CoV has challenged clinician academics globally because of the unique pattern of the symptoms they're presenting. This happy hypoxia has perplexed a lot of people. They say, why these patients are not becoming unconscious? Why are they happily walking around? And like I'm able to actually, I think, able to explain to you all why it happens and why it's important to monitor the oxygen saturation of patients. You need to introduce antivirals at early stages and only introduce steroids when the hypoxia set in. So as soon as the SpO2 starts going down to around 94, 95%, you introduce steroids, and you will be able to prevent the cytokine storm as well as stabilize the lungs. You're able to actually maintain the saturation and use non-invasive methods of giving oxygen like high flow oxygen nasal therapy or also proning. Okay. So thank you for listening to this lecture, and I'm happy to take any questions.
Thank you, Dr. Shiv Kumar.
Yeah.
Thank you, Dr. Shiv Kumar Singh.
Thank you, sir.
For upgrading our knowledge about hypoxia and baseline of the treatment of the COVID-19 cases.
Yeah.
Now I hand over Dr. Nishant for questions and anything more.
Hello. Thank you.
Yeah.
Thank you, sir. Very nice speech. Sir, there is one question.
Yeah.
Does COVID has any effect on thermoregulation?
No, we haven't actually seen that. I think that is not as widely seen as you would actually think. There is nothing of that sort been reported. Why have you actually seen patients shivering or something like that? We don't actually see them. What is important is that these patients, they tend to actually stop eating and drinking as well. And that's why it's important to actually make sure that nutrition is actually maintained, hydration is maintained, is like equally important. Like I said, they lose the taste and smell. Taste and smell are two important things why people actually eat. बोले ना चटोरापन तो tongue से ही आएगा ना. Yeah. So if you actually lose the taste, you are not going to eat. So in nutrition is very, very important. And that's important. And hydration. you need to keep them hydrated as well. Okay, so these two things. And other therapy, I think I'm not against any of these therapies जो grandma की और दादी और नानी की therapy होती है ना, कहते हैं कि भाई हल्दी वाला दूध पियो और इससे immunity बढ़ेगी. Yeah, these things are also equally important, and they are actually very important for psych. The other thing I forgot to mention, these patients, even though they are hypoxic, okay, they are very coherent. So they might be taking short rapid respiration. You can actually encourage them. And that's what deep breathing exercises can be taught to these people. Okay, so that's why those yoga thing, all these are actually got some science behind it. If people are not able to explain it, but there is science behind all that, that why we need to actually teach them to do deep breathing exercises. Okay. So the brain is actually playing, the COVID is actually playing tricks with our sensors. At the same time, it is actually playing tricks with the brain as well. It's good thing, it's making you happy, but if you actually don't actually treat that, we don't have to treat the happiness, but we need to treat the symptoms of what it's causing. So monitoring the patient is very, very important.
Thank you very much, sir.
Shan, there is a question.
Yeah.
Shan, can you ask or should I ask? Shan?
Yeah, go on.
Please ask, please ask.
Okay, there is a question from Dr. Rajesh Raj. The
Yeah.
question is there any role of prophylactic steroids or enoxaparin in non-hypoxemic patients?
Yeah, so enoxaparin, I think it is actually, I actually strongly believe in it, because even in patients who actually are asymptomatic, the virus, even though it may not cause symptoms, it does affect the endothelium. And it is now actually coming that we are actually coming to know that there are long-term effects of this endotheliitis which are happening. Okay. There are also patients which actually may not present with actually, cardiovascular symptoms, but they can actually present with even cerebral events, even with asymptomatic patients. So that is important. But steroids, no, no, no. Okay, you do not actually start steroids early. If you do that, you can actually cause more harm. The steroids need to be actually only initiated once the patient is actually the response, inflammatory response is building up. And when the hypoxia is setting in, that is the point. And that's why I said that when my first graph, that is very, very important. You need to reduce the viral load. So start them with antivirals. Make sure the nutrition, like I said, दादी नानी की दवाइयां शुरू कर दो, कोई प्रॉब्लम नहीं है उसमें, हल्दी वाला दूध और जो भी है चीजें देते हैं, that is fine, but monitor them, उनके oxygen saturation monitor. The moment saturation starts dipping down below 90-95, you still start them on steroids. Okay.
Sir, in the UK, do you prescribe any antiplatelets given the endotheliitis after this?
Oh, yes. Like I said, I've said that second part is very, very important. Is giving them, enoxaparin or any kind of low molecular weight heparins are very important. At home, we can also start. Patients can be started on even on aspirin as well. It's very important part. I think that's the most important part of the things. Like I said, there are only 2 or 3 things you have to take from this lecture. Is that yes, you need to monitor oxygenation. You only start steroids when they start actually showing hypoxia. Maintain oxygenation, maintain their nutrition, maintain their hydration. Okay, and yes, early institution of the antiplatelets therapy is very, very important, even in asymptomatic patients. So even though they're saying that it's not, but if somebody gets COVID, it's not going to cause any harm. That's one thing you have to take from that. But steroids can, but low molecular weight heparin or aspirin is not going to cause any harm to the patients.
Okay, sir. Yeah, I think that was very enlightening, sir. It was very, very enlightening. I mean, there was so much to learn from that lecture of yours. We are very thankful, sir.
Yeah, I have cut down on the lecture, but this lecture is actually in extended form, is available on my YouTube site. So if it's very important there's got a lot of physiology in it for understanding. So it's very good for postgraduates to actually listen to the lecture, so they can go on that anytime. It is available on my YouTube channel. Yeah. Thank you very much.
Thank you, sir. I'll hand over the stage to Dr. Neelam now for the corporate sessions. Dr. Neelam, ma'am.
Thank you very much, Shiv sir. Thank you.
Yeah, thank you.
Thank you, Shiv sir, for your wonderful deliberation. Lots to learn. And thank you, Nishant and Sharan. It's now time to acknowledge our official partners for this first WEBCON of BJSA 2020. As we are already running short of time, without any delay, I'll first invite our speaker, Dr. Pulkit. He is a clinical specialist with ResMed India. He has done his MD Pharmacology. He has got 8 years of experience in medical affairs and clinical research in pharmaceutical industries. Dr. Pulkit will be speaking on non-invasive ventilation. Dr. Pulkit, you can start your screen sharing, please.
Yeah, I have started it. Is the screen visible to you all?
Yes, okay.
Fine. So thank you, Dr. Neelam, for your for a wonderful introduction. At the outset, I am thankful to the organizing committee of IESA BJ WEBCON 2020, especially Dr. Bhadani, Dr. Sharad Kumar, and Dr. Neelam for their for allowing us to present from on behalf of ResMed. So I'll just quickly take you through what exactly we have in ResMed, and I think this is the app platform for me to introduce our new product, that is a non-invasive ventilator, premium non-invasive ventilator. So as ResMed, we are the pioneers providing solutions that help treating the patients and helping them keep out of the hospitals, let them stay healthy. The important point about ResMed is that we are the world's largest connected care devices. So all our devices, they are cloud connected. So it gives us gives the prescriber and the doctors to have follow up over online media, through online channels as well, where the patient has the minimum contact to the hospital, or the healthcare services in person. So virtually, even the patient can monitor. We have operations in over 100 countries. We are serving around 120 plus countries. The major therapy area that we operate into are the sleep medicine and the respiratory care. In respiratory care, we have non-invasive ventilators. So you all must be aware of our non-invasive ventilator range, namely Lumis, Stella, and Astral. So today I'll be talking more about the GA. It's a new non-invasive ventilators that we have launched recently in India. So it's a premium non-invasive ventilator. So this is something how it looks. Talking about the features, so it is indicated to us. It is a assist ventilator, and which is intended to augment the patients who are breathing spontaneously, and it is solely for those patients who are spontaneously breathing, specific and require mechanical ventilation. Specifically, those patients who have respiratory failure or chronic respiratory insufficiency, obstructive sleep apnea, and this is to be used in hospital or institutional settings. The intended weight that is for the patient should be it is indicated in those patients who have a weight of more than 20 kgs. The departments that can utilize this ventilator are mainly ICUs, the emergency departments when we need to transfer the patient from one department to other, and the pulmonology department. So coming on to the major features, because this is a premium or a high-end device, we have a maximum flow rate of 280 liters per minute. There is a very powerful leak compensation that is around 120 liter per minute. We have a greater range for inspiratory time from 0.2 second to 4 second. This can be achieved very rapidly and a stable pressurized. And despite having so many features, it is still very quiet or less on noise. The noise levels are less than 40 decibels. Another thing that I feel is important, because I was listening to the previous sessions, that might be important for our August listeners, is that it has a very high precision of air oxygen mixture, and the interfaces can provide a very high pressure oxygen or a low flow of oxygen. The maximum oxygen supply capacity is 180 liter per minute, and precisely we can control or adjust the oxygen concentration from 21 to 100%. There are a variety of modes that are available. So presently we have the model that we have in India. So we can have these 9 modes, the basic ventilation modes, the TVV modes, and the CPAV mode. I'll just show you a video, a quick 2-minute video to understand more about this. So just to reiterate, so the major departments that might use this product is ICUs, emergency department, for patient transfers, and the pulmonology department. And for further queries, you can contact my colleague Sukant Mahapatra, who's based out of Patna, and this is his number. We at ResMed, we work in close conjunction with the KOLs and the key opinion leaders across the industry, across the therapy areas, to provide the patients with the best-in-class care for respiratory medicine. So we would be happy to collaborate with you for any scientific or academic requirements as well. So that was about my session. Thank you.
Thank you, Dr. Pulkit, for your wonderful deliberation. And really, this non-invasive ventilators are in present scenario, they are the need of the time. And thank you for your lecture once again. And with this, we will move ahead to acknowledge and thank our other official partners. And I request Anand to start sharing this slide. The first ICJ BJ WEBCON 2020 thanks Fresenius Kabi for their continuous support. And they have helped us to go through. We are going through their logo and a small video.
At these times, nosocomial infections have a new meaning in the coronavirus pandemic. Nosocomial infections are the infections which develop to a previously healthy patient coming to the hospital for other treatment, but gets infected after 48 hours of admittance. This happens because the hospital and ICU settings have pathogens lurking in the atmosphere. These airborne infections can enter directly into the bloodstream of admitted patients through the IV bottle of saline administered to almost every patient. In In an ICU or hospital, there are multiple infections in the atmosphere, which through the poor ventilation and close patient vicinity, get transferred into the vein of the patient. Infusion systems are an important part of overall surgical and ICU care. These systems are either open or closed. All open systems or semi-closed systems that are fully not collapsible require an air vent to fully drain into the vein of the patient. Usage of the open systems, like plastic and glass bottles, can increase 54% of mortality rate due to hospital-acquired infections. The chances of contamination in an open system are 10 times higher than closed system, like the collapsible bag. Closed infusion system is superior to open system in providing prevention against hospital-acquired infections. Hence, it is now time to break this chain of hospital-acquired infections. Introducing the new innovation from the leaders in volume therapy worldwide. FreeFlex DEHP-free, non-PVC environment-friendly solution to infusion therapy. Sterilized at 121 degrees centigrade within secondary wrap, hence no re-sterilization required. It ensures maximum asepsis of the primary bag. FreeFlex bag is made of polyolefin and is water vapor resistant, so no adsorption of drugs on the inner surface of the bag. FreeFlex bag is self-collapsible bag and therefore does not require any air vent. FreeFlex bag has innovative infusion and injection ports, especially designed for safe and easy handling. It has rigid sterile injection and infusion ports. Therefore, force required to pierce is adequate, hence prevents needle stick injury. The ports are sterile and have tamper-evident break-off caps with color and arrow indications. Membrane below cover is aseptic. Disinfection of the membrane is not necessary. The ports are self-sealing to prevent leakage even after multiple spiking. FreeFlex has an excellent drug compatibility with over 40 commonly used IV drugs. Fresenius Kabi has TGA, WHO, FDA Taiwan, and NDA Uganda approved plants, which export to Australia. From the makers of innovative infusion system solutions, we offer you a range of fully closed system bags. FreeFlex Standard Solution, Kabi Light FreeFlex, Valu Light, Kabi Mold, Valuvan, and Kabi Solid. Together, we can create an infection-free world with FreeFlex, a state-of-the-art, award-winning innovative patented bag like none other across the market.
Anand, can we move ahead with the next logo and slide? Next company. Next. So our next official partners are Sonosite. The ultrasound, as we all know, is the point of care in the present scenario. We heard so much of lectures on the ultrasound guided techniques and the methods. So thank you, Sonosite, for always being there with us. The video now.
We find it in the everyday. Those everyday moments when we can be there. The hundreds of sunrises or hours logged on the move. It's those moments that make us, where the smallest things can make a difference. Our decisions and experiences, they shape us into who we are. They can take us halfway across the globe, to new places, places that we barely know. Within these experiences, we gain insight that allows us to remember that we are all connected. Like the ripple of a sound wave, our actions have the power to impact those around us. Our actions can save lives. Our tools, training, skill set, education, it all comes down to one thing: care. Care is about connection, the connection that is made with others. It's about having something that works right every time. And at the end of the day, we know that our job is done. We think, concept, and craft every element of what we make. The time has been spent and actions and decisions made that make it all worth it. At the end of the day, or the beginning of a new one, we are driven by ingenuity and fueled by the passion to innovate. It comes back to this, that those everyday moments are the ones that matter. This is to all of you that work hard every day to care for others. From saving a life to seeing a new one for the first time. To those that make the sacrifices, the hours away from home and time spent on call, all of you, your experience, your care, you make us who we are.
Thank you, Sono Site, for all the support. We move on to next logo and video. Thank you, Neon, for being with us in this first WebCon. Next logo, and please. Thank you for B Brown for their unconditional support. Next logo, please. Special thanks to Otuska for joining us and supporting us in this WebCon BJSA 2020. Next, please. I think we are done with the corporate session. Thank you, Anand. So we come to the end of the corporate session, and our special thanks from all the organizers, all the coordinators, all the moderators, to the participating companies, to the sponsoring companies for making this conference, the first virtual conference, a great success. Thank you very much. And without any delay, we move on to the next session of the guest lecture 3, and I request Dr. Rajesh Raj to take over. This session will be coordinated by Dr. Rajesh Raj and Dr. Neelam Sinha.
Okay, thank you, Dr. Neelam Sinha, ma'am. Good afternoon and a very warm welcome to all for this session. I think it's time for everyone to grab a cup of coffee or tea to freshen up. This session, that is guest lecture 3, has 5 very good speakers with some very interesting topics to cover. Each speaker gets 13 minutes to present. The first topic is asthmatic crisis by Dr. Rajiv Shukla sir. And to preside over this presentation, I welcome and invite upon Dr. Vijender Prasad sir and Dr. Alok Jha. Dr. Vijender Prasad sir is Associate Professor at Vardhaman Institute of Medical Science at Pawapuri and has graced many key posts of ISA Bihar, Jharkhand. We also have Dr. Alok Jha, a very renowned anesthesiologist and intensivist at KM Memorial, Chas, Bokaro, and GC member, ISA Bihar, Jharkhand. I would request Dr. Vijender Prasad sir to welcome and introduce Dr. Rajiv Shukla sir to the WEBCON delegates. Dr. Neelam, request you to kindly display and share CV of Dr. Rajiv Shukla sir. Dr. Vijender sir, you are not audible.
Please unmute your mic, sir.
Are you audible now?
You are audible, sir.
Yeah. Dr. Rajiv Shukla, Head Consultant and HOD Anesthesia, Tata Main Hospital, Jamshedpur. Ex-Honorary Assistant Professor, Department of Anesthesia, MGM Medical College, Jamshedpur. His area of interest is difficult airway and critical care.
इसके पहले सब बाहर का स्पीकर था, फिर कॉर्पोरेट सेशन किया जिस
Hello. Now, Dr. Rajiv Shukla is very good speaker. He is going to present on an interesting and informative topic, that is asthmatic crisis. Thank you. Dr. Shukla.
Respected seniors, fellow delegates, a warm welcome. Today my topic is asthmatic crisis. It's always an honor and pleasure to be presenting before such an august gathering, and especially for a momentous occasion like this, which is our first webinar of the ISA Bihar and Jharkhand chapter. Asthmatic crisis, we all know, and in the US alone, about 12 million people each year experience an acute exacerbation of their asthma, about a quarter of which will eventually be requiring hospitalization. It is a medical emergency, and it is basically described as an acute exacerbation of asthma which is initially unresponsive to treatment with bronchodilators. This causes bronchospasm, airway inflammation, mucus plugging, later on causing carbon dioxide retention, hypoxia, respiratory failure. Basically, it starts with an exposure to an allergen, or which triggers a characteristic form of airway inflammation. There is mast cell degranulation and release of many inflammatory mediators such as interleukin 3, 6 to 7, 8, 10, 13, and leukotrienes. Eventually, there's involvement of the mast cells, the neutrophils, and the eosinophils. And this is what leads to an early bronchospastic response. This is basically a mast cell degranulation, release of inflammatory mediators, histamine, prostaglandins, leukotrienes. There is smooth muscle contraction, and there's an increased capillary permeability. This is the state which is generally responsible to the beta-2 agonist therapy, the early bronchospastic phase. If we lose this phase, it goes on to a late, more ominous phase, which is called the late inflammatory response phase. This is now to increase mucus plugging, edema in the peripheral airways. This results in closing of the small airways and increased airway resistance. There is also an increase in the pleural and the intrapleural pressures, which will eventually cause a decrease in the alveolar perfusion because of the increase in the intrathoracic pressures. This ominous combination of atelectasis and a decreased perfusion would now result in a VQ mismatch. And this, along with the resultant hypoxia, will trigger an increase in the minute ventilation initially. The treatment goals are airway obstruction to be relieved rapidly by the use of aggressive early beta-2 agonist agents and corticosteroids. Correct the hypoxia by monitoring and administrating supplemental oxygen, and definitely prevent or treat complications like pneumothorax or, God forbid, respiratory arrest. The complications are hypoxemia, which could result in a hypoxemic ischemic insult, a pneumothorax or a pneumomediastinum, respiratory failure or a respiratory arrest, and a cardiac arrest. How do we approach such a patient? We basically should first start with an arterial blood gas. This is especially indicated if the PEF or the FEV1 is less than 30% of predicted, if the patient has got a progressive airway obstruction or is getting progressively fatigued, if the SpO2 is less than 92%. ABG would help us in assessing the severity of this attack. could help in substantiating the need for further care and may be somewhat helpful in determining whether we need to intubate this patient or not. This ABG can, if properly interpreted, would help in further assessment the severity of the attack. A breathless patient with a PSCO2 of 45 is an omnious patient. He must be transferred, he or she should be transferred to the ICU for further care. However, fortunately, less than 10% of such patients usually report with the CO2 levels of more than 45 or PO2 levels less than 50. There are 4 stages of these patients. The first stage, the PSCO2, is decreased because of the hyperventilation, which I had said before. As we go on to the 3rd and 4th stage, the PSCO2 would be normal or would be then high, as smaller units will start to shut off. The PO2, which was initially normal in the stage 1, would now progressively start to decrease because of the ensuing hypoxia, because of the VQ mismatch, and later on would be decreased in the stage 4. Stage 4 is the most omnious stage with a PSO2 which is high and a PO2 which is low. And this is going to culminate in an imminent respiratory failure if not treated exactly. Hello?
Continues.
Pulse oximetry, monitoring. Yeah, okay. Monitoring the patient by pulse oximeter is extremely important because we all know the primary cause of death is hypoxia. We must aim to meet a saturation of 92%, and in pregnant or cardiac patient, it should be tamed at 95%. X-ray chest is vital. It could rule out pneumonia, pneumothorax, pneumomediastinum. COPD may be congestive cardiac failure, and especially important for those people who are not responding or those who have an atypical presentation to start with. PEF or FEV1 are important. If a PEF is less than 20%, it means impending respiratory failure or a severe airway obstruction, and same is true for an FEV1 of less than 25%. However, the practical application of this would be doubtful, as these patients are usually unable to perform this because of the breathlessness. Electrolytes and glucose extremely important. We could be looking at hypokalemia because of concurrent use of beta-2 agonists. A low pH could also elevate the potassium transiently. Because of the stress, beta-2 and corticosteroids, you could get hypoglycemia. However, in children, because of stress, they present frequently with instead hypoglycemia. CBC would be looking at infectious cause. If it is raised, definitely there was serum lactate, and there could be a demargination and an increase in peripheral blood count of the WBC straight of the WBC arm because of the use of concurrent beta-2 agonists and the corticosteroids. This is a very simple chart which basically says that how do we assess the severity. We are looking at the last 2 subsets, which is the severe and the life-threatening forms of the asthmatic attack, in which it is important if the patient is dyspneic at rest, could not speak full sentences, a PF is less than 40, he comes into the severe category. There are many patients who would be coming with a life-threatening form, too dyspneic to even complete a word or so, perspiring, a PF, if possible, would be less than 25%. How do we treat such patients? Our primary treatment is oxygen. We should also give short-acting beta agonists by the nebulized form preferably, anticholinergics again by the nebulization form, and corticosteroids. We must administer oxygen to maintain a saturation, like I said, of 92%, and in pregnant and cardiac patients more than 95%. Beta-2 agonist is the mainstay. It is the first-line therapy. They act by stimulating the cyclic AMP, and by this they cause bronchodilation. Ideally, it should be given by continuous nebulized aerosol way, and it is most effective in the early asthmatic phase. However, patients on long-term inhaled beta-2 agonists could exhibit some resistance. This is extremely important. SABA or the short-acting beta-2 agonists, and the guidelines currently recommend that we only use selective SABAs in high doses, that is albuterol and levoalbuterol. Initially, there was a lot of work on salbutamol, but these are the 2 drugs of choice because of the risk of cardiotoxicity, and many patients are elderly and asthmatic, so we would like to use these albuterol and levoalbuterol preferentially. We should also use a nebulizer because many of these patients are unable to cooperate using an MDI because of their severity of the asthma or their age or their agitation. And continuous nebulization should always be considered because this has an evidence of reducing the hospital admissions and improving the pulmonary function of such patients. How do we give it? In children, albuterol is nebulized at the dose of 0.15 mg per kg. You could repeat that every 20 minutes up to 3 doses, and thereafter every 4 hours in the dose of 0.5 to 0.3 mg per kg. In the adult, it is nebulized at 2.5 to 5 mg every 20 minutes, again up to 3 doses. And thereafter, every about 1 to 4 hours, you could give 2.5 to 10 mg. The newer drug, which is the levalbuterol, which is the R isomer of the albuterol, is basically at half the dose of albuterol it could be used. And this is given in the dosage of 0.63 mg to 1.25 mg. And levoalbuterol has got lesser side effects, and because it also has, the doses used are much less, it is found to deliver comparable efficacy and safety. However, studies for continuous nebulizations have not been evaluated for the same. Beta-2 agonists, if you do it well, it shows to improve the pulmonary function test, reduce hospital admissions with no differences in pulse, blood pressure, and tremor. There was a time that we used high-dose albuterol, 7.5 mg every 20 minutes, and there was some work on intravenous beta-2 agonists. This, however, doesn't appear to be beneficial and is not recommended. Anticholinergics suppress the conduction in the vestibular cerebral pathways, inhibit the parasympathetic nervous system, help in decreasing the mucus production and improving mucociliary clearance. These work better in children because of the preponderance and more cholinergic receptors in this age group. Ipratropium bromide is commonly used. It doesn't cross the blood-brain barrier. The dose is 500 micrograms, which you can nebulize every 4 hours. And the good part is that it has a synergistic effect with the beta-2 agonist and albuterol. It's also a very good alternative if a patient has intolerance to inhale beta-2 agonists. Anticholinergics, a meta-analysis comparing anticholinergics along with beta-2 agonists versus beta-2 agonists alone in children especially showed a good evidence that when you added the inhaled anticholinergic medications, it improved the lung functions in children with acute asthma. However, the use of inhaled ipratropium for the treatment of asthma in adults is not very clear, but it definitely is beneficial for those with a severe exacerbation. So these work much better in children as compared to adults. Glucocorticoids, again, mainstay. We can give IV hydrocortisone 2 mg per kg, repeated every 6 hours. This helps in decreasing mucus production, bronchial hypersensitivity, and also reduces the beta-2 agonist and the theophylline requirements. The initiation of its anti-inflammatory effect, however, takes about 6 hours or so. Therefore, the initial mainstay of the treatment and the improvement is concurrent oxygen, beta-2 agonists, and the use of anticholinergics to tide over the crisis before the effects of the glucocorticoids can kick in. Oral and parenteral both have been effective in preventing hospital admission in children, but in such cases, in adults, only parenteral corticosteroids have been used. However, there is insufficient evidence to recommend the use of inhaled corticosteroids. So usually the dosage is always using the intravenous route. The secondary treatment is adrenaline, magnesium, heliox, methylxanthines, NIV, and mechanical ventilation. Adrenaline has a both alpha effect, which helps in decreasing the edema, and the beta effect is for bronchodilation. It is basically used as a rescue therapy. It is basically used as a rescue therapy in severe asthma, which is complicated hypertension that is not secondary to dynamic hyperinflation. And the dose usually is about 0.5 mg subcutaneously, although varying doses have been used, and the absorption is also variable. Endotracheal adrenaline is not advocated in intubated patients. There is no specific advantage if we get it by using this. Magnesium sulfate causes bronchodilation by competing with the calcium at the smooth muscle binding sites, and you can give a maximum of 2.5 grams. There's no data, however, regarding the duration or the efficacy with repeat doses, and no guidelines for monitoring the serum levels of serum magnesium levels also. The addition of magnesium sulfate to standard therapy has been studied in children and adults with divergent effects. It is basically seen in adults who have a severe exacerbation. Magnesium sulfate therapy resulted in better lung function tests. In children, however, it significantly increased the lung function and decreased hospitalization. So just like ipratropium, magnesium also works better in children as compared to adults. Heliox, it was proposed that heliox has a lower density and flow easily through the constrictive airways and improve outcomes. There's insufficient data to propose the use of heliox for treatment in acute asthmatic exacerbations. Methylxanthines have a diminished role since the advent of beta-2 agonists. They are weak bronchodilators and have many undesirable side effects. And there is no additional benefit when administered to patients who are already on corticosteroids and beta-2 agonists. So the use of methylxanthines is waning as the other therapies are increasing. Commonly used is aminophylline, and this is basically because of its bronchodilation action, increased diaphragmatic function. Adverse effects are nausea, vomiting, and palpitation. You could load it at 5 to 6 mg per kg and thereafter maintain it with 0.5 to 0.9 mg per kg per hour. The therapeutic range is extremely important to be monitored, 8 to 15 mics per ml. The addition of IV aminophylline to conventional therapy has no additional benefit for both children and adults, and also significantly increases the risk of adverse effects like vomiting, palpitation, and arrhythmias. NIV is extremely important. It is to be considered with patients with impending respiratory failure in order to avoid intubation. Status asthmaticus patients tend to, however, require more invasive means of ventilation, and severe bronchoconstriction and secretions are the obvious signs which will need to move away from NIV to conventional mechanical ventilation. NIV will basically help in enhances our breathing by resting the tired muscles, could be used intermittently to reverse the breathing problem, but it has a limited role always. Many RCTs have been done to see whether effectiveness of NIV in severe acute asthma. Compared to the usual medical care alone, it is definitely better, but there is only a limited amount of options which is available with the NIV. However, it does improve the respiratory rate and the lung function measurements. Paucity of data to support the use of NIV in status asthmaticus. Larger prospective trials are necessary for the role of the same in such conditions. Mechanical ventilation indications are basically patients who are getting progressively drowsy, significant hypoxemia, refractory to supplemental oxygen, impending respiratory failure with increasing CO2 and fatigue, and God forbid, respiratory arrest. Basically, we have to look at controlled hypoventilation. We have to allow for high levels of carbon dioxide by minimizing the tidal volume and the PEEP. The ventilator settings have a lower ventilatory rates, and the prolongation, because of the prolongation of the time constant as there is an air resistance, we have to allow for permissive hypocapnia as long as the oxygenation remains all right, and the longer inspiratory to expiratory ratios, which could be as long as 1:3 or 1:4 even, to provide or to PEEP. Significant intrinsic PEEP is present in such patients, which could be worsened by the initiation of PEEP in such patients. However, some patients could benefit from PEEP, which will open up the airways. Cautiously increase PEEP in such patients who are refractory to the initial settings. Start with very low or low PEEP and then increase the PEEP gradually. To conclude, the current guidelines recommend the use of high-dose beta-2 agonists, ipratropium, in conjunction with systemic corticosteroids. We all need to have greater awareness of the severity markers for such patients so that the treatment could be started at the earliest. When in doubt, it is always safe to treat and to overtreat rather than to undertreat, as because we may prevent a potentially fatal attack. Large-scale studies are, however, necessary to resolve mixing issues like the use of large volume spacers, heliox, intravenous beta-2 agonists in severe asthma cases. Thank you for your patient hearing.
Thank you, Dr. Rajiv Shukla.
Yeah, if there are any questions, I'll be happy to answer the same.
Yeah, for such an elaborate lecture on asthmatic crisis, which is more pertinent in COVID era. Sir, what are your experiences with magnesium sulfate per se, in practical experience?
No, to be honest, I've never used the same for an asthmatic crisis, but I have counterparts in the respiratory care who have used it from time to time, but it's standard of care in all the current guidelines, and especially for children. So I think that is another way forward, that we could all be starting at giving at least a single loading dose of magnesium sulfate, and it is supposed to have a very high level of safety. When I went to the literature, I was myself surprised that this is one thing that we all could easily use, and it is not recommending multiple doses, and it causes a huge amount of relief. And it's in the primary treatment, it's going to come to that level now. The use of magnesium sulfate is increasing all over, but I have personally never used magnesium sulfate when I was in medical care.
We have used quite a few times in cases of refractory cases, but I found it quite useful. That's why I had got a question.
Yes. Guidelines recommend it very strongly, especially for children.
It works like wonders sometimes.
Yeah, that's what I was. I also was a little surprised to see the safety profile. Also, it is extremely safe. I was having
Yes.
doubts whether we would need to monitor, knee jerks and stuff like that. But they say that it works like magic. Yes, absolutely correct.
Thank you, sir. Thanks for such an elaborate lecture.
Thank you. Thank
In
you, Dr.
afternoon
Shah.
session when
All-
everybody was feeling sleepy, you just kept us awake and like kicking. Over
Thank
to
you, organizers.
Neelam, madam.
Thank you for this wonderful initiative. Thank you, Dr.
Thank
Shah.
you, Dr.
My
Shukla, very
fellow-
much for your nice deliberations.
Thank
And I
you, Chairperson.
sincerely thank our chairpersons, Dr. Vijendra Prasad sir and Dr. Alok Jha for chairing this session. Over to you
Most
for
welcome,
next
ma'am.
session.
Thank you, Chairperson.
Dr.
Thank you.
Shukla, please stop sharing.
Yeah.
The second topic is on pediatric airway by Dr. Vishal Vaibhav. To preside over this presentation, I welcome and invite Dr. Hari Damodar Singh sir and Dr. Prashant as chairpersons. Dr. Hari Damodar Singh sir is Associate Professor at Darbhanga Medical College and Secretary ISA Darbhanga branch. Dr. Prashant is GC member ISA Bihar Jharkhand and is a senior resident at Patna Medical College and Hospital. I request Dr. Hari Damodar Singh sir to welcome and introduce Dr. Vishal Vaibhav to our WEBCON audience. Dr. Neelam, kindly display and share the CV of Dr. Vishal Vaibhav. I think Dr. Hari Damodar Singh
Yes,
sir.
yes, sir.
I request everyone to please mute your mic. I request everyone to please mute your mic. Please check this.
Good afternoon,
Dr.
sir.
Hari Damodar, please
Yes.
introduce Dr. Vishal.
Good afternoon, ma'am. Dr. Vishal Vaibhav, welcome, please. He is an assistant professor in Patna Medical College, winner of Dr. Ashok Gupta Award for Young Anesthesiologist in 2018, winner of late TN Jha Travel Grant Award in 2013, university topper of MD MBBS. He has 11 publications in national journals and 2 in state journals. He is going to present a topic on assessment of pediatric airway and newer techniques in difficult pediatric airway management. Please proceed.
Thank you, sir. Thank you so much for your kind introduction. And since this is a post-lunch session, all of you may be a bit exhausted. Well, I'll not take much of the time. We are running short of time, and but it's a very important topic, and that too big one to be dealt in a very short span of time. So I'll be faster. And first of all, the question arises is, why do we need to assess a pediatric airway? And the answer is simply because they have a different anatomy. Now, you can very well imagine what sort of anatomy or what sort of challenges we get when we encounter a pediatric case by looking at this image. So really, it can be a very big challenge for each of us, especially those who are not very much well trained in pediatric anesthesia. So first of all, have a look on the difference in the anatomy compared to the adult. What we find is that the infants, they have a large occiput, and therefore the head is a bit difficult to handle. Then besides this, the mandible is thin and underdeveloped with a floppy omega-shaped epiglottis. Then there are narrow nares, and there is a large tongue to be housed inside a small box, that is the oropharynx. Besides this, the larynx is high arched and there is a narrow subglottis. So in order to evaluate, we have to look on to the background history, whether the patient is having a hyper-responsive airway, or is the patient had any history of previous difficult airway management, if any anesthesia was being given to the patient or not. So a proper background history is very, very important, followed by an anatomical examination to look for any congenital malformations or obvious tumors or a missing teeth or a buck teeth, say for example. And then comes the physiological examination, where the respiratory rate and the work of breathing has to be taken care of, especially in cases of physiological variations like inflammatory infections, as for example, epiglottitis. So, and then we proceed on to the clinical evaluation and radiological evaluations. So the question can now be divided into two parts. The question is, first, whether we will be able to face mask ventilate the child, or whether it will be a difficult intubation. Now, remember at this point of time that if you have a difficult face mask compared to a difficult intubation, because the reason is that difficult face mask ventilation can actually cause catastrophic event and make you land in CI/CV situation, that is cannot intubate, cannot ventilate situation. Whereas if you are unable to secure the airway by intubation, and if you are still able to ventilate, you can at least save your child. So if the face mask ventilation is supposed to be difficult, it can be because of an obvious tumor or abnormal face shape, or because of the syndromes associated with mid-face hypoplasia. And the children with obstructive sleep apnea, when they land up in sedation, because as for say, for example, because of the tonsillar hypertrophy, then it would be a difficult face mask ventilation, because the tongue is going to fall back and there will be complete obstruction. So, and we all know that infants are obligate nasal breathers. So in this case, you have to be very, very cautious about the face mask ventilation. And then you have to make your airway patent all through the ventilation process. Coming to the intubation, it would be a difficult intubation in case there is mandibular hypoplasia or poor mouth opening or obstructive sleep apnea, stridor, and syndromes like the Goldenhar syndrome or Treacher-Collins syndrome or the Perry-Robin syndrome. All these can cause a very difficult and challenging intubation. Now, have a look on this slide. Now, this child, you can very well imagine, it's not going to be a difficult and a challenging intubation, but I think it will be a very, very difficult ventilation for the child as well, and obviously all of us. Contrary to this, have a look on this slide, and this is a very cooperative child with the mouth fully open. You can very well assess the airways scoring, and you can do even the Malampati in this cooperative child. Maybe the cooperation is because of the ice cream she is holding in her hand, but still we have to make our child cooperate if we happen to have a child more than 5 years of age. So then we proceed on for, if we have such a child, we'll proceed for the clinical evaluation, which includes the mouth opening and the inspection of the oral cavity. The range of motion should always be looked on by the flexion and extension of the cervical spine. And the modified Malampati test should be done, thyromental distance should be measured, or the upper lip bite test should be taken. But actually, and also I will tell you that you all know about the Malampati. I'll not go into the details. Just have a look on the fact that it is impossible to do Malampati in kids less than 18 months. And it's very difficult below the age of 5 years old child. But the even more important, which actually needs highlightation, is these tests have a very poor predictive value. Have a look on these slides and look at the sensitivity of the tests. None of the tests are above more than 70% sensitivity. So actually, you need to have further evaluation techniques in order to assess a difficult airway. And this can be done by radiological evaluations, which are important from anesthesiologist perspective point of view. And the first is the röntgenograms or the X-rays, which are very cheap, easily accessible, and the lateral views are very, very useful to obtain. And but definitely they have an inherent risk of radiation exposure. Then comes the role of computed tomography, a bit costlier and sometimes clumsy, requires sedation many a times. So we'll go into the details of all that. Just have a look on the X-rays, how informative it can be for an anesthesiologist. If you happen to have a lateral view of the neck X-ray, you can easily diagnose the thumbprint sign, which is a diagnostic of acute epiglottitis. And therefore, you can anticipate that you'll be having difficulty intubating such a child. Now, similarly, this is an AP radiograph of the neck showing narrowing of the subglottis, and there is a stipple sign in case of croup. So these are the cases you need a proper evaluation. Now, one of the things which we commonly encounter is the thyroid mass. So this thyroid mass can actually cause tracheal deviation and compression. And this is very much evident and can be easily done at the low setup institutions as well, where we have a provision of portable X-rays. Definitely, if you are trying to delineate a congenital malformations where bony lesions have to be evaluated, computed tomography would be definitely better than even the X-rays. But it has its own inherent limitations, and the limitations are motion artifacts, radiation exposure, may require sedation. So all these taken into account, we have to weigh which one to choose and why. Besides this, coming to even a better form, that is the CT bronchography and virtual bronchoscopy, which is an emerging part. They are superior to the regular CT scans for airway assessment because they are non-invasive and operator independent, and therefore does not require sedation or general anesthesia. But definitely they have also some of the limitations like altered impressions due to airway secretions, and they are costlier than the röntgenograms and the ultrasounds. And besides the fact that the mucosal tumors or the mucosal collections, they cannot be differentiated by the use of this CT bronchography or the virtual bronchoscopy. Then comes the role of MRI. Well, we all know that MRI is very much suited for the soft tissue lesions and is devoid of any radiation exposure, but definitely a very big cost issue, as well as the fact that you need to have a properly cooperative child, and especially the kids who are less than 5 years will actually require sedation and general anesthesia. You can't imagine a child to be cooperative inside an MRI suit. And then comes the role of 3D printing, which is actually a revolutionary technology for simulation of the patient's airway, and it involves conversion of 3D models which are printed according to the image data which are collected from the CT scans. The extensive application, it has extensive applications for planning and management of complex medical cases, but definitely cost factor is an issue. And besides the fact that the flexibility of the tissues actually cannot be simulated. So many a times it happens that actually the airway, which sounds much more difficult in a 3D printing, will actually be not that difficult because of the flexibility of the tissues. Well, now airway ultrasound, especially the point of care ultrasound, is now considered as the visual stethoscope, and we all must try to command ultrasound techniques for assessing the airway, and it is the emerging first line non-invasive adjunct assessment tool of the pediatric airways. It can actually help you in identifying the anterior neck soft tissue thickness, as well as the airway size can be determined. Besides the fact that vocal cord dysfunction and pathology and detection of the tracheal stenosis and tracheal wall thickness can also be done with the use of ultrasounds. Intrathoracic extent of the goiter can be done. Besides, other diagnostic tools can be used simultaneously, but definitely it will help you in diagnosing epiglottitis, laryngeal edema. Even LMA malposition can also be detected by the use of the airway ultrasounds. But definitely airway ultrasound has a big limitation that it is operator dependent and definitely requires a very good expertise. And as a result of this, it is a bit time consuming, and training to master the technique is one of the major limitations, which I think all of you would agree to the fact that we as conventionally trained anesthesiologists, now we are supposed to become even radiologists. I don't know what we have extra to do, so many things to be done. Anyway, so the theme becomes What is the role of radiological evaluation? The theme is that we have, if you are anticipating a difficult airway, if you want to be sure, definitely you will try to make a cocktail of the things. If go for a background clinical evaluation, anatomical, physiological evaluations, and if you are still suspecting that, okay, there could be any further difficulty, as for example, in cases of congenital malformations or congenital syndromes, then you can definitely go for these radiological techniques to evaluate the airway properly. Now, since I'm here to deal also with the equipments of difficult pediatric airway management, so there are various instruments, but I will just skip on the face mask, the supraglottic airway devices. Not much has changed. And the changes have been there with the aids of intubation, the oxygen delivery devices, video laryngoscopes, and the flexible fiber optic bronchoscopes. So I'll quickly move on to that. I'll skip the face mask and airways. The supraglottic airway devices, I'll just mention a few lines about this. The third generation, that is the BASCA, has actually no pediatric size. So you have a provision of using either the first generation or second generation. We have sizes available. What we need to constantly monitor is the airway cuff pressure when we are using these supraglottic airway devices. And this is another Miller classification. If you remember, well and good. It's fine. And coming to the tracheal tubes, one special mention about the micro cuff tube, which was found thought to be causing less post-intubation stridor because of the very thin cuff and low pressure cuff. But actually, the incidence has been found to be similar with the normal conventional PVC tubes. And these are the various tubes. Now, coming to the lung isolation devices, most commonly used devices are the Fogarty catheter or the ardent blockers, which are used for infants and younger children, whereas uniblockers and univents can be used only for older children. Regarding the use of double lumen tubes, the smallest size available is 26. Then we have provision of using 28 or even the 32 for even older children. Say, for example, if the child happens to be older than 12 years, you can go for the size 32 as well. Then we have Mararo pediatric bilumen tubes. These are some of the tubes which can be used for lung isolation devices. Coming to the laryngoscopes, we are all familiar with the curved blade and the straight blade laryngoscopes. But actually, the question, if you ask me whether you can go for a curved blade or a straight blade, definitely the answer depends upon the choice, depends upon the age, as well as how much you are well acquainted with the use of which blade. You can even intubate a child of, say, 2 years with a Macintosh. It's not that you will always go for a Miller blade. First thing. The second thing is that Miller will be helpful in neonates and infants much more than compared to the Macintosh, because it can it actually requires less room for in the infants with a low oropharyngeal space and a large tongue. Then we have fiber optic versions which uses the light source, and the OXP port versions which are actually the plastic single-use versions. Then comes the rigid optic laryngoscopes with the Bullard laryngoscope with pediatric and the sizes, that is 0 to 2 years and 0 to 10 years. And then we have different aids for intubation like the pediatric stellate, the bougies, and the optical intubation stellates like the Shikani optical stellate, the Bonfils retromolar intubation fibroscope, track lights, light bands, and the searchlights. Then we have provisions for oxygen delivery devices, and actually it finds use because, as I pointed out, we have to be very much cautious that we should be able to ventilate our child rather than just going for an intubation. I'll just mention the high flow nasal oxygen therapy, where we can give the patient 40 to 60 liters of oxygen and achieve an FiO2 of 1 at PEEP of 5, and we can administer humidified warmed air at 33 to 34 degrees centigrade. And then we have Thrive technology, which uses which is actually a transnasal humidified rapid inflation ventilatory exchange, which actually causes apneic ventilation by creating a supraglottic primary vortex as well as a cardiogenic oscillations from below. And we have pediatric versions which are called Vapotherm 2000i and the OptiFlow Juniors. Then the future of the airway management, which is the video laryngoscope, actually is a miniature form of the adult ones, and definitely it gives a better, wider glottic visualization, because the angle which with the conventional laryngoscope is just 15 degree, which is increased to about 60 to 80 degree with the use of these video laryngoscopes. Besides the fact that it has a faster learning curve and a very high success rate. So these are the video laryngoscopes. I don't have that much of time to go into the details, but these are only the pediatric versions and the sizes available for them. And just have a look on the King Vision Ambu, and I have photographs for all of them. You can just go through if you wish to. The important point to be mentioned about the video laryngoscope is that you need to master at least one or two of the video laryngoscopes for dealing with the difficult airway. It is not necessary that you need to master everything. It's not possible. You can't have that provision of going for everything. Now, coming to the flexible fiber optic bronchoscopes, they are actually the gold standard for airway securation because they are ultra thin scopes, and the sizes available are 1.8, 2.2, and 2.7 for neonates and infants. Definitely, they will facilitate intubation in anticipated difficult airway and positioning of bronchial blockers, and the inspection of the airway for diagnostic purposes as well. But it is not devoid of complications. So inexperienced hands, they can cause trauma, laryngospasm, and subcutaneous emphysema and pneumomediastinum as well. Lastly, but not the least, the All India Difficult Airway Association recommends that if you land in a CICV situation, you have to keep cricothyrotomy sets available. And we have provisions of 18 gauge, 16 gauge, and 14 gauge cannulas. But the cannula cricothyrotomy is not available for children, and tracheostomy should be performed as soon as possible after the cricothyrotomy has been done and ventilation has been secured with high pressure jet ventilations. So that, but this tracheostomy should be done by an ENT surgeon. That's all. Thank you for your patient hearing.
Thank you, Dr. Vishal, for excellent and illustrative presentation. One question I have received, that among the various newer devices, which one would you recommend for management of a difficult pediatric airway?
Well, management of a difficult pediatric airway does not depend upon the device actually. There are so many devices you have, and you can pick you are convenient with most. So actually the answer to this question is the availability. You're accustomed to the device which you are having. If you are very much well trained with the flexible fiber optic, you can straightway use that. Or if you have a especially say for example McGrath or CMAC, even if you are well trained with that, you can go for that. You need not have to just go for anything which is very clumsy, or there is no guideline regarding that. Besides this, pediatric age group should also be taken into consideration before selecting any airway.
Thank you.
Thank you. Yes, Prashant, carry on.
Yes, ma'am. We can wind up now.
Thank you so much, Dr. Hari Damodar and Dr. Prashant, for chairing this session, and thank you, Dr. Vishal, for a very nice and wonderful deliberation.
Thank you, ma'am.
We move on to the next session, and before going into the next session, I would like to tell all the chairpersons, speakers, that we are running almost 1 hour behind the schedule. So we would like to cut short the times little bit and try to wind up as early as possible. Thank you. Over to Rajesh.
Neelam, can I suggest one thing? If we are running 1 hour, can we cut the question session to 2 minutes? Because we are running 1 hour late.
Yes, we can.
Please. I request all the speakers to please stick to the time.
Okay. So to preside over our next topic, that is perioperative strategies to prevent myocardial infarction by Dr. Abhyuday Kumar, I welcome and invite Dr. Naseem Akhtar sir and Dr. Abhishek Chatterjee as chairpersons. Dr. Naseem Akhtar is consultant at Medanta Ranchi and Secretary Ranchi Society of Anesthesiologists. And Dr. Abhishek Chatterjee is consultant at Tata Main Hospital, Jamshedpur. He is a GC member, ISA Bihar, Jharkhand, and Secretary, Jamshedpur, ISA City Branch. I request Dr. Naseem Akhtar sir to welcome and introduce Dr. Abhyuday Kumar, and request Dr. Neelam to kindly display and share his CV.
Hello, good evening. Am I audible?
You are audible, sir.
Okay. The next speaker is Dr. Abhyuday Kumar. He is the Assistant Professor, Department of Anesthesiology, AIMS, Patna. He is also the GC member of ISA, Patna City Branch. He had many publications, national and as well as international. His topic is the perioperative strategy to prevent the myocardial infarction. I have to say about, as an anesthesiologist, we should be proud that the perioperative mortality is remarkably reduced in the last 3 decades. It has not happened by the magic, but it is the people like you to apply a good assessment tool and a strategy to prevent it. Without delay, I am inviting Dr. Abhay Uday Kumar for his talk, the perioperative strategy to prevent the myocardial infarction.
Thank you, sir. Thank you, sir, for the nice introduction. I will ask the host to please start my video. I am not able to start. Please allow me for my video.
Anand, please allow sir video.
Okay, sir. Okay. Sir, I have given the permission, just check.
Okay.
Okay.
Thank you, sir. Thank you so much. Good afternoon to all of you. I am thankful to the organizers for giving me the opportunity for to present this topic on this platform. The topic is preventive strategies to prevent the perioperative myocardial infarction. I will deal these topics under following headings: problem statement, definition, types of perioperative MI, risk evaluation, and preventive strategy. So why we are so worried about this topic? Why we want to know about it? Coming to the problem statement, the problem statement is that in some of the recent trials and studies, it has been found that in moderate to high risk cases, the 30-day mortality is around 2% because of any of the cases, whether the patient is having cardiac risk factors or not, it doesn't matter. But when this high risk cases got additive of high cardiac risk, the 30-day mortality increases to 5%. And most important thing is that 50% of these perioperative MI goes clinically unrecognized. So when the patients go clinically unrecognized perioperative MI, the hospital mortality rate increases to 15 to 20%. And you think that the patient is very fine, but the effect lasts even up to 6 months. So perioperative MI detection is very important. Coming on to the definition of acute MI. So for defining or diagnosing perioperative MI, we should know the definition of acute MI. According to fourth universal definition of myocardial infarction, which was released in 2018, there should be rise and fall of cardiac troponin levels, either at troponin T or troponin I. This is a must for diagnosis of acute MI. And it should be, apart from this, one of the following should be there. Either the patient should have symptoms of acute MI, or the patient should have some new ischemic ECG changes, or the patient should develop pathological Q waves, or the imaging modalities show a new loss of viable myocardium or new regional valve motion abnormality on echo is seen, or on angiography a coronary thrombus is seen. Even after death, post-mortem finding, if we get a thrombus, then also it can be said that the patient was having MI. So the first thing is rise or fall in cardiac troponin E with either of these criteria. Perioperative MI is not different. The definition is the same. Definition is the same as of acute MI, but it should occur in the perioperative time. The problem is, the thing is that some of the symptoms of acute MI may not be so can be seen in the perioperative period, because the patient is either sedated, or the patient is under anesthesia, or the patient is having post-operative other pain. Second thing, the ECG changes. The ECG changes are in the perioperative time are subtle and transient, so they can be missed very easily. So the diagnosis is very difficult in the perioperative time. and that is the cause for a large number of undiagnosed cases. So what are the types of perioperative MI? Normally, the acute MI is divided on the treatment modalities. We all know about ST elevated MI and non-ST elevated MI, but other thing is that it is also characterized on the basis of pathological changes into 4 categories: type 1, type 2, type 3, and type 4. So in perioperative MI, basically type 1 and type 2 MI are prevalent. So what is type 1 myocardial infarction? The pathogenesis of type 1 myocardial infarction is atherosclerosis or thrombosis. So there will be thrombosis or plaque rupture which will lead to type 1 myocardial infarction. And the predisposing factors are sympathetic activity, hypertension, tachycardia, and hypercoagulability. Second is type 2 MI. The main pathogenesis behind this is oxygen supply and demand imbalance. Say, suppose the patient is having more demand, like in sympathetic overactivity, postoperative pain, and tachycardia, or the patient may have a decreased oxygen supply, like in anemia, hypoxemia, or hypotension. But one thing we must keep in mind that these two types of MI are not exclusive. They are overlapping. But yes, in type 2 MI, the oxygen supply demand imbalance will be more over the atherosclerosis factors. The most common perioperative MI is type 2 MI. And you can see ST depression mostly in type 2 MIs. How will you evaluate which patient is at more risk of perioperative cardiac risk? So there are many scores, but the most common and the trusted one is Lee Revised Cardiac Risk Index, RCRI index. So it is having 6 criteria, each having 1 point. So for high risk surgeries like emergency surgery, major thoracic procedures, cardiac procedures, aortic or major vascular procedures, or procedures exceeding 4 hours, 1 point is there. Then ischemic heart disease, history of congestive heart failure, history of cerebrovascular disease, diabetic patient on insulin therapy, or a serum creatinine level of greater than 2 milligram per deciliter. Each category have 1 point. So when you add up the points, if the patient is having 1 point, the predicted cardiac event rate is 0.9%. If 2 points, it's 6.6%. And if greater than 3, it's 11%. So what are the preventive strategies? The preventive strategy will be dealt under 3 headings: pharmacological therapy, coronary revascularization, and perioperative management. So under pharmacological therapy, what is the role of beta blocker? What is the role of cancer channel blocker, alpha 2 agonist, statins, AC inhibitor, or angiotensin receptor blocker, or antiplatelets? Whether interventional PCI or CABG should be done as a preventive part or not, and how your perioperative management can change the outcome. Like we will discuss about the monitoring, hemodynamics, pain management, and temperature. Coming on to the pharmacological therapy, the most important is beta blockers. We all know that the beta blocker should be continued in patients undergoing surgery who have been on beta blocker chronically. This is ACC AHA guidelines 2014. So beta blocker must be continued even on the day of surgery. So whether we can use beta blocker as a prophylactic in patient or not. So in patient which have a RCRI index of 3 or greater than 3, it is reasonable to start a beta blocker before surgery. So in other patient, if the RCRI is less than 3, there is no role of starting a prophylactic beta blocker. And beta blockers therapy should not be started on the day of surgery in a knee patient. If the patient is not taking beta blockers previously, it should not be started on beta blocker on the day of surgery or even on the day before surgery. It should at least be started 7 days and preferably around 1 month, if to have some effect on the perioperative time. Calcium channel blockers definitely have significantly reduced the perioperative ischemia and supraventricular tachycardia, especially diltiazem is very effective in preventing these MIs. Alpha 2 agonists like clonidine are not recommended in patients who are undergoing non-cardiac surgery for prevention purpose. The statins should be continued in patients who are currently taking statins and are scheduled for non-cardiac surgery. And statins could be initiated in patients undergoing vascular surgery at least 2 weeks preoperatively. AC inhibitors and ARB, there is long conflicting controversies controversy is there that the American guidelines, ACCHS guidelines suggest that it is reasonable to continue the ACE inhibitor or ARB, but the European guidelines say it should be discontinued at least 48 hours before surgery. Coming on to the antiplatelets, what should we do? So in any non-emergency, non-cardiac patient, non-cardiac surgery, aspirin should be continued when the risk of potential cardiac events outweighs the risk of increased bleeding. So taking the risk-benefit ratio, you must continue the aspirin if possible in non-emergency, non-cardiac surgery. But if the patient is on bare metal stent or drug-eluting stent and the time duration of a surgery is 4 to 6 weeks, elective surgery should not be done. But for an emergency surgery, and if the patient is on bare metal or drug-eluting stent and the surgery is before 4 to 6 weeks, what should we do? The patient is basically on dual antiplatelet therapy and it should be continued if there is not much risk of bleeding in the surgery. And if there is much risk in the surgery, what should we do? We should discontinue the clopidogrel and continue with the aspirin part, if possible. Coming on to the intervention, whether revascularization before a non-cardiac surgery is recommended or not. So doing a PCI or a CABG just for the sake of doing a high-risk case is not recommended. It can only be done if there are other criteria of the clinical practice guideline are meeting, say like a blockage of the left anterior descending or 3-vessel disease, then you can go for it. But for the sake, just for doing surgery, it is not recommended as a prophylactic part to do a PCI-IVG. So for elective surgery, the timing is for balloon angioplasty, elective surgery should be postponed for around 14 days. For bare metal stent, it should be postponed for 30 days. And for drug-eluting stent, at least you should wait for 6 to 1 year. Coming on to the peri-operative management, the monitoring part, what you can do in monitoring, ECG is the gold standard. Apart from all ASA standard monitoring, you should at least add precordial leads during patients who have high risk of cardiac events. And if you add up two or more than two precordial leads, the sensitivity of detecting the peri-operative MI increases to more than 95%. Invasive BP should be applied in high-risk cases. What is the role of transesophageal echocardiography? For monitoring purpose, it has no role. But if the patient is having an intraoperative hemodynamic instability, you must go for transesophageal echo if available. Similarly, the case with pulmonary artery catheter, you should not put pulmonary artery catheter even in high-risk patient. But if the medical condition is significantly affecting the hemodynamics, you can put it. So intraoperative event that can influence the balance of oxygen and supply and demand, which is the basis of the event, is some of the factors that decrease the oxygen supply are decreased coronary blood flow, tachycardia, hypotension, hypocapnia, coronary artery vasospasm, decreased oxygen content, anemia, arterial hypoxemia, and shift of oxygen dissociation curve to the left. Some of the factors that increase the oxygen demand, like increased preload, sympathetic overactivity, tachycardia, systemic hypertension, increased myocardial contractility, and increased afterload. So you have to keep all these things in mind in your intraoperative management. Coming onto the oxygen, do we need to give more oxygen to the patient who are having at the risk of perioperative MI? No, the answer is no. Hyperoxia can increase the infarct size in acute ST elevated MI. So lowest possible FiO2 should be given. That can
Dr. Abhyuday,
yes,
please hurry up. You are exceeding the time limit.
Okay, sir. Thank you. So heart rate, obviously, tachycardia should be avoided. Temperature, there is no role of even mild hypothermia. Normotherapy should be. Transfusion threshold should be increased. 80 gram per deciliter is the transfusion trigger as per NICE guidelines. Choice of anesthesia, GA, neuraxial, regional, no statistical difference is seen. Volatile TIVA, no statistical difference is seen. But in post-op pain, neuraxial anesthesia have added advantage. So thank you. Thank you so much, sir.
Well, thank you, Dr. Abhyuday.
Thank you.
It was a very nice and very informative presentation. This is not only very useful for the practicing anesthesiologists, but it is also very beneficial to the postgraduate students who are appearing for their exam. Due to paucity of time, we are not going to take up any question as already discussed. So thanks, Dr. Abhyuday. Thanks a lot for presenting such an interesting topic.
Thank you.
Thank you, Dr. Abhishek and Dr. Naseem Akhtar for chairing this session. Thank you, Dr. Abhyuday, for a wonderful presentation. We are over to Rajesh for next lecture.
Nausea vomiting after surgery. An update by Dr. Nidhi Chaube is our next presentation.
अभिषेक अकेले कर लेगा. अभिषेक को तो बोला था हम लॉग्ड इन हैं.
Am I audible, sir? Am I audible?
Just a minute, Nidhi. You're audible, Nidhi. Just a minute. Hang on.
Okay.
Okay. Dr. Prabhat Dwivedi.
Hello, Rajesh. Dr. Prabhat has just left for hospital due to an emergency. Dr. Abhishek Basuki is there.
Dr. Abhishek Basuki.
He was there.
I can't see him. So I request, hello.
Dr. Nitin Ojha
yes,
asked him.
Is anyone from the, hello?
Dr. Nitin Ojha, please take over.
Okay. Don't worry. I will do. Don't waste time, please. I will do. So the CV I will read. No issue.
Okay, boss.
Don't waste
Okay,
time.
boss.
Don't waste time, please.
Sure. Boss. Okay. So,
hello. Dr. Nidhi Chaube is consultant in the Dr. Nidhi Chaube is consultant in the Department of Anesthesia, Bokaro General Hospital, Bokaro, and he was the winner, second prize winner in the TQM paper in ASMOC, and he has presented paper in the state conference and journal conference, and he is co-examiner in the FAT. So I request Dr. Nidhi Chaube to proceed with her lecture.
Thank you, sir. Thank you very much. Good afternoon, chairpersons, respected seniors, and my dear friends. PONV still remains a simple yet complex aspects of anesthesia practice, with incidence of 30% in general surgical population and as high as 80% in high-risk population. It is defined as nausea or vomiting occurring during 24 to 48 hours after the surgery and is the second most common complaint in post-operative period after pain. Many patients have experienced this sensation worse than pain. It may lead to many surgical and anesthetic complications apart from delayed discharge from post-anesthesia care unit, increased healthcare cost, and unanticipated readmission. The pathophysiology of PONV is very complex and poorly understood. The vomiting center receives afferents from central nervous, vestibular, and gastrointestinal system, as well as chemoreceptor trigger zone after being stimulated by certain external stimulus. There is further interaction between area postrema and nucleus of tractus solitarius, and efferents are carried through 5th, 8th, 9th, 10th, and 11th cranial nerves, leading to the cascade of vomiting and vagal and sympathetic activity. Now, there are certain neurotransmitters involved in whole of this process, like histaminergic, muscarinic, serotonergic, neurokinin, and dopaminergic receptors. The antiemetic drugs used for PONV can be classified into 5-HT3 antagonists, corticosteroids, butyrophenones, anticholinergics, neurokinin 1 receptor antagonist, and antihistaminics. Among 5-HT3 antagonist, ondansetron still remains the gold standard of treatment for PONV. All the 5-HT3 antagonists are given at the end of surgery apart from palonosetron, which is given at induction. They are associated with prolonged QT interval when used in higher doses, but at these doses, the risk of prolonged QT is very low. They are very effective in prophylaxis and treatment of PONV. Another very efficacious drug is aprepitant, which is given in dose of 40 milligram per oral 1 to 2 hours prior to induction. Has no significant side effects, but it is very costly. The next one, most commonly used drug is dexamethasone. It is a wonder drug, I should say. It is when it is used in combination with the other agents for PONV prophylaxis, it acts very well. It decreases the fatigue, pain, and improves the post-operative recovery also. It is given in dose of 4 to 8 milligram IV at the time of induction. And methylprednisolone is effective in late PONV. Droperidol and haloperidol were banned by FDA in 2001, giving a black box warning due to adverse cardiovascular effects. But recent studies have proved that if they are used in lower doses, there is very unlikely risk of QT prolongation and cardiovascular side effects. These are the drugs which are very effective in prophylaxis as well as rescue treatment. The role of antihistaminics is much controversial and they are not very well recommended for treatment of PONV. Anticholinergics like scopolamine can be used in the form of transdermal patch applied evening or 2 to 4 hours prior to induction. The side effect is severe sedation. They cannot be used for treatment, only for prophylaxis. The anesthetic drug which has shown a very promising result is alpha-2 agonist due to direct antiemetic and opioid sparing effect. Nowadays, combination antiemetic therapy is very highly recommended by the experts due to the greater efficacy and less adverse side effects when we combine agents from different classes. So 2 to 3 agents are given together, keeping in mind the maximum safe and effective dose of each agent. The recommendation in adult are droperidol should be used along with dexamethasone, or you can use a 5-HT3 antagonist along with dexamethasone or droperidol or both. While in children, ondansetron along with dexamethasone or droperidol is the recommendation of choice. The promising non-pharmacological prophylactic agents could be adequate hydration, preoperative adequate hydration, and acupuncture. Others are found to be not effective. Coming to management of PONV, these can be directed at 5 strategies like identifying the risk factors, risk mitigation, risk stratification, prophylaxis, and rescue treatment. I will deal each one of them one by one. The risk factors for PONV can be classified into patient, anesthetic, surgical, and post-operative factors. Female gender still remains the most consistent and strongest risk factors for PONV. Non-smoking status roughly doubles the risk of PONV. History of PONV and motion sickness also contributes a lot. Anesthetic risk factors like use of volatile anesthetics increases the risk of PONV by 2-fold, and nitrous oxide increases it by 1.4-fold. Actually, the use of volatile anesthetic agents, the risk associated is dose dependent. As well as for opioids, the risk is dose dependent. When you use it in higher doses, the risk of emesis is more. The surgical risk factor which are responsible is the duration of surgery, where each 30-minute increase in duration increases the PONV risk by 60%. Another one is type of surgery. Certain type of surgeries like laparoscopic surgeries, otological surgeries, ophthalmological surgeries, and gynecological surgeries are associated with high risk. The post-operative factors which increases the risk is pain, early ambulation, and use of opioids. Can we reduce the risk, baseline risk? Yes, we can, by using certain strategies. General anesthesia is associated with 9-fold increase in risk factor of PONV as compared to regional anesthesia. Peripheral nerve blocks are associated with less risk of PONV when compared to central neuraxial blockade. Use of propofol tiva, avoiding nitrous oxide and volatile agents, minimizing the use of opioids, all contributes to the to decrease the risk of PONV. Adequate hydration also plays a major role. For stratifying the risk, certain scoring systems were developed, but the most common ones used are AFL scoring in adults and POVOC scoring in pediatric patients. AFL scoring system takes into account the factors like female gender, non-smoker, history of PONV, and post-operative opioids into account. They have classified 0 to 1 as low risk, 2 to 3 as moderate risk, and more than 3 as high risk. Additional number of risk factor increases the risk of PONV in an increasing manner. POVOC scoring is used in pediatric patients. It's take into accountability the strabismus surgery, age more than equal to 3 years, duration more than 30 minutes, history of PONV in patient, parents or siblings. They have classified 0 as low risk, 1 to 2 as moderate risk, and 3 to 4 as high risk. Here also the additional number of risk factor increases the risk of PONV. Prophylaxis remains the major pillar of PONV management. For prophylaxis, the current recommendations are to use no prophylaxis or a 5-HT3 antagonist in the low risk group, while in intermediate risk patient, 2 antiemetics from different classes should be combined with or without propofol tiva, while in high risk patient, 3 to 4 antiemetics from different classes should be combined along with propofol tiva. In pediatric patient, in low risk patient, we can use no prophylaxis or a single agent like 5-HT3 antagonist or dexamethasone. For moderate risk patient, the recommendation is using a 5-HT3 antagonist along with dexamethasone, and in high risk, these 2 agents along with propofol tiva is the recommendation of choice. Rescue treatment is given when either the prophylaxis fails or the patient has not received any prophylaxis in intra or preoperative period. In case of failure of prophylaxis, if the time elapsed is less than 6 hours, antiemetic from another class which was used for prophylaxis should be given, because there is no use of giving same agent again. If more than 6 hours has elapsed, 5-HT3 antagonists or butyrofenones can be used. And if the patient has received no prophylaxis, 5-HT3 antagonist still remains the first line drug of choice. Droperidol should be used in children if other therapy fails. Any drug from any class can be used except for dexamethasone, transdermal scopolamine, aprepitant, and palonosetron. However, there is limited evidence on optimal combination for therapy, and clinician discretion is always advised. This is the algorithm for management of PONV. Here we have discussed all the factors, almost all the factors. Here you can see 2 new terms. This is cost effectiveness and multimodal approach. I will tell what are they one by one. Multimodal approach is doing a preoperative anxiolysis by using midazolam, using a prophylactic antiemetic, either droperidol or dexamethasone at the time of induction, and ondansetron at the end of surgery. Propofol tiva local anesthetic infiltration greatly decreases the risk of PONV. Local infiltration can be done either in the form of fascial plane blocks, peripheral nerve blocks, or simple wound infiltration. NSAIDs in place of opioids can be used for postoperative pain. There should be no or minimal use of nitrous oxide. We should always keep in mind the cost effectiveness of treatment when treating our patients. Reducing baseline risk is the most cost-effective strategy. Prophylaxis is 100 times more cost-effective than the treatment. Modifying anesthetic regimen is another cost-effective strategy. However, the data on cost-effectiveness of multimodal approach is very limited. So to summarize, PONV is one of the most distressing aspects of surgery after surgery. Reduction of baseline is the most cost-effective strategy. Multimodal approach should be practiced if the patient has one or two risk factors. Combination therapy is highly recommended. Every institution should have a PONV treatment policy in place, and they should make antiemetics from at least 4 classes so that two can be used for prophylaxis and 2 for additional treatment. This presentation was based on 4th consensus guidelines for management of PONV established by American Society of Enhanced Recovery and Society for Ambulatory Anesthesia in September 2009. It was published in Anesthesia and Analgesia recently in August 2020 by Tong J. et al. These are the other references. Thank you for a patient hearing.
And talk, but due to the shortage of time, we are not taking any questions. So I will immediately move on to the next. I will invite the next chairperson, who is Dr. Ashutosh Jha and Dr. Nitin Ojha. Dr. Ashutosh Jha and Dr. Nitin Ojha, please carry forward the program.
Okay. Thank you, Nidhi.
Welcome, sir.
Thank you, Dr. Sharad and Dr. Rajesh. Will now invite. Dr. Sharad has already invited Dr. Nitin and Dr. Ashutosh Jha. And Dr. Rakesh Singh is requested for his presentation.
My video has been stopped, madam, by the host.
Rakesh, please try.
Yeah.
Started.
Okay.
Nitin, take over.
Yes, Nitin, start. Dr. Ashutosh, are you there?
Nitin is there.
Yeah, Nitin, please start. Your mic is mute. Nitin, your mic is mute.
Our speaker is Dr. Rakesh Kumar Singh. He is a professor of Katihar Medical College and the co-coordinator of Medical Education Unit at Katihar. And his topic is about the medical legal aspects of the anesthesiologist. Sir, kindly start the session, please.
Thank you for a nice introduction. Are my slides visible?
Yes, sir, visible, sir.
Am I audible?
Yes, sir, well audible. Sir.
Okay, thank you very much. Respected chairpersons and dear delegates, the new Consumer Protection Act 2019 have been implemented since 20th of the July this year, and it has created so many confusion among the physicians. So it is a high time to discuss the medical legal responsibilities of the anesthesiologist. I will discuss my topic in the following heading: Consumer Protection Act 2019 changes, landmark cases for anesthesiologists, what constitutes a medical negligence, and what are the preventive measures to avoid the legal litigation. Consumer Protection Act 2019 have been implemented since 20th July of this year, and it aroused a sense of euphoria among medical fraternity that the healthcare have been removed from the list of these services. But this is not the reality. What they have done, they have removed it from the list of the services. So they have not included it, but they have also not put into the exclusion list. So they have left it to the will of judiciary to decide whether the healthcare would come in the purview of the Act 2019 or not. And the status is QA status, so it is applicable to the healthcare facility. As per the changes, you can see that keeping in mind the rising inflation rate, claim limit for the district forum has been enhanced to 1 crore. For the state consumer forum, it has been enhanced to 10 crore, and for the national consumer forum, it has been enhanced to more than 10 crore. For the relief of the consumer, they have given facility to file cases anywhere, including the places where they reside. They can do e-filing, but the respondent cannot go for virtual appearance. They will have to go to the court. And in the last Consumer Protection Act 1986, there was a fine of 10,000 rupees for frivolous and vexatious complaints. That has been removed this time. So I first discuss some landmark cases which are referred frequently in the court of law, and the first of it is the VP Santa and the others. This decision was in 1995, and from this date, actually, healthcare is included in the service list. So Indian Medical Association tried its hard not to include the healthcare services in the list of services, but the Supreme Court held that the services rendered to the patient by medical practitioner would fall within the ambit of the service as defined in section 210 of the Consumer Protection Act, because this decision has not been challenged yet. So it is a status quo. Next is the Mr. Bolam versus Prime Hospital. This decision is from the western part, but it is still used in the Indian law also, and it lays down the typical rule for assessing the appropriate standard of the reasonable care. So if there are two methods, physician has the liberty to choose any treatment modality accepted and practiced by different bodies is skilled in the particular field of the medicine at the point of time. There are so many debatable topics, like in severe eclampsia, what would be the most appropriate modality of the anesthesia, whether it is spinal or it is GA, somebody is doing spinal, other are doing GA. So both will be accepted as a standard care of practice. In a case of Dr. Suresh Gupta versus government of the NCT Delhi, they have given decision that if medical negligence is gross, then it amounts to the criminal negligence, and relative may file cases against doctor at consumer forum as well as the criminal court at the same time for the same case. They can go to the different agencies. This is this decision of Jacob Matthews versus the state of Punjab on 5th of 2005 brought a great relief for the doctors. It says that the criminal charges cannot be framed against a doctor unless it is supported by expert opinion from the doctor of the same specialty, preferably from a government hospital. And even if the charges are framed against doctor, a doctor may not be arrested in a usual manner. Arrest can be avoided if the investigating officer has believed that physician will help in the investigation. So what is the penalty for not obeying the summon of the consumer court? So they will have to face imprisonment of 3 years with a fine not less than 25,000 that can be extended up to 1 lakh. So what is the medical negligence? Medical negligence is defined as failure by healthcare professional to exercise a reasonable standard of the care. So a doctor can be considered negligent when the following is proved. 3 things has to be proved. First, the doctor has a duty of care. Second, there is a deficiency in service. And the third, there is direct relationship between the deficiency and the damage. So 3 Ds should be there: duty, deficiency, and the damage. So what is our role? Duty of care. Role of doctor is to diligently and prudently provide a reasonable standard of care as per the accepted practices available in that period of time. So before taking any case, we must take informed consent from the patient. And in the case of Samira Kohli, Supreme Court has given judgment that informed consent would have 4 parts. So part 1 can be remembered from the acronym NAME, that will include name, address, mobile, email. Part 2 will include procedure, diagnostic or therapeutic, name of the specific procedure, type of anesthesia, local or regional. Part 3 will include benefit, risk, complication, and possible alternatives. Part 4 will include doctor's name, signature, patient signature, and the signature of the 2 witnesses. There are certain conditions. Supreme Court has given judgment that in these conditions, consent will not be required. In a life-threatening emergency, the therapeutic privilege, if you think that if I say this complication to the patient, perhaps patient would make some harm to him. So during that condition, that information is not given to the patient, but you should tell that information to the relative. This is called the therapeutic privilege. If patients have ever in writing for do not resuscitation order, living will, then in that condition, it is not required. And for the treatment of criminal also, the consent is not required. Who is captain of the ship? Inside the operation theater, in the law, in the eyes of the law, surgeon is always considered the captain of the ship. So if anything wrong happens, surgeon will always be held liable. But the situation is gradually changing. In a decision of the Rasmi B. Fadnavis versus Mumbai Grahak Panchayat, in which 124 kg Rh negative patients undergoing fibroid surgery died due to the hemorrhagic shock, fine was imposed, but Supreme Court held that anesthetist will have to pay separately because it is a different specialty. So nowadays, the anesthetists are charged separately. So what charges are framed against anesthesiologists? It is the wrong drug, wrong gas, overdose of drug, inadequate pain control, tube catheter in wrong place, broken needle or catheter, incompetency, post-spinal meningitis, local anesthetic causing convulsion, malignant hyperthermia, awareness during anesthesia, and seepage of the blood into the trachea causing aspiration. So how we can prevent the malpractices claim? So first, we all have to follow this surgical safety checklist given by the World Health Organization as the Safe Surgery, Save Life Initiative. So if you follow this checklist, there are 3 parts: before induction of anesthesia, before skin incision, and before patients leave the operating room. So if we follow this checklist, the chances of the something missing will be minimal. So we all have to adopt this surgical safety checklist. We are fortunate enough that we have a society that has given clear-cut guideline for practicing anesthesiologists in India. So if we utilize this guideline, then we are completely safe, because then the society will come in our favor, that because these are the guidelines and he is doing as per the practices, so no charges can be made against him. It includes the list of the minimum mandatory equipment in the operating room. So I will not enumerate all because it is an exhaustive list, but here you can see that the multi-para monitor, including pulse oximetry, ECG, NIBP, ETCO2. So ETCO2 is mandatory for all. This is the list of minimum mandatory equipment. And for the difficult airway, mandatory equipment would be the intubating boogie, LMA, McCoy blade, cricothyrotomy set. And the desirable instrument would be the intubating LMA, video laryngoscope, fiber optic intubating scope. These are the recommended anesthetic drug that should be available in OT all the time. Then these are the other drugs. And here you can see that it will include amiodarone, adenosine, metoprolol, and esmolol to control any kind of arrhythmia. And it should have also the intralipid 20% to combat the local anesthetic tissue toxicity in the cases of the spinal anesthesia. This guideline has given clear-cut pre-anesthetic checkup list in which the most of the information has to be filled by the patient himself. Okay, so he cannot deny at a later stage, and the last part of it is the informed consent by the patient. So for the surgery, there should be separate informed consent, and for the anesthesia, there should be the separate informed consent. And this is the anesthesia record in which all the vitals has to be filled at the 5 minutes interval. So what are the measures to avoid litigation? First, you have to keep yourself updated with recent advances and the evidence-based practices. You must spend some time to make rapport with the patient and the relative. Always do PAC and optimize the patients if needed. Obtain informed consent to discuss all the foreseeable complications. Maintain intraoperative monitoring record in real time and never alter it. Do not accept case if you are exhausted. Protective measure, professional indemnity cover for yourself as well as for your hospital. The maximum fine imposed on any doctor in India is 71 lakhs. So it would be better if you take at least indemnity cover of 1 crore. If legal action is anticipated, immediately inform your lawyer. And if death occurs inside the OT, do not handle the body directly to the patient, even if they say that they do not want autopsy. If they want to take their body, inform the police and let police handle the situation. Okay. So thanks you for attending the first web conference, ISA BJ WebCon 2020. Thank you very much.
Thank you, sir. Thank you, sir. So my question is, sir, is that, sir, this recent of the pandemic situation of COVID-19, sir. So if anyhow, if whatever the surgery is elective or emergency surgery, if the patient is refusing for the COVID-19 test, what are the legal responsibilities of the anesthesiologist to cancel the case or to postpone or to delay? What are the legal aspects for that? If the patient is avoiding for the pre-testing of COVID-19 test, because in some houses we are facing such
because it is a pandemic situation, so the COVID test would be must, because other patients' safety may be at risk, so it should be done. But if the patient is not willing for it, in my opinion, you cannot force him to go for this. You will have.
And
to,
what are the legal responsibility for us?
You have to take all the, you will have to take all the precaution to safeguard yourself and the others.
Okay, sir. Okay, sir. So thank you, sir. Thank you, sir. Yes, Neelam, madam, our next session.
Thank you, Dr. Nitin, for chairing this session, and thank you all the speakers of session 3 for such a wonderful deliberation. I thank my partner coordinator, Dr. Rajesh Raj, for helping me to conduct this session smoothly. And without any delay, I will ask Dr. Nidhi Arun and Dr. Rajesh Raj to take over for Dr. B.K. Prasad Private Practitioner Forum Award.
Okay, thank you, Dr. Neelam. Welcome all to this award session. Dr. Braj Kishore Prasad Private Practitioner Forum Award session was introduced last year at 32nd ISACON Bihar Jharkhand at Bokaro Steel City, with the sole aim to encourage private practitioners to share their expertise, experiences, interesting cases, or innovative ideas in an academic environment at an ISA forum. This award is named after and has blessings and patronization of Dr. B.K. Prasad sir, an academician par excellence and a man of unbound energy, and happens to grace the post of President ISA Bihar Jharkhand presently. The award carries a prize money of Rs 5,000, Rs 3,000, and Rs 1,000 for first, second, and third prizes respectively. In this award session, we have a total of 4 participants who are given a duration of 6 plus 2 minutes. And to judge these participants, we have 4 very esteemed judges. Dr. Moti Lal Das, Associate Professor at NMCH Patna. Dr. Mohib Ahmed sir is consultant intensivist and neuroanesthesiologist at the Medanta, Ranchi, and has many papers and citations to his credit. Dr. Sushil Kumar, Associate Professor at Darbhanga Medical College, and who took leading roles in organizing first full-fledged Bihar State Conference in 1988 and ISA National Conference in 1991 at Darbhanga. Dr. Rajesh Verma sir, Associate Professor at Patna Medical College. I welcome all the judges to this awards session and request Dr. Nidhi Arun to call upon the first participant for the presentation.
Thank you, Dr. Rajesh Raj sir. And I've just got a message from Dr. Mohib Ahmed. Due to some network issue, he will be bit delayed. He has already joined, but he had just logged out due to some network issue, and he'll join us in few seconds, few minutes. So as already stated that all presenters have to finish their presentation in 6 minutes, and I'll request all the presenters to adhere to this timeline. So starting with the first presentation, I'd like to invite Dr. Niharika Singh from Nachi. And I'll also request other presentations to be prepared with their presentations open on their screen and kept it minimized to save the time as we are already running late. So Dr. Niharika Singh from Ranchi.
Dr. Nidhi, just make sure all the judges are present before starting any presentation.
Okay. Mohib Ahmed sir perhaps he has not joined yet. He had just messaged me due to some network issue. He's just trying.
Yeah, hello. I have joined. Yeah, you can continue.
Okay,
Thank
sir
you.
is here. Now we can start. Okay,
Dr. Rajesh Verma sir? Dr. Rajesh Verma sir? Dr. Sushil Kumar sir?
Yes, I am here.
Dr. Motilal Das sir?
Sir, are you there?
Dr. Motilal Das sir?
Yes, I am listening you.
Okay, Nidhi Arun, you may continue.
Okay, thank you, sir. Now I'd like to invite Dr. Niharika Singh from Ranchi to start her presentation. Dr. Niharika, please.
Oh, good afternoon, ma'am. Good afternoon, everyone. Ma'am, currently I'm having some network issue. Can you call some other participant?
Sure, but please be ready.
I'll check in with my. Yeah, it's not getting shared. Yeah, yes, ma'am. I was ready. It's not getting shared.
Hello, I'm Dr. Rajesh Verma. Okay, move on. Nidhi, move on.
Okay, the next participant is Dr. Pallavi Gautam from Jamshedpur. Are you ready, Pallavi?
Yeah, hello.
Yeah, you are audible. You can go ahead.
My screen sharing video has been stopped by the host. Can it be started? Host has stopped my video.
Given permission, already given permission. Please accept it.
All are requested to please keep their mic mute.
Pallavi, please start. Your video is on. Pallavi, please share.
Yeah, is it visible?
Yes.
A very good afternoon to all. I am Dr. Pallavi Gautam, and I'll be speaking on regional anesthesia as an alternative to general anesthesia for laparoscopic cholecystectomy. Introduction. Use of laparoscopy has revolutionized the surgical field with its advantage of reducing procedures have been traditionally performed under general anesthesia due to respiratory changes caused by pneumoperitoneum. The control of ventilation under has proven it to be an ideal for such procedures. Regional anesthesia has emerged as an alternative choice for laparoscopy. Various reports in literature suggest the safety of use of spinal, epidural, or combined spinal epidural anesthesia in laparoscopic procedures. The advantages of regional anesthesia includes prevention of airway manipulation, an awake and spontaneously breathing patient, minimal nausea and vomiting, effective post-operative analgesia, early ambulation and recovery. Regional anesthesia may be associated with few side effects like requirement of higher sensory level, severe hypotension, shoulder discomfort due to diaphragmatic irritation, respiratory embarrassment by pneumoperitoneum. Aims of my study: It is an observational study to evaluate the efficacy and safety of conducting laparoscopic surgery under spinal anesthesia. The other aim was to compare the efficacy of intra-use of ketamine and dexmedetomidine in group A, along with ketamine and propofol to prevent discomfort due to shoulder pain in group B. Methodology. It is an observational study conducted between September 2019 to August 2020. ASA grade 1 and 2 patients undergoing laparoscopic cholecystectomy were offered first choice of spinal anesthesia for the surgery. A total of 50 patients have undergone abdominal laparoscopic cholecystectomy under spinal anesthesia in this study group. Out of 50, 9 patients had acute cholecystitis, while the 41 had elective cholecystectomy. Exclusion criteria: patients who prefer general anesthesia, contraindications for spinal anesthesia, children less than 15 years of age or more than 60 years of age, any spinal deformity, cardiac problem, or skin pathology overlying the spinal site. Procedure: preloading of 500 ml of ringalactate was done in all patients. All patients were pre-medicated 45 minutes before surgery with either injection ranitidine or injection anesthesia was lumbar puncture needle or L1, L2 intervertebral better. Mixed with 25 micrograms of fentanyl was used. Down tilt of 20 degrees was kept for 10 minutes till level of T4, T5 was achieved, was brought back to normal if patient complained of any respiratory problem. The patient was monitored. Injection ketamine 0.5 mg per kg along with dexmedetomidine infusion was used in group A, while propofol 50 mg was used in group B alternatively. If the patient was not relieved, rescue dose of fentanyl was given, and if patient was still anxious and uncomfortable, conversion of general anesthesia was done. If bradycardia occurred, it was treated with either atropine or glycopyrrolate, depending on the hemodynamic stability. So was it done for the blood pressure, which was managed by use of mefentramin. In all the laparoscopy, we used 4-port entry techniques, and intraperitoneal pressure was maintained between 8 to 12 mm of Hg. The post-operative parameters evaluated included operative site pain, urinary retention, headache, and incidence of post-operative vomiting. In this, we can see the image of palpating the intervertebral space, spinal anesthesia being given in between L1, L2 level. The third image shows the gallbladder with 4-port technique entry. In first image, we can see the just before, at the time of development of pneumoperitoneum, we are seeing the vitals, which is between BP was 148/86. Other vitals were stable. While we dexmedetomidine, in the same patient, the BP had come down to 127/84, heart rate 78, and saturation was 100%. Results: the socio-demographic comparison in both the groups were same. There was no significant difference. There were 25 patients in both the groups. Male is to female ratio in group A was 13:12, while in group B was 15:10. The average age in years was 41 years, while in group B was 39 plus 1.1 years. The ASA grade 1 patient in group A was 10, while in group B was 16. And ASA 2 in group A was 15, while in group B was 9. This again was not significant. I'm sorry, my slides are skipping. In group A, spinal anesthesia along with ketamine and dexmed, the time for creation of pneumoperitoneum was 4 to 6 minutes, while in group B was 2 to 5 minutes. The p-value was not significant. Shoulder pain in initial 5 minutes, which was significant, was complained by 8 patients in group A, while in group B, only 4 patients had complained. While after 5 minutes, shoulder pain in group A was less, that was in 5 patients, and in group B was more, that was in 12 patients. Post-operative nausea vomiting was reported in 5 patients in group A, while that in group B was 9. It was non-significant. Rescue fentanyl was used in 2 patients in group A, while none of the patients in group B required it. Hemodynamic stability, that was on the basis of heart rate variation and blood pressure. The stability was seen in 21 patients. Only 4 patients required either atropine or glycopyrrolate or mefentramin supposition, while in group B, 16 patients showed hemodynamic stability, and only 9 patients required support of mefentramin or glycopyrrolate. This was significant. Need for bag mask ventilation or conversion to GA, 1 patient required it, while in group B, 5 patients required. Post-operative pain was seen better in after use of dexmedetomidine. That was for generally after 6 hours. Patient asked for first rescue analgesia, while it was less for group B, that was around 4 hours. Conclusion. Laparoscopic cholecystectomy using spinal anesthesia is better and safe alternative, as there is no intubation related exposure or complication. Excellent muscle relaxation.
I request everyone to please mute your mic. Please mute your mic.
Rapid return to gut function. Decreased post-operative nausea and vomiting. Intraoperative sedation has better outcomes. The obvious advantage of providing consistent safety to
You're
all
crossing your time limit. Dr. Pallavi,
last slide.
please.
This is the last slide. The obvious advantage of providing consistent safety to operating theatre team due to less airway manipulation in this COVID pandemic. With my STALS observational study, I would like to conclude that laparoscopic surgeries under regional anesthesia should be the new normal and should be studied on a larger group of subjects. Thank you.
Questions from the judges?
Hello.
Hello.
I am Rajesh Verma.
Yes, sir. Good afternoon, sir.
So, what was the point of lumbar puncture?
So I would palpate in between L1, L2 or T2, L1, whichever space was better palpated, I would give my shot in that area.
Don't you think this was a high risk approach?
So almost 50 patients that I have given, none of the patient had any complications.
No. I am asking, it is recommended or not?
So the recent studies are recommending it. There is always a chance of damaging the spinal cord as the cord is progressing to a lower level.
So the thing is, what was the purpose? There is hypercarbia, and you are going for a procedure which does not remove carbon dioxide from blood.
But the patient was breathing spontaneously on room air, and the saturation was 100% maintained, and the patient was controlling his through the CO2 was being eliminated. So.
Okay.
Hello. Hello, this is Motilal.
Good afternoon.
Hello. Good afternoon. First of all, spinal anesthesia is not recommended. Okay. So then what is your indications for this spinal anesthesia for lap cholecystectomy?
So one, we are avoiding the airway, especially in private practices where we do not have very good backup of for airway management. The basic Boyle's machine is available where we are bag mask ventilating with our hand. So we are at increased risk of contracting infection as compared to if we don't know if we like give spinal anesthesia and give oxygen via nasal prong or simple anatomical mask. So
as you have said, the oxygen was 100%. So yes. That was with oxygen or without oxygen?
So,
without support.
So most of the patient did not require. I have also mentioned in patients where there was a dip of saturation, we had to mask ventilate around 6 patients out of 50 patients. We had to supplement bag mask ventilation. But most of the patient did not require oxygen supplementation with bag mask.
How many patients not required?
So 6 patients required in group B, where we were using propofol, while 4 patients required in group A, where we were using dexmedetomidine, while most of the patients otherwise did not require oxygen supplementation.
And how you have find the discomfort in the soldiers?
Sir, we have cross the limit, 2 minutes
The
limit
patient,
of question session.
after giving sedation, if still patient was raising either hand or was vocalizing at few times, कि दर्द हो रहा है, that was the thing with which we made sure there was shoulder discomfort.
Thank you. Okay. Thank you, Dr. Pallavi.
Thank you, ma'am.
Thank you for the nice presentation. Now I would like to call upon our next presenter, Dr. Ravindra Jha from Madhubani. Dr. Ravindra. Please share your screen, unmute yourself. Dr. Ravindra, are you there?
We may escape him for a later chance.
Do you want to present?
Let Niharika present her topic.
Okay, Niharika, are you ready with your presentation? Dr. Niharika?
Dr. Ravindra Jha is presenting. Wait.
Okay.
Hello?
Yeah, you are audible.
Niharika, you wait. Niharika, you wait. Dr. Ravindra Jha is presenting.
Okay, sir. Okay, sir.
Hello, I'm audible. Hello.
Ravindra, are you there? Please reply.
Yeah, I'm here, sir.
Please
Your
make some
voice is
changes
not
in your
audible.
setting.
And
Voice is not audible.
So in the meantime, can I request all the judges to fill up the forms real time so that as the session is over, they can send the results.
Yes, we are doing. Yeah, we are doing it in the real time. Thank you.
I think we should allow Niharika, Dr. Niharika, to present
Yes,
for the time
that
being.
will be the right time.
yes, that is true.
Dr. Niharika, please start your presentation.
Ma'am, I can't upload my slides. That's a problem. Net is
Are
not
you on a
working.
laptop? Then I'll request
No,
Mr.
ma'am, my
Anand.
laptop is not working and I don't know how to start it from mobile.
Dr. Sanjeev Kumar from Patna, are you ready for the presentation? May I request you to start your presentation? Dr. Sanjeev, please. Dr. Sanjeev, are you there? Dr. Niharika's presentation, she is unable to upload. Dr. Ravindra Jha is also not ready. Dr. Sanjeev?
With mobile, it will be difficult for her, Nidhi.
I also think so, ma'am. If she can't manage a laptop,
ये है क्या है कीनोट में नहीं जाएगी.
Excuse me, just wait for everyone. Please mute your mic, everyone, please. I request the coordinator to please call individual speaker. If they are able to present, good. If they are not, please move on. We can't wait.
Okay, Dr. Sanjeev Kumar.
Ready, ma'am.
Okay, Dr. Sanjeev, please start your presentation.
Okay. अच्छा सुनो, तुम्हारा स्लाइड मेल कर सकती हो जल्दी से किसी को? नहीं, मेरे को नहीं कर रहा हूँ, तुमको एक नंबर दे रहा हूँ, उस पे करो, ठीक है?
म्यूट करो.
Am I visualized?
Dr. Ravindra, you may start.
My presentation is ready, but hello. Okay, ma'am. Okay, I'm ready with my presentation.
Dr. Ravindra is ready with his presentation. He is going to start his presentation.
Good afternoon, everyone. Today, my topic of presentation is.
Your voice is very poor, not audible.
Hello.
Yes, now okay.
No, now it's fine.
Can I start?
Your
Yes.
time starts now. Your time starts now.
Good afternoon, everyone.
Start your presentation, Dr. Ravi.
Can I start, sir?
Yes, we
your
are waiting.
time has started.
Myself, Dr. Sanjeev. Hello.
No, Dr. Ravindra is presenting.
Dr. Sanjeev, please wait. Dr. Ravindra Jha is ready with his presentation. He is
Okay,
presenting
I'm
now.
waiting.
Okay.
Good afternoon, everyone. I'm Dr. Ravindra Jha, and my topic of presentation is the post-operative analgesia efficacy of pain. The word pain is derived from Greek word point means penalty, and ponia in Latin is punishment from God. And IASP defines pain as unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. In 1819, the pain was managed like this. Why to treat pain? Pain is the most common reason for patients seeking medical attention each year, between 50 to 90%. So, proper optimal management of pain is necessary. Moral responsibility, suffering, and post-operative complication, likelihood of chronic development of pain. Cesarean section is major surgical procedure after which substantial post-operative discomfort and pain can be anticipated. The provision of effective post-operative analgesia is important to facilitate early ambulation, infant care, including breastfeeding, mother-infant bonding, and the prevention of post-operative morbidity. The analgesic regimes need to meet the goal of providing safe and effective analgesia with minimal side effect of the mother and her baby. A multi-mode approach to post-operative analgesia after cesarean section is required. Consequences of poorly managed post-operative pain is psychological, like anxiety, depression, chronic post-surgery pain, increased medical expenses, and prolonged hospitalization needed for this. The aim of this randomized double-blind study was to evaluate the post-operative analgesia efficacy and opioid sparing effect of transverse abdominis plane block after cesarean section under spinal anesthesia. The transverse abdominis tab block was redefined in 1980s, where we need a single puncture technique via the lumbar triangle of Petit, and recently the ultrasound guided has modified the tab block with better results. But in my study, we used the double pop technique. Landmark of this triangle, as in this diagram we can see, which lies just above the pelvic rim in the mid-axillary line. The inferior border of triangle is the iliac crest, and the anterior border of the triangle is formed by lateral edge of the external oblique muscle, and posterior border is formed by the lateral edge of latissimus dorsi muscle. It is just above to the mid-axillary line with triangle of Petit. 24 gauge blunt tip 50 mm needle is inserted perpendicular. It will give two pop. First pop is between the external oblique muscle and facial extension, and on further advancement, second pop that indicates that facial plane above the transverse abdominis, and after the aspiration, 25 to 30 ml of anesthetic is injected. Complications include infection, hematoma, nerve injury, local anesthesia toxicity, peritoneal perforation, and bowel and vessel perforation rare. Assessment of pain this study was done on visual analog scale from 0 to 10 centimeter, where 0 is no hurt and 10 is the worst pain. Other pain scale is also available. Ropivacaine drug was used, which is long acting and preservative free. It is mainly metabolized by liver and eliminated through the kidney. And doses what we use is 1.5 mg per kg ropivacaine 0.375%, maximum dose 150 mg per site, and upper dose limit is 275 mg. Ropivacaine should only be administered in incremental doses. Method: after getting approval from ethical committee, 50 ASA grade 1 and 2 female patient, pregnant female patient who is planning for elective surgery in prepenical incision was double-blinded control clinical trial. Baseline data like pulse rate, blood pressure, respiratory rate, and basic investigation were collected. The study group and control group explained about the procedure of tab block and spinal anesthesia. The post-operative follow-up pattern was explained to the patient and asked to tell the number. Patients were randomly allocated the undergo tab block with 25 divided into two groups. Ropivacaine group level as R and normal saline group is N. Before patient was come to the pre-operative room, 18 gauge IV cannula was secured, preloading done with the crystalloid. Under asepsis condition, spinal anesthesia with 5% bupivacaine, 12 mg is used, 25 gauge Quincke needle. After the finishing the surgery, the tab block was performed bilaterally by anesthesiologist who was blinded to the drug, and double pop-off technique was used to locate the transverse abdominis plane. Group R received 20 ml of 0.35% ropivacaine on each side, with normal saline in second group 20 ml on both sides. And then patient, after observing closely for sign of toxicity, patient were shifted to the post-operative ward. Rescue analgesia tramadol 100 mg IM was used when patient demand or visual
Dr.
analog
Ravindra,
score is more than 3. Then rescue
please
analgesia.
sum up.
If, between 3
You are
to 6
exceeding
hours,
your time
patient
limit.
again demand 50.
Please sum up fast. Conclude it fast.
Conclusion. Ma'am, actually some disturbance in
You had already crossed your time
in
limit.
our study, we have evaluated analgesic efficacy.
Just come to the result and conclude it. You have already crossed your time limit.
Okay, post-operative pain, as we see visual analog scale in our basis for up to first 4 hours. In ropivacaine group, there is no need of analgesia, while in normal saline it is used. Heart rate was lower in all hour. In the ropivacaine group, blood pressure is also, which is significant. Time demand for analgesia, here is the main comparison. 4 hour, up to the 4 hour, no need of rescue analgesia in the ropivacaine group, while in bupivacaine is needed. Total tramadol requirement is much more in the normal saline group than the ropivacaine. So summary, the study has evaluated the analgesic efficacy of opioid sparing effect of tab block post-operatively analgesia after cesarean section. The result was shown that tab block with ropivacaine, a standard analgesic, provided superior analgesic effect with reduction in post-operative VAS score, reduced mean opioid consumption, and longer time for first rescue analgesia without complication. So tab block was superior than the normal saline group. That is my conclusion.
Questions from the judges, please.
Myself, Rajesh Verma. So, Ravindra, are you in a private practice scenario or in a medical college?
Nidhi.
Yes, sir.
Can I interrupt for a second?
Sure, sir.
This is my fault. I have not introduced a judge also. And the external judge of this session is Dr. Sachidanand. Dr. Sachidanand is also with us. Sorry, sir. This was my mistake. Just forget to introduce you. My mistake, please. And you, sir, Dr. Sachidanand is an additional professor, onco anesthesia and palliative medicine, AIMS, New Delhi. Sir, welcome, sir. Dr. Sachidanand, sir. I'm sorry, sir. You can ask the question from the speaker, sir. Dr. Nidhi, please take a note of this.
Oh, sure, sir. Sure. Questions for presenter? Any more question from the presenter, or we should move ahead?
No, where was the place of work, Dr. Ravind? Where did you experimented all the patients? In which hospital? Ravindra, are you? Am I audible? Dr.
Okay,
Ravind,
Ravindra, you are not
can you
audible.
hear me?
Yes, sir. I am hearing you. It's Scripps
So-
Hospital, Madhubani, 100-bedded hospital.
So, are all the slides made by you, or have you copied some of the slides from somewhere?
No, sir. Made by me, sir.
Okay. Hello. We can move to another speaker.
Okay, sir. Thank you, Dr. Ravindra. And Dr. Sanjeev, are you ready with your presentation? Next speaker
Ready.
I'd like to invite is Dr. Sanjeev Kumar. He's from Patna. He's working in Paras, HMRI Paras, Patna. Dr. Sanjeev, please start your presentation.
Okay. Good afternoon, sir. I am presenting a case of foot drop following combined spinal cord anesthesia. Case details: a 60-year-old male patient, known case of osteoarthritis and diabetes mellitus type 2, scheduled for left total knee replacement under combined spinal cord anesthesia. Preoperative was uneventful.
Dr. Sanjeev, you are not audible.
Not audible.
Now you're audible. Please move to your next slide.
Okay, next. Intraop, by the use of an aseptic technique with the patient in the sitting position, combined spinal epidural block was given with 18-gauge Tohi needle at L3, L4 epidural space, followed by spinal intrathecal block with the 25-gauge Quimke needle at L3, L4 level. After a good flow of CSF, 2.5 ml of hyperbaric bupivacaine was injected. Epidural catheter was fixed and patient was made supine, followed by test dose of 3 ml of 2% lignocaine with adrenaline given. After 10 minutes, sensory block to pinprick was obtained at T10 level. The surgical procedure was uneventful and lasted for 90 minutes. Post-op, day 1, after surgery, patient was shifted to high dependency unit. Vitals was stable. Pain relief was provided with easy pump containing 123 ml of 0.2% ropivacaine and 100 microgram fentanyl started at the rate of 5 ml per hour. On day 2, vitals were stable, but patient complains of not being able to move his right foot, while he was able to move his left foot easily. Examination. On examination, I found there was weakness of right extensor hallucis longus and right extensor digitorum longus. The neurological examination was done every 4 hourly. Epidural catheter was removed immediately. Electromyography was done of right lower limb, which shows normal study. MRI of lumbosacral spine was done, which shows mild to moderate diffuse disc bulge fascicopathy at L3, L4 level and L4, L5 level, accentuating the neural foramina and lateral recesses, causing compression over bilateral exiting nerve roots. So diagnosed as a case of foot drop as a result of exacerbation of pre-existing disc bulge due to epidural drugs. Treatment. Injection solumedrol, methylprednisolone 1 gram IV OD started. Injection CB max, which contain vitamin B12, started giving IV. Tablet gabapentin 100 milligram, 1 tablet BD, and tablet tetrafol, which contain folic acid and pyridoxal phosphate, started OD. The patient was discharged 1 week later with advice to gear foot drop splint, physiotherapy to be continued, steroid in lowering dose for 15 days, gabapentin and folic acid for 1 month, and to review after 1 month. Discussion. Foot drop may be due to lesion of common perennial nerve, L5 radiculopathy, or partial sciatic nerve lesion, or lesion involving lumbosacral plexus or chordae icona. The differential diagnosis of foot drop should be carefully considered centrally or peripherally location of the pathology. Nerve conduction study and MRI of spine are the mainstay of investigation. Pitfalls of the case.
History of back pain was missed as his knee pain masked the back pain. Proper neurological examination not done preoperatively. Take-home messages. Unilateral foot drop is unusual and rare complication of epidural or spinal anesthesia, but it should be considered as differential diagnosis if previous history is present. Here is the importance of history taking and neurological examination is emphasized, which may have prevented it. Thank you.
Thank you, Dr. Sanjeev, for completing before time. Now it's time for a question from the judges.
Hello, Sanjeev.
Yes, sir.
Are you hearing me?
Yeah, hearing, sir. I'm not getting your voice, sir. I'm not here getting your voice, sir.
Dr. Motilal Das, please unmute
Please
yourself.
unmute yourself.
Hello, are you hearing?
Yes, sir. Now I'm getting your voice, sir.
Yes, you have told epidural drugs may cause foot drop. So how
Yes,
it
sir.
can produce the epidural foot drop by using epidural drugs? It may
Sir,
be
already
due to damage of the
yes,
nerve
sir.
root, nerve
Yes,
fiber.
yes, sir. Already when the patient develop foot drop, we get MRI done, and in an MRI it was shown the result that there was a moderate disc bulge, and it was causing the bilateral nerve compression, and the drug might have exacerbated the disc bulge leading to foot drop.
Pre-operatively, you have not done the MRI.
No, sir. Pre-operatively, I don't did the MRI.
They didn't even examine properly. The neurological examination and local examination was not proper.
Foot drop may be due to nerve injury or nerve fiber damage.
Yes, sir. Most electromyography was done, sir, but it was normal. And in the MRI, it showed that there was a moderate disc bulge causing bilateral nerve compression at L3, L4 level and L4, L5 level.
Dr. Sanjeev.
Yes, sir.
I am Dr. Mohib Ahmed from Ranchi. You called the patient after 1 month. Did you follow up the case? What happened?
Yeah, I following the case, sir. The surgery was done on 31st of this August. He developed on 1st. I met him yesterday also.
Okay,
He has full blown this foot drop, and he has been back to Assam. And I have his phone number. I will be following him till he gets back to normal, or didn't go back to normal. Only time will tell.
Is there any improvement after this after the discharge, or is it still the same?
Till 13 days, there is no improvement, sir.
Okay, thank you.
Thank you, judges, for the questions. And now I will again like to ask from Dr. Niharika Singh, are you ready with your presentation? Or we...
Yeah, Dr.
Yes, ma'am. Yes, ma'am.
I will be sharing the presentation of Dr. Niharika, and so she can present.
Niharika, you can start.
Yes, ma'am. Yes, ma'am. I'm ready. Dr. Shividya, ma'am, will share my slides.
Okay.
Good afternoon, everyone. My topic for today is evaluation and analysis of bedside pulmonary function test in Hospital of Eastern India. This was my thesis topic also. Next slide, please. Pulmonary function test is a test that measures the function of the lung capacity and lung and the chest wall mechanics to determine whether or not patient has lung problem. It is used for the following reasons: screening for the presence of the obstructive or restrictive diseases, evaluating the patient's condition for weaning from a ventilator. Next slide, please. Evaluating the patient prior to the surgery, especially for patients who are older than 60 years of age, who have pulmonary dysfunction, who are obese, and has history of smoking, cough, and wheeze, and expected to be under anesthesia for more than 3 hours, and who has to undergo abdominal or thoracic operation. Next slide, please. It is also used for documenting the progression of pulmonary diseases and to check the effectiveness of therapeutic intervention. So a bedside pulmonary function test is a simple, easy, cost-effective bedside test to assess the pulmonary function of a patient. Next slide, please. In this study, we checked for 4 bedside pulmonary function tests, which were peak flow meter test. It is a simple handheld machine which measures peak expiratory flow rate. The normal value for the male are 450 to 700 liters per minute, and for females, it is 350 to 500 liters per minute. It is mainly reduced in obstructive lung diseases. Then second was Sebras's breath holding test. Patient was asked to take a full breath and hold it to the time they can. The normal volume is said to be more than 25 seconds. If it was 15 to 25 seconds, it was said to have limited cardiopulmonary reserve. It is less than 15 seconds, it is very poor cardiopulmonary reserve. Basically, breath holding time correlates with the vital capacity of the patient. For example, if it's 25 to 30 seconds, it approximates with the vital capacity of 3500 ml. If it's 20 to 25 seconds, it approximates with vital capacity 3000 ml. If 15 to 20 seconds, 2500 ml. And if 5 to 10 seconds, it approximates to 1500 ml of vital capacity. The third test was cough test. Patient was asked to cough, and they were tested for the ability, strength, and the effectiveness of the cough. Inadequate cough was seen if the patient had peak expiratory flow rate of less than 200 liters per minute, forced expiratory volume in 1 second less than 15 ml per kg, and forced vital capacity less than 20 ml per kg. Then the fourth test was forced expiratory time. Patient was asked to expire, and a stethoscope was placed on the trachea, and the length of the expiratory time was measured. Normal value is said to be 3 to 6 seconds. If restrictive lung disease is seen, it is less than 3 seconds. If obstructive lung disease is there, it is more than 6 seconds. Next slide, please. The aim of the study was to perform the bedside pulmonary function test in the study population and to analyze it to the various factors such as gender and BMI in the study population. Next slide, please. The study was done in inpatient of the surgical ward of the Tata Main Hospital, Jamshedpur. And all the patients who were 20 to 40 years of the age and who fulfilled the inclusion criteria were included in the study. Next slide, please. The inclusion criteria were patient willing for the pulmonary function test, who are of ASA grade 1 and 2 with no comorbidities and normal airways. Next slide, please. And exclusion criteria were patient not willing for the observation and who had pre-existing pulmonary or cardiac disease or had recent eye surgery or have thoracic abdominal or cerebral aneurysm. So the total sample size was 200. Next slide, please. So coming to the result, coming to the first bedside pulmonary function test, that is peak expiratory flow rate, we saw that the mean peak expiratory flow rate of a total male study population was 560 liters per minute, while that of the female was 422 liters per minute. Highest peak expiratory flow mean value were seen in both male and the female in the BMI category of 18 to 25 BMI. While in the male population, least value was seen in the BMI category of less than 17.9, while that of the female was seen in the BMI category of more than 25. Next slide, please. Now coming to the breath holding time. In the study, it was seen that the mean breath holding time of total male study population was 42, while that of the female was 36 seconds. Across all the BMI categories, female mean value were found to be less than that of the male mean values. In male study population, least value of mean breath holding time was seen in the BMI category of more than 30, as it was the same case scenario with the females. Next slide, please. Now coming to the forced expiratory time. The mean forced expiratory time of the male study population was 4.2 seconds, while that of the female was 3.4 seconds. The forced expiratory time of female in all the BMI categories are lesser than male's forced expiratory time, with exception of BMI more than 30. That is, female who were of BMI more than 30 had higher peak forced expiratory time in comparison to the male counterpart of BMI more than 30. Next slide, please. Coming to the cough test, total study population was able to cough adequately and effectively. Next slide, please. So to conclude, to summarize the study was undertaken with the aim to perform the bedside pulmonary function test and to analyze the distribution of the bedside PFT with the factors like gender and the BMI. Our results reveal that the bedside pulmonary function tests are higher in males compared to the females.
Please sum up.
And a negative correlation was found between pulmonary function tests and the BMI. Thank you.
Thank you, Dr. Niharika. Now it's time for the questions from the judges.
Dr. Niharika.
Yes, sir.
Hello.
Yes, sir.
Yeah, I'm
Sir?
I'm Dr. Mohib Ahmed.
Yes, sir.
Yes, the results that you got, the peak expiratory flow rates as
Yes,
well
sir.
as the forced vital capacity, everything. If you compare on the gender wise, it's obviously it will be higher in the males and less on the females. There's nothing new to say. Okay, you could more sum up more on the BMI levels. Okay, that
Yes,
was
sir.
one
Yes, sir.
point I wanted to make. Another
Yes, sir.
point I want to ask, do you have any correlation between the tidal volume and the effective cuff? You said that it's related with the peak flow rate or force vital capacity. Any relation that
Yes,
you know
sir.
of?
No, sir. So actually, I didn't do tidal volume, sir. I just a bedside pulmonary function test, sir.
No. What I want to say, how much of the tidal volume? Do you know that if you have a tidal volume 3 times the vital capacity, if you have a tidal volume of like, if a tidal volume of 500, if the patient is having 1500, then
1500.
he can, yes, he can cough effectively. That is the 3 times the tidal volume the patient can cough. Yeah, that was one point I wanted to add to. Thank you very
Okay,
much.
sir. Okay.
One question, Dr. Niharika.
Yes, sir.
You have tabulated your observations and results so meticulously, but
Yes,
your
sir.
method is that method of listening the breath sound over the trachea with a stethoscope and noting the time. Can we do it so accurately? I
So
think this method is not so accurate for observational and analytical purposes.
So this can be come into few of the limitations of the study, that it's not very, it can't be predicted very accurately.
Yeah.
Dr. Niharika.
Okay.
Yes, sir.
Myself, Rajesh Verma.
Yes, sir.
There
Good
is
afternoon,
one
sir.
Snyder's match stick test. Do you know about
Yes,
it?
sir. Yes, sir. I knew, sir. I included it in my study, but the ethical committee, they said to remove this test because of the match blowing and fire alarm issues. They removed it from my studies. Snyder's match blowing test. So in this test, we lit a match and with 6 centimeters away, asked the patient to blow the match, and it shows the maximal minute ventilation. It correlates with the maximum minute ventilation. But sir, I couldn't include it in my study because of the ethical committee.
It is 6 centimeter or 6 inches.
Sir, 6 inches, sir. Sorry, sir. 6 inches. 6 inches. Sure, sir.
And
6 inches.
you don't have to purse your lips, you have to open your
Yes, sir.
mouth and then blow
Open
it.
the
Yeah.
mouth wide. Yes, sir.
The 2 minutes for the question session is over now.
Okay, thank you.
With this, we come to the end of the session. And I'd like to request all our judges to please fill that form and send it back to the concerned person. As well as I'd like to apologize Dr. Sachidanand on the behalf of all the coordinators that we didn't introduce him at the beginning of the session due to some communication gap. And I'd like to thank all our respected judges as well as our active participants for their enthusiastic participation. Thank you. And now I'd like to hand over the station to Dr. Ajay for the next session. Dr. Ajay.
Thank you. I will be sending.
Good evening to all of you. I am audible?
Yeah.
Yes. Good evening to all of you. Now session start for Best Paper Award. Postgraduate Best Paper Award. 6 candidates are selected in this session, and our judges, 4 judges with us, and our judges are renowned person. And the first name, I want to take the first name, Dr. Prithvish Bhattacharya. At present, Director NIGRIMS, Dean's ex-registrar, and the HOD Anesthesia and Critical Care. And the second judge is Dr. Shasikant, past President ISA Bihar Jharkhand,
and ex-HOD, TMH Jamshedpur. And our third judge, Dr. Prakash Dubey, sir, at present Professor, the Department of Anesthesia, IGMS Patna, and he is academic person known for the research and publication, so many publications in different journals. And next is Judge Dr. Chandni Sinha. At present, she is working as an additional professor, Department of Anesthesia, Patna AIMS, and she is known for the master in regional anesthesia. And the four judges, please, आप लोग लॉगिन हो चुके हैं? Sir?
Yes. Yes,
Okay,
I have logged in.
Okay, thank you, sir. And our speakers, you all are logging?
Yes, sir.
Yes,
Yes,
sir.
sir.
Yes, sir.
Okay, okay. And the session, first speaker,
Dr. Apurva Baski.
Dr.
Apurva
Umesh,
Baski.
please call
Yes,
her.
sir. Okay, okay. Judges, wish you to start the session?
Yes.
Yes.
Yeah. Please go ahead.
First candidate is Dr. Apurva Baski. Dr. Apurva Baski, are you ready?
Yes, sir.
Yeah, start please.
Good evening to one and all. I'm Apurva Bakshi, and today I'd like to present a paper which is a prospective randomized control study on evaluation of the efficacy of ultrasound-guided transmuscular chordatus lumborum block in a multimodal analgesic regimen for post-operative analgesia after total laparoscopic hysterectomy. So first of all, why is post-TLH analgesia challenge? Because we expect less pain because it's laparoscopic procedure. And it is difficult to control because of various perioperative predicaments like incisional pain, pneumoperitoneum, stretching of the intra-abdominal cavity, when there is blood left in the abdomen, and because we are basically dissecting the pelvic region. So what are the various post-TLH analgesic options that we have? We have opioids, NSAIDs, regional anesthesia, which is mainly epidural, local anesthetic wound infiltration, and truncal nerve blocks. And in our study, we used transmuscular chordatus lumborum block, in which basically a needle is advanced in the posterior anterior direction through the chordatus lumborum muscle, and the local anesthetic is injected in the space between the chordatus lumborum and the psoas major muscles. And even the spread of the local anesthetic can be confirmed on USG. Coming to the objectives of our study, primarily, we wanted to know the time to the first analgesic request by the patient. Secondarily, we wanted to know the amount of fentanyl consumption, severity of pain on rest and movement, patient satisfaction, complications of the QL block, incidence or severity of nausea, vomiting, pruritus, sedation, and respiratory depression due to the fentanyl consumption. We obtained the approval of the ethical committee before starting the study. Even the patient's informed consent was taken, and our study population included the patients who were undergoing TLH under general anesthesia. They were more than 18 years of age, and they belonged to ASA grade 1 and 2. So our sample size was 72 patients, and after randomization and blinding, they were divided into two groups equally of 36 each. And the patients in QL block group received 20 ml of 0.375% ropivacaine, whereas the patients in the control group received saline. Also, all the patients received fentanyl as IV patient-controlled analgesia, which included 20 microgram fentanyl as demand dose with a lockout period of 10 minutes. They also received diclofenac 75 mg as IV infusion, which was 12 hourly. All these patients were assessed at regular intervals. Coming to our results, it was significant. The primary objective that we had, that is the time to first analgesic request, was highly significant because it was seen to be 7 hours and 7 minutes in QLB group, whereas it was significantly less in the control group. Similarly, our secondary objectives like mean dose of fentanyl used, comparison of pain on rest and on movement, and the patient satisfaction, they were significantly higher and in favor of the subjects in the QL group. Coming to nausea, vomiting, and sedation, it was significantly lesser in the QL block group, whereas side effects like pruritus and respiratory depression, they were just comparable between both the groups. Also in our study, there were no complications due to QL block or OPVKN which were found. So basically, a study demonstrated that TQLB provides effective analgesia when it is used as a part of multimodal analgesic regimen in patients undergoing TLH. And the main reason for us to use TQLB block among the other blocks was the mechanism of action. According to cadaveric studies, it has been hypothesized that the local anesthetic spreads from the thoracolumbar fascia via the diaphragmatic openings into the endothoracic fascia and from there into the paravertebral spaces. As a result, the somatic routes that are blocked are lower thoracic and upper lumbar routes. Not only this, it has also been hypothesized that the local anesthetic blocks nociceptors, mechanoreceptors, and the sympathetic fibers in the thoracolumbar fascia. The limitations in our study was that this was the first randomized controlled trial which was used to evaluate the efficacy of TQLB for analgesia and TLH. And at present, there are no defined criteria or guidelines for the performance of this procedure. And we weren't able to determine the extent of the sensory blockade. Also, there could have been technique variability between the different operators. So I would like to conclude by saying that in our study, we found that QL block effectively reduces pain after TLH. It significantly increases the time to the first analgesic request. It decreases the total 24 hours fentanyl requirement and hence their associated adverse effects. And the patient satisfaction scores were visibly higher in QL block. Thank you.
Thank you,
Question
Dr.
from Delhi.
Apurva. Thank you, Dr. Apurva,
yes,
for
sir.
keeping in time. Now, the one thing I would request to you to clarify is you said it is as a part of multimodal analgesia.
Yes, sir.
Now, where are the other modes that you used and what were their confounding possibilities?
So we used fentanyl as IV patient control analgesia. So that could have been one. And we regularly gave 12-hourly diclofenac 75 mg. So that's how we use it as a part of multimodal analgesia.
So if you are using fentanyl, what was the dose?
20 micrograms, sir.
The 20 microgram was a bolus or a demand bolus?
Demand
and
bolus,
how many
sir.
boluses? Okay. Control group, how many microgram were needed for fentanyl in the control group and how many in the block group?
So the mean dose that was found in 24 hours was QLB block required just 150.32 microgram, whereas the control group required 247.28 micrograms.
Okay. Okay.
Dr. Apurva.
Okay.
Yes, sir.
Can I have a question?
Yes, sir.
I'm Dr. Sasikant.
Yes, sir. Good evening.
What is your end point when you are injecting the needle and drugs as a transversus transmuscular coordinator? So
Sorry,
what
sir, I
is the
couldn't get your
end?
question.
What is the end point? Where you use your needle to make it safe? Because there are so many types of block.
Yes, sir. In my block. Sir, in my block, it was inserted, the local anesthetic was injected in front of the cortices lumborum muscle and behind the psoas major muscle, sir. In the thoracolumbar fascia, so that was the end point.
So, do you expect any complication out of this?
Yes, sir. The complications that can be seen is if we ended up giving higher dosages, there could have been prolonged motor block, and they could have been, due to vascular absorption, there could have been local anesthetic systemic toxicity, sir.
Motor block means?
Sir, because it has been hypothesized that the nerve roots which are blocked are lower thoracic and upper lumbar. So because of upper lumbar blockade, it may affect the distribution of those nerves, sir. So the lower limb muscles weakness may be observed in some
Can
cases.
it produce high block also like a spinal epidural?
Yes, sir. In such cases, hypotension can be seen, sir.
Hypotension because of lumbar spinal sympathetic also, is it? I don't know.
Yes, sir. Because it went into the paravertebral spaces and there was sympathetic blockage, so hypotension can be seen as a complication of it.
And you said that fentanyl and diclofenac used as a multimodal. So
Yes,
this is the basic requirement of any laparoscopic procedure. Because what is the concept of pain during the laparoscopic procedure? Is it only local pain or is it something pain related with visceral pain?
It includes visceral pain also, sir.
And what is those? What is the role of fentanyl? Which type of pain it reduces? Fentanyl.
It helps in reducing the visceral pain, sir, because it blocks the slow C type of
You are
fibers.
right.
It helps
You are
in.
right. But diclofenac, why you have added diclofenac? Yes, it has got some meaning.
Yes,
why there is shoulder pain after laparoscopic procedure? And what is the management of shoulder pain? Because in TLH, you have to put patient in different position after putting pneumonia. So what is the concept of what is the reason behind this pain in the shoulder region and how will you manage it?
If there has been any diaphragmatic irritation, maybe we can come across the shoulder pain.
Of course, should come across most of the time. So what is the management of that pain? It is linked with your representation.
Sorry, sir.
So diaphragmatic pain, how will you manage that? Because diclofenac is supposed to helping that.
Okay.
Apurva.
Okay.
Apurva.
Yes, ma'am.
Yeah, I just have one question.
Yes, ma'am.
This limitation, you said that you did not assess the sensory blockade. Why didn't you assess the sensory blockade? It is, you have adult patients, you could have given bilateral blocks, could have
Yes,
assessed
ma'am,
the
we could
sensory
have.
blockade and then gone ahead.
We could have
Then
assessed
why
it,
didn't you
ma'am,
do it?
but in our study, we didn't do it because we were trying to concentrate on the other objectives, ma'am. So we didn't have this as our objective to determine the extent.
See, in adults, whatever in adults, the recommendations are the block should be done under general anesthesia or in an awake patient. Ideally, should be done under in awake patients, right?
Yes, ma'am.
So could have gone ahead doing it in awake patient, then do GA, right? Okay. And how did you assess your block failure? What was your criteria for block failure?
Block failure.
You gave the block, right? You saw it and you gave the block. What was your criteria for block failure?
We just tried to analyze. We just tried to analyze the time which was required for the first analgesic request, ma'am, and that's how we tried to know, because it was significantly seen, and hence we figured it that there wasn't any block failure as such.
So you have given 72 blocks, right? You have 22 blocks.
Yes,
so imagine 72 blocks. So you would have defined your block failure also. Or right from the beginning, you expected all the blocks to work.
No, ma'am.
Time is over, madam. Time is over.
Dubey sir.
Yeah, Dr. Prakash here, Dr. Apurva. You have in the limitations, first point you have written that this is the first RCT, such RCT. Okay.
Yes, sir.
How did you calculate the sample size in your study?
So the sample size, we took, the power of the study was taken as 80% and the confidence interval we took as 95%, sir. And the type 1 error was kept at 5%, sir. And we tried to select a sample size based on similar studies, laparoscopic studies, but not the, yes, sir, not the similar study, but similar laparoscopic gynecological studies. We tried to compare with them, sir.
Okay. Thank you.
Thank you, sir.
Thank you, Dr. Apurva, for nice presentation.
Thank you, sir.
Next candidate is Chetan. Dr. Chetan.
Good evening, sir. Yes, sir. Present, sir.
Are you ready?
Yes, sir. I will share the screen, sir. 1 minute.
Okay. Start, please.
Sir, is it visible, sir?
Yeah.
Shall I start, sir?
Yes. Go ahead.
Good evening. Good evening, all respected secretaries. My topic is ultrasound-guided rhomboid intercostal plain block in pediatric patients undergoing video-assisted thoracoscopic surgery. It's a randomized controlled trial. Myself, Dr. Chetan. Video-assisted thoracoscopic surgery, it can be used as both diagnostic as well as therapeutic. It causes post-operative pain. As such, there are no gold standard exists for adequate pain management in bats. In RACPB block, we inject local anesthetic into the facial plane between rhomboid major and intercostal muscle. Previously, it was used for thoracotomies, rib fracture, and breast surgery. Its role in VATS is less established, and no RCTs have been done to establish its role in thoracoscopic surgery, especially in pediatric age group. Our hypothesis is ultrasound-guided RACPB block would decrease fentanyl consumption during perioperative period in patients undergoing VATS. Our aim is to study the efficacy of this block in pediatric patient 7 to 12 years undergoing thoracoscopic surgeries in terms of analgesic requirement, pain scores, and side effects. Our primary outcome was to assess amount of intraoperative and postoperative fentanyl consumption for a period of 24 hours.
Please unmute camera. Camera unmute. Camera
Sorry?
is not. Camera is not on.
1 minute, sir. Sir, I'm.
You are not visible. Okay.
Am I visible, sir, now?
Yes, yes. Continue.
Now you are visible. Our secondary outcome is to assess the post-operative pain score in terms of mean numerical rating scale and side effects like vomiting and respiratory depression. Methodology. Ours is a prospective randomized controlled double-blinded trial. Here, the patient and the outcome assessor was double-blinded. IEC clearance and CTR registration was done. We include pediatric patient of age group 7 to 12, ASA physical status 1 and 2, and posted for thoracoscopic surgery. We exclude patient of ASA 3 and 4, patient with coagulopathy, refuse to give consent, patient who do not have communication capacity, do not understand NRS, and hemodynamically unstable patient. All these included patients were examined and parental consent was taken. They were educated about the use of PCA pump and NRS assessment preoperatively. Methodology. Ours was a randomization was done to decrease confounding bias by computer generated random numbers, and concealment was done to decrease selection bias by opaque sealed envelope until a group was assigned. We got two groups, group R and group F. Both got general anesthesia and standard precautions, and group R received the block. In group R, patient in lateral position, ipsilateral arm on the opposite side with transverse linear probe medial to the angle of scapula at the level of T7. We defined triangle of auscultation. We gave 10 cc of 0.2% ropivacaine. Group F didn't receive the block. They received only fentanyl top-ups. Statistical part. Sorry, sir. Post procedure, after 20 minutes, surgery was done, and post surgery, patient was shifted to post-operative recovery unit, where they received fentanyl in the form of PCA pump, 20 mcg, 10 minutes lockout interval, 6 doses, maximum 6 doses in an hour. And also in post recovery, we assessed vitals and saturation, and also nausea, vomiting we assessed. Statistical part, we did pilot study on 8 patients previously, and mean intraoperative fentanyl was assessed as 1.5 plus or minus 0.5 microgram per kg in block group, which was very much less than the fentanyl group, that is 2 mcg per kg. Hence, we took alpha error of 5% and power of study 80%. We got sample size of 16. Considering dropout rate of 20%, we increased the sample size to 20. An unpaired t-test and chi-square test was applied. P-value results were considered statistically significant if p-value less than 0.05. In post-op, we assessed perioperative opiate consumption and pain assessment in terms of mean NRS at serial intervals, and also we looked for side effects like nausea, vomiting, and respiratory depression. If the patient had respiratory rate less than 12 or saturation less than 90, we stopped the PCA pump. Coming to the result, our primary outcome was the opiate consumption. Here in the blue box, we can see the group 1 who received the block have received decreased opiate consumption in both intra-op and post-op, which is statistically significant. And in secondary outcome, in terms of NRS at serial intervals, group 1 who received the block had experienced less pain throughout this interval, which is also statistically significant. Coming to the side effect, 2 out of 20 patients experienced nausea and respiratory depression, comparing to 7 and 6 respectively in the fentanyl group. It is clinically significant. Our limitation of the study was small sample size, fixed age group, and hence we conclude RACPB block lowers perioperative opiate consumption and improved pain score in patients undergoing video assisted thoracoscopic surgery. Hence, we recommend it can be used as a part of multimodal analgesic regimen for VAD surgery. But further RCTs with large sample size are required to validate our findings. Thank you, sir.
Dr. Chetan, you have mentioned dropouts.
Yes,
what was the criteria for dropouts?
Sir, one is the exclusion criteria itself is one of the dropouts, sir. Totally, we took initially 46, sir. Out of 46, 6 members were excluded from our study. 3 for thoracoscopy were converted into thoracotomy, and 2 refused to take. 1 refused to take part, and 2 didn't understood NRS. We were excluded. Coming to the dropout, where in post-operative patient who could not assess the PCA use, and also PCA pump malfunctioning 2 patients. These were dropouts, sir.
So the 7 to 12 years age, did you really expect that the children would understand PCA very well, or was it their parents doing the PCA part?
Sir, in 7 to 12 years, we explained usually the mean age group we took, sir, but more commonly 10 to 12 years patients were underwent surgery, sir, because surgeons prefer much on the higher childhood than the lower patient. For that kind of patients, sir, we explained the use of PCA.
But then you should not have included below 10 years, because then that will automatically be a dropout. There will be a bias for that. And who was the PCA pump was being handled by the child, na?
Yes, sir, and by the child, sir.
So the 7 years and 8 years, I think it's very, very difficult to have an assessment which can be valid. I'm not sure my colleagues may give
sir, it's like pressing the button. Whenever the we explained in a simple language, sir. Whenever you feel the pain, just press the button.
So my colleagues.
Yes, sir.
Very difficult, and it is yes, it will be difficult for child to understand the pain and then push the button, and it is unsafe also. So it should be nurse staff assisted sort of thing. Visual analog.
Okay, sir.
Okay.
Okay, then why did you use only bolus dose in bolus demand dose in PCA? Why not? Why wasn't any infusion given?
Ma'am, the risk benefit ratio is almost same, and also post surgery, if the continuous infusion is given, it again increases the side effect, ma'am. So only the bolus dose. If bolus dose is given, it decreases the side effect.
Means what? Side effect? What side effect you're talking about?
Ma'am, side effect like post-op nausea, vomiting, and more commonly pulmonary complications like respiratory depression, ma'am.
Chetan, I have a question.
Yes, sir.
You said that 2 of your case probably has got severe respiratory depression.
Yes,
How
sir.
you manage that case?
Sir, in post-operative period, we assess for the vitals and pain assessment. In the vitals, sir, if the child experience respiratory rate less than 12, or if the saturation drops down less than 90%,
what do you do with those patients? Did you use anything because it was fentanyl induced or something? How you manage those cases?
Sir, I'm not audible, sir.
How
not
you
clear,
manage the cases of respiratory depression?
Sir, not audible, sir, clearly. How do you assess, sir?
No, how you manage?
How do you manage? Sir, we had the emergency track with naloxone kept ready, sir.
So these patients required naloxone?
No, sir. Firstly, we stopped PCA pump. Next, we connected to oxygen oxygen mask. We connected, sir.
No, I do not want to
saturation improved.
Not details. Did you give naloxone to these patients?
No, sir. No, sir. None
if
of the
required,
patients.
what will be the dose of naloxone to these children?
Sir, if required, naloxone in pediatric patient is 50 mcg bolus, sir. IV bolus.
50 mcg?
Sir?
Microgram per kg or something? What is this?
50 microgram IV bolus only, sir.
At whatever age. Naloxone dose is in children is bolus. Is it weight wise or is it as such? What is the naloxone dose in adult?
100 mcg bolus, sir.
Sure, bolus. So what is the naloxone dose in children?
50 mcg per kg body weight, sir.
I don't know. You have to find out. Okay. And once it's good thing. Okay. Nice
Chetan, a
presentation.
single dose would be enough. Chetan, a single dose would be enough of naloxone. Or you...
Ma'am, no, ma'am. Single dose is not enough, ma'am, because it's very short acting. Even if the respiratory depression is occurred, second dose can be given, followed by infusion to be started, ma'am.
Okay. And what are the side effects of naloxone?
Increased sympathetic activity, tachycardia, hypertension, it can occur, ma'am.
No, what about the pain?
Pain, sir.
Whether after giving naloxone, is naloxone has got effect on the pain and analgesia term?
Naloxone on pain management, sir.
No, yes. Effect of the pain relief. Whether there will be aggravation of the pain and analgesia, the term analgesic effect will wear off something.
Yes, sir.
पासवर्ड क्या है? ठीक है.
Sir.
वाईफाई का पासवर्ड क्या है?
Okay, sir. I think we can shift for next speaker. Prakash, sir. Any questions, sir?
No, please continue.
Okay, sir.
Thank you, sir.
Next speaker, Dr. Umesh. I think Dr. Khalid.
Good evening, sir.
Unmute Umesh.
Good evening, sir.
Okay.
Okay. Good evening, judges, panelists, and my colleagues. Today, I will be talking on a topic which is of very common interest. Majority of the patients in the orthopedic inpatient that are admitted are usually with hip fractures, especially a subset of population with existing comorbidities, polypharmacy, and extreme pain associated with it. Surgical management remains the
Your video is not
mainstay
visible.
of these.
And slide also fix. Okay.
Surgery remains the mainstay of these hip surgeries, and spinal anesthesia is the preferred technique. Many analgesics have been tried in the perioperative period, but none has been complete or without fallacies. Nerve blocks have been in use with recent advances, changes, but none has been found ideal. During a recent study, anatomical study of the hip joint innervation, anterior capsule seems to be richly innervated with the sensory supplies, that is nociception, and posterior capsule is richly supplied for
Your slide is
proprioception.
not moving. Your slide is fixed. Okay. Okay.
With this, I started a study which was recently published. There are only few case reports. FICB, there were 35 RCTs, and FICB and others in hip surgeries were 8. On ease of spinal positioning, only one paper was available as an RCT, that too comparing IV opioid. Our study is the first study with low volume and a comparative study between FICB and PENG. So the aim is the analgesic efficacy of PENG for the ease of spinal positioning. My primary objective will be the ease with which the spinal positioning is attained for spinal anesthesia. Secondary assessments were pain post procedure scores at rest and movement and patient acceptance. The study designed after getting ethical committee clearance and registry set up. It is a prospective randomized double-blind comparative study done between July 2019 and July 2020 using ultrasound guided peripheral nerve block with the same amount of drug. Follow-up period was 24 hours for patient acceptance, complications, and to see whether additional analgesics were required. Sample size were calculated using a pilot study which was done on 10 patients, and using that data of mean, it was calculated. The sample size came out to be 62 with 80% power and 90% confidence interval. Patients who were above the age of 40, proximal fracture femur undergoing surgery under spinal anesthesia and who consented in the study after getting them detailing and written consent from them, they were put. Exclusion criteria were patient refusal and any contraindication to local anesthetic, and if epidural use was done intraoperatively, as it will interfere with the study. Randomization was done by computer generated random numbers and sealed envelope were used for methods. A double blinding of the observer and the patient was done. Curvilinear probe was used for PENG, whereas a linear probe was used for FICB. The approach was suprainguinal for FICB with 20 ml of bupivacaine and 8 mg dexamethasone for both the blocks. 30 minutes were elapsed before they were reassessed for pain scores as well as positioning for spinal. All of the patients in both the groups received spinal anesthesia, though they were put under CSA, but spinal anesthesia was only given with bupivacaine 1.8 milligram plus 20 microgram of fentanyl. In the post-operative period is covered by 1 gram of paracetamol plus tramadol of 50 milligram every 8 hourly. We had 68 patients, which included 10% attrition value. 34 were in the FICB group, 34 were in the PENG group. 2 were lost as surgery could not be done. One case, the implant was not available of the correct size, and the other in the patient passed stool. So the surgery was deferred. In PENG group, 2 patients received epidural top-up, and 1 was lost due to surgical reasons. So we ended up with 31 in each group. Data was calculated using Medcal version, and p-value of 0.05, less than 0.05 were considered significant. Preoperatively, demographic profile were comparative with no significant statistical difference. Preoperative pain scores were not different in both the arms, both at rest as well as with after the with rest and on movement. For movement, 15-degree passive leg raise test was done. Marked decrease with a statistically significant results for post-operatively. Patient's acceptance was same in both the groups. Ease of spinal positioning were better in PENG. So to conclude, effectively marked analgesia of PENG than FICB. Ease of positioning for spinal anesthesia is better than PENG. Lower volumes was used for blocks than previous study, yet attained effective analgesia. It was a single RCT. The drawbacks was single RCT. Dermatable blockade was not assessed. Multiple operators performed the block. Patient acceptance were equal in both the groups. Very few complications were there. One case of hematoma and one case of pruritus was reported. No major allergic reaction, no major side effects, no paresthesia was observed. Thank you.
Question from judges.
Thank you, Khalid, for timely presentation. Now,
sir, good evening, sir.
Yes, really positioning during the spinal anesthesia, primary aim. Is it?
Sir.
So how?
Yes, sir, my primary aim.
So by giving just femoral nerve block and adductor compartment block, it would have been done. So what is difference between?
Sir, all these blocks.
Yes.
Sir, the previous literature shows that accessory obturator nerve was missed and the positioning attained was not much better. The patient still winced and experienced pains, or they had abnormal positioning. So for this reason, the other blocks did had motor weakness with them, associated motor weakness with them. This is a novel technique, new techniques which need to be studied.
Okay, so what is your recommendation?
रिजल्ट भेज दिया है,
Sir,
मिला।
What is your recommendation?
चेक के ओके करो।
Every patient of hip
I will,
surgery should.
Sir, I will recommend.
कितना बजे होगा?
Now, if there are no contraindications to LA, and there are no contraindications at the site where the LA will be implanted, I will recommend PENG over FICB or other blocks,
So,
as it is a specific to the capsule joint.
You have mixed bupivacaine with the dexamethasone.
Sir, I am unable to hear it. The voice stripped.
You have used dexamethasone along with bupivacaine.
Sir, as an adjuvant.
Oh, what is the role of dexamethasone?
It prolongs the duration of the block, sir.
Once
And
you
eases,
have that, okay.
and eases in the spread, sir.
Okay, Dr. Khalid.
Yes, ma'am. Good evening.
You mentioned something about sealed envelope.
Yes.
What is that? What is that?
The sealed envelope contained the procedure so that the operator who was performing did not know which procedure he had to perform, and he was not prefixed with the idea that he will go for a better block, and the patient also did not know which block he will be given. He was told about it that this is a new block and we have an existing block. So the bias, to remove the bias, is this closed envelope method. Only when the random number generated, the patient is about to be performed, that random number generated along with that envelope was given to the operator.
So anyways, what
And the
envelope
observer
do you
was kept blind to it.
So from where does the patient come into this into the picture? What does he have to do with the envelope? That's not meant
Exactly.
for the patient
That
anyways,
is what
right?
I was
No,
going to
the
ask.
envelope. The operator is blind, and
Does it
the
have to do
operator is
something
blinded
with
to it.
blinding? Khalid, is it something to do with the blinding or something else? Blinding is
It
a
is-
separate entity.
It is for randomization that everybody gets an equal chance. We don't have a bias in selecting the procedure for a particular patient.
Randomization is again different. Randomization is different. That you use computer generated random
Yes.
number. Those you keep in closed envelopes, closed sealed envelopes. Why is that done for? Don't confuse it with blinding. Don't confuse it with randomization. Since you mentioned it in the slide, I wouldn't
Yes.
have picked it up otherwise.
See, whoever
What
was
is that-
giving the
that done
block
for?
would have ultimately, someone else would have assessed. So whether the patient is told a particular technique, if he doesn't get the block, then he is going to know he's not getting the block. You see, you're giving the procedure before the spinal. So we're putting him in position. So therefore, he will know that you have done something or not.
The operator might had a preference for giving a type of a block to the patient. The bias of the operator picking up a specific technique
I'm sorry,
of the patient.
envelope did not take away that. Envelope did not take away a bias. It was simply a study has to be done like that. So bias is no question here.
And
Sure.
Dr. Khalid,
What is you were actually in the right track. What is that bias known as? And what is this nose?
That is what is that bias known as?
Yes.
Yeah.
That is.
Now, since you have included blinding, randomization, and finally you have come to bias, if you're mentioning something in this, you should know.
That is.
Right.
Recall.
Recall. So where does the question recall come in this study? Okay.
No.
That's all. I say.
Okay.
Time is over. Now, thank you, Dr. Khalid, for nice presentation.
Thank you, sir.
Next candidate is Dr. Pawan Kumar.
Yes, sir. Good evening, sir.
Are you ready?
Yes, sir.
Okay. Start, please.
Sir.
Come on screen.
Yeah, am I visible, sir?
No.
Dr. Khalid, please,
Yes.
please mute your video and audio.
Sir, am I visible, sir?
Please wait.
Yes.
Yes, sir. Khalid को बोलिए तो अपना slide share हटाए.
Sir.
Dr. Khalid.
Khalid slides have to go.
खालिद स्लाइड शेयर को हटाओ.
Yes.
Okay.
Yes. Start.
Time.
On.
Yes.
Good afternoon, everyone. Today's paper presentation, the topic of mine is fentanyl versus dexmedetomidine nebulization as adjuvant to lignocaine, a comparative study during awake flexible fiber optic bronchoscopy, and myself, Dr. K. Pavan Kumar. Coming to introduction, flexible fiber optic bronchoscopy is a commonly used procedure for diagnostic as well as therapeutic purposes. It is essential to optimally anesthetize the upper airway and suppress the gag, swallow, and cough reflexes prior to awake flexible fiber optic bronchoscopy. Conventionally, 4% lignocaine nebulization is used for awake FFP. Our aim is to compare the effect of fentanyl and dexmedetomidine nebulization as adjuvant to lignocaine during flexible fiber optic bronchoscopy. Primary outcome: episodes of cough during procedure and post-procedure. Secondary outcome is episodes of gag, sedation with Ramsey sedation score, requirements of additional sedatives like midazolam, patient comfort during procedure by 3-point score, post-procedure patient satisfaction, heart rate, mean arterial pressure, oxygen saturation at 0 minute, that is baseline, 5 minutes, 10 minutes, 15 minutes, and at 20 minutes. That is the insertion of a bronchoscope is inserted at 20 minutes, followed by 25 minutes, 30 minutes, 45 minutes, and at 60 minutes. Methods. After clearance from the Institutional Ethical Committee and CTRI registration 2018-016429, this randomized prospective double-blinded study was conducted over a period of 8 months. Inclusion criteria is 90 ASA physical status 1 and 2 patients aged between 18 to 65 years scheduled for elective bronchoscopy procedure. Diagnostic and therapeutic were recruited. Exclusion criteria consists of unconscious patients, patients on ventilator, patients needing general anesthesia, patient allergic to study drugs like fentanyl, dexmedetomidine, and lignocaine, patients with a history of asthma, epilepsy, coagulation abnormalities, hemodynamic instability, and bradyarrhythmias. After these 90 ASA1 patients are ASA1 and 2 patients are recruited. Written and informed consent is taken from each and every one of them. All the patients are examined and evaluated a day prior to the procedure. Computer-generated random numbers have been raised for this study, and all the patients are divided into 30 patients. All the patients are divided into 3 groups with 30 patients each. This random allocation sequence has been done by concealed opaque sealed envelope technique, and after the allocation of group, patients received the following drugs. Group 1 or group fentanyl, patient was nebulized with a mixture of 4% lignocaine 4 ml and fentanyl 2 microgram per kg. Group 2 or group dexmedetomidine, patient was nebulized with mixture of 4% lignocaine 4 ml and dexmedetomidine 1 microgram per kg. Group 3 or group lignocaine, patient was nebulized with 4% lignocaine 4 ml with saline. The volume was kept constant at 6 ml in all 3 groups. These patients are shifted to the procedure room. IV access has been secured. ECG, oxygen saturation, and non-invasive blood pressure monitors are connected, and baseline vitals are noted down. After this, injection glycopyrrolate 0.2 mg IM is given, and xylometazoline 0.1 nasal drops have been given. After 20 minutes, nebulization has been done with an ultrasonic nebulizer, and during the procedure, supplemental oxygen has been given through the working channel of the bronchoscope by connecting a 2 ml syringe and oxygen tubing to it. During the procedure, in case of any cough or gag reflexes, an additional sedative in the form of midazolam 0.02 milligram per kg body weight in IV was given. Coming to results, our primary objective episodes of cough, group dexmedetomidine showed a mean of 1.6 with a standard deviation of 0.67, and when compared with group fentanyl and group lignocaine, the difference is highly statistically significant with a p-value of less than 0.001. In gag reflexes, the group dexmedetomidine showed a mean of 1.57 with a standard deviation of 0.68, and the dexmedetomidine group, when compared with the group fentanyl and group lignocaine, is highly significant with a p-value of less than 0.001. Coming to Ramsey sedation score, group dexmedetomidine has a mean of 1.67 with a standard deviation of 0.48, and when compared with group lignocaine, the difference is highly significant with a p-value of 0.037. And compared to the additional use of midazolam, group dexmedetomidine showed a mean of 0.47 with a standard deviation of 0.57. And when compared with group lignocaine, the difference is statistically significant with a p-value of 0.047. Coming to patient comfort, patients of group D were more comfortable than group fentanyl and group lignocaine with a mean of 1.23 and a standard deviation of 0.43. And this difference with other groups is statistically significant with a p-value of 0.001. Patient satisfaction, coming to patient satisfaction, patients of group dexmedetomidine are more satisfied than group fentanyl and group lignocaine with a mean of 1.40 and standard deviation of 0.56. And coming to differences, group D and group L are statistically highly
Please
significant.
conclude, Pawan, conclude.
Group fentanyl and group lignocaine are significant, and group D and group F are significant. There is not much variation in heart rate in patients having dexmedetomidine group, and in mean arterial pressure and oxygen saturation, we did not find any much difference. Coming to conclusion, dexmedetomidine as an adjuvant to lignocaine nebulization provides better condition for bronchoscopy than fentanyl or lignocaine alone. Further studies are required to validate these results and also decipher its sites of action. Thank you.
Yeah, Dr. Pawan, this is Dr. Prakash.
Yes, sir. Good evening, sir.
Good evening. You have concluded that dexmed nebulization provides better condition for bronchoscopy than fentanyl or lignocaine.
Yes, sir.
So, do you think this is due to its sedative effect?
Sir, it's both a sedative effect, sir, and also the mechanism of action we hypothesized is transmucosal migration and blockage of nerve endings in the mucosa, sir.
Okay.
Along with sedation effect.
Along with sedation. That's for dexmed, not for fentanyl, no?
No, sir.
Okay. Okay, right. Thank you.
Thank you, sir. Ma'am, yes, ma'am.
See, I'll ask you the same question which I asked you previously.
Ma'am.
What is already the British Thoracic Society says that IV sedation is the gold standard for your fiber optic bronchoscopy, right?
Yes, ma'am.
So, why should I add on or why should I replace it with nebulization? In which patients will it be helpful?
Ma'am, in IV sedation, ma'am, there are chances of patient airway reflexes to be completely diminished, ma'am. In nebulization, especially with dexmedetomidine, ma'am, we get
that is
even
why you
though
titrate the dose, right?
Ma'am.
Pawan, that is why you titrate the dose, right?
Yes, ma'am.
What is conscious sedation?
Ma'am, here the patient will be sedated, ma'am, but can be we can communicate with the patient, ma'am, even though the patient is sedated. In IV sedation, ma'am, the patient will be completely sedated and communication with patient will not be possible, ma'am. And also
you're using very short acting agents nowadays, no? So the patient will be waking up very quickly.
Yes, sir. But in order to abolish the cough or gag reflex and other airway reflexes, sir, we need more amount of dosage of IV sedation when compared to the nebulization dose, sir. And also the side effects with IV sedation will be comparatively more than the nebulization route, sir.
So, Pawan, that is why they have said that you club IV sedation with spray as you go technique.
Yes, ma'am. In spray as you go technique, ma'am, the problem is the lignocaine will not be spread over entire mucosa, ma'am. It will be focused on a particular point where it is being sprayed, ma'am. Whereas in nebulization, there will be diffuse absorption of lignocaine over the entire mucosa, ma'am. Yes, sir.
So, in case of difficult airway for anesthesia purpose,
yes, sir.
We are using what Madam said, that there is approach while you are doing sedation. So, would you recommend this technique only alone?
Sir, I can't hear you properly, sir. Can you please repeat the question?
For difficult airway,
yes, sir.
Anesthesia room, are you going to recommend this technique alone?
No, sir. No, not only this technique, sir. Along with this, we can give other blocks also, sir. Blocks for we can give a suprahead block, sir.
Suppose suppose I do not want to give block.
Yes, sir.
Suppose I am not conversed with the block, I am not able to get block because of the difficulty of external.
Sir.
Are you going to recommend this technique only? Is there any limitation of this technique?
Sir, this limitation, sir, is like this particular study, sir, we have only one pulmonologist who has done all the bronchoscopy procedures, sir.
It is diagnostic and therapeutic one. Can
Yes,
this
sir.
thing be used in anesthesia practice?
Can we use in difficult area? Yes, sir, we can use, sir. The advantage is that, sir, the patient will be sedated, sir, but again, the respiratory drive will not be abolished, sir. Though the patient is sedated, he can still breathe on his own through this method.
So, did you find any gag reflex in it when the tube was going in, bronchoscope was going in? The
Sir,
trachea?
very little with a group of dexmedetomidine, sir, when compared with fentanyl and lignocaine, sir.
Here comes the role of while you are going, get 10% 2% the side of the.
So when you had complex, one gave midazolam, right? How did midazolam help? How does midazolam help in cough reflex?
Ma'am, can you repeat the question, ma'am?
When you were doing fiber optic bronchoscopy, you had
Yes, ma'am.
cough, and then you have written whenever there was cough, you gave midazolam instead of doing spray as you go. You gave
Yes,
midazolam.
Ma'am.
So how does midazolam help in cough reflex?
Ma'am, it increases the plane of sedation in the patient, ma'am, by which the cough reflex can be decreased, ma'am.
Again, you're saying that you want an awake patient and you don't want. That is why you're using this.
Yes, ma'am.
Nebulization compared to IV, right?
This midazolam has not been used in all the patients, ma'am. It has been used only in a few patients.
So that means that you are not having a standard protocol.
Sir? Ma'am? Hello? Hello?
Wouldn't it have been better if you used spray as you go when the patient was having cough or gas? Then for midazolam, you not mentioned anything about spray as you go, right?
Yes, ma'am. We didn't use the spray as you go technique in this study, ma'am.
But Dr. But there should be always a side by side you have to be ready for a spray while you are going. Because during cough process you cannot abolish the cough with only midazolam.
Sir, yes, sir.
So in technique or any bronchoscopy technique, the 2 ml syringe with lidocaine 2% must be there loaded, and while there is cough, it should be lifted a bit. Otherwise, there will be no abolition and bronchoscope may come out and go somewhere else.
Sir.
No, that is the limitation in practice, clinical practice, what we find.
Yes, sir.
I think judges will agree.
Sir.
Thank you, Dr. Praveen, for nice presentation.
Thank you, sir.
Next candidate is Dr. Surbhi Srivastava. Dr. Surbhi Srivastava.
Yes, sir.
Are you ready? Dr.
Start.
Surbhi Srivastava.
Yes, sir.
Start fast because shortage of time.
And Dr. Ajay, I will take 1 second. I request everyone to please mute the mic. There is a lot of disturbance going on. I request everyone just.
Am I audible?
Dr. Sharad this side. Dr. Sharad this side. Please.
Start, Dr. Surbhi.
I request everyone to please mute the mic. There is a lot of disturbance going on. I am getting information.
Dr. Ajay, there is lots of problem with audio also today.
Good evening, everyone. This is Dr. Surbhi Srivastava, and I'll be presenting a pilot study comparing dural puncture epidural, that is DPE, and lumbar epidural analgesia, that is LEA. Lumbar epidural analgesia is the gold standard technique for pain relief during labor. Over the years, many modifications have been done in the basic technique to improve the efficacy and reduce the side effects. In the standard technique, we pass a needle in the epidural space via loss of resistance to saline technique, and after placing it, we give the test dose or pass a catheter to give the drugs via continuous infusion. However, in DPE, before inserting this catheter, we pass a very fine pencil point needle to puncture the dura, but no drug is administered in the subarachnoid space. After the insertion, and then we pass the catheter like the standard technique to give the drug via continuous infusion. About the mechanism of action, it is said that the drug from the epidural space slowly diffuses into the subarachnoid space through this dural hole to produce its effects. The primary objective of my study was to assess the onset of pain relief, that is, time to achieve reduction in VAS more than 50% and time to achieve VAS less than equal to 3. The secondary objective of my study was to assess the mode of delivery as a result of our intervention, the APGAR score to assess the fetal outcome, and the side effects on the maternal side. So we enrolled 30 primary patients who desired and consented for labor analgesia, age between 18 to 35 of years, randomized them into 2 groups in each. Group A taken lumbar epidural analgesia and group B was taken for DPE. In group A, after cleaning and draping, we introduced a 16-gauge Tuhoi needle in the epidural space through the loss of resistance to saline technique. In group B, we did the same thing, but in addition, we introduced a 27-gauge Whittaker needle through this Tuhoi needle to puncture the dura, but no drug was given in the subarachnoid space. And then the epidural catheter was introduced, fixed at 3 cm in the epidural space through which the drugs were administered. So we use bupivacaine 0.125%, 12 ml bolus given in the beginning, bupivacaine 0.08% with fentanyl 1.6 microgram per ml at the rate of 10 ml per hour as infusion. And if the VAS was more than 5 with continuous infusion also, we use bupivacaine 0.125% 5 ml bolus every 10 minutes as rescue analgesia. So after getting clearance from the ethical committee, a prospective randomized study was conducted with the clinical registered trial number as shown. The duration of my study was from March 2020 to August 2020. It was a 6-month duration study. Parametric data were analyzed using the unpaired student t-test, while the nominal data using the chi-square test. A p-value of less than 0.05 was considered as significant, and the statistical analysis was done using the Metcal 4.0 version. So the outcomes were time to achieve reduction in VAS more than 50% in group A was around 7 minutes and in group B was around 5 minutes. Time to achieve VAS less than equal to 3 in group A was around 15 minutes and in group B was 10 minutes. Coming to the side effects, as we can see, the side effects in both the groups were comparable and the side effects were documented and treated as per hospital protocol. The APGAR score at 1 and 5 minutes was again comparable and the mode of delivery in both the groups was again comparable. So from my study, I would like to conclude that the analgesia onset with DPE is faster without adding any side effects. Also, the time to achieve complete pain relief was earlier with DPE. So the birth process for the parturient was quite satisfactory. But this is just a pilot study, so we need a large randomized data to assess the risk and benefits of this new technique. Biases were present because this is an open study and no imaging was done to assess the continuous functioning of the dural hole, which can be explored in the future studies. Thank you.
Thank you, Pallavi. Judges, please question.
Sudhi, why is it a pilot study? There have been studies which have been done earlier, right?
Yes, ma'am.
On DPI, you do a pilot.
Yes, ma'am. Ma'am, this is a pilot study because yes, the studies which have been done in DPE, but they are very less in number, and the drug regime which they have used is different from the drug regime what we are using in our hospital. So we have a standardized technique of epidural analgesia that we are using for the past 13 years with excellent results. So while registering our RCT, we were to have two criteria. That is one, a reference from the previous study, or we have to have our own pilot study. So we chose a different drug regime based on this particular criteria. Hello?
Okay, and Surbhi, so you tell me one thing. What do the latest recommendations? What is the latest technique? Not technique. Latest regime of PCA which should be used for labor analgesia.
Ma'am, the latest technique we are using this programmed intermittent epidural bolus that is being used for labor analgesia.
So you have PCA pumps in your institute, right? So how come you have not used PCA? How come you used only continuous infusion, no bolus technique?
Yes, ma'am, we haven't used this is the limitation.
See, bolus is given for which you have not mentioned. In limitations, you haven't mentioned this.
Yes, ma'am. This was the limitation. No, ma'am. This was the limitation for our study that we haven't used the continuous epidural PCEA.
Dr. Surabhi. Okay, Dr. Surabhi.
Yes.
Some clinical questions.
Yes.
What was the position of the patient while we are doing the epidural?
Yes, sir. So we did in sitting position.
So, did you find any PDPH incidents?
No, sir. The PDPH incident in the 15 patients which we have chosen, it was nil. Nobody complained of PDPH.
So, what is the latest guideline for PDPH? How will you manage PDPH? Because you are doing puncture. So, what is the management of PDPH?
So, for PDPH, the definitive management is epidural patch, which
okay. What is the management?
Sir, I can't get what we are saying, sir. Please.
Not definitive management. Suppose a person develops PDPH.
Yes, sir.
What will be the differential diagnosis and how will you manage?
Sir, if a patient develop PDPH, the most probable reason is because of the CSF leak. So we'll ask the patient to to take bed rest as bed rest and to have plenty of fluids, to take plenty of fluids, and the hello.
Yes, yes, I'm listening. I'm
Yes,
listening.
To take plenty of fluids, we can also give IV fluids, and in addition to that, we can give NSAIDs, which include paracetamol. Some patient get benefit from adding caffeine to it. So,
would you like to differentiate this headache with any other headache?
Yes, sir. There are differential diagnosis for PDPH. It can
one differential diagnosis which you must see.
Yes, sir. Sir, it can be a tension headache. It can be hello.
Yes,
I'm not.
I'm listening.
It can be.
You carry on.
Carry on
talking.
Survey, carry on.
It can be a headache due to tension. It can be hello.
Yes, I'm listening.
Yeah, go on, Surbhi. We have lots of questions to ask. Fast.
Yes, ma'am. This is that's all I want.
No, you must exclude the meningitis part.
Yes, sir. Meningitis.
Surabhi, please must exclude meningitis. Never think that meningitis is another. Okay.
Yes, sir. Yeah.
Surbhi, tell me about blinding in this study. You said it is an open label study, no blinding done.
No, ma'am.
Right? You could have easily blinded, right? The patient, how is the patient come to know, no? What the patient is receiving.
No, ma'am. Actually, the ethical committee was that it is a new technique, so you must take informed consent, inform everything to the patient, and then yes, we are planning to do this study further by taking a double-blinded study. In that case, we can blind the obstetrician that is telling us the APGAR score, and the obstetrician that will tell us the mode of delivery and the maternal side effect, and the pediatrician who is telling us the APGAR score.
But your primary outcome is VAS score, right?
Yes, ma'am.
What was your primary outcome? How will you blind that? Obstetrician will not be telling you the VAS scores, right?
No, ma'am. That will be assessed by us only.
So how would you double blind in that case?
Ma'am, the primary objective was to assess the VAS score, so we'll take different observer to blind the.
Elaborate.
Ma'am, the primary objective. Yes, ma'am. The primary objective was to find the time to achieve VAS reduction in VAS more than 50%. That is the 50% reduction. So we can take different observer to assess the VAS score.
Different observer, that is what I'm asking. The person who does the procedure is different from the person who's assessing the outcome, right?
Yes,
that is what I wanted to hear.
Okay.
And obviously the patient would not be knowing.
Yeah.
Right?
Yes, ma'am.
Please shift on next speaker.
Thank you,
Next.
Dr. Survi.
Thank you. Thank you.
Next and last, Dr. Vivekanand.
Yes, sir. Good
Dr.
evening, sir.
Vivekanand.
Yes, sir. Good evening, sir.
Dr. Vivekanand.
Yes, sir. Good evening, sir.
Are you ready?
Yes, sir.
Please start.
The last presentation.
Good evening, everyone. Myself, Dr. Vivekanand, and the topic of my presentation is bacterial colonization of an epidural catheter. And does the tunneling of epidural catheter has any help in reducing the bacterial colonization or not? It is a randomized controlled trial. Coming to the introduction, as we know, the fear of meningitis or infection may cause the early removal of the catheter in many patients, which lead to the suboptimal and catheter tip colonization is up to the 28%, and which may lead to the meningitis. The research question is, does the tunneling of epidural catheter have any impact on the bacterial colonization of epidural catheter tip versus conventional non-tunneling methods in adults? And the primary objective is to compare the effect of tunneling on the rate of bacterial colonization of epidural catheter tip versus the conventional non-tunneling method of epidural catheter fixation. And the secondary objectives are to determine the nature of bacteria which grows at the epidural catheter and the skin side of the catheter fixation, and to determine the frequency of bacterial colonization of the epidural catheter. Coming to the methodology, the study design is randomized controlled trial. The study participants are all the patients requiring the lumbar epidural catheter for analgesia or anesthesia in an elective surgery. The inclusion criteria were the ASA physical grade 1 and 2, and the age between the 15 to 70 years, and the body mass index is less than equal to 35 kg per meter square. The exclusion criteria were the immunocompromised patient, the diabetic patient, the patient with the fever at the time of epidural placement, any skin lesion at the site of catheter fixation, and the emergency surgery. Sample size has been calculated using the previous literature with the help of obstetrician. It comes out to be the 60 patients in each group, considering the 10% dropout, and the randomization was done by computer generated random number table, and the allocation concealment by the sequentially numbered opaque sealed envelope technique, and the institutional ethical committee approval taken, and the clinical trial registration done before the enrollment. After taking the written informed consent, the patients were divided into the non-tunnel and tunnel group, and accordingly the catheter were fixed as the non-tunnel and tunnel, and fixed by the standard sterile dressing like Tegaderm. And we have acute pain service team responsible for the catheter top-up and the removal and sending the samples. The catheter were removed after minimum of the 72 hours of the placement, and the 2 culture specimens were taken and sent for the microbiology lab. The first were from the skin side, from the insertion site, and the second is from the epidural catheter tip. And gram staining and bacterial morphology and motility was done. And the colony count at the 24 hours and 48 hours of the culture noted in all the patients. The data were collected in the following headings like the date of placement, date of removal, hours in place, the number of attempt in place, the skin site, inflammation, the company make, antibiotic in use or any culture positive, and identification of the bacteria as by colony count at 24 hours and 48 hours. Coming to the initial result, currently we have 24 patients have been enrolled, of which 11 are non-tunnel and 13 are tunnel. Both the groups were compared in all the respect, and the sites are usually between L2, L3 and L3, L4. And we have 14 patients in which catheter in situ is for 3 days, 7 patients in which catheter in situ for 4 days, 1 patient for 5 days, 1 patient for 6 days, and 1 patient for 7 days. And currently we have only one, we have found only one growth in only one patient, which was non-tunnel, kept for 3 days, which was 43-year-old female, and the bacteria was gram-positive cocci staphylococcus aureus, sensitive to the gentamicin. And coming to the results and conclusions, in the 24 patient whose catheter tip and the skin swab were cultured, we found bacterial colonization in only one patient. And coming to conclusions, the power of the study currently precludes any comparison of the two approaches, tunneling versus non-tunneling. The initial results do not indicate any significant bacterial colonization in the epidural catheter tip if kept for the 72 hours, which was lower incidence than other studies. In only one patient, we noted a growth in a non-tunnel catheter. However, since the study is ongoing, the final analysis can only be done after the completion of a study and the power analysis. Thank you.
Thank you. Thank you, Viveka.
Thank
you completed within time.
Yes, ma'am.
In 10 patients, you kept it for 72 hours. Okay. 3 days. And just 14, 10 patients, 14 patients for 72 hours and 10 patients more than 72 hours.
Yes.
Would it have been better had you standardized the duration of keeping the catheter in situ? I mean, the duration may affect the incidence of colonization.
Yes, sir. Yes, sir. So we have placed minimum 72 hours and maximum as long as the patient feels pains or the.
Okay. And do you think that the sample size is adequate?
Yes, we calculated the sample size from the past literature review that published in the Scientific World Journal.
Scientific World Journal. Okay, thank you.
Viveka, my question is on sample size. Could you elaborate how you calculated the sample size?
Yes, ma'am. We have reviewed one literature which was published in Scientific World Journal, and according to that, the incidence of bacterial colonization in non-tunnel is 13.5%, and in tunnel it was 25.9%. And we have taken the power of study 80% and calculate the sample size with the help of a statistician, and it comes out to be the 60 in each group.
This journal which you have taken is PubMed index, because I've not heard of this journal. I'm sure there would be other articles also on this topic.
Yes.
So how come you chose this journal and this particular whatever the article?
We have reviewed approximately 10 articles, and incidence of bacterial colonization is variable from 5%, 6% to 28%, 29%.
No, you see, the question that is coming is, why did you choose a particular journal alone? Now, you have chosen an article. Do you think that that was a good reference journal and article to base your study and start your study? That is what is being asked.
This article has a similar study, like they have also done tunneling and non-tunneling in the thoracic epidural catheter.
Agreed. You should understand what I'm trying to ask you.
Yes, ma'am. Why this particular journal?
Yeah, why this particular journal? There would be other journals which
Chandni,
impact.
Chandni, please conclude. Thank
अनम्यूट कीजिए अजय जी अनम्यूट कीजिए
Thanks to all of you, all speakers. Very nicely presented, all speakers. And judges, your questions are very nice, and speakers also given the answer very nicely. So please, you all requested as soon as result will send to our secretary, Dr. Sharad or Dr. Nishan Sahab. Thank you.
Thank you.
Next.
Thank you very much.
And
next
coordinator.
I request Nitin to start. Nitin,
Prashant
please start
and
immediately.
Yes.
Nitin, please start immediately. Don't waste time. And first of all, Nitin, please start.
Nitin boss, शुरू कीजिए. Introduction.
Just an announcement. I am really sorry for the delay, especially to our judge Ranju Singh madam and Dr. Rajiv Ranjan and Dr. Asif. They are waiting since long. Extremely sorry from my point of view. Sorry, madam. We are starting the session. Please call first speaker. Introduce the judges and start. Please.
I'm audible.
Yeah. Start कीजिए नितिन boss.
Hello.
Yes, please start.
Please start. Don't waste time. Please start.
Hello, Doctor. Hello, sir.
नितिन start कर दिया.
Thanks. First of all, very good evening to all my respected delegates. And this session is for the poster PG award session. And so before starting our session, I'd like to share the most important information that that is the first time in our WEBCON history, I think so, that more than 50 postgraduate students have participated from the state of Bihar and Jharkhand for the poster award session. And for this reason, it is really commendable and appreciable. And for that reason, we are bound to do for the 2-day session for the poster session. That is on 9th and 10th of the September. And it was well done by our scientific team. And out of 51 postgraduates, only six have been selected by our judges. And today is the final session award for the poster presentation for PG. And here we will start our award session. And this session is going to coordinated by myself, Dr. Nitin. I'm an assistant professor in Nalanda Medical College and the GC member of ICA Bihar Jharkhand. And the second coordinator, Dr. Prashant, a senior resident at Patna Medical College and a GC member of ICA Bihar in Jharkhand. And for the shortage of time, I will just really go for the brief introduction of my excellent judges. So I requested first judges, 4 judges of us. First is Dr. Ranju Singh. Ma'am, is you are online, ma'am?
Yes, she is online. She is online. Please,
okay.
Go ahead.
Okay. Ma'am
is
currently the director or professor of Lady Harding Medical College and the head division of pediatric anesthesia at Kala Saran Children's Hospital. And she's having more than 50 publications. And our second judge is Dr. Asif Ahmed sir. And sir is a senior consultant and the head of department at the Department of Critical Care Medicine at TMS Jamshedpur. Sir is having multiple publications and the national journals. And our third judges Dr. Rajiv Ranjan sir. Sir is the principal consultant at Medanta Institute of Anesthesiology and Critical Care, New Delhi. And sir is having multiple publications in journals and international journals also. And our fourth and last, Dr. Kishore Jhunjhunwala. Sir is the assistant professor at Nalanda Medical College. But due to some unavoidable circumstances, sir is not available, unfortunately for us. But still, we are having three excellent judges. And now we are going to start our this video poster award session. And please hand over to Dr. Prashant.
Okay, thank you, Dr. Nitin.
Please start.
Dr. Sadab Asif, are you there? Dr. Sadab Asif, are you there? Dr. Sadab Asif, please share your slides. Start your presentation.
Hello, am I audible?
Yeah, you are audible.
Yes, you are. Please continue.
Please continue. Please share. Yeah.
Good evening. Myself, Dr. Shadab Ashfi. My topic is emergence of tele-PAC in COVID pandemic, a boon for anesthesiologists, sharing our experience in first 30 patients. During this COVID-19 pandemic, the role of telemedicine has emerged as a proven benefit for doctors. We anesthesiologists, being the forefront doctors in this COVID pandemic, are maximally exposed to the COVID-19 infection from the very first day, that is from the day of pre-anesthetic checkup, when the COVID status of the patient is not known. We are sharing our experience of tele-PAC in first 30 patients. We can see in this pictorial diagram that patient is at home and we can do the PAC in this manner. The patient details were provided by the surgeon a day before PAC. The patient sent their investigations via WhatsApp and we provided them a time slot. We connected with the patient. First of all, we called the patient on phone, talked to the patient, inquired about their history, and took the history on phone about any comorbidities, any patient on any drug, and any other history. And then we told the patient to come via Google Meet or WhatsApp video and did the virtual PAC of the patient. We can also refer patients to other specialties if required, or can give any other pre-operative advice. After a satisfactory virtual PAC and COVID test is documented negative, the patient is called on the day of surgery. Physical examination is done on the day of surgery. So in the patients which we have done, the problems which we have faced, in 5 patients, the video was not so clear and there was problem in doing the tele-PAC. In 6 patients, the internet connectivity was not so good. In 3 patients, they were uncooperative and did not follow the commands properly. While in 16 patients, the PAC was done smoothly. The advantages of tele-PAC are, first of all, it avoids direct exposure of infection from patients whose COVID status are not known. It is economical for the patient, as the patient do not need to travel to the hospital. It saves their transport time and cost. It's also time saving. The patient do not have to stay in queue. It reduces the risk of nosocomial infection for the patients, as the patient do not need to come to the hospital. They do not acquire infection from other patients. The demerits of tele-PAC are, some patients are uncooperative. They do not follow the commands properly. It is difficult to do tele-PAC in underprivileged and uneducated patients who do not have access to smartphones. Physical examination is not possible in tele-PAC, and it requires good internet connectivity from either sides. So conclusions and discussions. In COVID pandemic and even in post-COVID era, telemedicine is going to be widely used by doctors, seeing its benefit and convenience. A multimedia resource center can be established in the institute for telemedicine PAC and in all other consultations. As the technology is advancing, telemedicine is becoming more popular, and during this COVID times, its importance has been realized. Therefore, telemedicine has emerged as a boon for anesthesiologists. Thank you.
Questions, please, judges.
Good evening. This is Dr. Asif.
Yes.
Sorry, madam, you want to watch?
No, please go ahead, Asif, please. Thanks a lot. I'm sorry. I started.
No, I'll ask after you've asked. It's okay.
Yeah. I have just quick questions for you, Dr. Shadab.
Yes,
You can just answer in a yes or no. Where else do you find that this practice is on? Is it something which has been agreed or which has been gone through the ethical committee, or there is an ethical concern related to this? That is my second question. And the third one, you have done this PAC in 30 patients, but how these patients presented, whether there was a disparity between your assessment at the time of tele-PAC, and how did you find these patients at the time of clinical assessment? Was there a gap, or was there any problem? That should have been brought out in your presentation. So anyway, you can just answer my first two questions. Where else is this being practiced, and what are the ethical concerns related to this?
Recently, during this lockdown time, the MCI has issued guideline regarding the telemedicine, and there should be this telemedicine has limitations. It has been legalized nowadays. Now in India, it has been legalized by the MCI, and it is practiced. It was practiced in as EOPD also in various parts of the country during lockdown.
What is the name of that EOPD which has been started by the government of India, which you're talking about? You're talking about an EOPD, Shadab. What is the name of this EOPD that has been started by the government of India?
Sorry, ma'am, I don't know.
Okay, carry on.
Thank you, Shadab.
Any other questions, please?
Okay, can you improve this PAC by incorporating something, provided you have all facilities available? You've just taken a history, and can you improve this PAC in any way if you have the facilities?
Yes, sir. Yes, ma'am. When we can consult, and we can when there is a centralized system, then it can be improved.
Can you do any examination online?
Yes, ma'am. We can do airway examination. We can We can tell for example, we can tell the patients to come and open the mouth. We can see the malam in the video.
What else can be done? Can you do an auscultation online?
No, we cannot do auscultation.
You can, provided you have facilities. What about the consent in these patients? What is the issue with consent in telemedicine?
Consent.
What kind of consent?
It is informed consent from both the side. That there is.
What type of informed consent?
What type? Yes, sir. The telemedicine has its fault that and many physical examination and many diagnoses can be missed, and it is understood from both the side that this is the demerit of telemedicine.
What kind of consent is this? This is an implied consent.
Right. Yes.
Okay. Thank you.
Dr. Shadab, can you hear me?
Yes, sir.
Dr. Shadab, as Dr. Asif was asking to you, that what differences did you find when you did the tele-PSC as an adjunct? Later on, you must have done the regular PSC. So did you find a major disparity? What did you find beforehand and later on?
So in most of the patients, there was not much disparity. In few patients, there, for example, after the patient arrived in the hospital, some patient has chest. When we ausculted on the day of surgery, they had finding in the clefts. For example, in one patient we had found clefts in the patient, so surgery had to be cancelled, postponed in that manner.
Okay, thank you.
Does telemedicine have any role, Shadab, in the process of anesthesia? Are you aware? Besides this PAC, does it have any other role in anesthesia?
Sorry, ma'am, in palliative care, in giving pain medicine, in pain
clinics. Anesthesia.
Yes.
Okay.
Okay, fine. Thank you.
Okay, thank you, ma'am.
Thank you.
It's most important information, ma'am. It's we're having for the presenters a 4-minute time limit, and for the question are 2 minutes.
Yes.
So I request our presenter and our judges, please be strict on time, please, sir.
Okay, thank you. Next candidate is Dr. Ashwini Ekka. Ashwini, are you there? Ashwini, you are there?
Yes.
Yeah, please share your slide. Open your camera and share your slide.
Ashwini,
Aswini, be quick.
are you there?
Aswini, be quick.
Okay, next is Dr. Babli Kumari. We move to next one.
Hello, sir. Am I audible, sir?
Yes, yes, please carry on, Bubbly.
Who is Babli Kumari?
Hello, sir. Am I audible, sir?
Okay, wait. Dr. Ashwini, you are ready now? Dr. Ashwini,
Aswini, you are ready?
Ashwini, are you there?
Aswini, Aswini,
Yes.
go to slideshow and start. Your time
I
starts now.
request all speakers to kindly put their slides in the slideshow mode because it's not visible clearly.
Aswini, go to slideshow. Aswini. Yeah, Dr. Babli, you are there?
Yes,
Dr.
sir. Am I
Babli?
audible, sir?
Yeah, you are audible. Please share your screen. Be quick.
So is my
Dr.
slide
Babli.
visible, sir?
It's visible now. You may start now. Your time started now.
Good
Babli,
evening,
please go to the
everyone.
slideshow. Babli, yeah, thank you.
Good evening, everyone. Today, my topic of poster presentation is anesthesia and CT of conjoined twins, Omphalophagus. Myself, Dr. Babli Kumari. Coming to the introduction, conjoined twins are the rare form of monozygotic twins. Incidence is 1:2 lakh and is commonly seen in female, that is 75%. My case is of Omphalophagus, where lower abdominal fusion occurs and incidence is 33% and 80% have the liver fusion. Imaging is important to know about the extent of anatomical abnormality, vascular, neural involvement, and any sharing of organs. Coming to the case report, a 3-month-old female conjoined babies of 30-year-old woman, total weight was 5.8 kg, resident of village Bakhtiarpur, Patna, Bihar, was diagnosed with conjoined twins since birth. They were term baby with institutional delivery via cesarean section. Total birth weight was 3.9 kg. At the time of birth history was normal and was immunized till date. Twins were joined ventrally in the umbilical region. USG abdominal showed a sharing of the liver with no vascular connection noted in the Doppler study. Pediatric surgery department planned for the surgery for separating the baby after CECT abdomen to know about the extent of sharing of liver between the babies. So we were called for the pre-anesthetic checkup. A day prior to CECT abdomen, detailed history, clinical examination, and lab investigation were evaluated, which were within normal limit. After discussing with the radiologist team, it was decided that CECT abdomen will be performed for 2 days, 1 day for each baby. Procedure was explained to the attendants and a high-risk written consent was also taken. NPO for 2 hours for liquid are also advised. On the day of imaging, NPO status, vitals, and clinical examination was again rechecked. Emergency equipment were ready with us. In the presence of radiologist, pediatric surgeon, sedation was given to the first baby, that is, injection midazolam 0.1 mg per kg intravenously and propofol 1 mg per kg intravenously in the graded dose. Face mask with oxygen at 4 liter per minute was given to both the babies and vitals were again rechecked. Only one child was sedated, other remained awake. That confirms no cross circulation between the babies. Second baby was weak, so he was not moving much. CECT abdomen was done and it was seen that the liver was common between the twins but no much crossover blood circulation was there. Post procedure, both the kids were good and healthy. Next day, second baby was sedated by using injection midazolam 0.1 mg per kg intravenously and propofol 1 mg per kg intravenously in a graded dose. Oxygen via face mask at the rate of 4 liter per minute was given to both the babies. Peri-procedural event were uneventful. Post-procedure, both the baby were healthy. And CECT abdomen showed the demarcation line and extent of liver sharing between the babies. In the first day, left side of the baby was given the contrast, and we can appreciate the demarcation line between the baby. And the second day, the right side of the baby was given the dye, and we can see the liver was common between them, and also we can appreciate the demarcation line and no vascular communication. Coming to discussion, difficulty in the positioning of both the babies. So anesthesia team was divided into halves so that each team can take good care of each baby simultaneously. We kept the baby in the lateral position and checked the vitals, and after sedating, CECT abdomen was performed. Next issue was if the baby was not sedated, then we have to be ready for the management of difficult airway because of their positioning, as we need other assistance for handling the baby's head. Coming to the conclusion, Conjoined twins are rare but unique challenge and require a teamwork of all the three departments, including pediatric surgery, radiology, and anesthesia team. So multidisciplinary communication and cooperation remain the cornerstone of the management of conjoined twins. The need of careful monitoring have been emphasized, and also we anesthesiologists should be ready with every emergency equipment for our backup. Thank you.
Okay, Dr. Bubbly, please tell me that why the CT was done on two separate occasions. Why was it not done in one sitting? Second, I also want to know if you have fasted. You said the babies were fasted on day 1 and on day 2. So both babies were fasted on both days.
Ma'am, coming to the first question, ma'am, why 2 days was why we took the 2 days, ma'am? Since we were dealing with the 2 babies, and our aim was to just see the vascular connection was there between the 2 babies or not. So
so that's not a very long procedure by CT. So why was not done one after the other?
To also see the effect of the drug, ma'am. That
what effect of drug? Propofol.
Yes, propofol also and midazolam. No, ma'am. Also of contrast also, and also of the sedated drugs.
But the circulation you have used propofol to determine whether the circulation was separate or not.
No,
in the dose of 1 milligram.
No,
how did you?
That propofol was given in a graded dose, ma'am. That is only for the sedation purpose only for the baby, and that was given in a graded dose. That is when required, then only it was given to prevent the apnea. Like our aim was to sedate the baby.
No, first, you haven't yet cleared why on 2 separate occasions was the CT done. Why wasn't it done one after the other on the same day?
Ma'am, if the anaphylaxis would have occurred, ma'am, then it would be very difficult for us to handle the situation, ma'am.
It would be the
Dr.
same.
Bubbly.
Yes, sir.
And secondly, what can you use to determine if the circulation is separate or not in case these kind of conjoined twins? Did you determine that before giving propofol?
Ma'am, we can buy some medication also. We can come
Which medication?
We can give anticholinergic drug like atropine.
Did you do that in these babies?
Ma'am, in this case, we didn't did that, ma'am.
So you directly gave midazolam and propofol without knowing whether the circulation was common or not?
Ma'am, we didn't did that.
Okay.
Okay.
Yeah, Dr. Bubbly, yeah, Dr. Asif here.
Yes.
So my question is, why did we expose, I think similar to what Madam just asked, why did we not take the consideration of exposing the baby twice,
exactly,
babies twice for the CTs?
Sir, we were dealing with the 2 babies, sir. And the
Second factor is, how were you difficult airway cart in this situation? So
sir,
at a time when you were doing a CT, you were only taking care of 1 baby at a time, or you were ready with
no,
2
sir,
carts?
No, sir. We have to take care of 2 babies simultaneously, sir. So we have to keep all the emergency equipments ready with us. 2 emergency equipments for each baby, sir, simultaneously. And we have, sir, 2 anesthesia team to take care of the baby, sir.
So very right. I think that was good, but then you should have done the CT in the same sitting for both the babies. That could have been done. Anyway, good. Thank you.
Thank you, Dr. Bubbly.
Thank you so much, sir.
Dr. Ashwani Ekya, are you there?
Sure.
Dr. Ashwani, you please leave, Dr. Bubbly. Dr. Ashwani Ekya. Dr. Harshita G.
Dr. Harshita, are you there? Dr. Harshita?
Sir, yes, sir, I'm here.
Yeah, please share your slide. Be quick. Open your camera and share your slide.
Dr. Aswani is joining. Dr. Aswani is joining.
Dr. Ashwani, please join.
She may take time. You can start with Harshita.
Okay. Doctor.
Sir, am I audible, sir?
So you're audible and visible too. This start of sales.
Good evening, respected sir and madam. Today I'm going to present a case of anesthetic management of a patient with severe aortic stenosis posted for ureteroscopy. Patient with severe aortic stenosis carry a significant risk of cardiovascular mortality and morbidity when subjected to surgery and anesthesia. In symptomatic patient with severe aortic stenosis, only urgent non-cardiac surgery should be performed under careful hemodynamic monitoring. Aortic valve replacement should be considered before elective non-cardiac surgery. In asymptomatic patient with severe aortic stenosis, aortic valve replacement should be considered before non-cardiac high-risk surgery. Maintaining hemodynamic stability is the ultimate goal of anesthetic management in these patients. Now coming to case report, a 62-year-old male patient of severe aortic stenosis with bilateral ureteric calculus was posted for urgent ureteroscopy in viewing of increasing renal parameter and decreased urine output. Symptoms revealed MET score of less than 4 and echo showed global hypokinesia, left atrium and ventricle dilated with aortic valvular stenosis with transvalvular gradient of 84 mm mercury and valve area of 0.8 centimeter square and ejection fraction of 40%. ECG showed ST depression and T wave inversion in V3 to V6 and there is left ventricular hypertrophy. The patient was accepted for surgery under ASA grade 4. The patient was successfully managed by administering general anesthesia using 3 Proceal LMA and hemodynamic stability was achieved throughout the surgery. Patient was shifted to post-operative ward after removal of LMA, where he developed pulses bigeminy with hypotension and was treated with injection noradrenaline infusion and discharged with advice for aortic valve replacement surgery. Discussion. Asymptomatic patient with mild obstruction and normal left ventricular systolic function can be managed conservatively, while those with symptoms of severe aortic stenosis are at higher risk. Symptomatic patient with critical aortic stenosis should be appropriately counseled for delaying surgery until treated by valve replacement or balloon valvotomy. Neuroaxial anesthesia has been thought to be relatively contraindicated in patients with aortic stenosis, considering a simultaneous decrease in preload and afterload associated with it. In patients with severe aortic stenosis, general anesthesia remains the gold standard. The goals of anesthetic management will be the maintenance of normal heart rate. We should avoid tachycardia or bradycardia. Tachy should be avoided as it decreases the diastolic filling time, and if tachycardia is present, we should treat with beta blockers. Sinus rhythm and adequate systemic vascular resistance should be maintained, and intravascular volume should be maintained, and venous return also should be maintained. Avoidance of myocardial depression during general anesthesia. We'll come to conclusion that general anesthesia is the technique of choice in a patient with aortic stenosis, and the patient requires post-operative management in an ICU. Thank you.
Dr. Harshita.
Yeah, Dr. Harshita. Sorry,
Yes.
please go ahead, Dr. Kishore, please.
Okay, Dr. Harshita, you have mentioned that the patient developed pulses bigeminy.
Yes, sir.
And you managed it with noradrenaline.
Sir, the thing is,
hypertension as well.
Yes, sir, hypotension.
So you didn't give anything for bigeminy. It reverted by itself?
Sir, actually, I think pulses bigeminy may be caused because of the pain or maybe due to surgical stress. Actually, I have given injection tramadol, sir, and after that I concentrated on treating hypotension, sir.
So for a severe AS patient, what could have been the better drug than noradrenaline? Any other choice?
Sir, we can give lignocaine also, and we can give
hypertension.
No, sir, not for hypertension.
Instead of noradrenaline, what you could have used?
Sir, actually, sir, first we have initially we'll give a fluid rush. After that, then we'll give.
Right. I'm just asking for a substitute for noradrenaline, if any.
Is there any vasopressor of choice he wants to know in patients with severe aortic stenosis who develop this kind of hypotension, Harshita?
Ma'am, phenylephrine also we can give. Phenylephrine also we can give, ma'am, which is alpha.
Okay, so one more thing. When do you give, in your practice, when do you give antibiotics?
Sir, antibiotics, if there is any chance of thrombus, any chance of
prophylactic antibiotic you must be using, no?
Yes, sir.
So
Yes, sir.
at what point of time, when the patient comes to your theater, you use it?
Sir, if That's what I'm saying, sir. There is a criteria for using antibiotic prophylaxis, sir. If there is any chance of, if we are using, if the patient is having any prosthetic valve replacement done earlier and there is a chance of thrombus or anything, then only we'll start the antibiotic.
Okay, Harshita, is there any other anesthesia technique? You said general anesthesia remains the gold standard, and you've had all the problems after you've given GA. You've had bigeminy, you've had hypotension and everything. Would any other anesthetic technique be used for this peripheral surgery in this patient with severe AS?
Ma'am, actually, we can use epidural also, but...
Anything else? What is your apprehension against using a simple spinal anesthesia?
Ma'am, actually spinal anesthesia, it will lead to, it will cause the sympathetic activation and it will cause the hypotension. And,
but you had hypotension under GA also with myocardial depression. What causes the hypotension in spinal anesthesia? What component of the drug causes the hypotension? It is the bupivacaine,
yes,
right? So if you reduce the bupivacaine, you will have no hypotension. With ureteroscopy, what level of block do you desire?
Ma'am, up to T10, T12,
T12, okay. And how much of bupivacaine do you think in this patient would have been required to produce this block?
Ma'am, around 1.8 ml.
Oh, 1.8 ml is too high.
1.5
so if you give low dose bupivacaine with an additive, could you not have gotten away with a good block with no hypotension and none of these problems which you've encountered? Okay.
I don't.
Thank you, ma'am. Thank you.
Okay.
Now we can. Dr. Subhajit, are you there? Dr. Subhajit.
Yes. Good evening, sir.
Yeah.
Yes, sir.
Yeah. Please connect. Share your slide.
Yes.
Subhajit, be quick.
Yes. Are my slides visible, sir?
Yeah. Go to slideshow and start.
Yes, sir.
Go to slideshow and start.
Okay, sir. A very good evening, everyone, sir. I am Dr. Shubhajit Ghosh. I am going to present today's poster presentation from my side. My topic of discussion is 3D reconstruction of CT, new modality of airway assessment. Coming to the introduction, we generally use Malampati score in clinical examination and Cormack-Lehane during the laryngoscopy is usual method of airway assessment. We have other investigational tools like X-ray, ultrasound, CT scan. Normal CT scan gives useful information, but 3D reconstruction of normal CT gives an extra edge. We present a case report where it is an example of management of difficult airway by 3D reconstruction technique. A 70-year-old female patient was admitted at our radiotherapy department with a huge thyroid mass. Thyroid mass with respiratory distress. She had a sudden respiratory arrest and she got intubated and was shifted to our ICU. There she was managed with ventilated care for 1 week. After 1 week, she got weaned off from the ventilator and post-extubation period was relatively uneventful. Then the primary department, along with coordination with ENT department and the oncosurgery department, they planned for an palliative thyroidectomy surgery. We planned a chest X-ray and lateral X-ray neck for assessment of the airway, which suggested compressive lesion in the trachea below the larynx. The primary department already had done CT scan for assessing the tumor. It was informed to us that intubation during the emergency management was difficult. So we requested our radiotherapy department, radio diagnosis department to do a 3D reconstruction of the CT available. And they gave us this pre-operative 3D reconstruction of the CT, where they reported that her report suggested multiple large, well-defined nodules in the bilateral thyroid lobe. Among them, the largest measured 35 by 33 millimeter in the left lobe. Bilateral neck vessels were displaced. Constriction was there in the trachea at about 4 centimeter deep. The narrowest long and short axis diameter was 13.1 mm and 3.4 mm respectively. Trachea was displaced right laterally and mild retrosternal extension was there. We can appreciate this finding clearly in our pre-operative 3D reconstruction picture, what I have shown with the white arrow. Coming to the management of the airway, since 3D reconstruction of CT showed a constriction in the trachea at about 4 centimeter deep, it was planned to do a fiber optic bronchoscopy. A written consent was taken from the patient for this thyroidectomy operation, and presenting this case also. At the operation theater, patient was induced to standard dose of anesthetic drug. First, an igel was placed and fiber optic bronchoscopy was done, and it was assessed a 6.5 mm size tube can be used for intubation. We used the fiber optic bronchoscopy to go through the most constricted site. And for intubation, confirmation of the intubation was done by bilateral breaks out auscultation and capnography, and also we saw the tip of the tube by the while removing the fiber optic bronchoscope also. Then the patient was handed over to the surgeon, and surgery was completed, and it was seen that the trachea was soft. So the surgery site planned to put a tracheostomy post-operatively. Patient was there in our hospital up to post-operative day 10, and then she was discharged and sent to home with the tracheostomy tube in situ. Coming to the discussion, 3D reconstruction of CT is an non-invasive modality that can be used as a replacement for conventional endoscopy for assessment of the airway, for evaluation of subglottic space in intubated patient, and may be used for planning of optical pan endoscopies and biopsies and surgeries in future. It can be used for measurement of normal airway dimension in children and different ethnic groups, for diagnosis of severe teeth and tracheobronchomalacia, and it can be used to assess the airway in different congenital anomalies affecting the craniofacial morphologies. The limitation of these advanced tools are they are not widely available, and their cost. They exposes the patient to radiation, and if there is poor aeration, that may exaggerate the asymmetry of the pathology. In unanticipated difficult airway, we can't use this modality.
Your time is over. Your time is over. Questions, please.
Dr. Subhajit, yeah, this is Dr. Asif. Now,
yes.
at the first instance, was the patient extubated when the first time the respiratory arrest had happened and the patient was on the ventilator? Was the patient extubated then?
Yes, sir. After 7 days, we could extubate the patient.
Then, if the patient was extubated, why was the surgery not planned at the same instance while he was on the the patient was on the ventilator? That's my first question. And the whole exercise that you performed in the pre-anesthetic checkup period, why was the exercise not done at the time of extubation? And what precautions or what readiness was there at your level while extubating this patient who was supposed to have a very difficult airway?
Yes, first coming to the patient, that coming to the first question, that why the patient was kept on ventilator for a prolonged period. That is during the patient was went into respiratory
arrest. That's not my question, Dr. Subhajit. That's not my question. My question is, if you planned an extubation, why did you not get the surgery done in that instance if the CT scan was done? That's my question. And if you had to extubate the patient, what were the precautions that were taken at the time of extubation? And why did you not do this 3D reconstruction at the time of your extubating this patient? Because you could have had a catastrophe there also.
Okay, sir. Okay, sir. Sir, the patient was intubated in our side, and the primary department then didn't plan for going into the surgery then, it was from their side that they wanted the patient to be first fit for the surgery. Actually, the patient was a known patient of thyroid cancer. She had all the biochemical parameters like blood, hemoglobin was not adequate, so we transfused some blood also, which I couldn't mention in this short slide view. So she was not fit for other parameters also.
What was the reason she got intubated in the first place? What was the reason?
Ma'am, actually, the patient was admitted in our radiotherapy department, and the tumor was compressible. She was lying supine, and the tumor anyhow compressed the trachea. And
so you intubated her to maintain the airway for 1 week?
Yes, ma'am.
So why didn't you operate her that would at the same time when she was with you and intubated? You said no, she had a respiratory collapse and then.
Yes, ma'am. Initially, the patient went into respiratory, that due to compressive lesion, the patient went into respiratory collapse, and the radiotherapy department themselves intubated the patient in outside. But the patient was not fit for surgery because of other biochemical parameters, like patient was anemic. The patient was mainly anemic, so we had to transfuse
Dr. Subhajit, anemia could be corrected within 24 hours. So that's not an indication, and that is the prerogative of the anesthesiologist to decide as to what are the parameters which are deranged.
And I
that can be
totally
corrected.
agree. And I totally agree saying that you have extubated this patient who was difficult to intubate and then did a CT and then re-intubated her again. That sounds ridiculous.
Yes, ma'am. Actually, ma'am, the decision of this, it is actually the surgery was, the plan for surgery was taken on the palliative ground, ma'am, not as a curative ground. So when we extubated the patient, then still that the horses of wires and some strider was still there on supine
Well,
position.
obviously.
Yes, ma'am. So then only, ma'am, the primary department, they consulted the ENT department. Then they told, okay, we can do some palliative surgery, which may help in
fine. You've talked about radiation exposure, saying as one of the limitation. What is the radiation exposure in this 3D reconstruction CT scans which you do?
Yes, ma'am. There is theoretical radiological exposure that is
how much is it?
Very minimum from 0 to 0.2 milligray. That is the theoretical radiological exposure in this CT scan. That is why theoretically we don't have much data.
And another question I have is that you extubated this patient initially with tracheomalacia, and later she required a tracheostomy for the same thing.
Yes, ma'am. Actually, due to tracheomalacia, we extubated the patient with tracheomalacia, and all the finding of compressive lesion stridor was there. So, in our concern, it was always there that this patient we need to situate the airway if we go for future management. So, when we went for surgery, finally, then during after the surgery, due to this prolonged compression, and this actually it is an invasive lesion which invaded some portion of the trachea, and some portion of the trachea was permanently damaged, so it couldn't be reconstructed immediately. So the surgery department ENT surgery department planned that we should for maintaining the airway, we should put tracheostomy, and they put the tracheostomy and kept it in situ and discharged the patient with the tracheostomy tube.
Okay, fine.
Thank you, Dr. Subhajit. We can move to next speaker. Dr. Supriya, are you there?
Okay, sir. Thank you, sir.
Dr. Supriya, are you there?
Yes, sir, I'm here. Am I audible?
Yeah, you are audible. Please share your screen. Please share your screen and start your presentation.
Yes, sir. Yes, sir. In a moment, please.
Be quick. Yeah, go to slideshow and start your presentation. Your time starts now.
Yes, sir. Good evening, everyone. My name is Dr. Supriya Kumar, and I will present a poster entitled Out of the Box Solution in a Box. The COVID-19 pandemic has given way to a number of preventive strategies for the protection of the healthcare workers against aerosol-generating procedures. One such innovation was the intubation box, the concept of which was by Dr. H. Lai from Taiwan. We incorporated such a box at our institute with the aim of implementing barrier protection against aerosol-generating procedures like suctioning, tracheal intubation, bag and mask ventilation, and extubation. We got made a custom-designed acrylic box of the dimensions 43 x 36 centimeters with 12 centimeter diameter openings for the hands of the operator. We covered the caudal end of the box with plastic sheets. This is a cost-effective and easily sterilizable box which may be used repeatedly. Some of the limitations that we faced while using the box were the lack of flexibility. Now, this was not unique to us because we found that this particular limitation was in box. The time for tracheal intubation was found to be increased with an increased number of attempts required for successful intubation. Beagley et al. Reported a similar finding. We found that the box was unfavorable for LMA insertion and nasal intubation. Instrumentation was limited where airway adjuncts were required. J.P. Simpson et al. Reported an increased particle contamination of the laryngoscopist. An observational study to assess the efficacy of the intubation box was undertaken at our institute, where the observers found that the intubation box increases the time to intubation and decreases the user efficiency. Post-intubation installation of methylene blue in the nasopharynx done to assess the efficacy of the box, however, revealed soiling of the box and personal protective gear of the operator in more than 50% cases during extubation. Keeping in mind the limitations that we faced, we delved into what limited literature was available and found a series of modifications that the intubation box has undergone. Figure A here shows the most primitive form of the intubation box, which was a makeshift disposable box made of cardboard and plastic sheets. Figure B is a modification by Johnny Way Bai. They transformed the traditional cuboid shape of the box into a dome shape. This design made the box more easily and thoroughly sterilizable. They also introduced wider arm ports, which were placed asymmetrically for better operability. Additional ports for assistance hand increased. Picture C here, an airtight modification by the University of Minnesota. Picture D is the latest modification of the box called a portable negative airflow chamber. This modification was introduced by Javier Cubelos and his team, who added a port for standard wall suction connector. In conclusion, I'd like to say that despite certain limitations, we feel that with practice, the intubation box, in conjunction with adequate personal protective equipment, significantly become an essential adjunct of the anesthesiologist's armamentarium. Thank you very much.
Dr. Supriya, how many cases did you use this intubation box in?
So we are using it fairly regularly in most of the elective surgeries that we are performing at our
How many
institute.
cases? My question is specific. How many cases have you used this intubation box in?
So more than 30 actually.
That should have come in your presentation. Did you do any of them, any modification in the last four modifications that you showed, or you have used any one of these?
No, sir. Basically, the box that we are using at our facility is a replica of the prototype.
Okay. So what is the out-of-box solution that you have offered? Because this is something which is known in the COVID. So what is intriguing in this particular aspect that you have used?
So we are only advocating the use of the intubation box in our regular procedures. Whilst there are studies which say that we may not use them and there are limitations, we just say that we prefer the use of it as an adjunct to all the barrier protections that are being used.
Okay, good. Suppose there is a failed intubation. How do you go about?
So we have had difficult intubations and we have had to remove the box in such situations, sir.
In how many cases? So all this should have been part of your presentation actually, rather than giving the details of what modification the world is using or what is the background with advantages and disadvantages.
So
in a poster
I
presentation,
that
should come out with what is your original experience and what is the finding that you have had.
Yes. Thank you.
Okay, how did you sterilize this box, Dr. Supriya?
We used sodium hypochlorite 1% solution and we wiped it. We did not use aerosol. We did not use fumigation in this.
So the fumigation is anyway not recommended for the box, and the hypochlorite solution is recommended in a concentration of 2%, not 1%. So what is the innovation that you are trying to convey through this presentation?
So, ma'am, we are just advocating the use of the box. We are simply saying that it needs to be used in a regular practice in order to avoid aerosol transmission.
Okay, and what do you do when you encounter a patient who's obese and difficult to intubate?
Ma'am, we have had a situation like that, and in obese patients, because our box is fairly rigid, this is again another limitation of our box. Because this box is so rigid, in obese patients, we have had difficulty with the sizes itself. So we have had to abandon the box. In that case, we depend simply on our masks and our shields and our protective gear now.
Does it have any role if you're already wearing PPE?
Definitely, ma'am. It is increasing the efficacy of the barrier protection.
How? If you're anyway wearing full level 3 PPE and you're using all the recommendations to minimize aerosolization, what added advantage do you think this box is going to give you?
Ma'am, it is giving us another layer of barrier protection.
Which otherwise you would not have if you were wearing PPE? With the PPE, you already have the protection you need. It only causes containment of virus at one place, and the moment you remove the box, that aerosolization of the virus which has got contained in one place anyway takes place in your theatre. Do you have a negative pressure theatre?
No, ma'am, we do not have one, no.
Okay, thank you.
Thank you very much.
Thank you, Dr. Supriya. Dr. Aswini, are you there?
Yes, sir.
Yeah, please share your slide.
Yes, sir.
Supriya, you can leave. Ashwini, please share your slide. Go to slideshow and start.
Photo slideshow.
So first of all, sorry for the inconvenience. A very good afternoon. This is Dr. Ashwini Ekka. My topic of presentation, TIVA, a safer and feasible alternative for anesthesia in COVID times. From
Can
aiding
you
in
just hold,
anesthetic
Dr. Ashwini?
techniques.
Dr.
We are
Ashwini,
unable
please.
to see your presentation.
Yeah, it's okay, sir.
Yeah.
Okay. Carry on, Dr. Ashwini, please.
Dr. Ashwini, start.
Yes. So from aiding in anesthetic techniques to acting as the sole anesthetic technique, TIVA, that is total intravenous anesthesia, has come a long way. TIVA has re-emerged as a safer alternative in COVID pandemic. So whenever there is a case where we have to choose between general anesthesia or TIVA, so we are more inclined towards TIVA because it reduces the incidence of airway manipulation, thereby reducing the likelihood of aerosol generations, which is the most important source of transmission of the infection. So keeping in mind the above points and keeping into account the current scenario, I'm going to present my report. 62 with complaints of swelling of the anterior chest wall, posted for tumor removal, tested COVID-19 positive, returned for the same with the negative reports after a month. A pre-anesthetic evaluation prior to the day of surgery, written and informed consent were taken. All investigations were within normal limit. Ultrasound showed echogenic mass. FNSC revealed adipocytes. General examination, the patient was conscious oriented afebrile, weighing 60 kilograms, blood pressure 140 by 70 mmHg, pulse rate 70 per minute, saturation 98%, systemic examination, no other comorbidities. Preoperative preparation, 20 gauge cannula was inserted in both the upper limbs, multipara monitors were attached and baseline values were noted. These monitors were attached. The patient was pre-medicated with injection glycopyrrolate 0.2 mg IV, followed by ranitidine, injection ranitidine 50 mg IV. Anesthetic management, oxygen was given via face mask at the rate of 6 liters per minute, injection Dexona 8 mg IV. The patient was induced with propofol, ketamine, and dexmedetomidine in the ratio 1:1:1, followed by infusion of paracetamol 1 mg IV. Surgical site was infiltrated with local. Following induction, the patient propofol was infused at the rate of 30 ml per hour to maintain depth of anesthesia to 60 in accordance with BIS monitoring. Was titrated there accordingly. The surgery was completed in minutes. Then the patient was shifted to post-anesthetic care unit for recovery. Discussion and recommendations in this case are one-touch or no-touch technique. So with which will lead to reduced airway manipulation and thereby reduce. So advantages, TIVA has advantages over other anesthetic techniques as it reduces immunosuppression, it increases innate immunity, reduces post-operative cognition deficit, leads to early recovery and decreased hospital stay. There is early ambulation. So keeping in mind the above following advantages, we can safely conclude that TIVA has emerged as a safer and feasible alternative for anesthesia in COVID times. Thank you.
Dr. Ashwini, now this patient had tested negative and has come to you after 1 month of having that result. So this patient doesn't stand in the COVID risk category at all. Now the second point that I want to put forward is, if this patient is negative and you have performed a TIVA as for any normal patient, what is so special about this poster presentation or this particular case that you want to bring it forward to us?
So first of all, we were not entirely relying on the reports because in the past there have been instances where the reports were negative, but the subsequent reports turned out to be positive.
I'm sorry, Dr. Ashwini, sorry to interrupt. RT-PCR is the gold standard, the confirmatory test. So you have to rely, then you should have relied on the first test at all when it was tested positive. So anyway, the point is, the patient who is already there, suspected positive or a confirmed positive, but TIVA is a known factor. So that is something we should be applying it. But why are you presenting this poster? What is a strong message that should come to us? With a single case, I think that's not coming out very clearly.
So we tried to take all the precautions as to prevent the patient-doctor interaction as well as the stay of the anesthesiologist in the operation theatre. We were infusing we were using propofol infusion via infusion pump using a PML line, so that the
That's what I'm
doctor
telling
or the
Dr. Ashwini. These are, sorry for interrupting these because time is a constraint.
Yes.
These are all known facts. I just want to know what is unique in this paper of yours or unique in this particular case.
So we could have gone for regional anesthesia as well, but we didn't opt for that because that would have been time consuming and that would have increased the stay of the anesthesiologist in the operation theater, thereby increasing the risk of exposure. And so we used so we tried to remove this tumor using just TIVA. So that is just.
Other judges, please.
So after institution of TIVA, you all moved out of the theater. How did you monitor the patient? Did you have a remote monitoring? Did you have a system where?
Ma'am, we were in the vicinity, but we're not in close contact with the.
What is in the
patient.
vicinity?
We were outside the OT theater, ma'am. We were constantly visualizing. We had used BIS monitoring, so we could have an eye on the depth of sedation. So
were you in PPE?
Yes.
You were in PPE. Then what was the need to leave the theater? And suppose this patient had a respiratory compromise. Suppose the sedation had become deep, and you needed to interfere and manage the airway. What would you have done?
Yes. Ma'am,
your backup plan.
Ma'am, we had kept in mind in the backup plans. If there would have been any such mishaps, then we would have gone for a supraglottic airway device, so we would have inserted a nasopharyngeal airway or a.
So you would have done everything that would have increased aerosolization. Why
Yes,
did you not start with a regional in the first place?
Ma'am, the main concern was we were just trying to cut short the time the anesthesiologist had to be in the OT theater just to reduce the incidence of airway the anesthesiologist and the patient interaction. We just had to cut short the times, so therefore we did not
But
go
is
for.
it not against the basic standard of anesthesia where a trained and qualified anesthesiologist has to present inside when you're dealing with a case with all PPs?
Yes.
Okay.
Thank you, Dr. Ashwini.
Thank you.
Thank you to all judges for their patience hearing. And I request all judges to please make the result and mail it to Dr. Saras sir and Dr. Nishan sir.
Thank you, Dr. Prashant. Thank you, everybody.
Thank you.
Yes, hello, just a second. I want to thank all the judges, especially Dr. Ranju ma'am. Actually, she waited too long. Madam, really sorry from.
No, it's okay.
Thank you very much for staying us. It was
okay,
really.
And I congratulate you on the effort, on all the preparations that must have gone in for this online event. And before we present the results, is it possible for me to talk telephonically to the other judges? Is it possible for you to share the numbers so that I can talk to them?
Sure, ma'am. Sure.
I request Nitin to please look after this because I have the panel.
Ma'am. Sure.
Yes, thank you so much.
I will send
Hello, Ranju madam.
other number of.
Thank you so much.
Hello, Ranju madam. Welcome.
Manoj sir. Hold on, Ranju ma'am. Manoj sir is online, sir.
Namaskar. Namaskar.
Hello, Ranju madam. How are you? Nice
I'm fine, Manoj. It's good to see you.
Now we can move to next session.
I have not seen Dr. Badani. My hi to him also, and to Nishant.
Okay.
Thank you, ma'am.
Thank you.
Now we can move to next session, and I hand over to our next coordinator, Dr. Nidhi Chaubey, ma'am.
Welcome, ma'am. Nishant here.
Hello. Thank you, Dr. Nitin Ojha and Dr. Prashant. So moving on to our last session of this academic extravaganza, our panel discussion on the topic obstetric hemorrhage, a real challenge. It's my privilege to invite Dr. Gautam Saha, Head and in charge of Department of Anesthesiology and Critical Care, Bokaro General Hospital, who has been invited as a guest lecturer in various national, zonal and state level conferences, And he has also played a major role as a examiner for FAT examinations conducted by National Board of Examinations across the state. He is a true academician, I must say. I welcome sir and ask him to proceed to the panel discussion. Thank you.
Good evening, Nidhi. Can you hear me?
Yes, sir. Yes, sir,
Okay.
I can hear you.
First of all, I congratulate all the organizers and all the participants for such an extravagant academic extravaganza. It was fantastic throughout the day. We are coming to the end of our today's proceedings, and today's topic is obstetric hemorrhage, a real challenge. In our midst, we have got 5 excellent academicians. I would like to introduce them briefly if I have the time, Nidhi. Can I take 2 minutes to introduce them? Hello?
Yes, sir, you can, sir.
Okay. I invite the first panelist, Dr. Sanjeev Kumar. He's a professor, head of the Department of Anesthesiology at IGIMS Patna. He has done his MD from Benares Hindu University, and he's also a nodal officer at National Emergency Life Support and Skill Center. Next panelist I invite is Dr. Sharad Kumar. He's a consultant, Tata Main Hospital at Jamshedpur. He's secretary of ISA, Bihar and Jharkhand. His area of interest is obstetric anesthesia, and he's the architect of today's WEBCON. And he has published many papers in national and international journals. I invite Dr. Neelam Sinha. She's a senior consultant, Department of Anesthesiology and Pain Relief at Tata Motors Hospital, Jamshedpur. She's a national faculty for chronic pain management and ultrasound and the role of ultrasound in anesthesia. She has several international and national publications to her credit. And I remember what a wonderful job she did last year at Bokaro during our Bokaro Jharkhand ISA conference. The next panelist on our list is Dr. Shivpriya. Dr. Shivpriya, he is MD from SGPGI Lucknow. He's a professor and head CTVS surgery at RIMS Ranchi. He has more than 25 publications in national and international journals to his credit, a top-class academician amongst us. Finally, let us come to Dr. Sukesh Kumar. He's assistant professor of anesthesiology at PMCH Patna and has more than 25 national and international publications to his credit. I would like to mention that he organized a very successful PG assembly in Patna in the month of January, February this year. Welcome to all the panelists. And without wasting any further time, there's a paucity of time, I would like to go ahead with today's proceedings. The first question for the day is for Dr. Sharad. Dr. Sharad, are you ready?
Yes, sir.
The first question is, obstetric hemorrhage is a dreaded complication, which we all fear. A lot of discussion has taken place, and practically in all the symposiums and seminars, obstetric hemorrhage is always a topic, and so be it in this conference. The first question to Dr. Sharad is, define and classify the major obstetric hemorrhage, causes of the obstetric hemorrhage.
Thank you, sir. Thank you very much, sir. So, major obstetric hemorrhage refers to any kind of excessive bleeding related to twins. This is, there is no universal consensus on the exact definition of the major obstetric hemorrhage. But for the practical purpose, we should define the major obstetric hemorrhage on 3 grounds: by volume, by transfusion, and by the rate. Coming to the volume, if in 2012, the World Health Organization said that if there is blood loss more than 1000 ml, we can call it major obstetric hemorrhage. But in 2016, RCOG guidelines says that if the blood loss is more than 2000 ml, we will call it major obstetric hemorrhage. And if there is fall in hemoglobin more than 4 gram, 4 gram per deciliter after acute blood loss will be called as major obstetric hemorrhage. Coming to the transfusion, if patient receives more than 4 units of the blood transfusion within 24 hours, we will call it as a major obstetric hemorrhage. Or coming to the rate, that is the third type, if the blood loss is more than 150 ml per minute, we will call it major obstetric hemorrhage. Or the loss of more than 50% of the blood loss in 3 hours, or the loss of 100% of the blood loss in 24 hours, we will call it major obstetric hemorrhage. Coming to the second part of the question, what you said, classify. So we will classify into 2 types, moderate and the severe. Moderate we will call when the blood loss is more than between the 1000 and 2000 ml. That is 1 liter to 2 liter. We will call it moderate obstetric hemorrhage. But we will call it severe when the blood loss is more than 2 liter. Thank you, sir.
Thank you very much. So, Dr. Sanjeev, here's a question for you. just as when there is an obstetric hemorrhage, before we start any resuscitative measure, we have to estimate how much blood loss is taking place. But what are the pitfalls in estimating the blood loss in obstetric hemorrhage? Could you please explore it properly?
Sir, most of the morbidity and mortality in the obstetric hemorrhage are due to inability to early assessment of the exact amount of the blood loss. And usually in such situation, blood loss is assessed by the visual estimation, which is often inaccurate and underestimated. And because of the contamination of the amniotic fluid, blood loss being concealed internally or in the form of the retroplacental clot. For the example, in case of the placental abruption, and sometimes is also hidden under the drape or on the floor. So since physiological changes associated with the pregnancy, like increase in the maternal blood volume and increased heart rate, a stroke volume, cardiac output, and uterine blood flow, all these mask the clinical presentation of the hypovolemia, like the cold periphery and pallor and tachycardia, hypotension. All these features are usually it should be find out, but it usually masked. So we should meticulous clinical observation and high index of the suspicion should be done to detect the eventually treat and such hemorrhage as earlier as possible.
Thank you. A very good answer. Dr. Neelam, I'm coming to you. We all know that a lot of the changes which take place in maternal physiology during pregnancy and term, it has a bearing upon the obstetric hemorrhage, the quantum and the method of it. Could you please outline the salient features of maternal cardiovascular physiology at term?
Yes, sir. Thank you, sir, for asking this question. Basically, the physiological changes of pregnancy at term, and especially the cardiovascular changes, to some extent are beneficial for the mother. The basic changes are changes in the intravascular volume and the red cell mass, changes in the cardiac output, decrease in the systemic vascular resistance, and presence of supine hypotension. So coming to the changes in intravascular volume, the intravascular volume, that is the plasma volume, increases by 50% of the pre-pregnant label at term, as while the red cell mass increases by 25% near term. And these increase in the red cell mass and disproportionately greater increase in the plasma volume, it helps the pregnant patient stay hemodynamically stable with mild to moderate loss of blood loss during the delivery. The second change is that plasma protein concentration also decreases. There is a decrease in 25% reduction in albumin, as well as 10% reduction in total protein, causing the colloid osmotic pressure to drop from 27 to 22 millimeter of mercury. There is leukocytosis. Then the changes in the coagulation factor. So pregnancy is a hypercoagulable state. In this condition, all the factors, factor 1 and factor 7, there is marked increase. Factor 11, 13 and antithrombin 3, they decrease. Factor 2 and factor 5 remain unchanged. The prothrombin time decreases to 20% of the normal. The APTT remains normal. And platelet is normal or slight, that is the 10% reduction in, at term. This hypercoagulable state prevails in pregnancy with increased fibrinogen and factors 7, 8, 9, supervening over the rise in natural anticoagulants like protein A, protein C, and antithrombin 3. This fibrinolytic system decreases in activity. Plasminogen is increased, but its activity is dampened by a corresponding rise in plasminogen inhibitor type 2. An exception to the general increase in coagulation factor is the fall in platelet level, so-called the gestational thrombocytopenia. The changes in the cardiac output at near third trimester, the cardiac output increases by 50% of the pre-pregnant label, and the cardiac output is a product of heart rate and stroke volume, both of which increase, and this fluctuates with the uterine contractions. So at term or near labor, the cardiac output increases maximum by 80 to 100% above the labor values during the third stage. and then it returns to pre-pregnant values into pre-labor values in 24 hours postpartum. The systemic vascular resistance is decreased. The systolic, diastolic, as well as the mean arterial pressure, they decrease by 5 to 20% by 20 weeks of gestation. There is more decrease in diastolic than the systolic blood pressure, but cerebral CVP and PCWP, they remain constant. There is another component of aorto cable compression, which is experienced by nearly 15% of patients at term, defined by decrease in mean arterial pressure more than 15 millimeter of mercury and increase in heart rate by more than 20%, beats often associated with diaphoresis, nausea, vomiting, and changes in mentation. This may exacerbate venous stasis in legs, leading to ankle edema and increased risk of venous thrombosis. Thank you.
Excellent presentation, madam. Very beautifully, you have elucidated the key features which has got the entire effect on the outcome of obstetric hemorrhage. Taking the discussion further, I will ask Dr. Shiv Priya to briefly state what are the major causes of antepartum hemorrhage and postpartum hemorrhage. Dr. Shiv.
Yeah, good evening, sir. I will keep my answer in brief. Like we know, among the cause of the antepartum hemorrhage, 1/3 are mainly due to the placental abruption, and that are actually is abnormal separation of the placental lining from the uterus. And another 1/3 are due to the placenta previa, that is the placental implantation abnormally low near the uterine os. And rest 1/3 are due to the other causes like uterine rupture or coagulopathy. Coming to the postpartum hemorrhage, that may be the primary that occur within 24 hours or secondary within 24 hours to 6 weeks after delivery. So the causes of postpartum hemorrhage, mainly it is easy to remember with the 4 T's. That is, first T is tone. So that is uterine atony, and that is around that cause around 70% causes of the postpartum hemorrhage. Another one is the trauma, like that is in emergency LSCS, or if the baby weight is more than 4 kg, and that is vaginal delivery, or some instrumental injury that may lead to the trauma of the uterus. Third is like retained placenta, that may also cause the postpartum hemorrhage. Actually, what the secondary cause of the PPH that lasts for the 6 weeks, that is the main cause is the retained placenta. And last T is the thrombin like coagulopathy. So this coagulopathy may lead to the postpartum hemorrhage. So postpartum is more commonly associated with placenta previa, multiple pregnancy, polyhydramnios, previous history of PPH, and if there is the prolonged labor or the obesity, like if BMI is more than 50, so the chances of the PPH is more. Thank you, sir.
Thank you, Shiv. Dr. Sukesh, could you please elucidate what are the complications of antepartum hemorrhage?
Thank you for giving me the opportunity, sir. The complications related to APH are usually dealt under 3 captions. And the first caption is fetal complications. Among the fetal complications, there occur fetal hypoxemia or birth asphyxia. The second one is premature delivery. The third one is growth retardation. And last one is intrauterine death may occur under the fetal caption. Second one is related to the maternal. There may occur, the complication is acute hemorrhagic shock, acute kidney injury, the occurrence of premature labor. There may occur retained placenta and postpartum hemorrhage. We can also see the higher chance of cesarean section delivery and